Okay. So guys, we are out of the technical issues. So we'll start with the session. So guys, we are going to focus next 4 hours on the important topics from medicine. Of course, only on the important topics. We are not getting into the details of individual topics, or we are not learning anything new. We are revising what we have already studied. But if you are not studied medicine well and you're not here for revision but for learning, I would recommend that I have done a 10 sessions on the revision for individual systems from medicine, each lasting for 2 hours. I would recommend that you can go through those videos if you're not started medicine at all. But if you're done and you're here for revision, well, next 4 hours, we will do a power packed revision. We will begin with the cardiology first. Now, what are important topics from cardiology? If you look at all the papers from the past, you will realize that at least one question comes from the JVP. Rarely they also ask questions on the pulse waveform. One question comes from abnormal heart sound. One question comes from either ischemic heart disease or the cardiac failure. And one question comes from either cardiac tamponade or the constrictive pericarditis, or differentiating between these two. So we will primarily focus on these topics. We will start with the pulse. Okay. So I will quickly revise the normal pulse waveform. Now, pulse is a pressure wave. We have to always remember that pulse is a pressure wave, because when left ventricle ejects the blood into the aorta gets stretched and triggers a pressure wave. Pulse is not a volume wave. We are not feeling the blood coming and hitting our palpating finger. It is the pressure triggered by the left ventricular ejection. Wave travels faster than the blood. Okay, so what we palpate is a pressure wave. So we have to always remember that pulse is a pressure wave. It's not the blood that we feel. Pulse is a pressure wave. Okay. Now, when we look at the normal pulse waveform, first thing you will notice is that it's a pressure wave. When I say wave, there will be an up and a down, right? So as soon as left ventricle ejects the blood into the aorta, the pressure inside the aorta increases because the aorta is getting stretched. So I get an upswing in the waveform. Okay. But as the pressure starts dropping down, I will have a downward movement, right? Now, this wave that we are seeing here, right, I will call it as the percussion wave. We will call it as percussion wave. Okay, but as the left ventricle ejects the blood and the aorta gets distended and the pressure increases and we trigger a wave, when the wave is receding, the aorta is recoiling. When aorta recoils, it increases the pressure inside the aorta again. So our waveform is not going to go down like this, but because of the recoil, there is increase in the pressure and the waveform will start going up again. So the actual waveform is going to look somewhat like this. It starts increasing again. So this waveform, we will call it as tidal wave. We will call it as tidal wave. So now what is responsible for the percussion wave is the question they ask. Percussion wave is due to left ventricular ejection. Left ventricle ejected the blood and that gave us to the percussion wave. What is causing the tidal wave? Tidal wave is due to recoil of the aorta. It is due to recoil of aorta. Now you may be thinking why recoil is increasing the pressure. Simple. There is a rule called as Boyle's law which says that pressure inside a chamber is inversely proportionate to its volume. So when aorta got distended by ejection of blood into it, we put the blood, aorta got distended, that created a pressure wave. But when aorta recoils back, what is happening to the volume of the aorta? Volume of the aorta is decreasing and volume and pressure have inverse relationship, right? If volume decreases, pressure increases. So that is why this increase in pressure we are seeing, because the aorta recoiled and decreased the volume. We are going to call this as tidal wave. And between this percussion wave and tidal wave, obviously there is a notch, right? What we should call this notch as? We will call this notch as the anacrotic notch. We will call this as anacrotic notch. Anacrotic notch. Okay. Now once this percussion wave and tidal wave is over, the wave should be coming down because it is a wave. Wave is always coming down. Now the question is, will it reach the baseline? Of course not. Why it will not reach the baseline? Because once I had ejected the blood into the aorta, I had sent a wave. A wave had gone to peripheries from the aorta, right? Now, will peripheries keep quiet? Newton had said that every action will have equal and opposite reaction. So when I send a pressure wave to the peripheries, peripheries will reflect the wave back. So that reflected wave back will increase the pressure again. So I will have again increase in the pressure. Of course, it will not go as high as the initial one, but I will still have a wave. This second part of the wave that I am seeing here, what should I call this as? We will call this wave as the dichrotic wave. Dichrotic wave. Now, what is it due to? Dichrotic wave is due to reflected waves from the peripheries. It is due to reflected waves from periphery. Indirectly, it is a measure of the peripheral vascular resistance. Peripheral vascular resistance. Okay. Now, if I have to map this to the cardiac cycle, remember your percussion wave and tidal wave are part of your systole, right? Part of the systole. This is going to be my systole because I eject the blood from ventricle to aorta during systole. That's why percussion wave and tidal wave are part of systole. The dichrotic wave is part of diastole. Diastole. Okay. Now, when I look at this waveform, it has a peak, right? Peak. I have already told you that this waveform is a pressure wave. So peak of the waveform is representing peak of the pressure inside the aorta. Now, what does that correlate with? This height correlates with our systolic BP. Systolic BP. And the peak of the dichrotic wave, this pressure correlates with the diastolic BP. Clear? In the pulse waveform, peak of the systolic waveform correlates with systolic BP. Peak of the diastolic waveform correlates with the diastolic BP. Clear? Okay. Now, what abnormalities can happen with this waveform? Because MCQs are not going to come from the normal waveform. They will ask you abnormal pulse waveforms. Okay. Now, to understand this, I have to tell you one important point. Please remember that this peak is systolic BP and it is going to be proportionate to the left ventricular ejection. Of course, if I eject more blood into the aorta, more distension, more will be the peak pressure. If I eject less into the aorta, less distension, less will be the peak pressure. So can I make a statement and say that systolic BP is proportionate to stroke volume, because left ventricular ejection, the volume that is ejected by the left ventricle is nothing but stroke volume in one contraction. So whenever stroke volume decreases, what will happen to the peak of this systolic waveform? It will come down. Whenever stroke volume increases, it will increase. This is a basic thing I want you to know. Video is still lagging. Can you give me a confirmation? If it is still lagging, let me check with any technical issues. If not, we will go ahead. Komal, Asia, can you just drop a text and let me know if the video is still lagging? Okay, I hope so far it is clear that systolic BP is proportionate to stroke volume. Now let us look at the important abnormal pulses. The first pulse I want you to remember is what is called as pulsus parvus. Okay. Now, what is the meaning of parvus? Parvus means small. Small. When we say pulse is small, what does that mean? The peak of the pulse is small. When the peak will become small? When the stroke volume is less. When the stroke volume is less, the peak of the pulse will become small. So, pulsus parvus means small peak. In what condition it can be seen? In what condition it can be seen? Whenever stroke volume decreases, it will be low. So when stroke volume decreases, there are plenty of conditions like the cardiogenic shock, low cardiac output states. Anything that causes the low cardiac output, it can cause pulsus parvus, small peak. Okay. Then the second thing we have is something called as pulsus et tardus. The word tardus means slow. Slow. Now, when I have this pulse waveform, I am achieving the peak after some time of the onset of left ventricular ejection, right? This is a time I am taking to achieve the peak. If my left ventricular ejection is slow, I will reach the peak slow. Peak will appear somewhere here, right? Late. Late peaking means pulsus tardus. Late peak is pulsus tardus. So in what condition the peak can be late? When left ventricular ejection will be very slow. When left ventricular depolarization is slow. For example, left bundle branch blocks. In LVBP, you can have pulsus et tardus, where the peak is very late. Why the peak is appearing late? Peak is appearing late because left ventricle is getting depolarized late. तो क्योंकि लेफ्ट बंडल ब्रांच ब्लॉक है तो लेफ्ट वेंट्रिकल गेट्स डीपोलराइज्ड लेट, तो लेफ्ट वेंट्रिकल का एजेक्शन भी लेट होता है, तो देन पीक विल अपीयर late, but peak height will be normal. But in one condition, you can have something called as pulsus parvus et tardus. What does that mean? It means peak भी छोटा है और आ भी लेट रहा है. Late as well as small peak. That is classically seen in severe aortic stenosis. We will call it as small late peaking pulse. Small late peaking pulse, classically seen in patients with severe aortic stenosis. Severe aortic stenosis. Severe AS. Okay. Now we have one more term called as pulsus bispherians. Normally pulse में कितने peak हैं? Theoretically there are two peaks in the pulse. One systolic peak, one diastolic peak. But we cannot feel the diastolic peak, we can only feel the systolic peak. That is why whenever we check the BP, palpation method, we can only recognize the systolic BP. Diastolic BP के लिए we have to follow the auscultation method because humans cannot feel the diastolic peak. If I put a cannula inside the artery and check the pressures, I can document this waveform. But feel तो सिर्फ systolic peak ही होता है. Only one peak. But sometimes you can have two systolic peaks. This anacrotic notch becomes deeper and you can have two systolic peaks. Such cases we will call it as pulsus bispherians. Pulsus bispherians refers to two systolic peaks. Two systolic peaks. For exam's sake, you have to remember two important conditions where you can have pulsus bispherians or two systolic peaks. The first and the most important one. In fact, सारे exam में they use this as a tool to diagnose HOCM. Means if there is a question where patient is having some symptoms like syncope, chest pain or sudden cardiac death, and then they mention that patient had two systolic peaks or pulsus bispherians, that means examiner is clearly telling you I am talking about hypertrophic obstructive cardiomyopathy. The other condition you have to remember is aortic regurgitation. Aortic regurgitation. Okay. Now last but not the least, what is this pulsus paradoxus? Paradox का मतलब क्या है? Normal से opposite में. Now normally what happens to the peak of the pulse with respect to respiration? During inspiration, right side of the heart gets more blood. So right ventricular ejection will increase, but left side of the heart gets more blood during expiration. So left ventricular ejection increases in expiration. Of course, when we measure the systemic BP, we are measuring the left ventricular ejection. So generally BP is higher in expiration in comparison to inspiration. कितना फर्क हो सकता है? Up to 10 millimeters of mercury systolic. BP drops by 10 millimeters of mercury systolic during inspiration. If it is more than 10 millimeters drop, then we call it as pulsus paradoxus. More than 10 millimeters drop. More than 10 millimeters of mercury decrease in systolic BP during inspiration. We will call it as pulsus paradoxus. We will come back to this part, the pulsus paradoxus, after we have spent few minutes on the constrictive pericarditis and cardiac tamponade, because this is one important tool which will be like we will be discussing again there. So we'll come back in what conditions we can have pulsus paradoxus. This is about pulse. What I want you to remember here, where do you get the pulsus bispherians? The single most important MCQ from the pulse is pulsus bispherians. Most importantly, HOCM. Pulsus parvus et tardus, again, that is the second most important thing, typically seen in aortic regurgitation. In fact, it is a marker of severity of AS. Okay, so that is about the pulse waveform. If you want more details, it is there in the cardiology revision video on the same channel. The next important topic from medicine is usually the JVP. Almost every FMG exam, there is one question on the JVP, and questions are no longer about the normal waveforms. The questions are about the abnormal waveforms. So first we will spend little time understanding the normal waveforms, and then we will make a list of the abnormal waveforms that you need to remember. So normally, as we already know, JVP represents the right atrial pressure. Whenever right atrial pressure increases, jugular venous pressure increases. Whenever right atrial pressure decreases, jugular venous pressure decreases. So if this is my right atrium, this is going to be my right ventricle, and this is going to be my inferior vena cava, which is connected to internal jugular vein, right? So this is where we are measuring the JVP, because this is the internal jugular vein. This is my right atrium. Now, what is the function of right atrium? Receive the blood from superior and inferior vena cava and transfer it to the right ventricle. This transfer happens during diastole, right? So during diastole, the transfer from right atrium to right ventricle happens in two stages. What are the stages? The first, in fact, three stages. The first phase is isovolumetric relaxation, where ventricle relaxes to receive the blood. After that, because of the pressure difference, the blood gets transferred. We call it as passive filling phase, right? This passive filling continues till pressure in right atrium and right ventricle become equalized. After that, to eject the remaining blood into the right ventricle, the right atrium actively contracts to push the blood into the right ventricle. This phase we call it as active filling or atrial kick, or you can also use the term atrial systole or atrial contraction. So during this atrial contraction, tell me what will happen to the pressure inside the atrium? What will happen to the pressure inside the atrium? Of course, Boyle's law. What Boyle's law says? Pressure inside a chamber is inversely proportionate to volume. अगर atria contract कर रहा है तो volume is decreasing, the pressure will be increasing. So at this point of time, the active filling phase, if I look at the JVP, what the graph will show? Atria is contracting, pressure is increasing. So the graph will show an upward line like this, right? So this wave, let me call it as A wave. We will call it as A wave. Once atria has contracted and ejected the blood, the ventricular diastole is over. Now the tricuspid valve will close and the ventricle will start relaxing on the other side. Ventricle will start contracting on the other side, because whatever blood I have given to the ventricle, now the ventricle will eject into the pulmonary artery, right? And this side, what atria will do now? The tricuspid valve is closed. Now it has to receive the blood from superior and inferior vena cava. To receive the blood, what should be the atrial pressure? अभी contract किया था, तो pressure यहाँ पे है, right? It is high. At high pressures, can it receive the blood? No, it has to lower its pressure. So it will start lowering the pressure. How can I lower the pressure? Simple. What Boyle's law says, pressure and volume are inversely related. अगर pressure कम करना है तो volume को ज़्यादा करना पड़ेगा. So this contracted right atrium will now start relaxing. It contracted to squeeze, active filling. Then now it is relaxing. So when it is relaxing, the pressure will start decreasing. So that gives us something called as X descent. We will call it as X descent. लेकिन जब atria relax कर रहा है, parallelly on the other side, right ventricle is in another phase of cardiac cycle called as isovolumetric contraction, because it has gone into systole. Atria is in diastole, ventricle is in systole. So it is contracting. And when it is contracting, it will be exerting pressures on the tricuspid valve, and it will push the tricuspid valve into the right atrium. थोड़ा सा pressure के वजह से. So when it pushes the tricuspid valve into the right atrium, right atrial pressure will again increase, because right atrial volume decreased. तो ये जो relaxing right atrial का जो downgoing pressure है, it will not continue like that, but we will have a slight increase in the pressure midway. So this we will label it as X descent, but midway there was a slight increase in the pressure. We will call it as C wave. C wave. Now what caused the C wave? Bulge of the tricuspid valve into the right atrium because of the right ventricular contraction. Which phase of cardiac cycle we are talking about? Isovolumetric contraction. Okay, but this right atrial bulge of the tricuspid valve will immediately revert back to its normal position, because after isovolumetric contraction, यहाँ पे जो pulmonic valve है, that will open and the blood will start moving from right ventricle to pulmonary artery. So there will be no more pressure exerted on the tricuspid valve. It will return back to its position and we will continue to have this descent. So this C wave splits the X descent into X and X dash descent or X1 and X2 descent. Okay. Now here if I ask you, where can I place the S1 sound in this waveform? पहले क्या हुआ? Right atrium was doing active filling or contraction, push the blood into the right ventricle. Now the right ventricular diastole is over. क्योंकि first we transferred the blood through passive filling, बाद में through active filling. Once the active filling is over, diastole is over. Right ventricle is going to get into systole. But before the systole, tricuspid valve should close. So right after the A wave, the tricuspid valves close. So this is where we have the sound S1. S1. Okay. Now, where is the pressure? Pressure in the right atrium is at very low. Pressure in the right atrium is low. Veins are filled with blood. So, of course, because of the pressure gradient, now the blood will start flowing into the right atrium. As the blood starts flowing into the right atrium starts getting filled. And because of the filling, the pressure inside the right atrium will start increasing. So, again, my graph will go upward. So this wave, I will call it as V wave. Now what is causing it? Blood filling into the right atrium. From where? From superior vena cava and inferior vena cava. I can call this as venous filling. Venous filling. Now the right atrium is filled with blood. It's ready to transfer this blood to right ventricle. Kab transfer karega? Of course, during diastole. So when the diastole starts? After the systole is over. So now I close the pulmonic valves after the ejection is over and then I start the diastole. So right here after the V wave, I will have the closure of pulmonic valve and what sound it is expected to produce? Closure of aortic and pulmonic valve produces S2. So one important JBP MCQ they ask is, which of the following is not a systolic sound, a systolic waveform? Okay. Is A wave happening inside the systole? No. Systole happens between S1 and S2. This is going to be my systole. So your X and X dash descent, C wave and V wave are systolic waveforms. A wave and whatever next wave that is going to come is going to be diastolic waveform. So now this pulmonic valve closed, we enter into the diastole. And what is the first phase of diastole? Isovolumetric relaxation. Our ventricles relax to lower the pressure. Once the pressure inside the ventricle is lower than the atria, the tricuspid valves open and the blood starts flowing from atria to ventricle merely because of pressure gradient. What we call this phase as? We will call it as passive filling. Now as the blood starts leaving the atria, what will happen to pressure inside the atria? See, we had reached this point in pressure, right? Quite high because the atria was filled with blood. Now the blood is leaving the atria. What will happen to the pressure? Pressure will start coming down. So my waveform will now start going downward. So I will call this waveform as the Y descent. Y descent. Okay. So now there are two waveforms which are happening in diastole. A wave and Y descent. X descent, C wave and V wave are happening in systole. So we'll just write down what are the reasons for these waveforms and then we will look at the abnormal waveforms. A wave is due to atrial contraction. When atria contracts during ventricular diastole. What we call this phase as? Which phase of cardiac cycle this A wave correlates with? It correlates with the active filling phase of cardiac cycle. It correlates with active filling phase of diastole. Easy to remember hai, A for atrial contraction, A for active filling. Simple. Now we have X and X dash descent. X and X dash descent. What is it correlating with? This is of course happening inside the systole as we know, and this is because of the atrial relaxation. The easiest way to remember this is give emphasis to the relaxation, X word, relaxation. So X descent is for atrial relaxation. Of course, this is happening inside the systole. Then we had a C wave. This X and X dash were separated by a small rise in the pressure called as C wave. What is it? What is responsible for it? The tricuspid bulge into the right atrium. So we will remember it for the C. C for the cusp bulge. C for cusp bulge. C for C. Easy way to remember. Cusp bulge. Now the question they will ask is which phase of cardiac cycle it correlates with. It is the isovolumetric contraction. जब right ventricle contract कर रहा था, it was exerting the pressure in all directions, and because of that the cusp bulged into the right atrium. जब pulmonic valve open हुआ and ejection started, the pressure decreased and cusp came back to its normal position. So it correlates with isovolumetric contraction phase. Isovolumetric contraction phase of the cardiac cycle. Okay. Now what are we left with? V wave and X descent. V wave easy to remember. हमने एट्रिया को रिलैक्स करके प्रेशर लो किया है, वेन से ब्लड एट्रिया में आएगा. सो V for venous filling. V wave is for venous filling. Again easy to remember. V for V. Venous filling of right atrium. Pretty easy to remember. V for V. The last one is Y descent. Y descent. So what Y descent represents? Y descent represents atrial emptying. When we started emptying the atria because of passive filling into the right ventricle, pressure decreased, and that's why we got a descent. So it indicates atrial emptying. While reading it, give emphasis to emptying. Why? That way you can remember it for Y descent. And which phase of cardiac cycle it represents? It represents the passive filling phase. Passive filling phase. So there are three important JVP waveforms which you can correlate with the cardiac cycle. The first one is the A wave, which is again diastole, that is active filling phase. Another is Y descent, again diastole, passive filling phase. In the systolic waveforms, it is only isovolumetric contraction phase we can clearly map to the C wave, right? So point to remember here, X descent, C wave and V wave are systolic waves, right? They are happening inside the systole. A wave and the Y descent, as we know, active filling, passive filling are phases of ventricular diastole. Okay, so this is normal waveform. Even if they give you a waveform, you should be able to identify the waveforms looking at this correlation with S1 and S2. Now the question is abnormal waveforms. First thing we will take up is the absent A waves. What is causing A wave? A wave is caused by atrial contraction. Atria contract nahi karega, to A waves absent होंगे, right? If atria doesn't contract, from where the pressure will increase and how will I get the A wave? So when atria doesn't contract, there's only one condition where atria doesn't contract, that where instead of contracting, it merely shakes, right? Vibrating atria without contraction. What we call the condition as atrial fibrillation. So A waves will be absent in atrial fibrillation. Absent A wave, you should always think of atrial fibrillation. Atrial fibrillation. Okay. In what condition the A wave can become taller than usual? Harshavat, no. In case of the stenosis, you will not have tall A waves. You will have when there is a tricuspid stenosis. Atrial fibrillation, you will have absent A waves, where I can have tall A waves. So as we already know, the right atrial pressure is what is represented as JVP. Now, if the tricuspid valve opening is narrow, when I transfer the blood from right atrium to right ventricle, do I need to put more effort or less effort? Of course, I need to put more effort. I need to squeeze in more. I need to build more pressure inside the right atrium to transfer the blood to right ventricle if the tricuspid valve opening is narrow. So in that case, right atrial pressure will increase, and when it increases, I will have taller A wave. So when A wave is tall, you can call it as tall A wave or giant A wave. You can use either term tall or giant A wave, typically seen in conditions like tricuspid stenosis. In what other condition I have to put more effort to push the blood into the right ventricle? If the right ventricle has concentric hypertrophy, means if the cavity of the right ventricle has become small and stiff, in that case I need to squeeze in more forcefully to push the blood into a small cavity. See, if I have to pour blood in a large vessel, it is easy. But if I have to forcefully push it into a small non-relaxing chamber, it is like I need to put more effort. So when I have concentric right ventricular hypertrophy, concentric right ventricular hypertrophy. Similarly, if I have pulmonary hypertension. Why pulmonary hypertension? If the pulmonary artery pressure is high, eventually I will have the right ventricular hypertrophy, and that will make it difficult for me to put the blood into the right ventricle. In these three conditions, we will have tall A or giant A wave. Then we come across another term called as Canon A waves. Now, what do I mean by Canon A waves? Canon A waves basically refers to tall A waves which appear intermittently, not continuously. If every A wave is tall, then we will simply call it as tall or giant A wave. But if 3 A waves are normal and fourth one is tall, again next 2, 3 are normal, and then next one is tall, we will call it as giant A wave. So the best way to remember giant A wave is the Canon A waves is to remember it as intermittent tall A waves, which are typically seen when there is AV dissociation. Seen in AV dissociation. Now, what do I mean by AV dissociation? Remember, when atria contracts, ventricle relaxes and receives the blood. When ventricle is contracting to eject, atria is relaxing. That is how the heart works, right? Thanks to the AV nodal delay, when atria contracts, ventricle will be in relaxed state. When ventricle is contracting, atria will be relaxing. But if I dissociate, and then if both contract simultaneously, then I will not be able to transfer the blood from atria to ventricle, because ventricle is also contracting, atria is also contracting. In such cases, the atrial pressure will increase very high. But of course, atria and ventricle cannot contract simultaneously in all the cycles. If that happens, we will not survive, because no blood comes from atria to ventricle. Ventricle can eject nothing, and of course, that is death. But there are conditions where intermittently atria and ventricle contract simultaneously, but otherwise atria is contracting first and then ventricle is contracting. In such cases, the tall A waves will appear intermittently, and such conditions we call it as AV dissociation. Can you give me examples for AV dissociation? When AV dissociation can happen? The simplest way to create AV dissociation is either increase the atrial rate more than ventricular or ventricular rate more than atrial. Then we will get AV dissociation. So if atrial rate is greater than ventricular, in what conditions I can have atrial rate greater than ventricle? Mainly AV blocks. That too, more particularly, we should remember the third degree or complete heart block. In that case, what happens? SA node sends the impulse for atrial depolarization, but AV node doesn't pass it on to the ventricle, and thus AV node or something else becomes the pacemaker. So ventricular rate will be lower than the atrial rate. In what conditions ventricular rate can be more than atrial rate? Simple, it is there in the name. In medicine, lot of things are there in the name itself. In what condition ventricular rate will be more than atrial rate? Ventricular tachycardia, ventricular fibrillation. Ventricular tachycardia and ventricular fibrillation. See, otherwise, atrial rate and ventricle rate has to be same. Only then, when atria contracts, ventricle will be relaxing. When ventricle contracts, atria will be relaxing. We can maintain this ratio when it is 1:1. If atria contracts faster, but ventricle is contracting at lesser rate, at least some contraction, atria and ventricle will be contracting simultaneously. That time I will get a tall A wave. Similarly, if ventricular rate is high and atrial rate is low, at least some contraction, ventricle and atria will be contracting simultaneously, and I will have a tall A wave. Such cases we will call it as Canon A wave. Among the waveforms, this is one of the commonly asked MCQ. Where do you get Canon A waves? What does it mean? Intermittent tall A waves, typically seen in AV dissociation. AV dissociation means either atrial rate should be more than ventricular or the vice versa. Okay. Next question they will ask you is, where do you get prominent X descent? Where do you get prominent Y descent? Okay. What do I mean by prominent X descent? Which one will be more prominent? Okay, let me draw two X descents. This one and this one. The first one, the taller one, appears to be more prominent, or the second one? Of course, the taller one, right? It's more prominent. We can also use the term steep. In simple words, whenever the A wave becomes taller, the X descent appears more steep, right? जितने ऊपर जाएगा उतना ही steeply नीचे आएगा, it will appear more prominent. So anything that causes tall A waves can cause prominent X descent. So the simplest way to remember prominent X descent is anything that causes tall A waves. Tall A waves. Okay. Now the question is prominent Y descent. Where do I get? Where do I get prominent Y descent? The Y descent becomes more steep. More steep. When it can become more steep? When the Y descent has to happen much quickly. Means in other words, steepness is nothing but the angle, right? At the peak, what is the angle? Lesser the angle, it appears more steep. So if I give sufficient time for the Y descent to happen, the angle will be more and it will not appear steep. But if I give less time for the Y descent to happen, the angle becomes less and it appears more steep. So when do I give less time for the Y descent to happen? Y descent represents which phase of cardiac cycle? It is representing the passive filling. Passive filling gets cut short in one important condition, which is constrictive pericarditis. In constrictive pericarditis, what happens? The pericardium has become stiff. So till the pericardial limit is reached, तब तक ही passive filling चल सकता है. Once the pericardium stretch limit is reached, passive filling stops. So once it stops, it is not continuing for few more fraction of time, and the passive filling time is cut short. So remember, your prominent Y descent, you get it in constrictive pericarditis. Constrictive pericarditis. This is a very, very important point which helps you to differentiate between constrictive pericarditis and cardiac tamponade. What I want you to remember is, in cardiac tamponade, passive filling की scope ही नहीं है, because इतना fluid है pericardium में, it is compressing the ventricle. Ventricle is completely compressed. I can't fill the blood into this ventricle passively. Only forcefully I can put into it. So only active filling happens in cardiac tamponade. There is no passive filling. If no passive filling, no Y descent, because Y descent is due to passive filling. So in case of the cardiac tamponade, the Y descent will be absent. Very, very important point, because last 3 years, every exam has this question between differentiating between constrictive pericarditis and cardiac tamponade based on present or absence of Y descent. In cardiac tamponade, Y descent is absent. Why is it absent? Because Y descent represents the passive filling, and in tamponade passive filling नहीं हो सकता है, सिर्फ active filling हो सकता है. That's why it is absent. Okay. Now next 2 points, I am not getting into the details. I just want you to remember where the C and V wave becomes fused. Means X dash descent will not be there. C से सीधा V, or the V becoming taller. I just want you to remember in what condition it is done. Let's not waste time in understanding the concept behind it. It is seen in tricuspid regurgitation. Tricuspid regurgitation. Tricuspid regurgitation. And I also want you to remember that this fused CV wave is also called as Lancisi sign. Lancisi sign. So these are the important JVP waveform MCQs you can expect. So from the JVP, we will move to the next segment of MCQs, which is valvular heart diseases. What kind of questions are asked? Mostly they will give you a clinical story, like, okay, here's a patient, he presented with these symptoms, and this is the examination finding. Basically, they will describe the murmur, where is it best heard, and then they will ask you to make a diagnosis, whether it is MS, AS, TS, TR. So we will concentrate on the approach instead of learning individual valvular heart diseases. So whenever someone presents with a valvular heart disease, what is the, if there is a question on valvular heart disease, how will I approach? First thing you have to see is whether the symptoms are suggestive of left heart disease or right heart disease. What symptoms are suggestive of left heart disease? What symptoms are suggestive of right heart disease? The first question we should ask ourselves in the question is it a right heart symptom or is it left heart. Which part is affected? Of course, see, remember that we know the cardiac anatomy basically. We know that our superior vena cava and inferior vena cava bring the blood to right atrium. From there it goes to right ventricle. From the right ventricle, pulmonary artery takes it to the lungs. From the lungs, the blood comes to the left atrium. From the left atrium to left ventricle, and from the left ventricle to aorta. This is basics we know. Remember, whenever right heart fails or something happens with the right heart, ultimately pressure inside the right atrium starts increasing. That gives rise to rise in the pressure in the superior vena cava and inferior vena cava. When I have problem in the left heart, it is the pressure in the left atrium that increases. That results in buildup of the pressure in the pulmonary veins, eventually causing the congestion in the lungs. So what symptom do I expect if I have a left heart disease? Congestion in the lungs, giving rise to dyspnea or shortness of breath. On the other hand, if I have right heart disease, the congestion will happen in superior vena cava, giving rise to rise in the JVP, and inferior vena cava, giving rise to congestion in the liver, because from the liver, the blood drains into inferior vena cava, right? So if the question says that patient is having raised JVP, hepatomegaly, ascites, and edema, it is mostly suggestive of right heart disease. And if the question says that this patient presented with dyspnea or orthopnea, orthopnea is shortness of breath on lying down, or paroxysmal nocturnal dyspnea, these are suggestive of left heart disease. So any MCQ, first thing we should see is whether this question is talking about left heart or right heart. If the symptoms are these, what does it indicate? The problem must be in the tricuspid valve or the pulmonic valve, whatever it is, pulmonic regurgitation, pulmonic stenosis, tricuspid regurgitation, or tricuspid stenosis. Clear? If the symptoms are dyspnea, orthopnea, PND, the problem must be in the left side of the heart, means either mitral stenosis, mitral regurgitation, or aortic stenosis, aortic regurgitation. This is first step. With this only, you would have already ruled out half of your options. Clear? And before going to the next step, let me also tell you that PND is the MCQ point. It is most specific. PND is the most specific left heart disease symptom. Okay. PND is the most specific left heart disease symptom. Okay. Once I have done that, half of my options are out. Now next, what will come to my help? Next thing that will come to my help is, generally after the symptoms, they will mention examination findings. And in the examination findings, classically they will mention the murmur, whether it is systolic or diastolic, and if it is systolic, whether it is early, mid, late, or pan, and same with diastolic. The third thing they will mention is from which area this murmur is better heard. And that's a very, very important part to concentrate in the question, because the area is directly telling you from which valve the sound is coming, right? So second thing we have to concentrate after this. So this is our step 1. This will help us to rule out some options. Step 2, area of murmur. And for this, we should be aware of which part of the chest represents which valve, right? So we'll just spend 2 minutes on it, and then we will come back to the approach. So we know that on the right side, right second intercostal space represents the aortic area. So if a question says that patient presented with dyspnea, orthopnea, PND, and I heard a murmur, whatever it is, I heard a murmur in the right second intercostal space, I know that it is coming from aortic valve. So now I have only 2 differential diagnoses, AS and AR. Everything else is out. As simple as that. So you don't need to know valvular heart disease in detail at all to get the questions right. Now, similarly, the left second intercostal space represents the left second intercostal space. This represents my pulmonic area. Pulmonic area. So if I get a patient where a murmur is heard in left second intercostal space, it must be coming from pulmonary valve. So either patient has PR or PS. You don't have to think of any other differential diagnosis. Okay. Similarly, the left third intercostal space. Left third intercostal space is an extra area. We will call it as Erb's area. This is an extra area for the aortic valve. This is also for the aortic valve. So aortic valve has two areas, the regular one, which is right second intercostal space, and an extra area in the left third intercostal space. Now the lower left sternal border, left lower sternal border, this area we will call it as tricuspid area. This is tricuspid area. So if the question says that patient had a murmur better heard in the left lower sternal region, it is telling you that the murmur is coming from tricuspid valve. Patient may be having TS or TR. Okay. Then medial to mid clavicular line in the fifth intercostal space. On the left side, fifth ICS, we have mitral area. So if the question says that there was a murmur heard at the apex, this is the usual apex of the heart. That is telling you that the patient has problem in the mitral valve. It may be MS or MR. Now one last area that I want you to remember is the left first intercostal space, which is called as Gibson's area. This area is for the murmur of PDA. Gibson's area is for PDA murmur. Of course, not important in medicine, but important in pediatrics. That is the second approach. So when you take these two steps, many questions without even knowing whether the patient is having systolic murmur or diastolic murmur, you might have reached the answer because you know that right versus left symptoms plus from which area the murmur is coming from. Only some cases you might have to know little more, like whether this particular condition is going to cause systolic murmur or diastolic murmur. So step 3 is now look at the nature of murmur, whether it is systolic, diastolic, or more details about the murmur, and with that you will reach the answer for sure. So what I have done is I have compiled a table where we will mention the summary of the murmurs. So if you can spend 10 minutes by hearting this, even if you don't know anything about the valvular heart disease, you will be able to reach the question. Okay. Simple thing you have to remember is when a valve opens in the cardiac cycle. Remember, in the cardiac cycle, we transfer the blood from atria to ventricles during diastole, and we eject the blood from ventricle to arteries during systole, right? So blood moves across the mitral valve normally during diastole. So if there is a stenosis here, the murmur will be produced and it will be a diastolic murmur. So MS and TS will be diastolic murmurs. Similarly, blood gets ejected from ventricles to the arteries during systole. So if the aortic valve is narrow, it will produce a murmur. So AS will be a systolic murmur. PS will be a systolic murmur. Clear? Now these valves are supposed to be closed, the mitral and tricuspid during systole, because we are ejecting the blood to the arteries. But if they are not closed, the blood will regurgitate back and it will produce a murmur. So this murmur of MR and TR is going to be systolic, right? Similarly, whatever I ejected out during systole from ventricles to aorta, to prevent it from flowing back, we close the aortic and pulmonic valves. But if the valves don't close, the blood will drop back during diastole. So my PR and AR murmurs are going to be diastolic murmur. We will just give you little more details of those murmurs, and also I'll give you the phonocardiographic image, because recent times there's a trend that they will give a murmur image and ask you to diagnose. AS and PS murmur is going to be same. What is the AS and PS murmur? It will be ejection systolic murmur. It will be an ejection systolic murmur. What do I mean by that? As we know, systole happens between S1 and S2. And systole, we have 3 phases of cardiac cycle. The first phase we will call it as isovolumetric contraction, where the ventricle contracts with all the valves closed. During this time, there is no flow of blood, there will be no murmur. But after isovolumetric contraction, the aortic and pulmonic valves open. Normally, opening of the valves does not produce any sound, but here the valves are abnormal. They are stiff. While opening, they may produce a sound, and the valves that open in systole, if they produce a sound, we call it as click. So now we are going to get here a click. We will call this click as the ejection click, because the click is beginning point of the ejection. After this, we eject the blood from ventricle to aorta in two phases. First one is rapid ejection. The second one is delayed ejection or slow ejection. During rapid ejection, the ejection of blood is with increasing velocity, so there will be more turbulence and the murmur goes on increasing in intensity. During delayed ejection, slow, so the murmur goes on decreasing. So it gives characterizing crescendo, decrescendo murmur. Same murmur in AS, same murmur in PS. Then the question is, how will I differentiate whether this patient with ejection systolic murmur with this phonocardiographic image is having AS or PS? Simple, right? We have learned the approach. पहले क्या देखना है? Symptoms. If I have PS, pulmonic stenosis, means I have a problem on the right side of the heart, right? So my symptoms will be raised JVP, hepatomegaly, ascites, edema. If I have aortic stenosis, it's a left-sided problem. My symptoms will be dyspnea, orthopnea, PND. It's as simple as that. Second, they will mention from which area this murmur is better heard. If they say that this ejection systolic murmur is heard in the right second intercostal space, then it is aortic stenosis. Ejection systolic murmur heard in the left second intercostal space, then it is pulmonic stenosis. Okay. So I want you to remember an extra point with respect to AS and PS, the MCQ point. What is the MCQ point? They will ask you what is the marker of severity of AS on the auscultation. It is the distance from the S1 to the peak of the murmur. More delayed is the peak, means more severe is the aortic stenosis. We have discussed this point earlier also when we spoke about the pulse, because the peak of the pulse gets late in aortic stenosis. So even the murmur peak will be late. So late peaking of the murmur is considered as the marker of severity of the AS. It indicates that we have severe aortic stenosis. Okay. Next, remember, if AS and PS, these murmurs are going to be systolic, then AR and PR murmurs will be diastolic. So they will be early diastolic murmurs. They will be early diastolic murmurs. So where diastole happens? Diastole happens between S2 and S1. Diastole happens between S2 and S1. So what are the phases of diastole? The first phase of diastole is isovolumetric relaxation. Followed by that, we have passive filling and active filling. So this AR and PR murmurs are early diastolic decrescendo murmurs. So they will only happen in isovolumetric relaxation phase. Do not continue beyond passive and active filling. So in fact, they have asked this question, which phase of cardiac cycle the AR murmur happens? It happens in isovolumetric regurgitation, isovolumetric relaxation. Okay. Now here, what is the marker of severity for the AR? Longer the duration of murmur, more severe is the AR. Longer duration of murmur, more severe is the AR. Longer duration indicates severe AR or PR. All these are MCQ points. I just want you to remember them. Of course, we will, those who are in the early phase of their FMG preparation and not giving this time, they will discuss in more detailed classes. Okay. Now coming to mitral stenosis and tricuspid stenosis. See, left side, we have mitral valve between left atrium, left ventricle. Right side, we have tricuspid valve between right atrium and right ventricle. Both valves open in same phase of cardiac cycle. They close at the same time, right? Okay. Now, when do I transfer the blood from the left atrium to left ventricle and right atrium to right ventricle? During ventricular systole or during ventricular diastole? Of course, during ventricular diastole. Systole में तो ventricle से भी eject the blood. So ventricles receive during diastole. And if this opening is narrow, it will disturb the flow, create the turbulence, and I will get the murmur. So MS and TS are going to be diastolic murmurs. What type of diastolic murmurs? They will be mid diastolic murmurs. Mid diastolic murmurs. Okay, so now as we know, diastole has three phases, right? I have diastole happening between S2 and S1. The first phase of diastole is isovolumetric relaxation. Next is passive filling and then is active filling. The typical murmur of MS and TS begins after isovolumetric relaxation, because during isovolumetric relaxation no valve is open, no blood is transferred. Valve opens after isovolumetric relaxation, and here the valves are stiff, so they may produce a sound. This sound we are going to call it as, what should we call it as? The valves that open in diastole, if they produce a sound, we will call it as snap. So we will call it as opening snap. And after that, the blood starts moving from left atrium to left ventricle. With the narrow mitral valve, it will start creating the turbulence. So I will start hearing the murmur in the passive filling phase. Now this murmur increases in intensity in active filling, because across this narrow valve, we are forcefully squeezing the blood during active filling. So turbulence increases, the murmur intensity increases. So this is classically a mid-diastolic murmur. It is not there in the early part. It is not there throughout the diastole. It is not pan-diastolic. It is not early diastolic. It is mid-diastolic murmur with increase in intensity in the active filling phase. Now what will be the marker of severity here? S2 opening snap gap. Smaller the gap, we will count it as more severe MS or TS. So please remember, smaller S2 opening snap gap indicates more severe MS or TS. It's a very important point, because we can trick you easily, right? Because in ASPS, late is the peak, more severe is the murmur. In the ARPR, longer the duration of the murmur, more severe is the condition. But here, shorter this gap is, more severe is the condition. So I want you to remember it. Smaller S2OS gap is suggestive of more severe MS or TS. Okay. Last but not the least, MR and TR. So if MS, TS are diastolic, MR, TR will be systolic. And MR and TR generally cause pan-systolic murmurs. They generally cause pan-systolic murmur. That means systole happens between S1 and S2. Irrespective of what all is happening inside the systole, the murmur will run throughout the systole. So we can have, whether it is isovolumetric contraction, rapid ejection, delayed ejection, the murmur will run throughout the systole. So we will call it as pan-systolic murmur. Clear? So in case of the MR or TR, we cannot use the murmur as a marker of severity, because it is running throughout the systole. There are no parameters that we can map here. So it is other things that we will use, like the regurgitant volume and all. No need to bother, right? So if you remember this, hopefully you will get one question right. Just to test our understanding, I'll give you a question so that we don't waste what we learned. We will put to test and then we will go forward. So here I have a patient with chest pain and dyspnea. On examination, a systolic murmur was heard. Systolic murmur was heard in right second intercostal space. What is the diagnosis? So options in front of us are A, pulmonic stenosis, B, aortic stenosis, C, aortic regurgitation, and D, tricuspid stenosis. So what do you think should be the answer here? Yes. So here the symptom is dyspnea, right? The question is not talking about raise in the JVP. So when you look at the option, I do agree that you can say sir chest pain to MI bhi ho sakta hai. In the examination, please do not overthink. Is there any option of MI here? No, right? So don't even think about it. Hoga. This patient may be having MI. Doesn't matter to me. I have to choose between the available options. All the options are talking about valvular heart disease. And I know that valvular heart diseases, I should look at left versus right. So here clearly patient is having dyspnea. I don't see any right symptoms. Raised JVP, hepatomegaly, edema, nothing is mentioned. So what options are ruled out from here now? Pulmonic stenosis is ruled out. Tricuspid stenosis is also ruled out, right? Because these are right-sided valvular diseases. Clearly, the question symptoms are left-sided. Next thing is, I can look at the area from where the murmur is best heard. Area is, of course, right second intercostal space. We know that it is aortic. So this can be either AS or AR. Here, instead of it, if I had mentioned, let us say MS, then I have already reached the diagnosis. I don't even need to know whether it is systolic or diastolic. I have reached the diagnosis. But in this case, I still have two differential diagnoses. Now to decide between AS and AR, I need to know whether AS causes systolic murmur or AR causes systolic murmur. So for that, you need to remember this table. So if you have by hearted this table, then you know the answer here has to be aortic stenosis. Because aortic stenosis, we will have systolic murmur. Aortic regurgitation, we will have diastolic murmur. So that is why the answer will be option B, AS. So the same question, they can complicate by giving you this phonocardiographic image. Instead of mentioning that this is a systolic murmur, they will give the image. So as long as you know this table, your valvular heart disease questions are generally sorted. Okay, so that was about valvular heart disease. So we have discussed three important topics: pulse abnormal waveforms, JVP important abnormal waveforms, valvular heart disease. We have learned the approach, right? From here, we will go to the next topic, which is abnormal heart sounds. You know S1 and S2, but beyond that, there are S3, S4 from which questions are usually asked. So now to get to that, I will give you a question. Try to answer this, and then I will give you the key points that you need to remember from the S3 and S4. What is the question? What is false about S3? S3 can be physiological, S3 can be pathological, S3 is a late diastolic sound, S3 is an early diastolic sound. Which one is the correct answer? Can S3 be physiological? Can S3 be physiological? Yogam, Kuturu, John, Mukesh Kamawat, right? That was a clear question on aortic stenosis. Okay, so normally we know that we have two major cardiac sounds, that is S1 and S. We know what produces S1, it is closure of mitral and tricuspid valve. What produces S2, it is the closure of the aortic and pulmonic valves, right? So when the valves close, they produce a sound. Opening of the valves does not produce a sound in physiological state, right? Okay, now when we transfer the blood from atria to ventricle, this flow, does it produce a sound? Closure produces a sound, we know, right? Opening does not produce a sound, we know. When blood moves from atria to ventricle, does that produce a sound? The answer is no. The flow of blood is usually streamlined. It does not produce a sound until and unless it becomes turbulent. When it will become turbulent? When we have stenosis, right? And mitral stenosis, tricuspid stenosis, it becomes turbulent and it causes murmur, which we discussed in the previous time. But in some conditions, the blood moving from atria to ventricle can produce a sound, and those sounds are S3 and S4. When can I produce S3? See, the transfer of blood from atria to ventricle happens in two phases. The first one is passive filling. After that, active filling. In the passive filling, when the blood comes and hits the wall of the ventricle, it can produce a sound provided the ventricle is large and dilated. See, just imagine, I take a bottle, pour the water in a small cup. It may not produce much sound, right? But if I take a bottle and pour it into a big vessel, when the water comes and hits that vessel, it will produce a reverberating sound inside that pot. Same happens with heart. So whenever left ventricle becomes dilated, large, entry of blood from atria to ventricle can produce a sound. We will call it as S3. So S3 is usually produced by S3, right? Point to remember about S3 is that S3 is produced by entry of blood from left atrium to large compliant left ventricle. Left ventricle has to be large and compliant. The main point is that left ventricle has to be dilated. Then we can have S3. When this is happening, when the blood comes from atria to ventricle for the first time in the diastole, when it comes during the passive filling, right? during passive filling. So S3 is a sound related to passive filling, not the active filling. So what can cause it? S3 can be caused by where the left ventricle becomes dilated cardiomyopathy or systolic heart failure, but it can be physiological. In what conditions it can be physiological? It can be physiological in athletes, children, and during pregnancy. In these conditions, it can be physiological. So S3 can be physiological. That is a true statement. Now the question is, should I call this S3 as early diastolic sound or late diastolic sound? So remember, of course, the transfer of blood from atrial to ventricle happens during diastole. So both of mine, S3 and S4, are going to be diastolic sound happening somewhere between S2 and S1. Okay. What is the first phase of diastole? Isovolumetric relaxation. Is there any transfer of blood during isovolumetric relaxation? No. The ventricle are relaxing with all the valves closed. After isovolumetric relaxation, there will be opening of mitral valve on the left side. On the right side, of course, tricuspid. After that, the passive filling starts. So in the early part of passive filling, so when my mitral valve opens and my left ventricle is abnormally dilated, thin, as soon as this valve opens and the blood comes and hits the ventricle, the sound that is produced reverberates and creates the S3. So S3 happens right after the opening of the mitral valve here in the early part of passive filling. This is my S3. So for producing S3, I need large compliant LV, right? For S3, I need large compliant LV. S4 is opposite. So now should I call this as a early diastolic sound or a late diastolic sound? If it is happening in the second half of the diastole, like after passive filling, maybe in the active filling phase, then I would have called it as late diastolic. So we should count this as a early diastolic sound. So with respect to S3, it can be physiological, like children, pregnancy, and athletes. It can be pathological in dilated cardiomyopathy. That is also true. It is a late diastolic sound. It is false. It is an early diastolic sound, which is true. S4 is late diastolic sound. Okay. Now we'll see where we can see S4. S4 is produced by, see, passive filling normally does not produce a sound, but if left ventricle is dilated, it can produce a sound. Active filling also normally does not produce a sound. But if my left ventricle is very stiff, it's not capable of receiving the blood, and I forcefully push the blood into the left ventricle, it can produce a sound. So to produce this active filling, to produce the sound, the left ventricle has to be small, compact, and stiff. When do we get that small, compact left ventricle? When left ventricle has developed concentric LVH. So it is the forced filling of small, stiff left ventricle during active filling. So what can cause it? It can be caused by concentric left ventricular hypertrophy. Now what do I mean by concentric? In concentric hypertrophy, muscle mass increases. Like let us say this is ventricle. I can increase the muscle thickness by adding more muscle outside. Then we will call it as eccentric hypertrophy. Thickness to increase hua, but muscle is more added outside. So we will call it as eccentric. Or instead, I can add more muscle inside. Ab bhi thickness increase hua, but inside increase hua. So now the cavity becomes small and stiff. So when I forcefully push the blood into it, it will produce sound. That sound is what we call as S4. So S4 can be produced in any condition where there is concentric left ventricular hypertrophy. And remember, the most common cause for concentric LVH is hypertension. Most common cause for concentric LVH is hypertension. So S4 is produced in the active filling phase when we are pushing the blood forcefully into a concentrically hypertrophied left ventricle. So S4 is produced by produced in stiff small LV. Of course, S3 is passive filling. It's a sound produced in passive filling. That's why it is early diastolic sound. And S4 is the sound produced in active filling. So it is a late diastolic sound. So somewhere here in the active filling phase, I will be hearing the S4. Clear? And the point to remember about S4 is always pathological. S4 is always pathological. So that's an important point you need to remember. S4 is always pathological. S3 can be physiological. S4 is always pathological. This is also a repeatedly tested MCQ point. Which of the following is true or false about S3, S4 kind of question? They often mention this. Now, two more added sounds we need to remember, which we have already discussed. The clicks and opening snaps. Normally, opening of the valve does not produce a sound. Closure produces S1, S2. Closure of mitral and tricuspid produces S1. Closure of aortic and pulmonic produces S2. Opening does not produce a sound, but if the valves are stiff or stenosed, while opening, they may produce a sound. Such sounds we will call it as clicks and opening snaps. Normally, the valves that open in diastole, if they produce a sound, we call it as snap. And the valves that open in systole, if they produce a sound, we call it as click. Which valve open in diastole, mitral and tricuspid? So if I have MS or TS, I can have opening snap. And if I have aortic stenosis or tricuspid stenosis, because these valves open in systole, they will produce a sound, we will call it as click. So this is about our added hard sounds, S3, S4, clicks and opening snaps. Clicks, you have to remember one more extra condition, which is mitral valve prolapse. Mitral valve prolapse also produces the click. Again, just writing it for your convenience, the clicks are systolic sounds. Snaps are diastolic sounds. That is why these are produced by the valves that open in diastole. Clicks are produced by valves that open in systole. Okay, so after that, we will go to the next important topic, which is heart failure. What MCQs are asked on heart failure? Mostly questions are asked on the pharmacology. Rarely only medicine. Whatever asked so far from medicine are usually simple and straightforward. Mostly what they will ask you is biomarkers of cardiac failure, classification of heart failure based on the ejection fraction. That's it. Rest of the questions are from the pharmacology. What are the drugs used? What are the side effects? Those. We will quickly revise the points. Okay, so we'll start with the definition of heart failure. What is heart failure? Heart has two functions, right? In other words, when we say heart failure, we are primarily talking about ventricle. Ventricle has two functions. One, contract to eject the blood during systole, and then relax to receive the blood during diastole. If I'm not able to relax, I cannot receive, and thus I cannot eject also. And if I'm not able to contract well, I will not be able to eject well, right? So whether I'm not able to relax or not able to contract, both are heart failure. So definition wise, it is the impaired left ventricular ejection, that is systole problem, or left ventricular filling, that is diastolic problem. Now, what can cause the heart failure? Obviously, long list, but we have to remember the MCQ point. The most common cause for impaired ejection, where ventricle is not able to contract well, we will call it as systolic heart failure. Systolic heart failure. What is the most common cause? When the muscle cannot contract well, when it is not getting sufficient blood supply, or the muscle is dead. So when muscle becomes dead, when it is infarcted, when it is not getting sufficient blood supply or infarcted, what we call it as ischemic heart disease, right? So the most common cause for systolic heart failure is ischemic heart disease. And what is the most common cause for diastolic heart failure? Most common cause for diastolic heart failure. Diastolic failure means it is not able to relax well, or it's not able to receive the blood well. Filling is not happening properly. When it will not be able to receive the blood well, when its cavity is small. Then if cavity is small, it can receive only small quantity of blood, it can eject only small quantity of blood. When cavity becomes small, when we have concentric LVH. And I have already told you what is the most common cause for concentric LVH. It is the hypertension. So the most common cause for diastolic heart failure is going to be hypertension. Hypertension is the most common cause for diastolic heart failure. Apart from that, myocarditis, cardiomyopathies, the list goes on, but these are the two important MCQ points we need to remember. Now, with what clinical features the patients of heart failure will present? Of course, if the right heart fails, what symptoms we are expecting? Left heart fails, what symptoms we are expecting? So if there is right heart failure, of course, the patient will present with raise in the JVP, ascites, and hepatomegaly. If the left heart fails, dyspnea, orthopnea, PND, right? Dyspnea, orthopnea, and PND. These are going to be the features of left heart failure. So when someone presents with these symptoms, and I have to make a diagnosis of heart failure, because the same symptoms we are seeing in valvular heart disease also, right? So how will I make a diagnosis of heart failure with these symptoms? Of course, with the help of laboratory investigation. And what is the important laboratory investigation? There is a biomarker for heart failure. So can anybody tell me what is the biomarker of heart failure? E. Chandran Patra, of course. HOCM, hypertension. Yes, see, for MI we have troponins, CKMB, ischemia modified albumin, and the list is long. But for failure of the heart, see, generally when ventricles are not able to contract or eject, the burden is on the atria. Atrial pressure increases and they release some signaling molecules to the kidney to tell them that lose a lot of water and reduce the burden on us. So signaling molecules are natriuretic peptides. So we use them as the biomarkers. And most importantly, the B-type natriuretic peptide or BNP, or precursor called as N-terminal proBNP. So we make a diagnosis of heart failure in patients with signs or symptoms of heart failure, which we just discussed, plus increased BNP or N-terminal proBNP, which is nothing but a precursor of BNP. So any patient with these symptoms with elevated BNP or proBNP, we make a diagnosis of heart failure. Now these patients of heart failure, traditionally we can classify them as systolic heart failure or diastolic heart failure based on which is affected. But how will I know? When someone presented with these symptoms, I cannot just know that it is ejection problem or filling problem. I will rely on the echocardiography, and in echocardiography there is one tool which will help you to differentiate between systolic and diastolic, and that tool is ejection fraction. So based on the ejection fraction, we classify the heart failure. We will classify the heart failure into three broad groups, as heart failure with reduced ejection fraction, heart failure with the preserved ejection fraction, and heart failure with mid-range ejection fraction. Heart failure with mid-range, heart failure with preserved EF. Now when I say reduced EF, what does that mean? Ejection fraction depends on the force of contraction of the ventricle. More is the force of contraction, more is the ejection fraction. So whenever force of contraction comes down, ejection fraction comes down, it indirectly means that if there is ejection fraction which is low, it is systolic heart failure. The normal ejection fraction is 60 to 70%. When it is less than 40%, we will call it as heart failure with reduced ejection fraction, and it indicates systolic heart failure. It indicates systolic heart failure. So any patient who presented with heart failure symptoms, you got a proBNP done, it is high. Now you know it is heart failure. You get an echo done and the ejection fraction is 30%. Now you know that it is systolic heart failure. And then what disease should come to your mind? The most common cause for systolic heart failure is ischemic heart disease. Second most common is dilated cardiomyopathy. And if the ejection fraction is close to normal, normally 60 to 70%, if it is close, means more than 50%. If it is more than 50%, then we will call it as heart failure with preserved, it's not lost much. Then it is indicating diastolic heart failure. And anything in between, that is 40 to 50%, right? EF 40 to 50% in between, we will call that as heart failure with mid-range ejection fraction, which is undecisive, means we cannot decide whether this patient is having systolic heart failure or diastolic heart failure. But less than 40, Reduced heart failure or systolic, more than 50, it is preserved ejection fraction or diastolic heart. Now, once you recognize heart failure, of course, you have to recognize the underlying cause and treat. If it is ischemic heart disease, do angioplasty and open the blocked blood vessels, or if required, do CABG. If it is hypertension, control the hypertension. But apart from that, the heart failure also has to be treated. So the question they will ask you is, what are the drugs that you are going to use for the treatment of heart failure? So I'll just take 2 minutes, quickly brief you about the pathophysiology that happens when heart fails, so that we will remember the pharmacology better, because pharmacology questions are frequently asked in heart failure. Okay, so what is the pathophysiology of heart failure? Normally when heart fails, two things happen. First thing that happens is, of course, heart is either not able to fill well or it is not able to eject well. So when the filling is impaired or the ejection is impaired, end result is, of course, there will be decrease in the stroke volume. Why there will be decrease in the stroke volume? See, if I'm not able to contract well, systolic heart, anyway, I'm not able to eject. Even if I have sufficient blood with me, I cannot contract and eject. Systolic problem. If I have diastolic heart failure, even if I can contract well, I'm not able to relax, I'm not able to receive, my filling is less. So if I am getting less, I can only give less to the aorta. I can't give more than what I have received. I am not a bone marrow to synthesize extra blood. Whatever I have received only I can eject. So both cases the stroke volume will be reduced. So whenever we have heart failure, there will be decrease in the stroke volume. Heart failure leads to decreased stroke volume, or in other words, we can say decrease in the cardiac output, because what is cardiac output? Cardiac output is nothing but heart rate into stroke volume. So there is decrease in the cardiac output. And please remember, our systolic BP is directly proportionate to stroke volume. Remember that I have already told you that systolic BP is directly proportionate to stroke volume. So if stroke volume decreases, systolic BP decreases, right? So don't you think body will not keep quiet if the systolic BP is decreasing? There will be decrease in the BP. And to correct that, two important systems get activated. What are those? The sympathetic nervous system and RAS. Sympathetic nervous system will have adrenaline, which will cause vasoconstriction. And by vasoconstriction, we can increase the BP. Good for the BP, but not good for the heart. Because when we constrict the blood vessels, ventricle has to now generate more force to eject the blood into constricted vessels. So ventricle's work increases. So this work we call it as afterload. So there will be increase in the afterload. And for a failed heart, any increase in the workload is more harmful. Okay. Second, in the RAS, we have two components, as we know. One is angiotensin 2, the other one is aldosterone. Aldosterone and angiotensin 2. What angiotensin 2 will do? This will also cause vasoconstriction, and that will increase the afterload. What aldosterone will do? Aldosterone will increase sodium and water reabsorption. Sodium and water reabsorption at kidneys, and because of that, they will increase the blood volume. Increase the blood volume means more blood comes to heart. Heart needs to now eject more blood. So heart's work again increases. We will call it as increase in the preload. Amount of blood coming to the heart is increased. So any load increase on the heart is harmful to a failed heart. So both this increase in the preload and afterload are harmful to heart. So now, if I have a patient with heart failure, what should I do with RAS and sympathetic nervous system? These are harmful. They may be helping you to get a little better BP, but they are harming the heart by increasing the workload. Now think about it. Ischemic heart disease. Heart is not getting sufficient blood supply. Now you ask it to do more work. Now its demand of oxygen increases and it fails more. Right? So these need to be blocked. So that's why we use beta blockers to block the adrenaline, and AC inhibitors or ARBs to block angiotensin 2 activity, and spironolactone to block the aldosterone activity. Okay. Similarly, there is one more axis which gets activated, which is nothing but natriuretic peptides. Natriuretic peptides. That is ANP, BNP. Atrial natriuretic peptide and B-type natriuretic peptides. And what they do exactly opposite of what aldosterone does. They go to kidney and they increase sodium and water excretion. Increase sodium and water excretion by kidney. And they have a tendency to also cause vasodilatation. Vasodilatation. So by doing so, they decrease the preload and they decrease afterload. And by doing so, they are helpful, right? Because reducing the burden on a failing heart will help the heart. So these both changes are beneficial to heart. Beneficial to heart. So when it comes to management, I should be blocking the sympathetic nervous system and RAS, and I should be supporting the natriuretic peptides. So for management, what all drugs we are using? We need to give AC inhibitors or ARBs, and these are traditionally considered as the drug of choice because I'm blocking the RAS, which is a harmful adaptation that is happening. Plus, I should be giving the beta blockers to block the sympathetic nervous system, right? Beta blockers. Plus, what else I can use for a patient with heart failure? I can use spironolactone to block the aldosterone. What is spironolactone? It is the aldosterone receptor antagonist. Plus, in the recent times, an anti-diabetic medicine called as SGLT2 inhibitors like canagliflozin, dapagliflozin, they have shown the reduction in the mortality in patients with heart failure by decreasing the BP, increasing the weight loss. They are beneficial. So these are the standard treatment. Now, if the patient is not responding to them or if it is reduced ejection fraction, I have one more option. I can increase the activity of natriuretic peptides. How I can increase the activity of natriuretic peptides? These natriuretic peptides, once produced, they get inactivated. They get inactivated by an enzyme called as neprilysin. So if I block this neprilysin, my ANP, BNP activity will increase and that will benefit my heart. So I can also consider neprilysin inhibitor, but it is not recommended for heart failure with preserved ejection fraction. If it is heart failure with reduced ejection fraction, that is systolic heart failure, right, we can add neprilysin inhibitor over and above medications. Example for a neprilysin inhibitor is sacubitril. Sacubitril is a neprilysin inhibitor. Please remember, it comes in combination with one more drug. Can anybody tell me which drug it comes in prefixed combination? ARNI. Yes, you can also call it as angiotensin receptor neprilysin inhibitor when it is combined. Comes in combination with valsartan. And this combination we call it as ARNI, where it is the valsartan which is an angiotensin receptor inhibitor and sacubitril is the neprilysin inhibitor. But of course, you can use it only for heart failure with reduced EF patients. For the preserved EF patient, just stick to the standard medications. No need to use the sacubitril. At least as of now, guidelines do not recommend. Okay. Now the point to note here is all these medications, whatever we have listed from here till here, they decrease cardiovascular mortality. They decrease the cardiovascular mortality. Now there's one more point to remember. Very often we think of giving digoxin to patients with heart failure. In pharmacology, they may teach you. But in medicine, we stay away from giving digoxin because digoxin improves the symptoms but kills the patient. That's a statement you have to remember. When you give digoxin, what is digoxin? It is a cardiac inotrope. It increases the force of contraction of the ventricle. So a failed heart is now able to contract. So your symptoms are getting better because your stroke volume is improving. Patient will not feel dyspnea, fatigue and all. But you are pushing the ventricle to do more work. And we know that whenever we push the ventricle to do more work, when it is already failing, it does more harm than good. So whenever you give digoxin to someone, they feel better but die early. That is the basic rule. So that is why whenever they ask which drug is associated with increased mortality, you should remember digoxin. Digoxin is associated with improved heart failure symptoms but increased mortality. This is a question that they have repeatedly asked from pharmacology. Which of the following drug does not decrease the cardiovascular mortality? It is the digoxin or any other inotropes, not just the digoxin. In pharmacology, whatever other inotropes names you come across, all of them are associated with increased mortality, like milrinone and all. So you should remember that. Okay, so that's about the heart failure. To give you a quick summary, what is heart failure? Impaired filling or impaired ejection. Classification is based on EF, less than 40, reduced, more than 50, preserved, in between is mid-range. Symptoms, right heart failure symptoms, left heart failure symptoms. Diagnosis, the investigation of choice for diagnosis is the BNP or pro-BNP. Very important point. The marker or the investigation of choice is BNP or pro-BNP. What is the role of echo? Role of echo is for classification into reduced EF and preserved EF. Once diagnosed, how do we manage? If it is heart failure with reduced ejection fraction, ARNI, beta blockers, spironolactone, and SGLT2 inhibitors. If it is heart failure with preserved ejection fraction, no role for the neprilysin inhibitors. So you stick to AC inhibitors, ARBs, or beta blockers, and the SGLT2 inhibitors and spironolactone. Right? That's about our heart failure. Next important topic from the cardiology is differentiating between two important entities, constrictive pericarditis and the cardiac tamponade. So that is where we will focus. First, we will understand what is constrictive pericarditis. Constrictive pericarditis is not a condition where the pericardium is constricting the heart. That is a misnomer. The term constrictive pericarditis is wrongly coined. Ideally, it should have been restrictive pericarditis, because what happens is when the pericardium becomes inflamed, right, it gets scarred. Especially when it is repeatedly inflamed, it gets scarred, and scarring makes the tissue become stiff. Right, you might have seen someone with burns, their skin becomes shrunken and stiff. It is stiff, they can't stretch that skin. Right, normal skin stretches better. Same is happening to the pericardium. So normally what happens, we have two layers of the pericardium, one adherent to the myocardium called as visceral pericardium, and one which is slightly separated from it called as parietal. In between that there is a little space, and we have small quantity less than 10 ml fluid called as pericardial fluid. And in constrictive pericarditis, what happens? This pericardium become, in normal condition, when we fill the blood into the ventricles of course expand. During diastole, ventricles expand. Does pericardium restrict its expansion? Of course not, because pericardium is highly elastic. It allows the ventricle to expand as much as it wants. Jitna chahe phail jao, phail jao. But in constrictive pericarditis, what happens? The pericardium becomes stiff. So it only allows little bit of expansion, not beyond that. So does that mean there is no filling of the ventricle happening? No, ventricle gets filled till the limit of pericardium is reached, right? Once the limit is reached, ventricle cannot be easily filled. So in other words, I would say the diastolic filling is reduced. Now when the diastolic filling gets reduced, which side of the heart gets affected more? Is it left or right? Remember, the left atrium is relatively more stronger and muscular in comparison to right. So somehow left atrium will be able to fill better than right. So it is right ventricle which gets affected more by this impaired filling. Okay. So let us write it down. What is constrictive pericarditis? Constrictive pericarditis is basically a condition where there is recurrent or chronic pericarditis or pericardial inflammation. Pericardial inflammation results in scarring and stiffening of the pericardium. Stiffening of pericardium. What that will lead to? This will result in impaired ventricular filling, because once the pericardium is stiff, it cannot expand as much as the ventricle wants. So it restricts the ventricular filling. That's why I said, like, if I was the person who was giving the name, I would have called it as restrictive pericarditis, restricting the ventricular filling. It is not squeezing it in. Okay. Which ventricle gets affected more? Right ventricle gets affected more than the left ventricle. So what symptoms these patients are going to come with? Right heart symptoms. What are those? Raised JVP, hepatomegaly, PND. Then the question is, how will I differentiate between right heart failure, right-sided valvular heart disease and the constrictive pericarditis, of course, with the help of examination and investigation. Will I get a murmur in constrictive pericarditis? No. If I had TS, PS, I would have got a murmur, right? Now, what can cause this? I have forgot to mention, when I say impaired ventricular filling, it's primarily affecting the passive filling. The passive filling becomes cut short. Ventricle starts expanding, reaches the pericardial limit, it cannot expand anymore, passive filling is stopped. Now, forcefully, I can push the blood during active filling, but passive filling is shortened. So, you have to always remember, in constrictive pericarditis, there is shortening of passive filling. Shortening of passive filling. So what can cause it? There are two causes we should remember. The most common cause worldwide. See, one time inflammation of the pericardium will not cause severe scarring. It has to be either chronic or recurrent. So for worldwide, it is the recurrent acute pericarditis. So if a British comes here with the constrictive pericarditis, it's mostly because of recurrent acute pericarditis. Every time acute pericarditis happens, some amount of scarring happens. Over time, the pericardium becomes severely scarred. Recurrent acute pericarditis. But the most common cause in India and developing nations like African nations is going to be tuberculosis. So TB or tuberculosis is the most common cause in India and developing nations. But if you look at whole world, it is the recurrent acute pericarditis, where you can have recurrent or chronic inflammation. Okay. So what clinical features these patients are going to present with? The clinical features are going to be that of right heart symptoms, because it is affecting right ventricle more than left, that is raised JVP, hepatomegaly and ascites. Now another differential diagnosis here is going to be cardiac tamponade. Cardiac tamponade. Now what is cardiac tamponade? Can I say too much of pericardial fluid is cardiac tamponade? No. If there is too much of pericardial fluid, I will call it as pericardial effusion. If it is too much, I will call it as massive pericardial effusion. When do you call it as tamponade? So please remember, like if I start filling fluid into this pericardial space, then it is pericardial effusion. If it becomes too much, then it is massive pericardial effusion. As the fluid starts accumulating in the pericardium, the fluid will start exerting pressure on the ventricles. Under the pressure, when ventricles collapse, then we will call it as cardiac tamponade. So when this fluid accumulation leads to collapse of the ventricles, then we will call it as cardiac tamponade. Which ventricle is likely to collapse early? Of course, right ventricle, because right ventricle is relatively less muscular. So under the fluid pressure, right ventricle, once it collapses, then we will call it as cardiac tamponade. So when right ventricle is in a collapsed state, then we will call it as cardiac tamponade. So when ventricle is collapsed, is it easy for me to do a passive filling into this ventricle? When do I do passive filling? When the ventricular pressure is lower than the atrial pressure. So here I have right atrium. Right atrial pressure should be much higher than the ventricular pressure. But a collapsed ventricle's pressure will be high. Why? Because pressure and volume are inversely related. So when ventricle collapses, its volume is very minimal. Pressure inside it will be very high. So in cardiac tamponade, passive filling is not possible. Anything that we do has to happen by forcefully pushing the blood into this collapsed ventricle. Only active filling happens, right? So that is the main difference between the constrictive pericarditis and cardiac tamponade. In constrictive pericarditis, passive filling is happening, but there is a shortening of the duration of passive filling. Here, no passive filling. That's the point. So what is cardiac tamponade? Massive pericardial effusion. Massive pericardial effusion. Too much fluid resulting in right ventricular collapse, resulting in absent passive filling. What is the waveform on the JVP for the passive filling? Recall and tell me. And second, if right ventricle, if there is absent passive filling, we are we are dependent on only active filling. In such cases, obviously, the right ventricular filling is reduced, right ventricular ejection will be reduced, and if the right ventricular ejection is reduced, patient's BP will be reduced. We'll call it as hemodynamic compromise or hypotension. So when effusion leads to hemodynamic compromise, that is the time I can say that this patient has got cardiac tamponade. The patient is stable, it's not tamponade anymore, and you know that there is something called as Bacterial and hypotension is required. Okay. Now, what is the most common cause for cardiac tamponade? The most common cause for cardiac tamponade is going to be trauma. Right? What trauma will cause? Trauma will generally lead to hemopericardium, because there must be at least 600 ml of fluid or more to cause cardiac tamponade. In fact, most patients is like 1 liter, 1.5 liter. So effusion doesn't come so easily, but if I rupture some blood vessel, it can bleed heavily and I can have the cardiac tamponade. So most of the patients of cardiac tamponade are seen after road traffic accident, or sometimes it is iatrogenic. When you do some thoracic surgery, you may induce the hemopericardium resulting in cardiac tamponade. Questions what they ask, because again, which chamber is getting collapsed here? Right ventricle. Which chamber is getting affected in the constrictive pericarditis? Right. So symptom wise, it is going to be same, raised JVP and ascites pedal edema. So how do I differentiate? There are a few points. We will go through that in a table, but before that, one more important thing, that is Beck's triad, right? So what do we get here? We get hypotension. Why am I getting hypotension in the constrictive in the cardiac tamponade? Because right ventricular filling is less. So amount of blood I eject into the pulmonary artery going to lungs is less. So amount of blood coming to left atrium is less. Amount of blood coming to left ventricle is less. Amount of blood ejected by left ventricle is less. So that is stroke volume is less. When stroke volume is less, what happened to BP? Stroke volume and BP are directly proportionate. So BP will be low. So hypotension is because less filling of the right leads to less filling of the left. Plus raise in the JVP because right ventricle is collapsed. So right atrium has to raise its pressure to fill this, raise in the JVP. And now if I place a stethoscope here and auscultate the sounds, obviously sounds will not be very clear because fluid is not a good conductor of sound. Whatever sound is produced by closure of valves will be muffled or diffused here, and you will hear it as faint, feeble. So you will have muffled heart sounds. Muffled heart sounds. These three things collectively we will call it as Beck's triad. Beck's triad. Okay. Now, how do I differentiate between cardiac tamponade and constrictive pericarditis? Few points which will help us. The first point we have to remember is JVP. Both the cases JVP will be raised because ventricular filling is reduced, so atrial pressure will be increased. But when we look at the waveforms, changes are there. In the cardiac tamponade, there is no passive filling, and the waveform for passive filling is the Y descent. So if no passive filling, no Y descent. So Y descent will be absent in the cardiac tamponade. Y descent is absent in the cardiac tamponade. While in the constrictive pericarditis, Y descent will be present. There are few points. Here what happens is Y descent is present, but not just that. Both become prominent. They become prominent. Why X descent becomes prominent? Because I have already told you, whenever A wave becomes taller, X descent becomes steep, and of course, when it is steep, it will become prominently visible. Why Y descent is prominent? Because the passive filling is cut short. Remember, we had a wave because of atrial contraction, C wave because of the tricuspid valve, otherwise X descent, V wave because of the venous filling, and then Y descent. Okay. Now, if I increase the height of the A wave, the X descent appears more steep. It becomes prominent. So I can see that prominent X descent in JVP as in cardiac tamponade as well as constrictive pericarditis. Simple rule is whenever A wave is tall, you can have prominent X descent. But here in the cardiac tamponade, no passive filling, so no Y descent, right? So directly from V wave, we go to A wave. But in case of the constrictive pericarditis, the duration available for the passive filling is cut short. So because of that, the Y descent becomes more steep, and whenever it is more steep, it becomes more prominent. So I will have a prominent X and Y descent. And the prominent X descent that we see in patients of constrictive pericarditis, We have given a name for it, prominent X descent in chronic constrictive pericarditis. It is called as Frederick's sign. Frederick's sign. Prominent X descent of constrictive pericarditis is called as Frederick's sign. Okay. Next, we were talking about pulsus paradoxus. What is pulsus paradoxus? More than 10 millimeters of mercury, inspiratory decrease in the BP. Normally, systolic BP drops up to 10 millimeters mercury during inspiration. But if it is more than 10 millimeters mercury, we will call it as pulsus paradoxus. In the constrictive pericarditis, it is absent. But in cardiac tamponade, it is present. Okay, that is the point I wanted you to remember. Okay. Then you have Kussmaul sign. Kussmaul sign is the JVP version of the pulsus paradoxus. So what is Kussmaul sign? During inspiration, what happens to JVP? During inspiration, JVP decreases. Why it decreases? Because during inspiration, intrathoracic pressure is becoming negative. So blood from the jugular veins gets sucked into the heart. So JVP decreases during inspiration. That is normal. Failure of the JVP to decrease during inspiration, we call it as Kussmaul sign. So JVP fails to decrease during the inspiration in constrictive pericarditis, but it does decrease in the cardiac tamponade. So Kussmaul sign is rare in the cardiac tamponade. Okay. What else can help? Some characteristic features. What is that? In the constrictive pericarditis, because pericardium is chronically inflamed, it becomes calcified, so that it may be visible on the chest X-ray in constrictive pericarditis. In cardiac tamponade, echocardiography will show massive effusion and collapsed right ventricle. Okay. What else helps us? The auscultation findings. What auscultation findings? In the constrictive pericarditis, as the left ventricle is expanding during the passive filling, but passive filling is abruptly stopped by reaching the pericardial limit. So this ventricle which was expanding suddenly starts vibrating because we have stopped it. We have put a brake. That vibration we can hear, we call it as pericardial knock. Pericardial knock. On the other hand, in the cardiac tamponade, we have what is called as muffled heart sounds. Heart sounds are not heard clearly. That is one more point that will help us to differentiate between cardiac tamponade and constrictive pericarditis. So hopefully now you will be able to differentiate between the two conditions. Both patients will present with same symptoms: raised JVP, hepatomegaly, ascites, hypotension. But if I mention there is muffled heart sound, you will take it as tamponade. If I mention that there is a pericardial knock, you will take it as constrictive pericarditis. If I mention that the Y descent is prominent, you will take it as constrictive pericarditis. If I mention that Y descent is absent, you will take it as cardiac tamponade. Last 3 years, every exam has a question on this table. So whatever we are discussing today, I personally consider that this table is the single most important table that we are discussing. Okay. So that's about the constrictive pericarditis and cardiac tamponade. Next up, what we have is acute rheumatic fever. Another important topic. Mostly what questions are asked? Major, minor criteria. You should know what are considered as major criteria, what are considered as minor criteria, right? So what is acute rheumatic fever? Is it an infectious disease? No. Acute rheumatic fever is an autoimmune disorder, right? It's a infection triggered autoimmune disorder. It's basically an autoimmune disorder. Infection is merely a trigger. So if that is the case, what questions they will ask you? Which infection is responsible, right? So which infection is responsible for the acute rheumatic fever? Group B, beta hemolytic streptococci, right? Usually causing pharyngitis or sometimes skin infection. So most commonly caused by group A, beta hemolytic streptococci. Group A, beta hemolytic streptococci, you can simply call it as gas pharyngitis. Usually gas pharyngitis. Gas stands for group A, beta hemolytic streptococci. Okay. Now, which gender is more likely to be affected? Simple. Autoimmune disorder, which gender is more likely at risk? It is the females, right? Females are more affected than the males. Okay, clear? Now, what clinical features these patients are going to present, right? Is it one system disorder, acute rheumatic fever? Ambika Sharma, I didn't get your question. You are referring to the pulsus paradoxus, right? In constrictive pericarditis, it is usually absent. Why is it absent? See, why the inspiratory BP drops? See, basically what happens is when I transfer the blood from right atrium to right ventricle, right? During inspiration, what happens? The intrathoracic pressure decreases. So because of that, all the blood from superior vena cava, inferior vena cava gets sucked into the right atrium. So jugular venous pressure decreases, right? Similarly, more blood is now coming to the right side of the heart. So now right ventricle, what it does, it pushes the interventricular septum into the left side. So left ventricle becomes smaller. So left ventricular filling decreases in inspiration. So left ventricular output also decreases. So stroke volume from the left side decreases. So that's why systolic BP decreases. This is normal. Clear? But if right atrial pressure is already high, then during inspiration it cannot take more blood because its pressure is already high. Like in constrictive pericarditis, I'm not able to fill the right ventricle well because pericardium is limiting how much I can fill. So that's why right atrial pressure is already high. It cannot receive more blood. If it cannot receive more blood, then right side flow during inspiration will not increase. Interventricular septum will not be pushed into the left ventricle, right? Will not be pushed into the left ventricle. So I will not be able to get that inspiratory drop in the JVP. Inspiratory drop in the JVP. So in cardiac tamponade, for some unknown reason, despite having increased right atrial pressure, it is still able to take more blood during the inspiration. Because it is able to take more blood during the inspiration, the JVP does drop and I don't see Kussmaul sign, and I will end up seeing pulsus paradoxus where more than 10 millimeters mercury drop will happen. But in the constrictive pericarditis, because right atrium cannot take more blood, right? Because it is not able to take more blood, JVP will not decrease. JVP will not decrease, and the pulsus paradoxus will not happen. When the pulsus paradoxus will happen? When we are able to take the extra blood during inspiration to the right side. If I'm not able to take, I may not get the pulsus paradoxus. Okay, so coming back to the rheumatic fever, of course, we are talking about autoimmune disorder. It is more common in females. And what age group? Of course, young and middle-aged females who are prone for autoimmune disorders. Now, what clinical features the patient will come with? So please remember, it is the multi-system disorder. It is not a cardiac disorder. It's a multi-system disorders affect multiple systems. So they will ask, what is the most common system affected by the acute rheumatic fever? The most common system affected is the musculoskeletal system. Musculoskeletal system is the most common system. It is not the heart. So what it does to musculoskeletal system? It causes arthritis. So most common symptom of acute rheumatic fever is arthritis. So basically it is an autoimmune disorder where you get a pharyngitis. Body produces antibodies against the group A beta hemolytic streptococci. Those antibodies, because of molecular mimicry, start damaging your own tissues apart from damaging the bacteria. And which tissue they target the most? Joints. That's why arthritis is the most common symptom. Now what kind of arthritis we get? Because arthritis can be polyarthritis, monoarthritis, oligoarthritis. So here it is usually polyarthritis. Again, the question is, if it is polyarthritis, there are different types of polyarthritis, means where simultaneous onset polyarthritis, where multiple joints get affected simultaneously, or you can have sequential, where one joint gets affected, then the next, then the next. So like it can also be called as additive polyarthritis. New and new joints get added to the list of joints affected. And then you have migratory polyarthritis, where one joint get affected. By the time next joint is affected, the first joint is already recovered. That we call as migratory polyarthritis. So here it is typically migratory polyarthritis. It's usually migratory polyarthritis. So when these patients come, at that point of time, you may have evidence of only one joint being affected because the other joints he would have already recovered from. Okay. Then what other systems can get affected? Heart. So when CVS gets affected, acute rheumatic fever, Shubham, right. Acute rheumatic fever affects all the layers of the heart. Means heart has pericardium, myocardium, endocardium, it affects all, plus valves. So in CVS, it causes valvulitis, then pericarditis, myocarditis, and endocarditis. It causes involvement of all the layers of the heart. When it affects the valves, which valves are most commonly affected is the question that they ask. So please remember, it is the mitral valve which is most commonly affected, followed by aortic. And what it causes to mitral valve? It causes MR. So it causes mitral regurgitation, more common than the aortic regurgitation. So if they ask an MCQ, what is the most common valvular manifestation of acute rheumatic fever? The answer is mitral regurgitation. Mitral regurgitation. Okay. Then pericarditis will of course cause chest pain. Myocarditis can cause heart failure because your myocardium is inflamed and it may not be able to contract well because it is inflamed, and reduced contraction means heart failure, right? We can also have endocarditis. So collectively we can call this as pancarditis. Pancarditis. All the components of the heart are affected, so we'll call it as pancarditis. Okay. Can the rheumatic fever affect CNS? Yes, it affects CNS. Primarily in the CNS, it affects basal ganglia. It affects basal ganglia. So we can call it as basal gangliitis. In the basal ganglia, particularly it affects a lobe called as caudate nucleus. It affects caudate nucleus. And because of the involvement of caudate nucleus, we get an involuntary movement called as Sydenham's chorea. Sydenham's chorea. Sydenham's chorea. Okay. Yes, endocarditis will lead to vegetations on the valve leaflets on one of the sides. Okay. What else it can affect? It can affect skin. In the skin, it causes two lesions. What are those lesions? Erythema. What are the cutaneous manifestations of the acute rheumatic fever? It causes erythema marginatum and subcutaneous nodules. Subcutaneous nodules. These are the cutaneous manifestations of the acute rheumatic fever. What is the biggest fear when someone has rheumatic fever? It is not the involvement of joints. It's not even the involvement of CNS. Sydenham's chorea, they will recover. What is my biggest fear? Involvement of valves. Because when valves get involved, we will have valvulitis. Valves become inflamed and they may not be able to shut well, giving rise to regurgitation. But if rheumatic fever happens repeated inflammation of the valves lead to scarring. Scarring leads to valve becoming stiff and it can lead to mitral stenosis. Recurrent rheumatic fever leads to mitral stenosis. And once recurrent rheumatic fever leads to MS, we will call it as rheumatic heart disease. Rheumatic fever is different from rheumatic heart disease, right? So remember, what is RHD? RHD refers to recurrent rheumatic fever resulting in mitral stenosis. Then we will call it as rheumatic heart disease. Till that time, whenever infection triggers involvement of heart, we will call it as rheumatic fever. Clear? Okay. Now for diagnosis of the rheumatic fever, which criteria do we have? Yes, you can have the Ashtop nodules on the biopsy, which Ranjit sir would have already discussed with you in the pathology. Yes, erythema marginatum is more on the upper part of the body, upper trunk rather than the lower part of the body. Okay. So which diagnostic criteria you follow? There are two named diagnostic criteria for two important diseases in cardiology. One is for infective endocarditis, one is for rheumatic fever. One of them is revised Jones, one of them is the Duke. So which one is for Duke and which one is for the acute rheumatic fever? So you just have to remember the RJ, radio jockey. RJ has to have an ID card. So what does that stand for? For the rheumatic fever, we have Jones criteria, And ID card, radio jockey should have ID card, where for infective endocarditis we have Duke's criteria. So for infective endocarditis, Duke's, Jones for the rheumatic, right? As simple as that. So in the diagnostic criteria, of course, we need to have the evidence of the preceding group A beta hemolytic streptococcal infection in the form of raised ASLO titers or other serological markers. In addition to that, we need clinical features. The clinical features are divided into major and minor criteria. Okay, so what are the major criteria? Can anybody name? So I have a mnemonic to remember the major criteria, right? Which is cases. Cases are the major criteria. So here the C stands for carditis, involvement of heart, whether it is valvulitis, pericarditis, myocarditis, doesn't matter. Any level of involvement of heart is carditis. C for carditis. A for arthritis. Okay. S for Sydenham's chorea. E for erythema marginatum. And S for subcutaneous nodules. So these are the major criteria: carditis, arthritis, Sydenham's chorea, erythema marginatum, and subcutaneous nodules. Okay. Now what are the minor criteria? You can remember with the mnemonic PFEM. Okay. So what this FEM stands for? F stands for fever. E stands for raised ESR. Okay. What P stands for? Is there any role of ECG in the diagnosis of the acute rheumatic fever? ECG. Please remember here, when I said arthritis, of course, the classical arthritis is what? Polyarthritis, right? Now, for the countries which are having high burden of acute rheumatic fever, even monoarthralgia is considered as a criteria, but of course, minor criteria. Monoarthralgia is for M. Now, P stands for PR interval, increased PR interval. Because when rheumatic fever affects, it affects whole of the heart, pancarditis. It even causes inflammation of the AV node, increasing the AV nodal delay. AV nodal delay increase means PR interval increases. So the mnemonic for the minor criteria is PFEM, increased PR interval, fever, raised ESR, and monoarthralgia. These are minor criteria. Classical cases is the major criteria. For diagnosis, what do I need? Either I need two major or one major plus two minor criteria. So the question is, can I make a diagnosis of acute rheumatic fever without involvement of heart? Yes. What criteria says? I need two major. So if I have arthritis and Sydenham's chorea, done. If I have erythema marginatum and subcutaneous nodules, then I don't need the carditis. Clear? Or else if I have, let us say, erythema marginatum, increased PR interval and fever, done. I still make a diagnosis of rheumatic fever. Okay. Now, how do you manage rheumatic fever? Should I give antibiotics to a patient with rheumatic fever? It is an autoimmune disorder. Infection triggered the autoimmunity. Right? By the time they present with the symptoms, mostly infection might be reasonably taken care of, but we still give the antibiotics. Why are we giving the antibiotics? Because many of us become carriers of these group A beta hemolytic streptococci in our nose or throat. From there, infection can again spread. Again, we can have one more episode of rheumatic fever. More and more episodes of rheumatic fever result in more and more scarring of the valves, resulting in mitral stenosis. Then I have to call it as rheumatic heart disease, right? So that is why we have to give antibiotics for eradication. And eradication is alone not enough, because next time whenever again bacterial infection happens, group A beta hemolytic streptococcal infection, your immune system will produce antibodies will go and harm some of your tissues. So we need to have penicillin prophylaxis, right? Antibiotics for eradication as well as prophylaxis. The antibiotic of choice is same, that is benzathine, penicillin, G. Benzathine, penicillin, G will be the drug of choice for the prophylaxis as well as eradication of the infection. Okay, so that's about rheumatic fever. What questions are asked? 90% of questions on rheumatic fever are either about major versus minor, asking you which of the following is not a major criteria, which of the following is not a minor criteria, or they are related to pathology like the Ashcroft nodules or the nature of vegetation. So don't miss out on the points from the pathology. Okay. So from here, we will quickly move to the next important segment. So far we have discussed the important topics from cardiology. We have learned about some important pulse waveforms, JVP waveforms, abnormal JVP waveforms. Then we have learned about heart failure, approach to valvular heart disease, constrictive pericarditis, and cardiac tamponade and rheumatic. These are the core topics from which questions come in medicine. Now coming to neuro, what kind of questions are asked? Half of the neuro questions are related to basics, your physio and anatomy slightly integrated with medicine, like differentiating between UM and element damage, the reflex arc, those kind of questions, or terms like spasticity, rigidity, clasp knife rigidity, those questions. After that, it is the acute management of stroke, investigations for a case of myasthenia gravis, and management of GB syndrome. These are the important topics from neurology. We will focus on that. Okay. So in neurology, first thing we should talk, that is the foundation, and almost every alternate exam will have one question, that is differentiating between UMN lesion and LMN lesion. So for that, first we need to understand what is UMN and LMN. So as we know, the motor system of the brain, which is concerned with the movement of body parts, obviously we'll have a network of neurons from brain to the neuromuscular junction. So neurons which are involved in this network concerned with voluntary movement, we will call them as motor neurons. Normally what happens is, when we look at the brain cross section, we have a dedicated area for controlling the movements of the body. We will call that area as the motor area. This motor area will have cell bodies of motor neurons. Cell bodies of motor neurons. And these cell bodies, we will call them as bed cells. Shubham Gai, of course, very good, very good. So these cell bodies are called as bed cells, after the person who described them. Now these cell bodies will send their axons down to form a tract. This tract we call it as the pyramidal tract. Pyramidal tract. Of course, this motor area is in the frontal lobe. More precisely, where is it located? Just anterior to central sulcus. So what do you call that sulcus as, or the gyrus as? Just anterior to central sulcus, you call it as precentral gyrus. It is there in the precentral gyrus. What is the Brodmann area number? Brodmann area number 4. Brodmann area number. Okay, so all those neurons will come down to form a tract. This tract is what you call as the pyramidal tract. We will call it as pyramidal tract. And this pyramidal tract will now pass through the structure called as internal capsule to reach the brainstem. And once it passes the brainstem, it will eventually enter the spinal cord. But because we know that my right brain will control left body and left brain will control right body, these neurons have to cross somewhere to reach the opposite side of the body. So that crossing over usually happens at the lower end of the medulla. So that is the first MCQ with respect to neuroanatomy. Where is the crossing over of the pyramidal tract happening? The crossing over of the pyramidal tract is happening at the lower end of the medulla. This crossing over is called as decussation of the pyramidal tract. So they cross to the opposite side at the lower end of the medulla. This is what we call as the pyramidal decussation. Pyramidal decussation, repeatedly asked MCQ. Where is it happening? Lower end of the medulla. Once it crosses, the tract enters the spinal cord, runs laterally. So we'll call it as lateral corticospinal tract here. Some neurons do not decussate, continue to descend down as anterior-corticospinal tract, not important for us. Now here, these neurons, let us trace one of them. Let us take one neuron which is supposed to go to some muscle. It will descend through this tract, cross to the opposite side, and then once its respective spinal segment is reached, it will move into the spinal cord and meet next order neuron. There will be another cell body in the spinal cord from which another neuron will send the axon to the neuromuscular junction. So for me to send signal from my brain to contract any muscle, I need the help of two neurons. One that starts in the motor cortex, passes through brainstem, goes to spinal cord in the pyramidal tract till concerned spinal segment is reached. Second one, from the spinal cord, it receives the impulse from the higher neuron and then passes on to the neuromuscular junction. So we have two neurons. One of them from the brain to the spinal cord, I will call it as upper motor neuron, and the one from the spinal cord to neuromuscular junction, we will call it as lower motor neuron. So there are two neurons. This is lower motor neuron, and from the brain to spinal cord, this is upper motor neuron. This upper motor neuron sends the signal to lower motor neuron sends it to the neuromuscular junction. So of course, both of them are required for the movement of my muscles. So if any one of them is damaged, I will not be able to move the muscle and I will present with weakness of those affected muscles. And how will I differentiate whether UMN is affected or LMN? Well, UMN does an extra, LMN and UMN have some extra work. What LMN does is, LMN constantly keeps sending electrical impulse to keep the muscle in a partial state of contraction. That partial state of contraction is called as tone. So who is responsible for the muscle tone? LMN. Similarly, when you hit your tendon with a knee hammer, you know that muscle contracts. So for that, the signal for contraction is also coming from the lower motor neuron itself. So for reflexes as well as tone, LMN is responsible. What UMN does is UMN suppresses the LMN. So indirectly, I can say tone is suppressed by UMN, reflexes are suppressed by UMN. LMN causes the tone, LMN causes the reflex. So if I damage the LMN, tone is gone, reflexes are gone. If I damage the UMN, because suppression is gone now, tone will increase, reflexes will increase. So in terms of differentiation between LMN and UMN, so UMN is associated with increased muscle tone because suppression of the tone is function of UMN. This increased tone, we call it as spasticity. Spasticity. LMN will result in, of course, we are talking about lesions, damage. So LMN lesion results in decreased tone. We will call that decreased tone as flaccidity. Flaccidity. That is first point. Okay. With respect to deep tendon reflexes, reflexes are suppressed by UMN. Damage to UMN results in increase in the deep tendon reflexes. We will call it as hyperreflexia. Hyperreflexia. But if I cause damage to LMN, LMN is responsible for the reflexes. If damage done, reflexes are gone or reduced. So it will cause decrease in the deep tendon reflexes. We will call it as hyporeflexia, and if they are absent, you can also use the term areflexia. Hyporeflexia or areflexia. Hemant Gurjar, very good, very good. Okay, next. What else will help me to differentiate between UMN and LMN lesion? Yes, it is the muscle bulk, whether atrophy happens or not. Please remember, our muscles do two levels of work. One, whenever we do voluntarily. Now I'm lifting this mouse, it is doing a voluntary work. But even when I'm not lifting, my muscles are still working because they have to maintain the tone. For that, they have to be in a partial state of contraction. So tone work, on top of that, voluntary work. These are the two levels of work that muscle does. And we know that more the muscle works, more is the muscle bulk, right? That's why we go to gym. Less the muscle work, muscle starts going into atrophy. So in UMN, what happens? Voluntary movements are gone because the upper motor neuron is damaged. So that work is reduced. Voluntary work is reduced, but tone work, tone is increased, right? Tone work is increased. So muscles are doing some work, not according to patient's wish, but they are doing some work. So they will not develop atrophy easily. But in LMN lesions, no voluntary work, no tone work, no work at all. So muscles are not working, they lose the mass. So we'll have severe atrophy, right? So LMN lesion is associated with severe atrophy and fasciculations. We won't get that. It is relatively rare. So we can get atrophy in UMN lesion because of not using the muscle for a long time. We will call it as disuse atrophy. but it happens in the long run, not immediately. But in case of element damage, within few weeks, the muscles will be severely atrophic. So whenever a question says patient has severe atrophy, think of element. This is the ground rule we have to remember. Last but not the least, what happens to the plantar reflex? What happens to plantar reflex? So normally plantar reflex is flexor, means when you stroke the plantar surface, great toe goes into flexion, other toes become crowded and may go into flexion. So normal response is flexor, but it becomes extensor in patients with UMN damage. So plantar becomes extensor, and whenever plantar is extensor, we call it as Babinski sign. So Babinski sign is positive when there is damage to UMN. The plantar remains flexor or mute. Flexor is normal. It is usually flexor, or it doesn't show any response if the LMN is damaged. So plantar is again an important tool, right? The simplest way to remember it is, in UMN damage, everything goes up. Tone increased, deep in reflexes increased, and plantar extends the response, going up to the sky, right? In element damage, everything is going down, tone decreased, deep in reflexes decreased, plantar flexor, going to the ground, going down. Element everything down, UMN everything up. So as long as you remember that, your element and UMN are sorted. Okay. Shubham Ghai, good, very good. So with that knowledge, we'll start with the first disease from neuro, which is myasthenia gravis. Mostly what kind of questions are asked? Only two. One, from the patient's symptoms, you have to recognize whether this is myasthenia gravis or not. Second, investigations. Okay. So what is myasthenia gravis? It is a autoimmune disorder. Autoimmune disorder affecting what structures? Affecting neuromuscular junction, affecting the neuromuscular junction. Of course, it is an antibody mediated disorder. Antibodies are affecting the neuromuscular junction. So which gender is most likely to be affected? Of course, females are affected more than males because it is an autoimmune disorder. But we characteristically say there is a bimodal age of presentation. Age wise, two age groups get affected. Mostly when we say females autoimmune, we think of middle age, right? In their 30s to 40s, and after 60 years we see one more set of patients. So usually females present in their 30s to 40s and males present after 60 years of age. Okay. So what antibodies are produced in myasthenia gravis? Remember, the most common antibody that we see in myasthenia gravis is anti-acetylcholine receptor antibody, right? Seen in more than 85% of patients. That is the most common antibody. And whenever we have this antibody positive, right? If positive, that patient of myasthenia gravis will be called as seropositive myasthenia gravis. Seropositive myasthenia gravis. And this is the most specific investigation also. We'll look at that later. The second most common antibody is anti-muscle specific kinase antibody or anti-musk antibody. Anti-musk antibody. If this is positive, we will call it as seronegative myasthenia gravis, because anti-acetylcholine would be negative, only then we just check for the anti-musk. And the least common is anti-lipoprotein 4 receptor antibody. And if this is positive, we will call it as double negative myasthenia gravis, because both commonest, the most common, second most common are absent, third one is positive. That's why it is called as double negative myasthenia gravis. Why is it important? Because myasthenia gravis is often treated with thymectomy, and thymectomy is suitable for only patients with seropositive myasthenia gravis. Okay. Now in myasthenia gravis, it's a neuromuscular junction disorder. So neuromuscular transmission gets affected, but there is a sequential involvement of muscles. Not all the body muscles get affected simultaneously. Which muscle gets affected? See, basically for me to send a signal from the nerve to the muscle, I need acetylcholine, right? And the more I use the muscle, more and more acetylcholine gets So whichever muscles are used most get affected earlier. The first muscle to get affected is levator palpebrae superioris, because for blinking we continuously use the levator palpebrae superioris. So in the neuromuscular junction of LPS, acetylcholine gets finished quick. That's why it gets affected first. After levator palpebrae superioris, it is the muscles of extraocular movement, because constantly when we are awake, we are looking here, there, our eyeballs are moving. The muscles of extraocular movement, that is the second set of muscles to get affected. After this, it is the proximal muscles. Proximal muscles means muscles around your shoulder joint and hip joint. Why? Because they're large muscles. Large muscles, for them to contract, they need more acetylcholine. After that, we will have involvement of facial muscles. Facial muscles. The last to get affected is going to be distal muscles, because distal muscles are like very rarely affected. That's why we say classical weakness of myasthenia gravis is proximal plus face. The involvement of levator palpebrae superioris muscle leads to ptosis, because I cannot lift the eyelid, ptosis. Once the extraocular muscles are also involved, now my eyeball movements are affected, so I will start seeing things to diplopia. Once the proximal muscle gets affected, I will have proximal weakness, right? I will not be able to use my shoulder muscles and hip joint muscles. I will have proximal weakness. Once there is involvement of face, the face droops, because facial muscles contraction is required to maintain the normal facial appearance. It droops. And when you ask this patient to smile, they will not be able to lift the angle of the lip, giving rise to a characteristic smiling face which resembles snarling of the dog. So we call it as snarling faces. Snarling faces. So distal weakness is the least common thing. So that is why we say the weakness that we get in myasthenia gravis is characteristically high proximal. Why are we calling it as high? Because face is involved, plus proximal because the proximal muscles are affected. And characteristically, this weakness will be associated with diurnal variation. Diurnal variation is considered as the hallmark of myasthenia and neuromuscular junction disorders, including myasthenia gravis. What happens here? When patient wakes up in the morning, he will have a lot of acetylcholine in the nerve terminal. The acetylcholine will be able to fight against the anti-acetylcholine receptor antibodies and win the battle. Patient will be able to contract the muscles. But as the day progresses, acetylcholine gets used up, and acetylcholine starts losing the fight against the antibodies. By the end of the day, you have completely lost the battle and muscle contraction becomes very poor. So symptoms are worse by end of the day or by evening. You can remember it as by end of the day or by evening, the symptoms are worse. In the Lambert-Eaton, by the end of the day, symptoms are best. So they have worse symptoms in the morning, better evenings. Myasthenia gravis, they have better mornings, worst evenings. So when we have someone presenting with ptosis, diplopia, proximal weakness, snarling face with diurnal variation, clinically it is myasthenia gravis. How will I investigate it? So investigation wise, most specific investigation is anti-acetylcholine receptor antibody, right? If they ask what is most sensitive investigation is single fiber electromyography. And in that single fiber electromyography, that is the most sensitive investigation. The point to remember here is what we do in single fiber electromyography is we repeatedly stimulate a muscle by giving electrical impulse. If it is myasthenia gravis, as I stimulate more and more, the muscle goes becoming weak. So we will call this response as decremental response. The muscle's contraction comes down. So we will call it as decremental response. Okay. Then most commonly performed test. Most commonly performed test is again a form of EMG itself. It is called as repetitive nerve stimulation test. In single fiber electromyography, we have to do EMG for a single nerve muscle fiber. We have to isolate a muscle fiber and stimulate, which is complex, cumbersome, not easy.
In repetitive nerve stimulation, instead of giving the impulse to the muscle, we give to a nerve, and then we know that which nerve supplies which muscle, and we will assess the contraction of that muscle. So this is more convenient. So of course, here also it is based on the same principle. Only difference is that instead of stimulating one muscle fiber, we are stimulating a nerve, and we are seeing the contraction of the whole muscle supplied by that nerve. Of course, we will get decremental response. If they ask you what is the screening test of choice, screening test of choice. The screening test currently it is the ice pack test. For the ptosis eye, we will apply an ice pack. After the ice pack, if the ptosis improves, it is myasthenia gravis. If ptosis does not improve, there may be other causes for ptosis like third cranial nerve palsy. Okay. What other tests we know? There is something called as hydrophonium test or tensilon test. It is not routinely performed today because of the risk of cholinergic crisis, but we should be aware about it. Normally what happens once we administer hydrophonium or the tensilon, we will block the acetylcholine esterase, increase the acetylcholine, and the ptosis is expected to improve. So in ice pack as well as hydrophonium, ptosis improves. That means it is myasthenia gravis. So once we have recognized that we are dealing with a case of myasthenia gravis, the question is how do we manage? Okay. Anyway, examiners are very much fond of this SFMG, so I want you to remember that. How do we manage? It's a battle between acetylcholine and antibodies. All I have to do is help the acetylcholine win the battle over antibodies. So how can I do that? By decreasing the antibodies, increasing the acetylcholine. So how can I increase the acetylcholine? I can achieve the increase in acetylcholine by acetylcholine esterase inhibitor. So we know that acetylcholine gets degraded to choline by an enzyme called as acetylcholine esterase. So if I block it, acetylcholine will increase. And how can I decrease the antibodies? Who produces the antibodies? B lymphocytes. So I have to give drugs which suppress the B lymphocytes so that the antibody production will come down. How can I do that? I can use steroids and immunosuppressants, right? So we can use steroids and immunosuppressants. Like azathioprine or 6-mercaptopurine, those can be used. The last thing you have to remember is that the training of B lymphocytes to produce antibodies happens with the help of antigen presenting cells and T lymphocytes, which are concerned with thymus gland. So thymus gland is somewhere the root cause for a problem. In fact, the antigen for production of antibodies is there in the thymus gland. It is called as myoepithelial cell antigen. So if I remove the thymus gland, antigen is also gone, and our immune system will now stop producing the antibodies. So we should think of doing the thymectomy. But thymectomy is only suitable for seropositive myasthenia gravis patients aged less than 55 years. More than 55 years, the surgery is considered as risky. Right? So to be able to do thymectomy, two things are required. Age should be less than 55 and it should be seropositive myasthenia gravis, means anti-acetylcholine receptor antibody that we were talking about. It should be positive. I can't do thymectomy for anti-MuSK positive myasthenia gravis or anti-LP4 receptor antibody positive myasthenia gravis. At the same time, even seropositive MG, if age is more than 55, I can't do. So that's about our myasthenia gravis. Next up in neuro, we have GB syndrome. GB syndrome is again a very important topic. Okay, I forgot to mention. Yeah, the acetylcholine esterase inhibitor that we use here, the drug of choice is pyridostigmine. Why pyridostigmine? Why not donepezil? For Alzheimer's, this is the drug of choice. Acetylcholine esterase inhibitor is donepezil. Why not neostigmine? Okay. Remember, we are not using neostigmine because it is relatively very short acting. We need to have a long-term control in the symptoms, right? Second, we do not want this drug to have high blood-brain barrier penetration because I want this drug in the peripheral neuromuscular junction, not in the brain. So pyridostigmine gives me that benefit. It is long-acting and it has relatively poor blood-brain barrier penetration. But when I want more acetylcholine in the brain, I will choose a drug which has high penetration of the BBB. That is our donepezil. That is why donepezil is a drug of choice for Alzheimer's, pyridostigmine for the myasthenia gravis. Okay. Now coming to GB syndrome. What is GB syndrome? GB syndrome is again an autoimmune disorder, just like myasthenia gravis, just like acute rheumatic fever. In fact, I can compare it to rheumatic fever. In rheumatic fever, infection happen, body produce antibodies, antibodies cause the damage to our multiple tissues. Here again, an infection happens, body produce antibodies, antibodies cause damage to our own nervous system. As simple as that. So it is a infection triggered autoimmune disorder. Infection triggered autoimmune polyneuropathy means basically the antibodies start affecting the neurons. Polyneuropathy, when I say affects the neurons, mainly the peripheral nerves. It's the disorder of the peripheral nerves. Which infection is usually responsible? It can be GIT infections or the respiratory infections. The most common infection is usually the Campylobacter jejuni infection. So usually 2 weeks after the loose stools caused by Campylobacter jejuni, patients develop the weakness because of the polyneuropathy. So when I say polyneuropathy, it refers to the disease of peripheral nerves. And peripheral nerves contain sensory neurons, motor neurons, and autonomic neurons. So all the 3 can be affected. What type of sensory neurons, what type of motor neurons are there in the peripheral nerve? See, from brain to spinal cord, we have UMN. From spinal cord to neuromuscular junction, we have LMN. So it is primarily the LMN which is getting affected, plus sensory nerves which are getting affected, plus autonomic nerves which are getting affected, right? So what symptoms these patients are going to present with? So in terms of clinical features, a GB syndrome patient will present with, because of the demyelination of the lower motor neurons, the signal conduction is slowed down, it will be impaired, so you will have weakness. Now generally when peripheral nerves or lower motor neurons get affected, longer neurons get affected first, and in the body the longest neurons are the ones which are starting in the lumbosacral region and going to the feet, right? They have the longest journey, so they get affected first, followed by next longer neurons which are going to the legs, then the thighs. So we will have this classical ascending paralysis, right? We will have ascending paralysis, and because this paralysis is due to element involvement, right? So what will happen to the tone? Tone will be low, so it will be flaccid, right? So there will be flaccidity. And what will happen to the reflexes? Reflexes will be down, so we will have hypo or areflexia, hyporeflexia or areflexia. Along with that, there will be mild sensory symptoms, mild sensory symptoms. Clear? Okay, so when someone presents with this flaccid ascending paralysis, how will I make the diagnosis of GB syndrome? So for diagnosis, it is primarily clinical. We follow a criteria called as Brighton's criteria. I'm not getting into the details of the criteria. You just have to remember the name. Most important point here is there should be ascending paralysis plus flaccidity, the muscle tone should be low, plus hypo or areflexia, reflexes should be diminished, plus you can do an investigation, which is the CSF analysis. It should be showing what is called as albuminocytological dissociation, because basically this is a autoimmune disorder which is antibody mediated. So only antibodies reach the CSF to cause demyelination of the nerves. There is no increase in the cell count in the CSF. Normally in meningitis, what happens? Cell count increase, antibodies increase. Antibodies are proteins. So protein is also increased in meningitis as well as the cell count. But in case of the GB syndrome, cell count is normal, only antibodies are reaching the CSF, so only protein is increased. This condition we call it as albuminocytological dissociation. Very, very important MCQ point, repeatedly asked, and also a clue in a clinical MCQ that this patient is suffering from GB syndrome. Another condition where we can have albuminocytological dissociation is multiple sclerosis. Once we have diagnosed, how will we treat? Can a GB syndrome patient die? Yes, of course. Why do they die? Ascending paralysis reaching the respiratory muscles. Once the respiratory muscles are involved, you will have respiratory paralysis. We can intubate, keep you on the ventilator till recovery happens, but by that time other complications can come in, ventilator associated pneumonia and other complications like barotrauma that can also become the reason for death. So in simple words, respiratory paralysis and consequences are the most common cause for death. So how do I prevent this patient from dying? Most common cause for death in GB syndrome is respiratory paralysis and complications. Respiratory paralysis and complications. Yes, I have to prevent this ascending paralysis from involving the respiratory muscles. How do I prevent? What is happening? Antibodies are causing the demyelination of the neurons. So what should I do? Reduce the antibodies so that the neuronal damage stops. How do I reduce? This is an acute condition where antibodies are being produced in a very rapid fashion, and produced antibodies will be able to complete the task of damaging the neurons over next few days to few weeks time. So I have to mainly remove the antibodies which are already produced. How do I remove? Plasma exchange or IVIG. So the management will focus on plasma exchange or IV immunoglobulins. IV immunoglobulins. Clear? That's about the management of GB syndrome. Mostly questions on GB syndrome are centered around the criteria or recognizing that this question is talking about GB syndrome based on the story of ascending paralysis, flaccidity, and hyporeflexia, sometimes related to albuminocytological dissociation. Okay. Next up, we come to a hot neurology topic, that is stroke. Okay. What questions are asked on stroke? 90% questions on stroke are about deciding the management, whether you will do thrombolysis or not, or whether you will do some other management for a given case of ischemic stroke. So we'll understand first stroke. Another set of questions are differentiating between stroke and TIA, repeatedly asked template. They give a story. One option is ischemic stroke, hemorrhagic stroke, TIA. You should have to decide whether it is TIA or stroke. Okay. So what is stroke? By definition, stroke refers to focal, means some part of the brain, or global, means whole of the brain, dysfunction, neurological dysfunction. Some part of the brain or whole of the brain is not able to do its work because of, due to vascular pathology. So basically some blood vessel problem is making your brain not work properly. Then we will call it as stroke. Now what can go wrong with the blood vessel? Either blood vessel can rupture and bleed. In that case, we will call it as hemorrhagic stroke, or blood vessel can get blocked because of atheroma or clot and does not supply sufficient blood supply, causes ischemic stroke. So the stroke is divided into two groups: hemorrhagic stroke and ischemic stroke. Hemorrhagic and ischemic stroke. What is the most common cause for the hemorrhagic stroke? And what comes under hemorrhagic stroke? See, bleeding can happen into the brain tissue, parenchyma, the cerebrum, right? Then we will call it as intraparenchymal bleed. Bleeding can also happen in the subarachnoid space, epidural space, subdural space. So only intraparenchymal bleeding into the cerebrum, brain's original tissue, and subarachnoid hemorrhage will be considered as stroke. Epidural and subdural are not considered as. I'll tell you why. See, what is the most common cause for epidural and subdural hematoma? It is the trauma, not a blood vessel pathology directly. But what is the most common cause for intraparenchymal hemorrhage? It is the hypertension causing the rupture of the blood vessel. Hypertension is a disease of blood vessels. What is the most common cause for subarachnoid hemorrhage? Rupture of berry aneurysms. Aneurysms are disease of blood vessels. So we have defined that stroke is some dysfunction of the brain because of blood vessels pathology. These two fit into it. So most common cause for intraparenchymal hematoma is hypertension. They ask you what is the most common site for hypertension bleed. It is the basal ganglia. Basal ganglia. To be more precise, a nucleus of the basal ganglia called as putamen is the most common site for hypertensive bleed. Okay. And then the most common cause for subarachnoid bleed is rupture of berry aneurysms. Rupture of berry aneurysms, or you can simply say arteriovenous malformations. Okay, so that's about hemorrhage. Ischemic stroke, of course, the atherosclerosis of the blood vessels or embolism into the brain's blood vessels. This is stroke. But the stroke definition has one important point. Focal or global neurological dysfunction due to vascular pathology persisting for more than 24 hours or till patient's death. Then we will call it a stroke. If the symptoms improve within 24 hours, then we can count it as TIA. So what TIA refers to? TIA refers to neurodeficits or neurological dysfunction persisting for less than 24 hours without objective evidence of an infarct. Then we will call it as TI. So in one of the previous FMGE exam, there was a simple question. I will write down the question here. You tell me whether that patient is having stroke or TIA. So that was a 40-odd-year-old person with right hemiplegia, lasted for 6 hours and improved. CT brain showed small infarct in internal capsule. That asked what is the diagnosis. So options were ischemic stroke, B, hemorrhagic stroke, and C, TIA, D, whatever option was there. So what do you think it is? Let me write it as meningitis. So what do you think it is? Is this TIA or stroke? Hemant Gurjaria, we will discuss the ABCD 2 score also. What is this? TIA or stroke? Harsh thinks, Mohit says it is TIA. Good, very good, very good, very good. Of course. So for the definition of TIA, there are 2 points involved which I want you to stay clear during the examination. What is it? Symptoms should improve within 24 hours and there should be no evidence of infarct. If symptoms improve within 24 hours but still infarct is visible, then it is stroke only. How can I call it as ischemic attack? Transient ischemic attack means short-living ischemia, no infarction. Infarction is there means it is always stroke. So in this question, infarct is clearly visible. So we have to count it as ischemic stroke. Unfortunately, most of the students had answered it as TI. No. In fact, recently in one of the PYQ books, there was another question where patient has improved the symptoms over 48 hours. And again, same option, stroke, TIA. Unfortunately, in that book, the answer given was TIA, but that's not right. To call it as TIA, improvement should happen within 24 hours. In that question, the improvement had happened over 48 hours. So we will still count it as stroke. So be aware about this definition very clearly. Okay. Now, before going to stroke, what is the problem of TIA? TIA means there is some block in your artery or a clot is there somewhere in the body which is getting embolized and coming to your brain blood vessels. So even if you have improved now, there's every chance that the next time an embolus happens or next time the clot forms in your artery, you may not be able to improve and you can have full-fledged stroke. So you already have high risk of developing full-fledged stroke. So whenever we have a patient with TIA, we have to assess them for the risk of stroke. The tool used for assessing the risk of stroke in patients with TIA is what we call as ABCD2. It's a mnemonic, easy to remember. So this ABCD2 score is to assess risk of stroke in patients with TIA. So where A stands for age of the person. If it is more than or equal to 60 years, we give 1 point. B stands for BP, more than 140/80, we give 1 point. Third, clinical features. If patient has unilateral weakness, 2 points. Very, very important. 2 points for unilateral weakness. Second, if there is impairment in the speech without weakness, then 1 point. Weakness, 2 points. Without weakness, only speech, dysarthria, aphasia, 1 point. Then duration of symptoms. If it is more than 60 minutes, see, up to 24 hours, we can call it as CIA, but if it is more than 60 hours, 60 minutes, we're going to give 2 points. But if symptoms improved within 60 minutes, we are going to give 1 point. And if the patient is diabetic, we will give 1 point. This is not very complex, easy to remember, because in the name itself, it is ABCD2 mnemonic itself, right? So here there are 2 D's, duration of symptoms and diabetes, otherwise ABC, age, blood pressure, clinical features, whether it is weakness or the speech impairment without weakness. Now, how will it help me to assess the risk of stroke? If the score is 0 to 3, right, the stroke happening within next 2 days is very low, and even the chance of having stroke in next 3 months is just 1%. If the score is 4 to 5, the risk is considered moderate, and the risk of stroke in next 3 months is 4%. But if it is 6 to 7, we will consider it as high. Within next 2 days, there is a high risk of stroke, and within 90 days, at least 8% of these patients will have a frank stroke, right? So I want you to remember this as well as the scoring system. Especially you should by heart for which parameters that we are giving 2 points. Unilateral weakness and duration of symptoms more than 60. Okay. Now there is a modified ABCD2. They may ask, what is this newly modified ABCD2 I score, where I refers for imaging, right? I refers for the imaging. So we have added an extra parameter to the ABCD score, which is called as ABCD2I. So same thing as above, plus imaging. If there is some evidence of acute infarction on the diffusion weighted imaging, or CT is showing any infarction, we will give extra 3 points. This is an added point over the ABCD2. So you just be aware that there is something called as ABCD2I, which is referring to imaging, and there are 3 points added if there are imaging features of infarction. Okay. Now that we are aware of stroke versus TIA, the next important MCQ from stroke is, how do you recognize the stroke early? There are 2 things. One is for the layman and other for the professionals. So for early recognition of stroke for laymen, we have an algorithm called as B-FAST. They will ask you mostly what are the components of this B-FAST, or B-FAST is used for. They will confuse you because there is something called as trauma fast, E-FAST for the ultrasound that you do in trauma patients to see if there is any intraperitoneal collection, intrathoracic collections. This B-FAST is for the stroke. Okay, so what B refers to here? B for balance, E for eye issues, F for facial drooping or asymmetry, A for arm weakness, S for speech impairment, dysarthria or the slurring of speech or aphasias, and T for time. So what is this? If a layman, like somebody's family member, is noticing that one of their family member is having issues with balance, or if they have issues with the eyesight, they have blurring of vision, loss of vision, diplopia, or any eyesight issues. If they notice that the face one side is drooping, one side arm is weak, or if their speech is slurred, or they're not understanding speech, they're not able to speak. If any of these are noticed, without wasting time, patient should be taken to the hospital. T here stands for time. Okay. For professionals like doctors, how do we recognize stroke early? There is a sign called as pronator drift sign. Pronator drift sign, which is also called as Barre sign. Barre is the Barre of Guillain-Barre syndrome. It's called as Barre sign. Basically, we have to ask the patient to hold his hands outstretched like this. Any side, if it is weak, that side, they will not be able to hold it in the supine position. It will start pronating and drifting away. Now we have to hold it in supine. It will start pronating and drifting away. So this condition we call it as pronator drift sign. This is for experts, clinicians. For family members, it is B fast. B fast is important. I want you to remember. Now, why should we recognize stroke early? Because once we recognize the stroke early, we will be able to help the patient recover or save the abilities. Because when some part of the brain is dying, as more and more neurons die, the weakness becomes more and more profound and the chances of recovery goes down and down. So the earlier we recognize, we can minimize the damage, we can maximize ability, minimize disability. Early recognition is important. Okay. Once we have recognized that this patient is having stroke, the next question is whether it is ischemic stroke or hemorrhagic stroke, because I cannot manage them same way, right? So that is why whenever you recognize a case as stroke, what is the first step? Investigation, imaging to recognize whether it is ischemic or hemorrhagic. What will be the investigation of choice? Remember, infarct becomes visible on the CT scan after 6 hours. MRI can pick up within few minutes. So what would you like to do, MRI or CT? If you're thinking MRI, no, we will be doing CT. Why? Because I have a question in my mind. What is the question? Whether it is ischemic or hemorrhagic. I don't want to see the infarct. I want to know whether it is ischemic or hemorrhagic. That doubt can be solved by CT, because CT is highly sensitive for bleeding. If CT shows no bleed, that means it is ischemic. CT shows bleed, then it is hemorrhagic. So investigation of choice is non-contrast CT scan. If the non-contrast CT scan shows that there is bleed present, then the patient is having hemorrhagic stroke. Depending on whether it is intraparenchymal or subarachnoid, you can evaluate further, ideally done by a neurosurgeon, right? But if there is no bleed on the CT scan, then we will count it as ischemic stroke. Ischemic stroke, right? So for the hemorrhagic stroke, it is more about reducing the intracranial tension and, if required, removing the blood from the brain by doing burr surgery or craniotomy. But for the ischemic stroke, some blood vessel is occluded. I need to open that blood vessels to re-establish the blood flow to the brain. So opening as early as possible is crucial, because more time I spend, more brain dies. So I can open by giving the medications that dissolve the clot. So there are two ways I can open a closed blood vessel. Let us say that there is a blood vessel which is having a block. Now this block, either I can give medication which will break down the block, break down the clot, we will call it as thrombolysis, or I can pass a wire and pull this clot out. In that case, we will call it as mechanical thrombectomy. So I have two choices for opening a blocked blood vessel in ischemic stroke patients. What are those? Thrombolysis and thrombectomy, mechanically removing the clot. That's a mechanical thrombectomy. What we will do, how we will approach, I'll just discuss. I want you to primarily focus on the approach, because mostly questions are like, decide what you want to do. You want to do mechanical thrombectomy or thrombolysis. The question is, what is best? Remember, success rate of thrombolysis is 50%. Mechanical thrombectomy is close to 100%. Close to, I don't say. And when I say success rate, doesn't mean patient improvement or patient survival. I'm saying success rate in dissolving the clot or removing the clot. If I'm passing a wire, if I'm a good skilled person, I will be able to remove clot for sure, 100%. If I'm giving medications, half of the clots will dissolve, half of the clots will remain. So what is best? Of course, mechanical thrombectomy. But the first step we take is not mechanical thrombectomy. It's thrombolysis. That is the current guideline. Why? Because mechanical thrombectomy is only possible if the clot is there in a large blood vessel. If it is in a small distal blood vessel, I cannot pass the wire to reach there. But my drugs can reach any part, right? Small blood vessel, large blood vessel, anywhere it can reach. That is why thrombolysis is the initial step. After that, if the clot is not open, then I can think of mechanical thrombectomy. So that is why whenever we have a case of ischemic stroke, first thing I would think of is going for thrombolysis. But thrombolysis can only be done if patient presents within how many hours? Within how many hours? Within 4.5 hours. Harrison says up to 6 hours, but guidelines are still 4.5 hours. So it is better that we stick to 4.5 hours for the exams. Okay. So if you have a patient with ischemic stroke, if he has presented within 4.5 hours. Presented within 4.5 hours. Then we are going for thrombolysis if no contraindications. If there are contraindications, of course, like I cannot do thrombolysis. That's as simple as that, right? What contraindications can be there? Recent major surgery, very high BP. No, of course, I cannot give medications to dissolve the clot. Okay. Now, if patient presents after 24 hours, after 24 hours, by that time, because of the blocked blood vessel, the area supplied by that blood vessel will be completely dead. Now, opening the blood vessel serves no purpose because the brain part is dead. Even if I open, I achieve nothing. So, in such cases, we do not do thrombolysis or mechanical thrombectomy, nothing. That opportunity is gone. What we can do is prevent another stroke from happening. So, for these patients, it's only about secondary prevention. Secondary prevention, because there is full infarct by 24 hours. Once the blood vessel get blocked, slowly some part of the brain start dying. By 24 hours, whole area supplied by this blood vessel will be gone. So how do we do second prevention? By giving statins and antiplatelets. By giving statins and antiplatelets. Statins plus antiplatelets. If patient presents after 4.5 hours, but before 6 hours. So please remember, this is the period where we are very sure that infarct is not completely set in. We have still a lot of alive brain tissue which we can save. But thrombolysis I can't do because within 4.5 hours I should do. Now patient is presented within 6 hours, but after 4.5 hours. Right? So I have to go for mechanical thrombectomy. That is the only choice I have. Now for mechanical thrombectomy, I have told you wires cannot reach small blood vessels. So I have to see where is the clot positioned. If the clot is in large vessels, I can go with the mechanical thrombectomy. How will I get to know where is the clot positioned? By doing a CT angio, right? I have to do a CT angio. And if the CT angio shows that there is a clot in large vessels. What are considered as large vessels? Okay. So what can be considered as large vessels? It is the M1 part of MCA, M1 part of Ambika Sharma. Of course, there should be no infarct in a TI. M1 part of MCA, internal carotid artery, and proximal part of the anterior cerebral artery. This is where current technology allows us to pass the wire and retrieve the clot. If it is present, of course, we are going for mechanical thrombectomy. If clot in small vessels, can I do mechanical thrombectomy? No. Can I do thrombolysis? No. Patient is presented after 4.5 hours. So what I can do? Nothing. No opportunity to treat these patients. So all I can do is secondary prevention by giving statins and antiplatelets. Okay. Now those patients who had undergone thrombolysis, only half of them will have successful opening of the blood vessels. Remaining half, no. So that is why after thrombolysis, my story is not over. I have to go for CT angio again. After thrombolysis, we should do the CT angio again, right? So if there is clot still present and if it is in large blood vessel, we can still go for mechanical thrombectomy. So after thrombolysis, we still have to keep in mind the possibility of mechanical thrombectomy. Now those patients who presented after 6 hours but before 24 hours, in them I need an additional investigation. What is that? See, up to 6 hours, I am very sure the infarct might not have set in because it takes more than 6 hours time to infarct to set in. That's why in CT within 6 hours we see nothing. But after 6 hours, infarct tissue started dying significantly. Now I want to know whether I have some tissue left to save or everything is gone. I know after 24 hours everything is gone, but I want to now know whether there is a good amount of tissue which can be saved. Then I will do mechanical thrombectomy. If there is no savable tissue, then of course I have to leave it and do secondary prevention. So for that, we have to go for these patients, we have to go for the diffusion weighted MRI, right? And if there is large savable tissue present, right, that is what we call as penumbra, then we can go for mechanical thrombectomy. Of course, the block has to be in the large vessel, right? If there is small or no penumbra, penumbra is alive tissue which we can save. In that case, again we go for secondary prevention. So from the stroke, this whole flow chart is very, very important. So after the class, I would urge you to spend 10 minutes trying to memorize this or remember. Anyway, to make it easier, let us go through a question and see if we can apply it as of now. So we have a patient, 48 years. Okay, I'm not framing full sentence to buy time. I will keep it short. Patient, 48 years, presented with right hemiplegia, CT on arrival, no bleed. Patient had onset 5 hours ago. What is the next step in management? Option A, thrombolysis. Option B, mechanical thrombectomy. Option C, CT angio. Option D, secondary prevention with statins and antiplatelets. So what would you choose here? Of course, patient is presented after 4.5 hours, right? So at this point of time, thrombolysis is out. I have to think of mechanical thrombectomy provided clot is in a place where mechanical devices can reach. To know where is the clot, I need the CT angio. So the next best step here will be CT angio, not the thrombolysis or thrombectomy. Now, if I tell you that CT angio is done for this patient, same question, building it further. CT angio is done and there is a clot in M2 segment of MCA. What is the next best step in the management? What will you choose as the answer? Very good. All of you chose the right answer. Now that there is a clot in the M2 segment, same question, CT angio is done. Angio shows clot in M2 segment of MCA. After 4.5 hours, thrombolysis is out. We are thinking of mechanical thrombectomy and the clot is in M2. Can I do mechanical thrombectomy for a M2 clot? No, I can do it for M1 clot. So that is also out. So I have to only think of secondary prevention in this case. I do not have any opportunity to treat. I can only prevent another episode of stroke from happening. So instead of this, I mentioned that this patient presented 10 hours after the onset of symptoms, and one of the option is the diffusion weighted imaging of the MRI or the perfusion brain scans. What will you choose? Of course, after 6 hours, I want to know whether there is reasonable amount of tissue which can be saved. For that, I need diffusion weighted imaging or the perfusion imaging, and that will be my choice. If I say that patient presented after 24 hours of onset of symptoms, I don't need to do any investigation. I have to just offer them secondary prevention, right? After 24 hours, all the areas applied by that particular blood vessel will be gone. Okay, good. So that is about the management of stroke. Few MCQs have asked beyond this with respect to pharmacology. They've asked what is the preferred agent for thrombolysis, and they've also asked about dosing of thrombolysis, right? and also contraindications for thrombolysis. So we'll spend just few minutes more on thrombolysis. So what are the preferred agents for thrombolysis? There are two types of thrombolytic agents, fibrin specific and fibrin non-specific. So preferred agents are fibrin specific agents like alteplase, reteplase, tenecteplase. Fibrin non-specific like streptokinase, urokinase are not preferred. Okay. Now they are usually asking about the alteplase dose, right? Alteplase dose. So dose is usually 0.9 milligrams per kg. The dose is 0.9 milligrams per kg. Out of this, 10% is given as IV bolus or stat dose, right? And 90% is given as IV infusion over 1 hour. So now let us say we are dealing with a 70 kg individual. 70 kg individual. Each Patra, very good. 70 kg individual. So what should be the dose for a 70 kg? 70 into 0.9, right? So that becomes, correct me if I'm wrong, 9 into 7. How much is that? 63, right? 63 milligrams. And what will be the loading dose or stat dose? 10% of it. That will be 6.3 milligrams. And the infusion dose will be 6.3 minus 63 minus 6.3, roughly somewhere around 56.5, 57 milligrams. I'm keeping it rough number. That's how we calculate the dose. And as someone mentioned, we should not exceed the dose of 100 milligrams. And what is the most common complication of thrombolysis? Bleeding. Most common complication of thrombolysis is bleeding. Okay. What are the contraindications for thrombolysis? Indication is simple. Ischemic stroke patient presenting within 4.5 hours. Contraindications. The first one, patient's BP more than or equal to 185 by 110. Please remember, I want your attention here, despite treatment. I'm mentioning the word despite treatment. Like suppose a patient presented with stroke within 4.5 hours. Let us say he has presented after 2 hours and I see that patient BP is 200 by 110. It's not a contraindication. I still have 2.5 hours. He presented 2 hours. I still have 2.5 hours to control the BP. Despite my attempt to control, if still it is more than 185, 110, then it becomes a contraindication. So sometimes they ask this question, what is the next best step? They mentioned that this patient presented within 4.5 hours. His BP is 200, 110. And then they will ask you, what is the next best step? Of course, he is presented within 4.5 hours. He is eligible for thrombolysis. Only roadblock is BP. So I have to control the BP. So next best step is to control BP. After controlling BP, I can go for thrombolysis. If I fail to control BP, then thrombolysis is out. I have to only think of mechanical thrombectomy. Okay. Second contraindication is large infarct involving more than 1/3 of MCA. Because if it's an infarct which is large, bleeding can happen in that infarcted area, involving more than 1/3 of MCA territory. More than 1/3 of MCA territory because of high risk of bleeding into the infarct. Third one is recent major surgery. Recent major surgery. Fourth one is coagulopathies or bleeding abnormalities. These are the contraindications one should be aware of. So that addresses most of the questions that can be asked from stroke, including some questions from pharmacology. Okay, so from here we will go to the little bit on the renal side. So on the renal side, mostly questions are asked about complications of CKD, then AKI different types and how to differentiate between pre-renal AKI and the intrinsic renal AKI or acute tubular necrosis. And almost every exam, one question on the acid-base disorders, right? Acid-base disorders. Acid-base disorders, the kind of question they ask keeps changing. Sometimes it is very straightforward, like last FMG, there was a question asking which of the following is not a cause for high anion gap metabolic acidosis. Sometimes ABG, you have to analyze, decide whether it is acidosis, alkalosis, metabolic, respiratory. And from there, you have to come, like the question will lead you to if it is acidosis, whether it is high anion gap or whether it is normal anion gap. And if it is high, then they may even ask which of the following may be the reason or which of the following is unlikely to be the cause. So we will analyze it methodically. Okay. So we will learn the approach first. But before that, we will look at the normal ABG parameters. Okay. So what is the normal pH of the ABG? What is the normal ABG pH? The normal pH is normal pH is 7.35 to 7.45. This pH is very much required for all the chemical reactions and functioning of the physiological organs that happen in our body. When pH goes beyond this, chemical reactions get impaired. So of course, physiological functions get impaired. So this pH is maintained by some acids in the body and some bases in the body. The major acid in the body is carbonic acid in the blood, of course. The carbonic acid. How is it produced? Carbonic acid is produced by dissolving carbon dioxide and water produces carbonic acid. So basically, when carbon dioxide gas gets dissolved in our blood, it becomes carbonic acid, and that is a major acid in our blood. So of course, we can measure it indirectly by looking at the partial pressure of carbon dioxide. So what is the normal partial pressure of carbon dioxide in the body? It is 35 to 45 millimeters of mercury. 35 to 45 millimeters of mercury. What is the partial pressure of oxygen? Not required for the acid-base disorders, but for a rough idea, around 80 to 100 millimeters of mercury. Okay. Now, what is the major base in the body? It is the bicarbonate, right? So, what is the normal bicarbonate value in the body? Sorry, I wrote ammonia. What is the normal bicarbonate value? Around 20 to 26 millimoles per liter. 20 to 26 millimoles per liter. Some books mention 21 as the lower limit, 22. That's a rough range we are talking about. This is our normal ABG. Okay. So basically, our body is trying to balance the pH suitable for maintenance of all biochemical functions in the body. And we are maintaining this with the help of acids and bases, right? So what is our main acid? It is the carbon dioxide in the form of carbonic acid. What is our main base? Bicarbonate. Bicarbonate is our main base, and with this we are maintaining the pH of 7.35 to 7.45. Okay, now let us say for some reason there is increase in the acids, more CO2 is added. Now what will happen to this weighing scale? It will, acid side will start going down, right? So this side will now start going down because there is more acid. If I have to get this balance back, what should I do with the base? Add more base or remove base? Acids are in excess. I want to keep the pH balanced. So I should add more base or remove base? Think of a weighing scale. For all ABG disorders, just think of a weighing scale. On one scale, I had some acid, I had some base. They were perfectly balancing. Now I have added more acid. So the scale is tilting this way. Now what should I do with the base? What should I do with the base? I should add more base, right? So if acid increases, base has to increase. So here what primary problem I caused? I added acids. I added acids. Now body has to add more base. So this what body does in response, we will call it as compensation. Primary problem I created was increase in acid. Increase in the base as a response to balance is compensation. Can I now say that the primary disorder and the compensation follow the same direction? If acids increase, base has to increase to balance. If base decrease, right? When the base decreases, the HCO3 is going up. Means the scale on this side is now up. If I have to set the balance, I have to also decrease the acid. So the first important statement you have to remember is primary abnormality and compensation follow same direction. Very, very important point, right? Acids increase, base has to increase. If base increases, acid has to increase. Base decreases, acid should decrease. Acid decreases, base should decrease. And this response we get from the opposite side is called as compensation. Now, which organs do the compensation? Of course, if I have to do something with acids, increase or decrease, which organ can do it? CO2 is under the control of the respiratory system. So lungs can control. If I have to increase the acid, I will reduce the excretion of carbon dioxide, exhalation of carbon dioxide. If I have to decrease the carbon dioxide, I will increase the exhalation. So that is respiratory system. Which system can regulate the bicarbonate? It is mainly the kidneys, right? Kidneys can decide how much of bicarbonate to be excreted and how much to be reabsorbed. If I have to increase the base, kidneys can reabsorb more, excrete less. Or if I have to decrease the bicarbonate, kidneys can excrete more and reabsorb less, right? Now, when lungs play a role, we will call it as respiratory. And when kidneys are involved, we will call it as metabolic. It's as simple as that. Okay. So with this idea, we will now look at how to approach the ABG. Approach to ABG. So in any ABG, first thing you have to do is step 1. You have to see the pH. pH. Okay. What can happen with pH? pH can be within the normal range or outside the normal range. What is the normal range? 7.35 to 7.45. So if it is in this range, 7.35 to 7.45, right, it can be normal, right? Or if it is more than 7.45, it is high, right? So I will count this as alkalosis. If it is less than 7.35, right, it is towards the side of acid. So we'll call it as acidosis. This can be counted as normal. But now I will give you an ABG as an example. So pH of this person is 7.38. Okay. Bicarbonate is 18 and PCO2 is 80. Now what is this? Is this a normal ABG or abnormal ABG? Dr. Ambika Sharma, yeah, I will repeat the whole concept. Okay. Basically what happens is in our body, we have acid in the form of carbon dioxide and base in the form of bicarbonate. These are major. Of course, there are other acids, other bases in the body. These are major. Their perfect balance keeps the pH in 7.32, 3.2, 7.45. Right? This is basically like a weighing scale. If I increase the acid, pH is going towards acidic side. Now I have to neutralize this acid. So for neutralization, what I need? Base. So I have to increase the base. So primary problem was increase acid. Correction was increase in the base. So both followed the same direction. Both are getting increased. If I decrease the base, right, my pH will tilt towards acid. In that case, again, I have to decrease the acid. So the main problem and the compensatory change, both are following the same direction. Okay. Now, is this normal? Of course not. Why? pH appears to be normal. But when you look at carbon dioxide and bicarbonate, they are not normal, right? Carbon dioxide is increased. Normal is 35 to 45. Bicarbonate is 22 to 26. It is decreased. It is decreased. So that means this ABG is not normal. It is abnormal. But then how will I decide whether it is acidosis or alkalosis? Because pH appears to be normal. Well, we have to remember that these changes generally tend to happen because of compensation. See, carbon dioxide increased. Now to compensate, ideally bicarbonate or some other base should increase. So if they increase sufficiently, the pH will be set back to normal. When the pH is set back to normal because of the effort of the compensatory system, we will call it as fully compensated ABG. So whenever you have abnormal ABG but pH appears to be normal, we will call it as fully compensated. So when pH is in the normal range, it can be either normal or fully compensated disorder. Now, how will I decide whether it is normal or fully compensated? Of course, in normal, every parameter will be normal, but if it is fully compensated, only pH will be normal, other parameters will be abnormal. Now, if it is fully compensated, how will I decide whether it is acidosis or alkalosis? Based on the median cutoff. The median cutoff is 7.4. So if it is on this side of 7.4, we will call it as acidosis, or more than 7.4, we will call it as alkalosis. We are applying the 7.4 rule only when it is in the normal range. So here it is 7.38, means on this side. So it is acidosis. What type of acidosis? Fully compensated acidosis. Now we have to decide whether it is respiratory or metabolic. Clear? Okay. So step number 1 is to decide whether it is acidosis, alkalosis, and whether it is fully compensated or not. If ABG is not in the normal range, it is not fully compensated. Step number 2 is to decide whether it is respiratory versus metabolic. Respiratory versus metabolic. For that, what we are looking at? We are looking at a criteria called as ROMS or ROM, whichever you want to remember, which stands for respiratory opposite, metabolic same side or equal. Respiratory opposite, metabolic same side. This applies to looking at the pH and PCO2. So we have to look at the pH and PCO2 direction. Means whether pH is increased or decreased. PCO2 increased or decreased. If pH and PCO2 are following the same direction, it is metabolic disorder. If they are following the opposite direction, it is the respiratory disorder. So let us give some examples. So here we have a ABG1. Let me label it as ABG1. So here we have a pH which is 7.42, PCO2 which is 82, okay, and bicarbonate which is 6. Okay, one example. And I have another example now where pH is 7.2, PCO2 is 10, bicarbonate is 4. Okay, and we have a third example where pH is 7.38, PCO2 is 40, and bicarbonate is 24. Okay, let us say this as 10. Okay, now let us approach this. See the first ABG. Okay, is this ABG normal? First ABG, is it normal? I can't call it as normal. I know pH appears in the normal range, but PCO2 is low, bicarb is low. So ये normal नहीं है, right? First ABG can't be called as normal because it is abnormal. Now if it is abnormal, it has to be considered as fully compensated because pH is in the normal range, right? So this I am going to label it as fully compensated. At least that much is clear. Now I have to decide whether this abnormality is acidosis or alkalosis. For that I take 7.4 as the cutoff. It is on the higher side of 7.4, so we will take it as alkalosis. It is fully compensated alkalosis. What type, whether it is respiratory or metabolic, I will apply the ROMS principle. Right? What is happening to PCO2? Decreased. What is happening to pH? Increase. Right? So we are applying this ROMS to pH and PCO2. pH is more than 7.4. In fully compensated cases, 7.4 is the cutoff. So pH is increased. PCO2, 35 is the lower limit. It is less, decrease. Are they in the same direction? No, they are in the opposite direction, right? So whenever they are in the opposite direction, it is a respiratory disorder. So it is a fully compensated respiratory alkalosis. Fully compensated. So basically, patient is washing out a lot of carbon dioxide. And to compensate for that, kidney is also washing out a lot of bicarbonate. You are losing acids, kidney is making you lose bicarbonate so that pH is maintained. So compensation is happening and it is compensating the pH to back to normal range. Fully compensated respiratory alkalosis. The second example. So when I look at the second example, pH is clearly on the acidotic side, right? It is not fully compensated. This is acidosis. Now I have to decide whether it is respiratory or metabolic. What has happened to carbon dioxide? Decreased. pH also decreased. They are in the same direction. So according to the ROMS criteria, same means metabolic. So this patient is having metabolic acidosis. Right? Now I have to decide fully compensated. It is not. We are very clear because the pH is not back to normal range. We think of fully compensated only when pH is within normal range. But I have to decide whether partial compensation is happening or not. Right? How do we decide? In the metabolic disorder, right? What is the problem? Kidney is the problem. What is the function of kidney? Bicarbonate regulation. So if you say metabolic acidosis, basically means kidneys are not able to reabsorb the bicarbonate. So bicarbonate is low. To compensate for that, respiratory system has to wash out the acid. Is it doing? Of course it is doing because carbon dioxide is less. I have already told you that main abnormality and the compensation should follow the same direction. So if bicarbonate is decreasing, carbon dioxide should decrease, and indeed it is decreasing. So that means there is compensation happening. Metabolic problem being compensated by the respiratory system. Right here in this case, right? Metabolic system is being compensated by the respiratory system. So we'll call it as partially compensated metabolic acidosis. We can also rephrase it as saying that metabolic acidosis with respiratory compensation, but not fully compensated. Clear? Okay. Now third ABG. What do you think it is? Third one. Third one, pH is in the normal range. So it can be either normal or fully compensated. When I look at PCO2, it is normal. When I look at bicarb, it is normal. So everything is normal. So that means this patient is having a normal ABG. Normal ABG. That's clear. So I hope at least you will be able to identify whether it is acidosis, alkalosis, even if the pH is given normal, that is the fully compensated, using 7.4 as the cutoff. After that, using the ROMS criteria, you will be able to decide whether it is respiratory or metabolic. After that, remembering that if one is decreased, the other has to decrease, or if one is increased, the other has to increase, and you have to see whether that change is happening in that ABG. If that change is happening in that ABG, that means there is partial compensation. If that change is not happening, then it is uncompensated. Like, just to give you an example, right? Let me give you a fourth example. So here we have a patient with pH which is 7.2, okay, PCO2 which is 100 millimeters of mercury, and HCO3 which is 24 millimoles per liter. Now what is this? By following the principle, looking at the pH, it is acidosis, right? pH is decreased, PCO2 is increased. They are in the opposite direction. So that means this is respiratory acidosis. So what is the main problem? Carbon dioxide is the main problem. So to compensate for that, what bicarbonate should do? If carbon dioxide is increased, bicarbonate should also increase. Kidney should reabsorb more bicarbonate. But kidney is not doing it. Bicarbonate is still in the normal range. Suppose this was 35, that means kidney is trying to compensate. But here, no change in the bicarbonate. That means there is no compensation, right? So this is uncompensated respiratory acidosis. Okay. Now that completes kind of one level questions, but there is one more level which is particularly applicable to metabolic acidosis. So if it is metabolic acidosis, two things can happen. One, you can have metabolic acidosis means problem is in kidney, right? Metabolic system, not the respiratory system. What is happening? Kidneys are losing more bicarbonate, or body is producing more acids other than carbon dioxide. Like for example, lactic acidosis. Extra acid is produced in the body. That's why your pH is becoming acidotic, right? So now I want to know whether it is the loss of bicarbonate or whether it is the excess acid being added into the body, like lactic acidosis or salicylic acid poisoning. For that, anion gap helps us, right? So there is a formula for calculating the anion gap. This applies only to metabolic acidosis. So you will not apply this for metabolic alkalosis or respiratory acidosis, only for metabolic acidosis. What is this anion gap? Anion gap is the difference between measured anions and measured cations. So normally in the body we have perfect balance of anions and cations, because we can't have more negatively charged particles or more positively charged particles, because having that means basically electricity. The electrons will get transferred and you will have whole body as a battery. Of course, our body is not a battery. So we have perfect balance of anions and cations. But normally we do not measure all the anions and all the cations. We measure some anions commonly, some cations commonly, and the difference accounts for the unmeasured anions. So the gap between the two is anion gap. So what are the measured cations? Sodium is the main measured cation. Apart from that, calcium and potassium. There are many formulas which use potassium also, some formulas that do not use the potassium. Our exam generally tend to not use potassium, so we'll restrict to sodium. Sodium is our main cation, right? Minus. What are our main anions? Our main anions are chloride plus bicarbonate. These are our anions. The difference between these two is what we call as anion gap. Okay, how much is normal? So the normal anion gap is 8 to 12 millimoles per liter. That is the normal anion gap. If the gap is more than 12 when you apply this formula, then we will call it as high anion gap. In a patient with metabolic acidosis, we will call it as high anion gap metabolic acidosis. If the gap is less than 8, you can call it as low anion gap metabolic acidosis. You don't need to bother about low. We have to only focus on high and non-high. So if the anion gap is more than 12, we will call it as high anion gap metabolic acidosis or HAGMA. And if the anion gap is less than 12, we will call it as normal anion gap metabolic acidosis or the film actress NAGMA. Why this is important? If the anion gap is high, that means some extra acid is being added to body. It is not because of the impairment of bicarbonate regulation by the kidney, but some extra acid is added to the body. If the anion gap is normal, it is the impaired regulation of the bicarbonate. That's the main difference. So they will ask you the causes for high anion gap metabolic acidosis and normal anion gap metabolic acidosis. But before that, one example, and then you should be able to move forward, right? Let us take this ABG pH 2 as an example, where I will mention chloride as 100, okay, and sodium as 140. Now let us calculate the anion gap for this patient, right, for ABG 2. So anion gap for ABG 2, let us calculate it. This we have already agreed that it is partially compensated metabolic acidosis looking at pH and PCO2. Now sodium is 140, right? So anion gap will be 140 minus combination of chloride, which is 100, and bicarbonate, which is 4. So 100 plus 4. So this will turn out to be 140 minus 104. That will be 36. Correct me if I'm wrong. Of course, anion gap is more than 12. So we will count it as this patient is having high anion gap metabolic acidosis. High anion gap metabolic acidosis. That means in this patient, some extra acid is being added. So what conditions we can have high anion gap metabolic acidosis? So in your workbook, there is a mnemonic to remember high anion gap metabolic acidosis, which goes like this: mud piles, gold mark. Mud piles, gold mark. At least remember mud piles, where M stands for methanol. Okay. U stands for uremia, urea being added. So in CKD, we get metabolic acidosis because urea increasing, right? Then D stands for diabetic ketoacidosis. This is a very important thing we have to remember, right? One of the most common cause for high anion gap metabolic acidosis is diabetic ketoacidosis, where the keto acids or ketones are being added, right? Extra acid being added. P stands for the fenformin and paraaldehyde drugs. I stands for INH and iron. L stands for lactic acid. Again, very, very important, because whenever there is tissue hypoperfusion, like in shock, sepsis, lactic acid increases. So we will have lactic acidosis. Lactic acid is an extra acid being added. Okay. Then ethanol, ethylene glycol, and S stands for salicylic acid or salicylate. So salicylate poisoning often present with high anion gap metabolic acidosis. Then glycols like propylene glycol poisoning or ethylene glycol poisoning. Then 5-oxoproline, L for lactate, L lactate, D lactate, methanol, aspirin, that is salicylate, R for renal failure or uremia, or K for ketoacidosis, or like diabetic ketoacidosis, starvation ketoacidosis. Either remember mud piles or gold mark. Mud piles is a traditionally used mnemonic, better to remember. Okay. Now what causes the non-high anion gap metabolic acidosis? There is a mnemonic for it also. The normal anion gap metabolic acidosis, used part, where U stands for urinary diversion or ureteroenterostomy, where ureter connected to intestine because of some ureteric obstruction surgically. Fistulas in the small bowel, right? Extra chloride being added. That can be seen in especially patients with tuberculosis. Diarrhea, right? Important point to remember here. So what kind of metabolic acidosis you get in diarrhea? Normal anion gap metabolic acidosis. Pancreatic fistula, drugs like acetazolamide, renal tubular acidosis, tenofovir, and topiramate. So again, RTA is an important thing, diarrhea is an important thing for normal anion gap metabolic acidosis. I want you to by heart this because repeatedly they are asking questions on it. I hope whatever ABG question they are asking, whatever you have learned so far, based on that you will be able to answer. Of course, solve some MCQs to get a better gist of approach. So from acid-base disorders, next we go to the topic which is acute kidney injury. Basically, acute kidney injury, what kind of questions are asked? 3 questions are asked. First one, definition of AKI. They will make statements and then they will ask you which of them is not fit to be called as AKI or does not justify the diagnosis of acute kidney injury. Second one, KDIGO classification of AKI. Third one, types of AKI, pre-renal, renal, post-renal. Fourth one is differentiating between pre-renal and renal AKI. Okay, so we will begin with the definition of acute kidney injury. In any individual, if the creatinine level increases by more than or equal to 0.3 milligrams per deciliter within 48 hours, then we can call it as acute kidney injury. For example, let us say one individual's baseline creatinine is 1 milligrams per deciliter, and in a span of less than 48 hours, like tomorrow I have checked, like that is for 24 hours, right? Tomorrow I have checked and it has become 1.4 milligrams. Of course, it is increased by 0.4 milligrams in a time span less than 48 hours. Fits the criteria to be called as acute kidney injury. More than or equal to 3 milligrams per deciliter rise in creat within 48 hours. Second criteria is if creatinine increases by more than 1.5 times or 150% within 7 days. For example, this patient's creatinine is 1 milligram. Okay, to start with, normal value, his normal value. Within 48 hours, it has not crossed by more than 1.3 milligrams. But by 7 days, right, within 7 days, what I notice is it has become 1.5 times the previous value. One has become 1.5. If that happens, or if let us say starting it was 2, it has become 3, right? That is again 1.5. If it becomes 1.5 times increased over 7 days, we can also call it as acute kidney injury. The third one, very, very important for hospitalized patients, when urine output is less than 0.5 ml per kg. Normal urine output is more than 0.5 ml per kg. If it is less than that, per hour, I forgot to mention that, per hour, for 6 hours or more, then we will call it as acute kidney injury. Like let us say there is a 50 kg person, and in last 6 hours, right, 6 hours, total urine output is 120 ml. Can I call it as AKI? In 6 hours, total urine output that I see in the bag is 120 ml. So per hour, how much is his urine output? 20 ml, right? 20 ml for a 50 kg person. Is it more than 0.5 ml per kg or less? 0.5 ml per kg for a 50 kg person should be 25 ml, roughly half, right? So if for a 50 kg person, urine output is less than 25 ml per hour, sustained for 6 hours, means like say now, next 2 hours, I may not produce any urine, but after that I produce, and at the end of 6 hours, the balance is 0.5 ml per kg or more, then it is normal. But sustained for 6 hours, it is less than 25 ml per hour, then we will call it as acute kidney injury. Any one criteria met, you need not meet all the criteria, right? If any one of these is met, we will call it as acute kidney injury. Now, what can cause the acute kidney injury? Either there can be direct damage to the kidney, or there can be block to the outflow from the kidney, or kidneys receive the blood supply from the artery, there may be decreased blood supply. So if the problem is decreased blood supply to the kidney, we will call it as pre-renal AKI. If the kidneys itself are damaged, we will call it as intrinsic renal. And if there is a block to the outflow, either ureter, bladder, or urethra are blocked, then we will call it as post-renal. So AKI is classified into renal, pre-renal, and post-renal. Pre-renal. Renal is also called as intrinsic renal because problem is within the kidney, and then we have post-renal. Okay, the post-renal most common cause is obstruction. It could be because of renal calculi, or it could be because of cancer or tumors. Okay, for this, investigation of choice is pretty simple because if I do an ultrasound, I can see the stones or I can see the tumor. So it is imaging, it is the ultrasound, or you can do the CT scan of the KUB. Ultrasound is considered as the initial investigation, CT scan for the confirmatory investigation. So post-renal is not challenging to diagnose at all, right? You suspect, you send it to radiologist, he will give you the answer. Pre-renal and intrinsic renal are important for a clinician to differentiate. Pre-renal is due to what? Due to decreased blood flow to kidneys, due to decreased renal perfusion. So in what condition the renal perfusion can decrease? Decreased renal perfusion. Chandrapatra, of course, yes. Okay. So in what condition I can call it as, in what condition I can have decreased renal perfusion, right? First one is hypotension. If the BP is low, renal perfusion will decrease, right? Second one, renal artery stenosis. Renal artery stenosis, which is one of the important cause for secondary and resistant hypertension. Renal artery stenosis. These are important causes for pre-renal AKI. Intrinsic renal, where kidney itself is affected, you have multiple causes. So within kidney, we know that the structural and functional unit of kidney is what? Nephron, right? Nephron has parts. What are the parts of nephron? So nephron can be divided into a glomerulus, which is primarily capillary, and the tubules, right? You have proximal convoluted tubule, distal convoluted tubule, collecting tubules, collecting ducts. Or simple words, I can split the nephron into glomerulus and tubules. So damage to glomerulus will become a intrinsic renal problem. Damage to tubules will also become a intrinsic renal problem. Apart from that, all these nephrons are held together by connective tissue. Damage to that will also be a renal problem. So intrinsic renal will be further divided into glomerulonephritis, where glomeruli are affected. Second, tubules being affected, we will call it as acute tubular necrosis. Third, the connective tissue that is holding the nephrons being affected, we will call it as interstitial nephritis. Interstitial means connective tissue. Interstitial nephritis. Interstitial nephritis. Okay. Of course, there are also chronic tubular disorders, which is a separate entity. So here, of course, acute tubular necrosis, which is acute. Now, glomerulonephritis, you know that there are a lot of types: post-streptococcal glomerulonephritis, drug-induced glomerulonephritis, right? SLE causing glomerulonephritis. You have again various types there. It's a different entity. Interstitial nephritis, there's a few points. The glomerulonephritis you study in detail in pathology, different types. Interstitial nephritis, I want you to remember few points. What can cause inflammation of the connective tissue? The most common cause for interstitial nephritis is the drug allergies. Drug allergies, and within the drugs, the most common category of drugs are antibiotics, and within the antibiotics, most common are beta-lactam antibiotics. Beta-lactam antibiotics. So penicillin, after penicillin, cephalosporins, if someone develops rise in creatinine, it could be interstitial nephritis. What is the clue in the exam that this patient is suffering from interstitial nephritis? What is the clue in the exam that patient is suffering from glomerulonephritis? What is the clue in the exam that patient is suffering from interstitial nephritis? The clue on the question for interstitial nephritis is presence of eosinophils in the urine. Eosinophils in the urine. Because whenever you have allergy, eosinophils increase, right? So even interstitium is being attacked by eosinophils and they make their way into the urine. So if normally you don't see eosinophils in the urine, but you start seeing, you suspect drug-induced interstitial nephritis. Okay. What is the clue for glomerulonephritis? Yes. In glomerulonephritis, you can have hematuria or proteinuria. So you can have hematuria, proteinuria. Of course, you can have hematuria even in the post-renal, right? When you have stone moves, it causes injury, you will bleed. So how will I differentiate whether the glomerulonephritis that I'm talking about is indeed glomerulonephritis? This hematuria is glomerulonephritis and not because of post-renal obstruction. Remember, whenever you have post-renal, you will have frank blood with clots in the urine, right? But if it is glomerulonephritis, you will not have frank blood, rather you will have altered blood, giving rise to cola colored urine. That is one clue. More important is when I look under the microscope, when these RBCs penetrate through injured capillaries, right, they are getting dysmorphed. So you will have hematuria with dysmorphic RBCs. So whenever a question says you have hematuria with dysmorphic RBCs, it is talking about glomerulonephritis. Of course, you have glomerular disorders where you do not have hematuria, like minimal change disease, but those are not causing AKI, they cause chronic renal dysfunction. Nephrotic syndrome is not an acute disorder, right? It is a chronic disorder. So we're talking about AKI. Mostly AKI is caused by inflammatory glomerulonephritis, like post-streptococcal glomerulonephritis or drug-induced glomerulonephritis. In that case, there is going to be acute, and of course, you will have dysmorphic RBCs, and there are other clues, like you can have also RBC casts, right? You can have RBC casts. On the other hand, in case of pre-renal, of course, you will not have hematuria. You may not have proteinuria. And when you do the urine routine, you may not have any specific cast. You may have only increased hyaline normal cast. Okay. Acute tubular necrosis, what is the clue? The clue for acute tubular necrosis is you will have something called as muddy brown cast. Right? So remember that, muddy brown cast. Muddy brown cast. Basically what happens is in acute tubular necrosis, the hyaline cast which is normally formed in the tubule. Those who don't know, let me tell you what are casts. Basically in the renal tubules, the Tom Horsfall protein, the small molecular weight proteins, they sometimes precipitate and create a small mesh of Tom Horsfall protein. This mesh is what we call as the hyaline cast, which is normal. Hyaline casts are normal. Now on top of that, if there is some bleeding in the tubule, those RBCs will get attached to it. Then we will call it as RBC cast. If you have RBC cast, you can think of glomerulonephritis. It can happen in pyelonephritis also, but relatively, like whenever you think of RBC cast with dysmorphic RBCs, you will always think of glomerulonephritis. Now, instead of RBCs, if there is acute tubular necrosis, these tubules epithelial cells that are lining the tubules, they will be shed and they will impregnate the hyaline cast. So now this will become renal tubular epithelial cast or RTE cast. This cast, these tubular cells will degenerate, release lipofuscin pigment, giving the brown appearance. Then we will call it as muddy brown cast, right? Muddy brown cast, and other cast is renal tubular epithelial cast. If these casts are present, you will think of acute tubular necrosis. But these are pointers. The best way to differentiate between the acute tubular necrosis and pre-renal AKI is a repeatedly asked MCQ. Why it is repeatedly asked? Because glomerulonephritis cases are straightforward. Post-renal cases are straightforward. Interstitial cases are straightforward. But acute tubular necrosis, though, can be caused by various conditions. The most common cause for ATN is pre-renal itself. If you are not giving sufficient blood to kidneys, they stop functioning. So your creatinine starts going up. But after some time, if they are not getting sufficient blood, the tubules will go into necrosis. They start dying because they are not getting blood supply. So the most common cause for ATN is pre-renal AKI itself. So I need to know whether my patient is still at AKI pre-renal stage or whether he has gone into acute tubular necrosis. So how do we differentiate between the two? That's the question. So I have put a table for us to understand differentiating between pre-renal AKI and acute tubular necrosis. Only one point I want to tell. How kidneys function. If you have a basic idea, you don't have any confusion between the acute tubular necrosis and pre-renal AKI. How kidneys function? First, afferent arteriole brings the blood to the glomerulus, and from the glomerulus, maximum amount gets filtered except large molecular weight substances, and the rest of the blood goes out. Right? Now, from the filtration, this has your glucose, sodium, potassium, most of the things, small molecular weight substances. Whatever we need, we start reabsorbing, right? Glucose we need, we reabsorb with the help of SGLT2, right? We need sodium. There are multiple locations where sodium reabsorption happens. We want water also, so we will reabsorb water. Okay, I'm not specific about the tubules. I'm just giving you an idea. We will start reabsorbing water, sodium, glucose. Where the reabsorption happens? Tubules. Where the filtration happens? Filtration happens at the level of glomerulus. Okay. Now think about a condition where you have pre-renal AKI, means blood supply to the kidney has come down. In such cases, you want to lose more water out in urine or you want to reabsorb more? Because pre-renal AKI, blood supply decrease, means basically that happens when your BP is low, right? Renal artery stenosis also happens, but otherwise most common cause is low BP. In low BP, you want to lose more water or reabsorb more water? Of course, you want to reabsorb more water. So low BP usually activates two things, but most important one is the RAS. It also activates the vasopressin. Okay. So what RAS does? RAS has aldosterone. Aldosterone will increase sodium reabsorption, right? You will reabsorb more sodium. What vasopressin will do? Vasopressin will increase water reabsorption. So you're reabsorbing a lot of sodium, a lot of water. So what is happening to the urine that you're throwing out? Is it diluted or more concentrated? Is it diluted or more concentrated? Because you're absorbing a lot of water, right? Other solutes, the sodium you're reabsorbing, but are you reabsorbing potassium, calcium, right? Whatever other substances we are throwing out in urine, are we reabsorbing that in large quantities? No. So urine becomes more concentrated when you reabsorb a lot of water. So if you have pre-renal injury, you will have concentrated urine. Okay. But where is this reabsorption happening? At the level of tubules. So let us say I don't have pre-renal but tubular injury. Now can I reabsorb? My reabsorption is impaired. So I start losing more of water, more sodium. I start losing all of that in urine. So my urine now becomes more dilute because I'm losing lot of water. Urine is more dilute and I'm losing lot of sodium in urine. So these 2 points we have to remember. Whenever we have pre-renal, we tend to absorb water and sodium. When we have tubular, sodium absorption and water absorption, reabsorption happens at tubules. If there is damage, I lose water, I lose sodium. That's the point we have to remember. So as long as we remember this, our pre-renal AKI versus ATN is sorted. Like now look at this table. This table talks about the urine specific gravity. In pre-renal, because I'm reabsorbing water, urine is concentrated. So urine specific gravity will be high. In acute tubular necrosis, tubules are damaged. So I'm not able to reabsorb. I'm losing water. And because I'm losing water, my urine is dilute. So urine specific gravity will be low. All you have to remember is this, right? Pre-renal means concentrated urine and acute tubular necrosis means dilute urine. And pre-renal means low BP, aldosterone is into picture. So pre-renal means because you want to conserve most, right? You will have concentrated urine. Acute tubular means you have dilute urine because reabsorption is function of the tubules. First point. Okay. Second, urine sodium. Of course, pre-renal, aldosterone is coming to elevate your BP, right? So it is stimulating reabsorption of sodium. So you're losing less sodium in the urine. So your urine sodium will be low. In the acute tubular necrosis, tubules are damaged. We reabsorb sodium in the tubules. We're not able to reabsorb. So your urine sodium will be high, right? Third, most important thing when it comes to differentiating between pre-renal AKI and the acute tubular necrosis. This is the MCQ point. That is fractional excretion of sodium. Now, what is fractional excretion of sodium? I will teach you in simple words. You don't have to remember the formula and all. See, some amount of sodium goes to the glomerulus in the form of blood, right? After that, glomerulus filters, and after filtration, we reabsorb. And then some amount we lose in urine. So out of how much I gave to kidney, what percentage is being excreted in urine? So if I have pre-renal, of course I do not want to excrete much. I want to reabsorb because aldosterone is there. I want to have increase in the BP. So excretion is decreased. So fractional excretion of sodium will be less than 1% in pre-renal. Excretion is reduced. I want to reabsorb it, right? On the other hand, in acute tubular necrosis, reabsorption happens in tubules. Tubules are damaged. We are not able to reabsorb. I'm losing more sodium in the urine. So fractional excretion of sodium will be more than 2%. This is the single most important MCQ point when it comes to pre-renal versus acute tubular necrosis. So again, it's very simple, right? Pre-renal, I will reabsorb more, excrete less. So excretion is less. In acute tubular necrosis, I fail to reabsorb, so I excrete more. Same applies to excretion of urea. Urea is not important. FeNA is what you need to remember. Okay. If they ask you about urine osmolality, again simple. In pre-renal, concentrated urine means osmolality will be high. In acute tubular necrosis, dilute urine, so osmolality will be less. Okay. The additional points, not important. So as long as you remember this concentrated urine versus diluted urine, you will be able to answer the questions asking you to differentiate between pre-renal AKI and ATM. Additional things, they can ask you what kind of cast you get. You get hyaline cast, which is normal. In normal condition, you get the same cast in pre-renal AKI. Acute tubular necrosis, you have tubules epithelial cells going into the hyaline cast, causing what we call as epithelial cast. And if you see it after some time, there will be degeneration of the cells, lipofuscin released, and you can have what is called as muddy brown cast. Muddy brown cast. So that is about our acute kidney injury. What are the points to remember? The definition. creat increasing by more than or equal to 0.3 milligrams within 48 hours, or 1.5 times the base value within 7 days, or urine output less than 0.5 ml per kg for 6 hours or more. We forgot one more thing, is that there is a staging of the kidney injury AKI, which is called as KDIGO staging. Easy to remember it is. What it says is you have a creat criteria and urine output criteria, because you can follow any of them for the diagnosis. Of course, you have to apply that. Even if the creat is normal, if urine output is less, I would still call it as AKI, right? So if creatinine increases from 1.5 times to 1.9 times the baseline value, then it is stage 1. 2 to 2.9 times, it is stage 2. And equal to or more than 3 times increase from the baseline, then it will be called as stage 3. And any patient initiated on renal replacement therapy means dialysis, because after dialysis you cannot validate creatinine because the machine is taking care of it. So we will count it as stage 3 itself. And last one, GFR less than 35 ml. Normal GFR is more than 90. This is stage 1, 2. Easy to remember, right? 1.5 to 2. You can, like, this 1.9 and all, don't take it too much to your head. 1.5 to 2 times the baseline is stage 1. 2 to 3 times the baseline is stage 2. More than 3 times the baseline is stage 3. Urine output wise, less than 0.5 ml per kg per hour for 6 hours at least, then we call it as AKI. If it is 6 to 12 hours, it is stage 1. If it is for more than 12 hours, it is stage 2. And if it is less than 0.3 ml per kg per hour for more than 24 hours, or no output, anuric, for 12 hours, we will call it as stage 3. By heart this for easy remembrance in the exam. Now coming to the next topic, which is CKD, chronic kidney disease. What are asked in chronic kidney disease? They will ask you causes, staging, complications, and some questions about management. So causes wise, there are only 2-3 important points to remember. They will ask you what is the most common cause for CKD. What is the most common cause for CKD? They will ask you what is the second most common cause and what other causes are there. The most common cause for CKD, responsible for more than 60 to 70% of cases. In country like India, more than 80% of the cases, it is diabetes mellitus. Okay, this is responsible for more than 2/3 of cases. Second most, see, diabetes causes what is called as diabetic nephropathy. Nephropathy ultimately is CKD. Second most common is hypertensive nephropathy, that is hypertension. Both coming together is a deadly combination for your kidneys. What others can cause? Chronic glomerulonephritis, lupus nephritis, that is SLE, right? Drugs like phenacetin or paracetamol, long-term use causes papillary necrosis. It can also cause CKD. So drugs, these are common causes. MCQ wise, they will ask you what is the most common cause? Diabetes. Second most common, hypertension. Now, how do we stage CKD? Staging of CKD primarily takes into account 2 things. We are not looking at creatinine anymore when it comes to chronic kidney disease. We are looking at glomerular filtration rate and proteinuria. 2 things are taken into account. Okay, glomerular filtration rate and proteinuria. And every patient of CKD has 2 components to his staging. Means staging is not like just stage 1, stage 2. There is a GFR parameter and proteinuria parameter. Okay. So let us look at that. Based on the GFR, patient is staged into 5 stages, and we will label them as G1, G2, G3, G4, G5. So when the GFR is normal, that is more than or equal to 90 ml per 1.73 meter square body surface area, we will call it as G1, that is GFR stage 1. If it is 80 to 90, we will call it 60 to 89, we will call it as G2. Okay. When it is less than 60 but more than 30 to 60, we will call it as G3, which is further divided into G3A and B. If it is 45 to 59, it is G3A. 30 to 44, it is G3B. You need to by heart it, spend some time on it, like take out at least 2 more hours later after the class for by hearting some points that we have discussed here, like ABCD to score, the rheumatic fever diagnostic criteria, AKI definition, AKI staging, and CKD staging. When it is 15 to 30, that is 29, G4. And when it is less than 15 or started on dialysis, it will be considered as G5. G5. Okay, clear? Okay, this is GFR criteria. We will also look at patients' proteinuria, because once the kidneys are chronically damaged, we start losing protein, mainly albumin. So we look at the albumin levels. Either we can look at the albumin levels by measuring 24-hour urine albumin, or you can do urine albumin creat ratio. Take only one sample, calculate how much albumin is there and how much creatinine is there. Okay, for both the values are same. So if it is 30 milligrams of albumin in 24 hours of urine, or for 1 gram of creatinine, if there is 30 milligrams of albumin excreted, patient is having fairly normal protein loss like in the urine, so we'll call it as A1, albuminuria category A1. If it is 30 to 300 milligrams per gram of creatinine, or 30 to 300 milligrams of albumin per 24 hours of urine, then it is A2. And if it is more than 300 milligrams, then it is A3. So every patient will have two components to be staging, a G and A parameter, right? So let us see if we can get it right, because this is the kind of question that they have asked in FMGE as well as the last INICET. Story, GFR mentioned, albumin mentioned, which stage it is, right? So let me say I have a patient whose estimated GFR is, let me say, 50 ml per minute per 1.73 meter square body surface area, and his urine albumin creat ratio is 48 milligrams per gram. So which stage of CKD this patient is having, right? So of course, stage wise there should be a G stage and there should be a albuminuria stage. So in terms of the GFR stage, right, he belongs to this 45 to 59 category, right? So that is his staging. He should be belonging somewhere here. And with respect to albuminuria, it is more than 30, but definitely less than 300. 30 to 300, he belongs to A2. 30 to 300, he belongs to A2, right? So G wise, he is G3, more precisely what G3? G3A. G3A. Albuminuria wise, A2. So this patient stage is G3A, A2. That is the stage of CKD that this patient is having, right? Now, once that we have understood the stage, we will also talk a little bit about complications. What complications if somebody's kidney is not able to perform well? What are the functions of kidney? Excrete urine, so help in balancing the fluid in the body. So if your kidneys are dysfunctional, you are not able to excrete fluid. Fluid accumulates in the body. That is fluid overload or edema. Fluid overload or edema. Okay. Second, of course, we just discussed the acid-base disorders. Kidneys are playing an important role in regulating the acid base, right? Bicarbonate excretion or reabsorption is regulated by kidney. If there is damage, will not be able to regulate, we end up developing acidosis. And when kidney pathology is leading acidosis, it has to be called as metabolic, right? So it can cause metabolic acidosis. Then third, kidneys are important in excreting uremic toxins. So if I'm not able to excrete uremic toxins, I will develop uremia, right? Blood urea level increases. That this uremia leads to a lot of problems, right? What problems it can lead to? Uremia can cause encephalopathy. It can affect the brain. Uremia often leads to intractable vomiting, severe vomiting. Most of the patients of CKD, they cannot tolerate food. It's like, I can't eat, I will puke, right? Intractable nausea and vomiting. High urea also causes acute pericarditis. We call it as uremic pericarditis, right? Uremic pericarditis. Uremia also causes hemolysis. Hemolysis. You can have mild hemolytic anemia in patients with acidosis. It also causes pleuritis, peritonitis, long list of problems. Okay. Next, I need my kidneys for regulating potassium, right? If I'm not able to have a good kidney function, I will not be able to excrete potassium well. My blood potassium increases, so I can have hyperkalemia. I can have hyperkalemia. What hyperkalemia can lead to? hyperkalemia can indeed lead to ECG changes. What ECG changes we expect? We can expect to see tall T waves, tall tented T waves. Right? Apart from that, we can have something called as sine wave, that is wide QRS bradycardia, sine wave, and then we can have complete heart block as well as ventricular fibrillation. So these are all complications hyperkalemia can lead to, and thus it is one of the leading modality of death in patients with CKD, uncontrolled hyperkalemia. Okay. Next, what else we can see in a patient with CKD? We can have something called as CKD related mineral bone disease. CKD related mineral bone disease. Under that, we have osteitis fibrosa cystica. Fibrosa cystica, which you call as brown tumor. And you can also have adynamic bone disease. Adynamic bone disease. Okay. Then you can also have something called as anemia of CKD. Anemia of CKD. Why CKD happens in anemia? There are many causes. Most important reason is decreased erythropoietin production. Apart from that, I told you uremia causes severe nausea, vomiting. So their intake of food comes down. They don't eat iron-rich food. Iron absorption also gets decreased. Multiple causes, but the most important one is the erythropoietin production, because erythropoietin comes from kidneys. Now such patients, right? How would you manage? How would you manage a patient of CKD? Fluid overload, right? How do you manage fluid overload? For everything, the end solution is dialysis or the renal transplantation. But initially, how do you manage? You can try to treat it with diuretics, right? Which diuretics? Of course, you need high intensity diuretics or what you call as loop diuretics. Okay. Metabolic acidosis, how do you manage? By giving sodium bicarbonate. Ultimately, dialysis. Okay. How do you manage hyperkalemia? You have anti-hyperkalemia measures, right? What anti-hyperkalemia measures you have? What anti-hyperkalemia measures you have? You can give dextrose insulin infusion, because insulin shifts the potassium from extracellular compartment to intracellular compartment. Okay. What else I can give? I can give potassium binders, potassium binding regimens, which will bind the potassium and make you lose the potassium in stool, right? Then you have to also give potassium restricted diet, right? And I can also give calcium gluconate, which reduces the impact of potassium on the heart, because heart is going towards fatal arrhythmias. Calcium gluconate can protect against it to some extent. Again, hyperkalemia is not a absolute indication for dialysis. When all these measures fail, you can think of dialysis. CKD related mineral bone disease is primarily because of hyperphosphatemia, hypocalcemia. So if you give vitamin D supplementation and calcium, you will be able to treat it with, right? Okay. Now anemia of CKD, how do you treat? We can treat it with erythropoietin injections or darbepoetin, which is a recombinant form. We can give. Only one condition that cannot be handled conservatively, that is uremia. Once uremia causes symptoms, only dialysis can bring down the urea levels. There is no other methods. So it is an absolute indication for dialysis. Uremic symptoms are absolute indications for dialysis. Okay, so one last question they will ask is, which of the I missed Usnanas, hyperphosphatemia, hypocalcemia. These are the manifestations of traditional CKD. Whenever we try to treat it by reducing the phosphate intake and giving the calcium excess, that can cause parathormone suppression and that can cause adynamic bone disease. Okay. So basically, osteitis fibrosa cystica is condition where there is secondary increase in the parathyroid hormone. Adynamic bone disease is where there is decrease in the parathyroid hormone. Okay. Now, if they ask you between dialysis and renal transplantation, which has better mortality reduction, is dialysis makes you live longer or is it transplantation? The answer is always transplantation. Contrary to what film stars have told in Satyameva Jayate, movie show. Studies after studies are very clear that if you're transplanted, you live longer than if you're on dialysis. The simple reason for that is kidney does myriad functions which we even don't know as of now, right? We should have no shame in saying that we don't know. We are able to solve by dialysis some problems, like fluid we are able to remove, urea, creatinine we are able to remove, potassium we are able to remove. Not all the functions that kidney does we are not able to replicate in dialysis. Only kidney can replicate that function. And that is why renal transplantation is the best treatment for CKD. When it is not feasible, dialysis, or when it is taking time, dialysis. Okay. So that's about the CKD. The glomerulonephritis, most questions are from pathology, so please read them from the. Okay. So from here, we will move to some important rheumatic topics. We will start with SLE. Okay. Now SLE, what kind of questions are asked? One of the standard simple question is that a patient, female, middle age, presented with malar rash. Something basic related to that, what is it? Or those you will be able to answer, I'm very much sure. Sometimes they ask you to differentiate between cloasma, melasma, and SLE, malar rash, which you know that there is nasolabial fold sparing in the SLE. In other conditions, it may not be. So you kind of deal with that. More complex questions is what we will try to address. Okay. So SLE, as we know, is an autoimmune disorder. Of course, it affects, being autoimmune disorders, it affects females more than males. What age group? Typically the middle age group, which we also call it as reproductive age group. This age group is particularly prone for getting SLE. Okay. Now it is an autoimmune disorder, primarily antibody mediated, right? It is an antibody mediated autoimmune disorder. And I would not rather say antibody mediated. There are a lot of cytokines involved in causing the tissue damage, because there is formation of antibody and like immune complexes, antigen antibody form the complexes, and the complexes are getting deposited. So it is primarily an immune complex deposition disease. Immune complex deposition disease. Now the tissue inflammation, once the immune complexes get deposited in the tissues, body mounts an inflammation against the tissue where the immune complexes are deposited. And that inflammation is carried through an inflammatory cytokine. So the first thing we should know is what is the principal inflammatory cytokine involved in SLE. The principal inflammatory cytokine involved in SLE is interferon 1. Interferon 1 is the principal inflammatory cytokine. Why is this important? Because when we come to treatment, we have to target this inflammatory cytokine. If I block this, I will minimize the tissue inflammation. Disease comes under the control. So for that matter, what is the principal inflammatory cytokine in the scleroderma? That is the transforming growth factor beta. What is the principal inflammatory cytokine in the rheumatoid arthritis? Right? I will just mention it in a table somewhere. Inflammatory cytokines involved in rheumatological disorders. SLE, it is the interferon 1. In case of rheumatoid arthritis, it is the TNF alpha. That is why we use TNF alpha blocking drugs when it comes to rheumatoid arthritis. For scleroderma, it is the transforming growth factor beta. Unfortunately, we don't have drugs which can block transforming growth factor beta. That's why we do not have great treatment for the scleroderma as of now. Okay. Now, of course, SLE is a multi-system autoimmune disorder. So they will ask you what are the common manifestations of organ involvement, right? We will begin with, of course, skin is the most commonly affected organ, but you're aware of it, so I'm not talking too much about it. Most feared consequences are involvement of CVS and CNS. So we'll start with CVS first. In CVS, SLE affects all 3 layers. It affects all 3 layers. All 3 layers get affected. But what is most common affected? It is pericardium. So most common manifestation is pericarditis. SLE causes pericarditis. But SLE can also cause myocarditis and endocarditis. Of course, endocarditis is without infection, right? It is not infective endocarditis, it's sterile endocarditis. It is the interferon 1 and other inflammatory cytokines which are causing the inflammation. So this condition we call it as Liebman-Sachs endocarditis, as you know. In the recent times, there is a trend of asking questions where instead of giving a clinical story, they will talk about the vegetations on the biopsy specimens, the location of vegetations, and then they will ask you to decide whether it is SLE or rheumatic fever or infective endocarditis, because in all cases you can have vegetations. Whenever you think of endocarditis, you can have vegetations. So what you have to remember is, let us say that this is left atrium, this is left ventricle. Between this, I have mitral valve. Okay. Now, this mitral valve, when I see at the valve level, it is somewhat going to look like this, right? It is a bicuspid valve. It is a bicuspid valve, so it is going to look like this is one cusp. This is another cusp. Now, where the vegetations are formed. In case of the rheumatic fever and the infective endocarditis, usually vegetations are formed on the commissures where two leaflets close, right? The closure points, you will have the vegetations. On the other hand, the Liebman sacs, the vegetations are formed on both the surfaces, on the ventricular surface as well as the atrial surfaces. So if the vegetations are on both the sides, then you should think of SLE. Because SLE patient can also develop rheumatic fever, SLE patient can also develop infective endocarditis. But if vegetations are on the lining of two valves closure, it is called as commissures. Commissural lining, you should think of acute rheumatic fever or infective endocarditis. Right? Clear? So here you will have vegetations. This can be image-based questions also on both sides of valves. Of course, what is the most commonly affected valve? Mitral valve. Whenever you think of acute, you should think of mitral valve. Okay. What is the most common CNS manifestation? The most common CNS manifestation is cognitive dysfunction. Means patients' memory and other higher mental functions get affected. Patients with SLE, slowly they do become demented. So their memory and other higher mental functions are much poorer comparison to normal individual over time. That is the most common CNS manifestation. It can also affect nerves, cause neuropathy and all. No need to remember. Remember only what is most common. Now, respi, what it causes? The most common respiratory manifestation is pleuritis. Pleuritis means basically this interferon 1 that we are talking about and other cytokines, they cause what is called as serositis. Now, what do I mean by serositis? They will cause Husnan Naz. Good, very good. So, this inflammatory cytokines cause inflammation of serosal layers, means pericardium, pleural membrane, peritoneum, meninges. So, can SLE cause meningitis? Yes, it causes aseptic meningitis or sterile meningitis, sterile endocarditis, that is Liebman sacs. Clear? Okay. Respi, pleuritis, that is most common. But there is one more important complication. This is what they have asked in one of the previous exam. It is called as shrinking lung syndrome. And third, it also causes ILD. ILD. Now, what do I mean by shrinking lung syndrome? Shrinking lung syndrome is where the problem is not there in the lungs, the surrounding structures, the pleura, the connective tissue of the chest wall, the chest musculature, the fascia, they start getting fibrosed. So they're shrinking the lung without having lung pathology. So when you do lung HRCT, lung portion is normal, but the lung volumes are reduced. So here you will have in these patients decreased total lung capacity. You will have decreased forced vital capacity because lung volumes are shrunken, but normal lung parenchyma on imaging or CT scan. It can also cause ILD. Of course, ILD is fibrosis of the lung, right? So here again, ILD, you will have decrease in total lung capacity. You will have decrease in forced vital capacity, but lung parenchyma will show fibrosis, right? It will show ground glass opacities on the CT scan because of fibrosis. So this is the main difference. In both cases, lung volumes are reduced, but if parenchyma on the imaging appears normal, we will call it as shrinking lung syndrome. Okay. Now, hematological, what is the most common manifestation? The most common manifestation is anemia of chronic disease. SLE is a chronic disease, and of course, it will cause anemia of chronic disease. What is the classical description of anemia of chronic disease? Normocytic normochromic anemia, right? Apart from that, in SLE, B lymphocytes are hyperactive, so there is also increased risk of lymphomas. Increased risk of lymphomas. If they ask you what is most common, of course it is the anemia of chronic diseases, which is the most common hematological manifestation. So this is about the most common organ manifestations in SLE. Now that we know that, the question is, how do we diagnose, right? Of course, for diagnosis, we have a ACR-ULAR criteria, which is actually a classification criteria. Some of you may not be aware what is classification criteria and diagnostic criteria. Diagnosis, the classification criteria is primarily meant for selecting the cases for clinical trials. It is not meant for diagnosis. You can make the diagnosis of SLE even when patient does not meet the classification criteria. So that is why at FMG level, don't bother much about the classification criteria. Questions are mostly going to be asked around the antibodies. And what they ask, they will ask you what is most sensitive, most specific, and which antibody correlates with which organ manifestation. That is the hot MCQ zone as of now. So we will learn that. First is ANA, right? ANA is considered as the most sensitive. It is the most sensitive antibody, and because it is most sensitive, it is also considered as the screening test. Of course, screening test is generally the sensitive investigations. Screening test. Chandran Patra, yes. So ANA, there is a standardized assessment method, because remember, when you follow non-standardized methods, 5% of the general population may turn out positive for the ANA. So it has to be indirect immunofluorescence. That is the method of assessment, as Chandran Patra mentioned here. And the titer to say ANA is positive, it should be more than 1:80. 1:40, 5% of the population. Some of you may be also positive. Yeah. If you want to remember, you can write it down. Method recommended is indirect immunofluorescence, and the titer should be more than 1:80. Okay. Now, anti-DS DNA. I'll come back to that. Some point about anti-Smith. Anti-Smith is the most specific antibody. It is the most specific antibody. Okay. No, but we don't routinely do anti-Smith. We do ANA and anti-DS DNA. The question is, why anti-DS DNA? Well, anti-DS DNA is the second most sensitive and second most specific. So it gives you best of both worlds for confirmatory quality as well as screening quality it has, right? So this is the second most specific as well as it is the second most sensitive. It is also second most sensitive. So most specific is anti-Smith, second most is anti-DS DNA. Most sensitive is ANA, second most is anti-DS DNA. Not just that, its titers correlate with disease activity. Very important point. So ANA, we do it only at the time of diagnosis as a screening test or for the entry level test for the classification criteria. Anti-DS DNA, we do regularly because it correlates with the disease activity. If your anti-DS DNA is rising, your disease activity or inflammation is increasing. If it is decreasing, your disease activity is coming down. So it can be used to assess the response to treatment. It not only correlates with the disease activity, it also correlates with the risk of lupus nephritis. So if your anti-DS DNA is high, you have a high chance that your kidney will get affected. Lupus nephritis. So that's why, if you ask me what is the most important investigation, sir, I would say anti-DS DNA. Keep checking the titers regularly to understand whether they are responding to treatment and whether they are heading into lupus nephritis. Okay. What is the method used for the assessment of anti-DS DNA? Like for the ANA, we followed indirect immunofluorescence. For anti-DS DNA, we follow a method called as Crithidia immunofluorescence. It is called as Crithidia immunofluorescence. Crithidia immunofluorescence. If they ask, you should be able to answer. Okay. Now next we have something called as anti-SSA antibodies. Anti-SSA antibodies. What does this correlate with? Anti-SSA antibodies correlate with, they correlate with a very specific skin form of SLE called as subacute cutaneous lupus erythematosus. Whatever you see as malar rash is an acute rash. You go to sun, it comes. You stay indoors, it goes. There is also a subacute form which is called as subacute cutaneous lupus erythematosus. So if you have anti-SSA titers high, you can have subacute cutaneous lupus erythematosus. Okay. Second, it also correlates with risk of neonatal lupus. Neonatal lupus. So if there is a mother of SLE, mother with SLE, and she has high anti-SSA, there's chances that the newborn to this mother will develop neonatal lupus. This is a MCQ point that is repeatedly asked. Neonatal lupus. There's also a third thing this correlates with. You know, SLE is often associated with, if you ask me, sir, what endocrine manifestation I can expect, what exocrine manifestations I can expect. Endocrine manifestations, most cases in SLE are because of treatment, like we give steroids and immunosuppressant. They will impair the pancreatic function and they become diabetic usually because of steroids particularly. Exocrine manifestations, they can develop Sjogren syndrome. And presence of this antibody correlates with the Sjogren syndrome. This also correlates with increased risk of secondary Sjogren syndrome. Okay. Now, last one, anti-histone antibodies. Of course, they correlate with each and then patra. Yes, the neonatal lupus often results in the complete heart block in the newborns because of these antibodies. Antibodies primarily target AV node, so they block the AV nodal activity, and the kid can have third-degree AV block. So, these anti-histone antibodies correlate with drug-induced lupus. Drug-induced lupus. Good thing about drug-induced lupus is it is usually mild and the kidney involvement or lupus nephritis is less likely, and usually upon withdrawing the inflicting drug, the drug-induced lupus resolves. If it is non-drug-induced lupus, of course, it is a long-standing disease that we have to face. Now, when we have diagnosed someone as having SLE, how do we treat them? They will ask you what is the drug of choice, like one blanket prescription that you give for all patients. See, whether it is rheumatoid arthritis, SLE, there is always one drug which is given for all patients until and unless there is a contraindication. Upon that, if patient is not responding, you can think of having more specialized drugs. So, for example, rheumatoid arthritis, it is methotrexate, right? We give methotrexate for all patients with rheumatoid arthritis if there is no contraindication. Contraindication hai, so then we have other drugs like leflunomide we can think of, but otherwise methotrexate can be considered as a drug of choice. Non-responders, yes, we have other drugs like TNF-alpha blockers, interleukin-6 blockers. Similarly, for SLE, what is the drug? Yes, SLE, if they ask you drug of choice, it has to be hydroxychloroquine. Okay. From Pharmac, they will ask you what investigation you would do prior to starting hydroxychloroquine. What investigation one should do prior to starting hydroxychloroquine? What major side effects you anticipate with hydroxychloroquine? What major side effects? So remember, side effects of hydroxychloroquine. It causes retinopathy. It causes retinal injury. Okay. Second, it causes QT prolongation. And whenever there is QT prolongation, there is risk of Torsades de pointis, a form of ventricular tachycardia. Torsades de pointis. So that is why before initiating hydroxychloroquine for anyone, you have to check their retina, fundoscopy or retinoscopy, plus you have to do a ECG. These are bare minimum requirements before initiating hydroxychloroquine. Okay. Non-responders, you can add steroids, other immunosuppressants. But in last 7-8 years, we have started developing drugs against interferon 1. If I block this, I don't need steroids, right? So what is that drug? There is an anti-interferon 1 monoclonal antibody. That monoclonal antibody is called as anifrolumab. Anifrolumab. As you know, MAB stands for monoclonal antibody, which is an anti-interferon one monoclonal antibody, which is a new drug. You should be specifically aware about it. Easy to remember. It is interferon is included in its name. Anti-interferon, one monoclonal antibody. Okay. So that's about the SLE. Key points that we need to know, we have addressed. Now we will move to another important topic, which is scleroderma. I'm skipping the rheumatoid arthritis because it will be addressed in orthopedics, pretty much an important topic there. Scleroderma, another important rheumatological disorder. Kind of questions that are asked from this is SLE is about recognize or antibody and its correlation, right? Or something related to management of pharmacology. But when it comes to the scleroderma, the questions are differentiating between two subtypes of scleroderma, limited cutaneous and diffuse cutaneous. Okay. So what is scleroderma? It is again an autoimmune disorder primarily affecting skin and blood vessels, right? It is an autoimmune disorder affecting skin and blood vessels. So what it causes to blood vessels? To blood vessels, of course, it causes vasculitis. Okay. Now what it causes to skin? Fibrosis of the skin. That is why it is called as scleroderma. Sclerosis means fibrosis or damage of skin. So skin fibrosis and vasculitis. Now a patient of scleroderma is classified into two broad groups, the limited cutaneous and diffuse cutaneous. These two are not continuous. It's not like, okay, I have a patient with limited cutaneous, after 5 years he will become diffuse cutaneous, or 10 years he will become diffuse cutaneous. No. These act as two different categories. A limited cutaneous remains limited cutaneous. A diffuse cutaneous remains diffuse cutaneous. So first of all, what is this? When there is fibrosis of the skin, which is restricted to parts distal to elbow and distal to knee joint, we will call it as limited cutaneous. So when skin fibrosis is restricted to distal to elbow and knee joints, primarily affecting only the hands and the forearm and legs and the feet, then we will call it as limited cutaneous, right? When this extends proximal to elbow, proximal to knee joint, we will call it as diffuse cutaneous. So skin involvement restricted to parts distal to elbow in the upper limb, knee in the lower limb, we will call it as limited cutaneous. If skin involvement extending proximal to elbow and knee, then we will call it as diffuse cutaneous scleroderma. In both the cases, there will be involvement of face. Both the cases, whether it is diffuse cutaneous or limited cutaneous, face is invariably affected. Okay. So what clinical features or symptoms I would expect in these patients? So again, it is just like SLE, a multi-organ disorder. So we'll start with face. It affects face. It affects skin. Okay. It affects lungs. It affects the cardiovascular system. It affects the GIT. Okay. What happens to face? There is fibrosis of the facial skin, and what that leads to, because the skin is fibrosed, patient will have difficulty to open the mouth, right? Patient will have what is called as microstomia. Mouth opening becomes small and changes around the nose. The skin changes around the nose, leads to parrot beak appearance of the nose. Parrot beak nose. Okay. What it will cause to skin? Of course, fibrosis of the skin of the fingers leads to disappearance or obliteration of the fingers. Fingers start receding, right? So there can be receding fingers. But if they ask you what is the most common symptom of skin, that is the Raynaud's phenomenon. What is it? Whenever patient puts our hand in cold fluids or cold water or exposed to cold, it becomes extremely pale, more than normal. Normally also we see that our hands become little pale, more than normal, paler. They will experience some tingling sensations. This is what we call as Raynaud's phenomenon. Why is this happening? Because scleroderma is a vasculitic disorder. Blood vessels are damaged in scleroderma. And when exposed to cold, already damaged, already flow is less, and they further constrict, making much more profound pain. Okay, and why the skin is receding here? Receding because blood supply is cut because of vasculitis. So slowly there will be development of infarcts or necrotic tissue, and slowly the fingers will be lost. Okay, so that results in Raynaud's phenomenon, and because of the tightening of the skin, it leads to fixed flexion deformity of fingers. Fixed flexion deformity of fingers. Fixed flexion deformity of fingers, because the skin becomes more tight on the palmar side. So these fingers will be like that. Okay, then they can have loss of fingers. They can have fingertip infarcts. Fingertip infarcts. Okay, so important points here is the Raynaud's phenomenon, fingertip infarcts, loss of fingers. Okay, it can affect the heart also. What it causes to the heart in the cardiovascular system? Mainly it can cause pulmonary hypertension, because it is a vasculitic disorder. It is affecting blood vessels, so it also affects pulmonary vessels, so it causes pulmonary hypertension. What it causes to lungs? Fibrosis is not restricted to the skin alone, it also affects the lungs, so you can have interstitial lung disease. And what it causes to GIT? It can cause gastroesophageal reflux disease and gastric antral vascular ectasia or GAVE, which in endoscopy it is visible as what is called as watermelon stomach. Watermelon stomach. Watermelon appearance of the stomach on the endoscopy is seen in gastric antral vascular ectasia. So these are all systemic manifestations of scleroderma. Okay. Now what other MCQ points they will ask? Is there any difference between these two apart from involvement of skin? Yes. So please remember, limited cutaneous patients are at increased risk of developing what? Finger tip ulcers, and increased risk of developing pulmonary arterial hypertension. On the other hand, these patients of diffuse cutaneous, they are at increased risk of what? They are at increased risk of developing interstitial lung disease. Interstitial lung disease. Okay. And some of you might have heard about a term called as scleroderma renal crisis. I will discuss that in a bit. So these patients are associated with increased risk of scleroderma renal crisis. Scleroderma renal crisis. So if I have diffuse cutaneous, it is kind of protecting me against pulmonary hypertension. And if I have limited cutaneous, it is kind of protecting me against scleroderma renal crisis and ILD. So they are like two different entities. It's not like behaving like one disease. Now, how will I get to know whether my patient is having limited cutaneous or diffuse cutaneous? Of course, based on the involvement of skin. Okay. What else can help me? Antibodies. Of course, scleroderma is an antibody-mediated disorder, right? So what antibodies I'm going to get? So the antibodies that I get in the diffuse cutaneous and the limited cutaneous are different. So in limited cutaneous, I get anti-centromere antibodies. Anti-centromere antibodies. And the diffuse cutaneous, what antibody I get is anti-DNA topoisomerase 1 antibody. I will make it easy for you to remember. It's pretty easy. There's nothing complex to remember this. How do I remember? Well, think about it. Limited cutaneous, right? Concentrate on the word limited. In diffuse cutaneous, concentrate on the word diffuse. Now think about a cell, right? Inside the cell, we have nucleus. Where do I find the centromere? Where do I find the centromere? Can I find the centromere in the cytoplasm? No. Centromeres are part of your chromosome, right? Central part of the chromosome. So they will be found only inside the nucleus where chromosomes are there. That too only when cell is in a replicative phase, right? When otherwise all the chromatin is diffusely present. So you can remember that the centromere has limited presence inside a cell. Its presence is limited to nucleus, limited to a particular phase of cell cycle. It's not there throughout, right? So that way you can remember that limited cutaneous will have anticentromere. Centromere's presence is limited to nucleus. On the other hand, DNA. Can I say DNA is limited to nucleus? No, right? You have freely circulating DNA. Not just that. Inside the cytoplasm, I have mitochondria, and you know that inside mitochondria you have circular DNA. So DNA has more diffuse presence in the cell. Centromere has limited presence in the cell. So that way, for diffuse cutaneous, you can remember anti-DNA topoisomerase 1, and for limited cutaneous, anti-centromere antibody. So if I have scleroderma and if I see this antibody, I know my patient is prone to develop pulmonary hypertension. And if I have DNA topoisomerase, I know my patient is prone to develop ILD and scleroderma renal crisis. Okay. Now, what is can a scleroderma patient die? Yes. What is the most common cause of death in scleroderma patients? Most common cause of death in scleroderma patients is pulmonary hypertension. And the second most common cause of death is ILD. So pulmonary hypertension is the leading cause of death. So I am not happy to see that, okay, my patient is having diffuse cutaneous, limited cutaneous. It's all the more dangerous, right? Okay. Now we were talking about scleroderma renal crisis. Scleroderma renal crisis. What is it? Once upon a time, before understanding of this disease evolved, the scleroderma renal crisis was the most common cause of death in scleroderma patients. No longer it is. What is it? It is a hypertensive emergency. Hypertensive emergency. Basically, scleroderma is also a vasculitic disorder, right? So there is the vasculitis of renal vessels that results in increase in renin production. Increase in renin production leading to sudden increase in the BP, leading to organ dysfunction. That is when we call it as hypertensive emergency. Mostly kidney itself gets affected. So it is a high renin state. So high renin hypertensive emergency. BP is usually 200, 230, 240. High renin hypertensive emergency. It is the organ failure because of hypertension that was the reason for death. But now that we know that it is a high renin state, of course, we can treat it. How do we treat? What is the drug of choice? I need to reduce the impact of renin. So what I can use? Of course, I can use AC inhibitors or ARBs. So since the advent of AC inhibitors, ARBs, and a clear understanding of the pathophysiology of scleroderma renal crisis, it is no longer the most common cause for death. Now it is the pulmonary arterial hypertension. Okay. Now, how do we treat these patients? Yeah, I forgot to mention the most common cytokine in scleroderma. The principal cytokine is transforming growth factor beta. Transforming growth factor beta. Unfortunately, we haven't been able to catch hold of any drug which makes an impact in saving these patients as of now. In future, I don't know, maybe there are drugs which are in trial phase. So currently it is the symptomatic management. Manage individual symptoms separately. Like for example, if you have ILD, you can treat it like ILD with the antifibrotic agents. If you have pulmonary hypertension, it's pulmonary arterial hypertension, so you can give calcium channel blockers, or you can give bosentan, which is endothelin 1 receptor blocker. If you have GRD, you can give prokinetics, antacids, gastric antral vascular ectasia. There are laser treatments available. So it is primarily treating the manifestation. There's nothing specific we can offer to a patient with scleroderma. Okay. So from there, let's go to some important respiratory topic, asthma and COPD. I will not get into a very detailed discussion of these topics because of course these are very big topics. Each topic will take 2 hours. We'll focus on what is asked in the exams. 2 templates I have seen. Template number 1, there is interpretation of PFT to decide whether this patient is having asthma or COPD. Basically differentiating between obstructive disorders into subcategories: reversible obstruction and persistent obstruction. Second, deciding the management, initial management. A story, read the story and decide what kind of initial inhaler you will give. These are the two things we will focus on. So we'll start with asthma. Asthma is a obstructive airway disorder, as we know. It's an obstructive airway disorder characterized by what kind of obstruction? It is characterized by reversible obstruction. Reversible obstruction. COPD, there is obstruction, but it is not reversible. That is the key point you have to remember. So how do I diagnose? Of course, when there is the air obstruction, patient will present with cough, wheeze, shortness of breath. As I have told multiple times in other lessons, all respiratory disorders have standard symptoms. What is that? Cough, shortness of breath. If it is an obstructive disorder, this is an added symptom. So can I diagnose any disease just based on symptoms? Mostly I have to rely more on investigation. So clinical features wise, this patient will present with wheeze, cough, and shortness of breath. Typically, asthma attacks are more common in the early hours of the day, early morning hours. When such a patient comes, the investigation that I will do, right, diagnosis will be based on the PFT. So for diagnosis, investigation of choice is PFT. In the PFT, we are looking at two parameters. The first parameter we are looking at is the FVV1 by FVC ratio. Whenever there is obstruction, this ratio will be less than 0.7, which is suggestive of obstruction. That does not mean you have asthma. Only obstruction is proved. Now I have to prove that this is reversible. So after that, I have to do one more test, which is called as bronchodilator reversibility test. Basically, I have checked the patient's baseline FEV1. Now I will give a bronchodilator. I will give a bronchodilator and recheck FEV1. If FEV1 increases, that means obstruction is reversible. So as simple as that. So in this, what we do is patient baseline FEV1 is checked. After that, okay, let me write this procedure here. Bronchodilator reversibility test. What do we do? Patient's baseline FEV1 is already checked for calculation of FEV1 by FVC ratio. And then we will administer a short-acting beta agonist nebulization or inhaler, and we will recheck FEV1. This FEV1 we will call it as post-bronchodilator FEV1. Okay. This is the basic procedure. So if this post-bronchodilator FEV1 has increased by more than or equal to 12% compared to baseline value, then the obstruction is reversible and then it becomes asthma. So if this is showing more than or equal to 12% increase, then it is suggestive of reversible obstruction. And if it is less than 12% increase, it is suggestive of persistent or irreversible obstruction. Suggestive of persistent obstruction. So if I have persistent obstruction, I would think of COPD or bronchiectasis. If I have reversible obstruction, I will think of asthma. Asthma is the only thing that should come to your mind when you have reversible obstruction in the examination hall. For persistent obstruction, you can think of COPD and bronchiectasis. And when you have reversible obstruction, you have to think of asthma. This is how we interpret the BDR. So for asthma, it should show more than or equal to 12% increase in FEV1 or at least 200 ml increase in FEV1 after administration of the bronchodilator injury. Dr. Rambika Sharma, okay. Probably I will run out of time, but I will definitely share a small recording on the same channel. Okay, so now we know the diagnosis. We will quickly talk about management. Of course, management of asthma, we will give inhalers. What kind of inhalers? Inhalers will have steroids and bronchodilators. So the steroids do not relieve an asthma attack, they will reduce the inflammation and thus help you prevent a future attack. Asthma attack can be relieved by bronchodilators. And again, to relieve attack quickly, it has to be a short-acting beta agonist. And for a long-acting beta agonist, it will be again used for prevention. So the medication that we use can be called as reliever and maintenance medication. So reliever is usually a SABA, short-acting beta agonist, which we can quickly use to relieve an asthma attack. And to prevent whatever we use, we will call it as maintenance medication, which is usually a combination of long-acting beta agonist plus inhaled corticosteroids. This used to cause a lot of problems in the patient management because patients get confused. Which one should I use when I have an attack? Which one should I use on a daily basis for prevention? So what happens is, in few years back, a new drug was launched called formoterol. Formoterol gave me the benefit of SABA plus LABA. SABA is used for relief because its onset of action is quick. Now this formoterol also has quick onset. LABA is used for long-term maintenance of prevention because its duration of action is long. Now formoterol has long duration. Quick onset, long duration. So best of both worlds. Since then, we no longer prefer using SABA, LABA all separately. We prefer using formoterol along with steroid. So currently, the preferred medication when it comes to asthma is a combination of formoterol, because formoterol is a LABA but quick onset LABA or rapid onset LABA plus inhaled corticosteroid. Formoterol is rapid onset, so it is same as SABA, but duration of onset is long, so it is LABA as well. The only question we have to address is, should I give it on a daily basis for prevention, or should I ask the patient to take only when asthma attack happens? Because not all patients of asthma are same. Some have very high frequency, every day go through asthma. There's some patients who are like once in 3 months, 4 months, one attack happens. So for those where asthma attacks are less frequent, you can ask them to take as and when required. But for those where there is more frequent, we need to ask them to take on a daily basis for prevention. How do I decide? So according to current GINA guidelines, all you have to do is read the question and see whether patient is having asthma attacks for more than 4 days per week, means 5 days, 6 days or 7 days per week he is having asthma, or he is having even a single nighttime asthma. This is the information I need to look into a question. If my patient is having, let us say there is a patient who says that, sir, almost every day, weekly 1 or 2 days I may not have asthma, but otherwise almost every day I have asthma. Right? Simple. Or a patient says that, sir, daytime maybe once in 2 weeks or something, but every week at least one night I get up with asthma, one nocturnal asthma attack. If any of these two circumstances, the answer is yes. Such patients require maintenance treatment. They have to take regular inhaler. And that maintenance treatment is called as MART. Why is it called as MART? MART refers for maintenance and reliever treatment. Why are we calling it as maintenance and reliever treatment? Because the same inhaler can be used for relief because onset of action is rapid. Same inhaler can be used for maintenance because duration of action is long. So all rolled into one, we call it as MART. No longer reliever versus maintenance, combined into one, MART. But patient requires regular if attack frequency is high. If attack frequency is low, like once in a week, daytime, nighttime, तो नहीं होता है. In such cases, patient can take as and when required reliever medication. He can prefer using the same combination or any other SABA to relieve. Now the question is, when I'm starting the MART, when attack frequency is more than 4 days per week or more than one nocturnal attack per week. In such cases, the steroid dose, whether I should keep it low or medium is the question. Of course, that depends on patient's FEV1. If FEV1 is more than 30%, okay, theek tak hai. Normally, of course, more than 80% predicted, but at least 30% plus. We will start with low dose of the MART. Steroid will be low dose. But if the FEV1 is very low, then I have to start with the medium dose. That's the starting point. Right, so regular inhaler with a lower dose of steroid if FEV1 is more than 30%, and if it is less than 30%, medium dose of steroid. If attack frequency is less, then no regular inhalers, only as and when required inhalers. This is the initial treatment. Once I have the initial treatment done, if patient does not respond, Then I have choices like I can go from as and when to low dose, from low dose to medium dose, from medium dose to high dose, and other monoclonal antibodies like dupilumab, mepolizumab. I will share a list of those antibodies later. Okay. So that is about asthma. Questions are mostly asked about making the initial choice. So I want you to by heart this flowchart and interpreting the PFT to decide whether it is obstruction or not, and if it is obstruction, whether it is reversible or not, to call it as asthma or COPD. Okay. Next topic we have is COPD. Now, what questions are asked in the COPD? I will just take 3 or 4 minutes more. I will complete the management aspect of COPD and I will pass it on to Dr. Jazeer. Okay. So COPD. COPD is an obstructive disorder, of course, and it is chronic. It's an obstructive disorder which is chronic, characterized by what? Persistent obstruction. Persistent obstruction. So when I do FEV1 by FVC, right? When I do FEV1 by FVC, it will be of course less than 0.7, but BDR is expected to show less than 12% increase in FEV1. Okay, because it is persistent obstruction. Obstruction doesn't relieve, so I don't get to see significant improvement in the FEV1. As you know, COPD has 2 subtypes, right? What are the subtypes? Chronic bronchitis and emphysema. Emphysema and chronic bronchitis. How do you define chronic bronchitis? Chronic bronchitis is defined as productive cough for more than or equal to 3 months per year for more than or equal to 2 consecutive years. And please remember, chronic bronchitis patients are also known as blue bloaters because these patients have cyanosis. Emphysema is defined as irreversible dilatation of acini. Irreversible dilatation of acini. Emphysema leads to certain clinical findings like barrel-shaped chest, pursed lip breathing, and when it is severe, it leads to something called as Hoover's sign, which is nothing but intercostal indrawing during inspiration, called as Hoover's sign. There can be hyperpigmentation of the skin on the thighs because these patients have this tripod position, that is called as Dahl's sign. This can be image-based question. You can go through the notes. Current template of MCQs is making the initial management categorization of the COPD, right? So whenever we have a patient with COPD, he has to be put into category A, B or E, 3 categories, A, B or E. How do I decide? Read the MCQ. What you have to concentrate on is in 1 year's history, in last 1 year, whether patient had more than or equal to 2 moderate exacerbation or more than or equal to 1 severe exacerbation. Exacerbation means worsening of symptoms, and when do you call it as severe? When it required admission. So in last 1 year, if patient had 2 hospital visits or 1 admission, yes, then patient will go into category E. E stands for exacerbation predominant category, right? This story is of exacerbation. Such patients will be treated with a combination of long-acting anti-muscarinic agents plus long-acting beta agonist. Category E for exacerbation, more than or equal to 2 moderate or more than or equal to 1 severe in last 1 year. Severe means admission. Moderate means hospital visits. If no, okay, 2 moderate nahi, no hospitalization, then the patient can't be into category E. He has to be in category A or B. How do I decide between A or B? I have to look at the shortness of breath of the patient. Of course, this patient does not have exacerbation as main problem. Exacerbation main problem, go into category E. If exacerbation is not the main problem, then we will look at the degree of shortness of breath with a scale called as Modified Medical Research Council. If this grade can go from 0 to 4. So if it is 0 to 1, patient will go into category A. And if it is 2 or more than 2, like 2, 3, 4, patient will go into category B. Now, what is the main problem in this category B patient? Exacerbation is not the main problem. His main problem is severity of dyspnea. Again, we will treat it with the combination medication. But when you look at category A, exacerbation was not a main problem. Severity of dyspnea is also not the main problem. So it is a mild case. Such patients, we don't need to give two medications. We will treat them with either LAMA or LABA. So summarizing, category A, LAMA or LABA. B and E, both combination. E is where exacerbations are more. B is where shortness of breath is more. A is where both are mild. That's about the COPD. So with this, I will sign off now. I will try to address the request that you made, tuberculosis, pleural effusion, and ECG in one more session. I will not take more than 30-40 minutes. But now Dr. Jazeer is waiting on the other side. So I will pass the baton to him. And of course, more than medicine, then the next few hours that you are spending with dermat is more important, because in medicine, we can only touch the key points. Medicine is very vast, and the examiner has choice to ask questions from anything. But subjects like dermat, they're extremely high yield. So whatever time you're going to spend will give you more marks than whatever we have spent in the last 4 hours. So stay focused. I will pass the baton to Dr. Jajir. I'll see you in the next class. Okay.
Very good afternoon, all of you. I hope all of you are having a great session. So, welcome back to FMGE Decoded. So, I'm Dr. Jazeer, your dermatology faculty. Uh, can you just let me know in the chat box if I'm audible as well as my screen is visible? So, hi Adil, Kanish Chowdhury. Very good afternoon. So, I hope your preparations are going fine, isn't it? So, the last few days, I think this is the fifth day of our FMG Decoded session, and I hope all of you are in track, isn't it? So, if everything is fine, yeah, thank you so much for responding. So, if everything is fine, we will just get it started. So, you must have done multiple subjects all these days. So in today's session, so what I'll be doing is we have a workbook, which I'm sure that all of you must have got it from by this time from our Telegram group. And just I'll be just following the same workbook today for the notes as well. And after completion of the classes, as usual, I'll be sharing you the annotated PDF as well. Clear? So have you done some revision of dermatology? The subject is already done or not, so that we can understand whether we can go fast or should I go slow. Yeah, by this time you have done the subject, isn't it? And what I'll do is in today's session, in this workbook that we have, it's completely images because in dermatology, we do expect image-based questions more, isn't it? So wherever possible, I'll just show you the image. Please try to make out a diagnosis by yourself. So even though this is going to be a lecture, just try to be more interactive and then we'll see one by one what all things you will have to remember about these images. Clear? So chalo. So let's start now with all of your permission. So yeah, revision. Yeah. So now let's begin with dermatology. Now, yes. Now, what is this first image that you're seeing in the screen right now? So this is a very important image in the basics of dermatology, isn't it? So what is this? You can see that there are some cells here which looks in a very typical shape, isn't it? It looks like a tennis racket. Can somebody tell me? Yeah, Kanish Chowdhury is telling that this is Langerhans cells. So I completely agree. So this first image that we will discuss today, this is about Langerhans cells. So we already know that Langerhans cells, these are antigen presenting cells, isn't it? Now, in which layer of the epidermis do we see these Langerhans cells? Is it stratum corneum, lucidum, granulosum, spinosum, yeah, basal? Yeah. So we can see them in the stratum spinosum. So we can see them in the stratum spinosum. Now this image that you can see right now, is it a normal micrographic image? Is it a normal microscopic image? Yeah, is it some other microscopy? Excellent. So all of you are answering. So yeah, many of you are saying this looks like a tennis racket cells. Yes, this one is actually not a normal microscopy. So please remember this very important point that this is an electron microscopy. So this is an electron microscopic image. Okay, this is not a normal microscopy, it is an electron microscopy. And what is the name of these kind of cells? So they look like tennis racket. They look like tennis racket cells. Or there is one more name for the cells. It starts with the letter B. Can you make a guess? Can you just let me know in the chat box? What is this B? So this is also called as, yeah, very good. Factor Leiden. This is called as Birbeck granules. They are also called as Birbeck granules. So the important point that I would like to emphasize with this first image is that this is an electron microscopic finding of the Langerhans cells, and they are called as tennis racket cells, or they are also called as the Birbeck granules. So now let's move on with the next image. So moving on with the next image, what do you see in this image right now? There is an instrument which can be seen here. So this instrument, once you put it on over the skin, you can see that the skin is giving a typical fluorescence, a whitish fluorescence and all can be seen. So what is the name of this investigation? So if they ask you what is the name of this instrument, your answer should be, yes, Vasundhara, this is called as a Woods lamp. This is called as a Woods lamp. So what is happening in a Woods lamp? When you turn on a Woods lamp on a diseased skin, you can see different colors of fluorescence. Now, what was asked in the last FMG exam was, what is the color of fluorescence which can be seen in erythrasma? So what is the answer? It is going to be coral red fluorescence. So it is very important that you learn this table. So what is the table? So let us do it together right now. So in Tinea capitis, which is a fungal infection of the scalp, you can see a greenish fluorescence. Whereas there is another fungal infection by the name Pityriasis versicolor. So in versicolor, what is the color you can see? You can see either a pale yellow, you can see a pale yellow or apple green fluorescence. Whereas in vitiligo, as you know, in vitiligo you get a deep pigmented skin, correct hai? So wo white color skin mein again you get a whitish fluorescence in vitiligo as well as in tuberous sclerosis. Whereas in porphyria cutaneous tarda we can get a red or a pink color fluorescence. Now ab ye bolo ki porphyria cutaneous tarda, so in this condition, are we going to get a Woods lamp finding over the skin or somewhere else? Who can answer this question? Where do we find this Woods lamp finding in Porphyria cutaneous tarda? I'll give you a hint. This is not seen in the skin. Then from where do we find this pink or a reddish colored fluorescence? Anybody who can answer in the chat box? Just give it a try. There's no problem even if you make a mistake now. So please remember that you can find this one over in the urine. So when you collect the urine of a patient with porphyria cutaneous tarda, and when you turn on the Woods lamp over the urine, you can see a red color or a pinkish fluorescence So that is about Woods lamp. So it's very, very important that you remember everything in this table. Okay, they always ask you, this is the disease, what is the expected Woods lamp finding? What is the expected Woods lamp finding? So with your permission, let me just go to the next one. Now, can anybody tell me what is the investigation that is being shown in this image? So there is some patient in whom we are just scraping over the skin and we are collecting those scraping over a glass slide. Now, what is this? Yeah, again, Vasundhara is answering it right. So this is an examination which is called as KOH test. Now, in which kind of diseases are we going to do a KOH test? Are we going to do a KOH, potassium hydroxide test, when you suspect any bacterial infection or when you suspect any fungal infection? So the answer is here itself. Yes, Adil. So here, what is happening is the KOH test is the investigation of choice in suspected fungal infections. Fungal infection. So for your exam, if you get any image where you are suspecting any fungal infection, जैसे ringworm infection हो गया, that is Tinea corporis. So any infection fungal, then the first investigation that you're supposed to do is going to be a KOH test. So what is KOH? Potassium hydroxide test. Now in potassium hydroxide test also, you need to remember about what are the findings in a potassium hydroxide test. जैसे dermatophytosis. Can anybody tell me the examples of dermatophytosis in the chat box? Dermatophytosis का examples. I'll just give you a clue कि dermatophytosis we name according to the site of the lesion. जैसे if there is a fungal infection of the scalp, we call it as Tinea capitis. Over the face, we call it as Tinea faciae. Over the nails, we call it as Tinea unguum. So depending upon the site of the lesion, we call it as Tinea XYZ, isn't it? So here, whenever there is dermatophytosis, we can see a fungal hyphae. Whereas in which kind of disease can you see a pseudo hyphae? Pseudo hyphae, please remember, that is seen in candidiasis. Pseudo hyphae, candidiasis. And this is a very, very important KOH finding which was asked in your exam. Now, where do you find hyphae as well as spores, which is compared to banana and grapes or spaghetti and meatballs appearance that is seen in Pityriasis versicolor. So these are the three very, very important KOH finding which you need to remember for your exam. Okay? So the only point that I have conveyed here is In dermatophytosis, you find hyphae. Where do you find pseudohyphae? Pseudohyphae is seen in candidiasis. And where do you find hyphae as well as spores? So both of them together, we can see them in Pityriasis versicolor. Pityriasis versicolor is also called as tinea versicolor. So both are the same. Okay, on the day of the exam, if you see tinea versicolor या फिर pityriasis versicolor, both are going to mean the same disease only, and this is what we can see in a KOH finding. Now just see this image. Now this image, I'll just zoom in for you. So in this image, what is this? So can anybody answer to me in the chat box? What do we see in this image? Is it a hyphae, or is it a pseudo hyphae, or is it hyphae as well as spores? Anyone in the chat box, please? Yeah, so all these things, these balls together, they are representing the spores, and whereas those lengthy ones, these are going to be the hyphae. So this is hyphae plus spores. So together, which disease? Yes, so this is going to be tinea versicolor. Tinea versicolor. So this is a KOH image of a tinea versicolor. Clear? So shall I proceed to the next one? Very good, Harsh, and very good, Vasundhara. Both of you are getting it right. Excellent. So now let's go to the next image. अब ये कौन सा investigation है? Now in this investigation, what is being done? I'll just zoom this image for you. So this is probably a patient who got a vesicle. So vesicle कहाँ पे है? It is just below the lips. Now over these vesicles, now we are just trying to de-roof a vesicle. मतलब vesicle को open कर रहे हैं, and whatever is the content of the vesicle, we are going to collect it in a glass slide. Now can anybody tell me what is the name of this test? Vesicle. Yeah, excellent. So I'm getting the answers in the chat box. Harsh, Vasundhara, all of you are answering. So this is called as a Zang smear. So this is called as a Zang smear. Now, when do we do a Zang smear? Zang smear is done in any vesiculobullous diseases. So whenever you find that a patient is having either a vesicle या फिर bulla, in such disease, in such cases, what do? We do an investigation which is called as a Zang smear. So in Zang smear, what happens is there are two basic findings in the Zang smear. Now let us see the findings in a Zang smear now. Now there are two images now. Now both these images are seen in a Zang smear. Now see the first one. So in this first one, you can see that there are rounded cells here. And there is a rounded cells, and the nucleus, is it small or big? We find a very large nucleus as well. So rounded cells with a large nucleus, this is called as acantholytic cells. Acantholytic cells. So the question is, in which kind of diseases can we see acantholytic cells? Yeah, so acantholytic cells can be seen in pemphigus group of diseases. Pemphigus group of diseases. Whereas, where do you find this kind of an image? Now, what is the name of this cell? Probably you have done this in your pathology and all. So what is the name of this cell? This is called as MNG cells. So what is the full form of an MNG cells? Anybody? In the chat box, what is the full form of a MNG cells? So these MNG cells means they are multi-nucleated giant cells. So please try to remember, multi-nucleated giant cells can be seen in infections. कौन सा infection? Viral infections. जैसे herpes simplex हो गया, varicella हो गया, या फिर herpes zoster. So in all these kind of infections, we see multi-nucleated giant cells. Now, in the last FMG exam, please concentrate here carefully. In the last exam, they gave you a image like this. Okay, the image was not similar. It was like multiple vesicles below the lips. They gave you an image like this, and they asked you, what is the Zang smear finding? What is the answer? If there is multiple vesicles over the lips, it is going to be herpes simplex virus, isn't it? Herpes labialis. So in such cases, the Zang smear finding is going to be multinucleated giant cells. Okay, multinucleated giant cells. Is it clear? So if that is clear, please remember these two very important findings of a Zhang smear. एक हो गया acantholytic cells and the second one is going to be multinucleated giant cells. So now let's go to the next one. So moving on to the next one, just see this image now, all of you, just see this image. Tell me what is the name of the test here. So it's a very simple thing that the physician has taken a glass slide and he has just pressed this glass slide over the skin. Now, what is the name of this test? Very simple test in dermatology, but it is important because it helps us to differentiate multiple findings. So what is the name of this test? This is called as, anybody in the chat box? So this test, it starts with D. Okay. So this one is called as diascopy. So this is called as a diascopy. So what do we do in a diascopy? So please remember, what do we do in a diascopy? We press over the skin. We press over the skin with a glass slide. We press over the skin with a glass slide. Yes, Kanish, we are just checking for blanching here. Anna? So in this image, just concentrate in the first image now, all of you. So in this first image, what has happened? A patient is coming to you with a red color skin, erythematous skin. So in this erythematous skin, you can see that there is some area. Once you press, there is this thing called as blanching. So this is called as blanching. So once you take off this glass slide, what will happen? The erythema or the redness will come back. Okay, so this is blanching, whereas in this image there is no change. जो भी erythema या फिर reddish discoloration था, that is still there without any change. So this one we can call whenever there is blanching, we call it as erythema, and when there is no blanching, we can call it as petechiae or purpura. So the takeaway message is that in diascopy, what happens? There is blanching, whereas in petechiae or in purpura, there is no blanching. So once again, what do we do is, we are going to learn this table now. So what is this table? These are the diascopy finding. These are the diascopy finding. So when we press over the skin with a glass slide, what do we see? Erythema will always blanch. Okay, this is blanching. Erythema always blanches. Whereas if there is some extravasation of the blood, जैसे blood vessels से blood has come out, in such cases, petechiae, purpura, ecchymosis में there is no blanching. There is no blanching. Whereas there are some more examples of where you use a diascopy. One is lupus vulgaris. How many of you know what is lupus vulgaris? Any idea what is lupus vulgaris? Lupus vulgaris means this is TB of the skin. Okay, cutaneous tuberculosis ko what do we call? We call it as lupus vulgaris. In lupus vulgaris, we can see apple jelly nodules. So there is some inconsistency, isn't it? So this is compared to a apple jelly nodules. The next one is sarcoidosis. In the sarcoidosis of the skin, it will give a sago grain appearance. Sabudan, isn't it? Sago grain appearance. And the last one, there are two more conditions which you can remember. जैसे nevus depigmentosis हो गया या फिर nevus anemicus. Nevus depigmentosis. See the name, pigmentosis. It is a pigmentary defect. Since it is a pigmentary defect, there will be no blanching. Whereas nevus anemicus, this is a capillary defect. So since it is a capillary defect, what will happen? There would be some blanching. So that is all about the various findings in diascopy. Now all of you, we don't have much time for your exam, so it is very important that we understand the concept. Okay, if there is any doubt, you can always ask me in the chat box. Hemanta, scrofuloderma is also an example of cutaneous tuberculosis. Now you see this word, right? This word called vulgaris. So what is the meaning of vulgaris? Does it mean that it look vulgar? बिल्कुल नहीं, isn't it? Vulgaris का मतलब है it is the most common. So the most common type of tuberculosis of the skin is lupus vulgaris. ठीक है, the most common type of vitiligo is vitiligo vulgaris. Most common type of psoriasis is psoriasis vulgaris. तो वो हो गया. And it's a very good doubt कि what is scrofuloderma. So just like what Hemant has asked, just let me just write it down for you. Scrofuloderma, scrofuloderma is the most common type of cutaneous tuberculosis in children. So this is the most common type of cutaneous tuberculosis in children. So just now when you had medicine revision, you must have noticed कि medicine हो या फिर pediatrics हो. In children, what happens if a child comes to you with a enlarged lymph node, especially over the which area, especially over the neck region, then what happened, this is called as scrofuloderma. This is called as scrofuloderma. Is it clear? So now let's move to the next one. Now we are moving to this next one, which is called as skin lines. Now how many different types of skin lines do you know? So how many types of skin lines do you know? So I'll just zoom this image first. This is the first line that we are going to discuss today. Yes, very good, Hemant. It is called as a Blaschko line. Now, if you get an image like this and the examiner asks you, identify the types of line. So the easiest way how you can identify this line is, now all of you just concentrate on this image. Can you see that there is some V-shaped pattern here? So you see this V-shaped pattern over the skin, that is going to be Blaschko lines. That is the easiest way to identify. So this is going to be Blaschko lines whenever you find a V-shaped pattern over the skin. Okay? Now, in which diseases can you see some skin lesion along a Blaschko line? So you just try to remember three diseases. Let's say high. Okay, what is this high? H stands for hypomelanosis of Ito. Okay, I stands for incontinentia pigmenti and E stands for epidermal nevus. So remember these three: hypomelanosis of Ito, incontinentia pigmenti, epidermal nevus. These are the three diseases where the skin lesions are going to follow a Blaschko lines. Okay, have you heard about any other lines? जैसे surgery में. So when Sandeep sir had done surgery with you, so in surgery, is there any important lines over the skin? जैसे Blaschko lines हो गया. Similarly, is there any lines which is important in surgery? Now this is the image for you. And I really would prefer to get an answer in the chat box. So what is this lines which you can see, which is very important in surgery? Excellent. So this is called as Langer's lines. So this is Langer's lines. Because in surgery, how do we give the incision? Yeah, all of you getting it right. Excellent. So this is called as Langer's lines. Because imagine कि a patient is developing an abscess somewhere here. Okay, what is abscess? Matlab, there is some pus underneath the skin. And now you are having a blade in your hand. You are going to obviously do a incision and drainage. So when you're going to do an incision and drainage, is there any rule? Can you just give an incision like this? या फिर you would like to give an incision parallel to the Langer's line. दो options है आपके पास. जैसे you can give an incision perpendicular to the Langer's line या फिर आप incision दे सकते हो parallelly to the Langer's line. Which one do you prefer? Yes, factor 5 Leiden is giving it right. So incision is given parallel to the Langer's lines. Parallel to Langer's lines. Now, why do we want to give it parallel? Because we don't want too much of tension against the direction of the skin, right? So when you give an incision which is going to be parallel to the Langer's line, wound healing is going to be much more quicker. And then there is very less chances of scarring as well. Less chance of scarring. So better wound healing and less chances of scarring. That is why we give an incision parallel to the Langer's line. Parallel to the Langer's line. So please remember these two lines over the skin. Is that clear? Shall I proceed to the next one? So I'm just proceeding to the next one now. Now let us talk something about hair disorders. Okay? So hair disorder is something that most of us face, isn't it? सब लोगों को ये होता है कि there's lot of hair fall and all these stuffs. So whenever there is a lot of hair fall, what do we call? The name that we call for hair loss is called as alopecia. Now, alopecia, there are two types. What are the two types of alopecia? जैसे the type of alopecia which all of us we may face is called as non-cicatricial alopecia. So non-cicatricial alopecia means that this is going to be non-scarring alopecia. Non-scarring alopecia. Whereas the type of alopecia which may leave a scar, this is called as cicatricial alopecia. So first thing on the exam, I am not expecting that the examiner will give you the term. All of the following can present to you with non-scarring alopecia except. But what they will mention, all of the following can present to you with non-cicatricial alopecia except. Non-cicatricial matlab non-scarring. Cicatricial matlab scarring. So please remember this term now. Now just try to remember that all the types of non-cicatricial or non-scarring alopecia either starts with A or with T. जैसे androgenic alopecia, alopecia areata, trichotillomania, telogen effluvium, anagen effluvium, all these A and T is going to be non-scarring alopecia. And just try to remember what are the examples of scarring alopecia. Scarring alopecia का examples है discoid lupus, lichen planus, chirion, pseudopelade, folliculitis decalvans. All these are examples of scarring alopecia. अब scarring alopecia का मतलब क्या है? Like a patient is having scarring alopecia. There is a loss of hair and there is no hair growth again that is happening. ठीक है? That is called as scarring alopecia. So please try to remember the examples of scarring and non-scarring alopecia. So now let us talk about some of the types of alopecia. I'll just zoom the first image for you. If you get this kind of an image for your exam and the examiner asks you what is the diagnosis. Now what do you see here? In this image, I can see that there is a well circumscribed area of hair loss over the beard area. So what do you call for these kind of patchy hair loss? Anybody in the chat box? So what do you call for these kind of patchy hair loss? I need the diagnosis. हाँ patchy hair loss है, I agree आदिल, पर मुझे ना diagnosis चाहिए अभी. What is the diagnosis? Is it androgenic alopecia? Is it trichotillomania? Is it alopecia areata? Yes, very good. So this is alopecia areata. So when a hair loss is confined to an area, this is called as alopecia areata. And remember, alopecia areata is a autoimmune disease. So this is a autoimmune disease. And in this autoimmune disease, once in the FMG exam, they asked you ki what is the microscopic finding that you can see in alopecia areata or the trichoscopy finding. So this is the finding that I'm talking about. If you want, I'll just zoom it for you. So this is a trichoscopy finding which we can find. Very good, Medico. So this one where you can find the hair looks something like this. Now what is this? So this is going to be called as a exclamation mark. Exclamation mark hair. So that is called as exclamation mark hair, which can be seen in alopecia areata. Now there is one more image in alopecia areata which is important. Once again, I'm zooming it for you. Now what is the finding that you see here? So the finding that you see here is that the patient is having a patchy alopecia. So ये patchy alopecia के अंदर, what do you find? Is it a retention of black hair or a loss of black hair? Yes, very good, Medico. You are answering the name of the phenomenon here. See, alopecia areata में क्या होता है कि wherever there is a patchy hair loss, in the patchy hair loss, the patient is losing the black hair. And then what is happening? There is a retention of white hair. This retention of white hair is called as turning gray phenomenon. So this is called as turning gray phenomenon. So please remember these findings. Alopecia areata is an autoimmune disease. Patient presents with a patchy hair loss. The patient can come to you with a turning gray phenomenon, and there is an exclamation mark here. Now in alopecia areata, did you learn about any nail findings? So during your sessions, did you learn about any hair findings in alopecia areata? So now let's talk about the nail findings now. Now what is the nail finding? Yes, the nail finding which you can see is there are multiple pits over the nails where you can find a regular and shallow nail pitting. So this regular and shallow nail pitting, this can be seen in alopecia areata. This can be seen in alopecia areata. Now I have one more question to all of you. Now if there is regular and shallow nail pitting, the nail finding here is nail pitting. But if you find the exact opposite, like in this image, यहाँ पे ये regular नहीं है because there is one here, there is one here, there is one here, here. So this is irregular type of a nail pitting. So when there is an irregular type of a nail pitting and deep kind of a nail pitting, what is the disease where you can find this finding? Excellent. Adil, factor 5, all of you are answering it. This can be seen in psoriasis. This can be seen in psoriasis. Exact opposite. जैसे irregular, irregular and deep. Irregular and deep nail pitting. Please remember, regular and shallow is equal to alopecia areata. Irregular and deep is equal to psoriasis, is going to be equal to psoriasis. नहीं, ये pterygium of the nails नहीं है. So once we learn about lichen planus, उस time पे I'll show you what is a pterygium. But please remember, this is just nail pitting. So we have learned two types. One is in alopecia areata and the other one is seen in psoriasis. Shall I move? Yeah. So let us talk about some more nail findings now. अभी nail findings में, what do you see this? So this is something which you may have learned in forensic medicine also. Like a patient is coming to you with a whitish discoloration over the nails. Can you see this? A pure whitish discoloration over the nails. Now this is associated with a poisoning. That is a clue for all of you. Can you tell me what is this nail finding which is associated with some poisoning? That is a clue for you. And no, it's not Murky, it's not half and half. It's okay to make mistake, but please give it a try. I'll give you one more clue. It again starts with M. Yes, Adil, yeah, arsenic poisoning mein you can find. Yeah, now you're coming closer. Yeah, Hemant is answering it finally. So this is Mees lines. Okay, this is Mees lines, which can be seen in arsenic or thallium poisoning. Arsenic or thallium poisoning. So when you find this whitish discoloration over the nails, which runs from one side to the other, this is called as Mees lines, which can be seen in arsenic poisoning or thallium poisoning. Okay, arsenic or thallium poisoning. Now, in case you find a whitish discoloration over the nails like this, okay, this looks like there is an overgrowth of something. तो क्या होगा? Is it going to be a bacteria? Is it going to be a virus? Or is it going to be a fungus? So this is due to overgrowth of a fungus. So whenever there is a whitish discoloration over the nails because of a overgrowth of a fungus, this can be called as SWO. So what is SWO? It is superficial white onychomycosis. Onychomycosis. So what are we discussing right now? We are discussing about some of the conditions where the nail can turn white in color. So what do we call for whitish discoloration of the nails? White matlab leuco. Trichia, sorry, Nichia means nails. So leukonychia. This is an example of leukonychia. Okay? So abhi dekho, this one is the first one that we discussed. So here you can see a white line. So this is called as Mees lines. The second one is you can see that there is some whitish discoloration over the nails. Looks like there is a fungal infection. कौन सा fungal infection है? SWO, superficial white onychomycosis. So now let's go to the next one. There are more nail findings that we will learn. So the next nail finding that we will learn is यहाँ पे क्या हो रहा है? There are parallel white bands like this. So when there are multiple parallel white bands, here we call it as Muir-Keys lines. So this one is going to be Muir-Keys lines. है ना? So where do you find this Muir-Keys lines? Any diseases where we can find a Muir-Keys lines? So I'll tell you, a patient can come to you with generalized edema, जैसे अनासर का. So when do you get a generalized edema? When a patient is having protein loss, isn't it? So proteinuria or hypoalbuminemia. So hypoalbuminemia as well as in chemotherapy, we can find Muir-Keys lines. So hypoalbuminemia or या फिर chemotherapy, we can find Muir-Keys lines. So that is one of the example. The second one is this. Now just concentrate on this image. Imagine that you're getting this image for your exam. Where do you find the whitish discoloration? I'll just label the whitish discoloration here. The whitish discoloration यहाँ पे है. Proximal है या distal है? Proximal part of the nails, isn't it? So proximal 50% of the nails is going to be white in color. So this 50% is your clue. Now can you name this nail finding? So what is this nail finding? This nail finding is going to be 50% matlab half and half nails. So 50% matlab half and half nails. This is also called as Lindsay nails. Lindsay nails. And in which kind of patients can we find this half and half nails? This is seen in chronic renal failure. Chronic renal failure. So imagine that there is a patient who is complaining of anuria, isn't it? Is a chronic diabetic patient. And when you check the lab investigation, the serum urea, serum creatinine, everything is going to be very high. In such a patient who is having a renal failure, when you examine the nails of the patient, you can see half of the nail is white in color and the half of the nail is normal. This is called as half and half nails. Now let us talk about the last nail finding. So this one. So यहाँ पे क्या हो रहा है? The entire nail has become more white in color. And this one starts with T. So here it is not half, but the entire nail has become white in color. So this one, anybody in the chat box? ये कौन सा nail है? Just give it a try. Just give it a try. It is okay if you go wrong, but please give it a try. What is it? It starts with T. Very good. This is called as Terry's nails. So this is called as Terry's nails. Just remember one example where you can find a Terry's nails. So earlier renal failure tha, abhi this is going to be hepatic failure. So this can be seen in hepatic failure. The Terry's nails are seen in hepatic failure. Clear? Very good. So happy to get these responses. So I hope things are going fine. Shall I proceed to the next finding? अब ये देखते हैं कि ये क्या है. So what is this? So in this first image, you can see that the patient is having a yellow discoloration. Where do you find this yellow discoloration? आपको यहाँ पे दिख रहा है yellow discoloration, isn't it? So that is the lateral nail fold. So what is this yellow color? Yellow color, common thing. It should be pus. So whenever there is pus anywhere in the body, what is going to be your treatment? The treatment anywhere in the body, if there is pus, take the blade, isn't it? Just do an incision, you drain off the pus. What is the diagnosis here? So you're getting an image like this for your exam. The examiner is asking, ki diagnosis kya hai, batao. Yes, very good. Who is answering? Dr. Ambika Sharma is answering. Yeah, this is paronychia. This is paronychia. So in paronychia, there is an infection of the lateral nail fold. Now tell me, यहाँ पे अगर pus है, so what is the causative organism? Is it going to be some fungus? Yeah, is it going to be some bacteria? So this is caused due to Staphylococcus aureus. Okay, remember this is caused due to Staphylococcus aureus. And यहाँ पे treatment क्या होना चाहिए? The treatment should be incision and drainage plus minus antibiotics. So that is going to be the management of paronychia. Just remember one thing, कि those ladies who are always in contact with water, जैसे washing the vessels, isn't it? Washing the clothes and all, they also can come to you with a pain over the lateral nail fold. उस time पे this is not going to be acute. This is going to be chronic paronychia. Chronic paronychia. So in those washerwoman, this is seen in washerwoman, that is chronic paronychia. This is due to a mixed infection. Mixed infection. So what do I mean by a mixed infection? Is it only caused due to is it only caused due to bacteria? Mixed है ना? So mixed matlab it should be due to bacteria as well as fungus. So the type of paronychia where you get a mixed infection is a chronic paronychia, which is usually seen in a washerwoman who is always in contact with water, isn't it? So please remember this one. Age, yeah, what I'm trying to do is जो भी important topics है, जो भी important images है, बस वही discuss कर रहा हूँ आज के session में. So if you are able to do that properly, I'm sure that you'll be able to achieve the pass percentage that is required for the exam. Okay, चलो. So now let's come back to this one. ये image already एक previous year question था. They gave you this image for your exam. They asked you what is the treatment of this condition. Does anybody know what is this nail finding? So can please answer in the chat box कि ये nail finding कौन सा है? Isn't it? So there is some depression over the nails. The entire shape of the nail has changed. Now what is this nail finding? Yeah, this nail finding is spoon-shaped nails. Spoon-shaped nails. So you must have learned about this nail finding. What is a spoon-shaped nails called as? This is called as koilonychia. This is called as koilonychia. And what is the most common association of koilonychia? The most common association is this is associated with iron deficiency anemia. So this is associated with iron deficiency anemia. So in the exam they asked you what is the management of this kind of a nail. तो मैनेजमेंट क्या है? ये नेल्स का मैनेजमेंट है. हाँ, आयरन डेफिशिएंसी है तो आयरन supplementation. So one of the option that was given in the exam was iron supplementation. So you just give iron and then that matter can be taken care. Clear? So chalo. So now let's go to the next one. So after nails we are going to some other gland. So ये दोनों images देख लो. Now tell me कि what is the gland which has become diseased here? The option that you have in your mind is ये तो axilla का image है, isn't it? So in a patient who is complaining of some skin condition over the axilla. So axilla means think about which gland. Are you going to which type of sweat glands can be seen in the axilla? Can you answer in the chat box? So here we are dealing with apocrine sweat glands. So we are dealing with apocrine sweat glands. So please don't answer it as sebaceous. Remember, axilla. Here you don't find eccrine glands. What do you find? Axilla, groin, all these areola, all these areas में you can find a apocrine sweat glands. Okay? So in apocrine sweat glands, we are talking about two diseases. This is the first disease. So what is the first disease? Where you can see that there are some interconnecting bridges. So this is called hidradenitis suppurativa. Hidradenitis suppurativa. That is one of the disease. Now can anybody tell me what is the second disease of the apocrine sweat glands? That is also seen in axilla. अभी differentiate कैसे करेंगे? So and if I zoom this image, you can see that the patient is having very small papular lesions over the axilla. These very small papular lesions over the axilla. This is all wrong. Okay, this I mean in the chat box, everybody is messaging as Fordyce disease. गलत है. This is Fox-Fordyce. This is Fox-Fordyce disease. Okay? So Fox-Fordyce disease and hidradenitis suppurativa, these are diseases of apocrine sweat glands. Now, since all of you have messaged about Fordyce, let me just write about Fordyce also. Now, what is Fordyce spots? Fordyce spots, all of you please remember, this is an example of ectopic sebaceous glands. तो ये हो गया sebaceous, isn't it? And this one is apocrine. Okay? So please remember that in apocrine sweat glands, we find hidradenitis suppurativa, Fox-Fordyce disease. Whereas a disease of sebaceous gland, ectopic sebaceous gland, this is called as Fordyce spot. We don't call it as a disease because Fordyce spots, this can be seen over the lips or over the genitalia. जो small whitish spots होता है over the lips and all, these are called as ectopic sebaceous glands. Is it clear? So now let's go to another very important topic in dermatology, that is acne. See, if you go through the previous year questions, you can see that acne has been asked multiple times. Every time they ask you. Okay, very simple topic. क्योंकि acne में क्या होता है, the patient can come to you with different kinds. What is acne? Acne means pimples. So the common name is pimples. यहाँ पे in acne, the patient can present to you with different clinical scenario. So देखते हैं what are the different clinical scenario in acne. Can anybody label this first image? ये first image क्या है? जहाँ पे you can see multiple black dots can be seen over the skin. ये black head है या white head है? Yeah, these are comedones. So these are, since it is black in color, we call it as black heads. So ये black heads, we also call it as open comedones. Open comedones. ठीक है? The second one, यहाँ पे the comedones are intact. ये जो open नहीं हो रहा है, so there is no oxidization reaction that is happening. That is why the second image I can label it as white heads or closed comedones. Clear? तो एक हो गया black heads, दूसरा हो गया white heads. Both are called as comedones. And please remember, any MCQ which will have this magic word क्या है? Comedones. Comedones matlab there is only one diagnosis, that is going to be acne, because comedones are seen only in acne. Now let us see another type of acne. So in this image, what are the lesions that you find? मुझे यहाँ पे pustule दिख रहा है, यहाँ पे pustule दिख रहा है, and along with pustule I can find some papules also. So this kind of acne is called as papulopustular acne. Papulopustular acne. Okay. And what is the most severe type of acne? The severe type of acne hai, that is what I can see in this last image. So in this last image, this type of acne is called as very large lesions. है ना, इतना बड़ा बड़ा lesions दिख रहा है. So what is this? This is called as acne conglobata, or let me say nodulocystic acne. Nodulocystic acne. This is the most severe type of acne. This is the most severe type of acne. Clear? So that is how an acne patient can present to you. Because the patient can have either a comedone or a papules and pustule, or it can have a nodulocystic acne. So putting all these things together, comedones, papules, pustule, all these things together, what do I see? How do I call them? Can I call them as polymorphic skin lesions or pleomorphic skin lesions? Can you quickly answer the chat box? ये polymorphic lesions है या फिर pleomorphic lesions है? So these are going to be polymorphic polymorphic lesions. So why polymorphic lesion? Because of different morphology of the lesions can be seen in acne vulgaris. Now in acne vulgaris, what they usually ask you is either they will give you an image of acne, they will ask you to identify. So what you will do, you will identify ये blackhead हो गया, ये whiteheads हो गया, ये papulopustular acne हो गया, या फिर nodulocystic acne हो गया. Next type of question that they can ask you is what is the drug of choice? Remember, in every type of acne, the drug of choice is going to be retinoids. Okay? So the drug of choice of every type except severe acne is going to be topical retinoids. So I am having some time space constraints, so this is going to be topical retinoids. And in the retinoids, very good. So in this retinoids, how about some examples? Do you remember any examples of topical retinoids? One starts with A. So what is the example of a topical? Topical matlab creams, ointments and all. So this is going to be adapalene. This is going to be adapalene. या फिर tretinoin. Adapalene or tretinoin. These are examples of topical retinoids which can be used. Whereas what about nodulocystic acne? जब बड़ा बड़ा lesions होता है over the face, उस time पे we are not going to just apply a cream and wait. उस time पे instead of a cream, you will have to go for a oral retinoid. So what is the example of a oral retinoid? The example is isotretinoin. The example is isotretinoin. Okay? Isotretinoin is going to be a oral retinoid. So that is going to be the different types. And then another important question that is usually asked for your exam is what are the side effects of oral retinoids? So anyone who remembers the side effects of oral retinoids? What are these side effects? Can you just let me know in the chat box? I'll just write down whatever you write. What is the most common side effect of a oral retinoid? जैसे isotretinoin ले लिया. What is the most common side effect? The most common side effect is going to be dryness of the lips. So dryness of the lips is okay because we have lip balms and all. So all those moisturizing balms that can be used. But what is the most problematic side effect? Problematic side effect is going to be teratogenicity. So what is the teratogenicity period? It is going to be 1 month when it comes to isotretinoin, which means when a patient is taking isotretinoin, what happens? There is a chance that if the patient is going to get conceived, the patient can deliver a baby with a birth defect. Okay, birth defect. That is why we call it as teratogenicity. So 1 month is going to be the teratogenicity period of. Yes, very good, Dr. Ambikam. There can be dyslipidemia also. Dyslipidemia as well. There are many side effects. So dyslipidemia is also going to be one of the side effect of isotretinoin. So please remember, if you get any image of a comedonal acne, the drug of choice should be topical retinoid. यहाँ पे भी topical retinoid. But if you get an image like this, where you are having a patient with large lesion, don't go for creams, just go for oral retinoids. Just go for oral retinoids. So now let's move on. So after acne, so now let's talk about some contact dermatitis. So what is the meaning of a contact dermatitis? जैसे my skin is in contact with this pen, isn't it? So after a contact with this pen, if I develop some allergic rashes over the skin, that is called as contact dermatitis. There are two types of contact dermatitis. एक हो गया ICD, जैसे irritant contact dermatitis, या फिर ACD. What is ACD? Allergic contact dermatitis. ICD or ACD. So in ICD, please remember, irritation always occurs because of chemicals. The most common example is going to be detergents. So this is going to be the most common. Whereas what is allergic contact dermatitis? Everything else is going to be allergic contact dermatitis. जैसे be it a footwear, be it bindi dermatitis, be it henna dermatitis, be it artificial jewelry, everything else is going to be ACD. So remember, ICD is due to chemicals, and everything else is going to be due to allergic contact dermatitis. This is the simplest way to remember. Okay, on this 11th hour, so when you are going to do some लास्ट मोमेंट रिविजन्स, बस इतना रिमेंबर करो कि केमिकल्स जैसे डिटर्जेंट्स हो गया, डिश वॉश हो गया, हैंड सैनिटाइजर्स हो गया. So whenever there is a chemical, it is going to be irritant contact dermatitis. Everywhere else, it is going to be allergic contact dermatitis. Now just see this image. ये image को आप कैसे लेबल करोगे? Is it allergic contact dermatitis या irritant contact dermatitis? Hand eczema. Okay, allergic contact या फिर irritant contact dermatitis. Most probably this is due to ICD, due to detergents. It is also called as housewife's eczema. So now let's see the next one. This is a patient who bought a slippers recently. After wearing the slipper, the patient has developed an allergic rash at the site of contact. So is it ICD or ACD? Yeah, this is going to be ACD, that is footwear dermatitis. Footwear dermatitis. So for your exam, if they give you multiple images, kahin pe bhi ho, if it is not chemicals, your answer should be allergic contact dermatitis. Allergic contact dermatitis. Very good. So now let's move on to the next image. Now, out of all these skin images, one of the FMG exams, they gave you an image of a plant. They asked you to identify this plant. And why am I teaching about this plant in dermatology? Because this is the most common cause of allergic contact dermatitis. Can anybody name this plant? Yes, Congress grass, isn't it? So this is called as Congress weed, or what is the chemical name? Very good, Harsh. This is called as Parthenium hysterophorus. This is called as Parthenium hysterophorus. So Parthenium hysterophorus or Congress weed, it is the most common cause of allergic contact dermatitis. Before I go anywhere else, let me quickly ask you one question which I just now mentioned to you. What is the most common cause of irritant contact dermatitis? Quickly in the chat box, just to see if all of you are aligned. What is the most common cause of irritant contact dermatitis? In the chat box, please. Excellent. Which chemical, Vasundhara? Yeah, Spidey is answering. See, remember, I had mentioned earlier, most common cause of irritant contact dermatitis is going to be detergents. Excellent. Spidey, Adil, Raman, all of you are answering. Harsh is also answering. Excellent. Remember? Now, going to the next one. What should be the problem here? Why did a patient develop this eczematous rash over the forehead? Problem kya hoga? Problem is patient must have used something like this for few days, and after that the patient developed this rash. So this is again allergic contact dermatitis, which can be due to bindi. So bindi dermatitis. So in bindi dermatitis, try to remember what is the culprit here. The culprit here in bindi dermatitis is, any answer? PTBP, para tertiary butyl phenol. Excellent. All of you are answering it. Para tertiary butyl phenol. This is the culprit in bindi dermatitis. This PTBP, it is actually the gum or the glue which is used in a bindi. So this gum or the glue is actually causing the allergic contact dermatitis in bindi dermatitis. Excellent, good going. So now let's go to the next one. So that is all about allergic and irritant contact dermatitis. Now let us come to a very important topic in dermatology. Without this topic, there is no FMG exam, or there is no dermatology questions in FMG exam. What is this topic? You see two of these images, bus correlate karo and give me a single diagnosis. I think the second image is more clear for you. Yeah, whenever you get a erythematous plaque and having a silvery white scaling, that is a diagnosis. The diagnosis is going to be psoriasis. Excellent. So please remember, any image, any part of the body, you get this erythematous plaque and a silvery white scaling, the diagnosis should be psoriasis. Psoriasis. So in psoriasis, what are the questions that is expected? In the last FMG exam, they asked you a question ki a patient after having an episode of sore throat, he took amoxicillin and the patient developed multiple small erythematous lesions over the body. ये कौन सा psoriasis है? So this one, the first type of psoriasis that we will discuss is guttate psoriasis. Guttate psoriasis, where in guttate psoriasis we can get small erythematous plaque lesions. We can find small erythematous plaque lesions. Usually what happens, there is a history of streptococcal sore throat. So usually there is a history of a streptococcal sore throat when it comes to guttate type of psoriasis. So please label this one as guttate psoriasis. That is the first image. Okay, this one is going to be guttate psoriasis. What is going to be the history? Patient is having multiple small erythematous lesion after a history of a streptococcal sore throat. Answer, guttate psoriasis. Now the second one is the most common type of psoriasis. What should be the most common one type of psoriasis? Psoriasis vulgaris. Psoriasis vulgaris. And how will a patient present with psoriasis vulgaris? The patient can present to you with erythematous plaque with silvery white scaling. With silvery white scaling. अब ये silvery white scaling जो है, where is it usually seen? ऐसे surfaces में देखते हैं या फिर ऐसे folds में? Is it extensor या flexures? What is the most common site of psoriasis vulgaris? So this can be seen over just 2 seconds for you to answer in the chat box. Very good, Spidey. Yeah. Please remember extensor surfaces. Extensor surface. So psoriasis is most commonly seen over the extensor surface. What is the type of scaling? The scaling is going to be silvery white scaling, and these are going to be erythematous plaque lesion. That is how the psoriasis can present. Now, that is not all about it. There are many other types of presentation in psoriasis. When you have lesions of psoriasis only over the palms and the soles. So palms and soles, which can show these kind of lesions, we call it as palmoplantar psoriasis. So this is called as palmoplantar psoriasis. And the last one, usually कहाँ पे देखते हैं? We usually see the lesions of psoriasis over extensor surface. Now, if you see the lesions over the flexures, like the armpit, isn't it? Over the axilla, so over the groin area, etc. If it is rarely seen over the flexural surface, we call it as flexural or inverse psoriasis. Flexural or inverse psoriasis. That is how it is called as flexural or inverse psoriasis. So we learned about 4 types. है ना? So psoriasis can be guttate with streptococcal sore throat. The psoriasis can be the most common, that is plaque psoriasis or psoriasis vulgaris. तीसरा, palms and soles, palmoplantar. Fourth one, over the flexural surfaces or inverse psoriasis. Now going to one more type of psoriasis, which is called as pustular psoriasis. So usually what happens, people think that psoriasis can only present to you with Plaque lesions. Galat hai, isn't it? Psoriasis can also present to you with pustular lesions. These are called as pustular psoriasis. These are called as pustular psoriasis. Pustular psoriasis mein, the first one is when the lesions are confined to the palms and soles. If the lesions are confined over the palms and soles, this is called as localized pustular psoriasis. So localized या फिर generalized. There are two options, localized या generalized. So where is localized means localized to the palms and soles. And what is the type of lesion that you see in localized? Localized may you find multiple pustules over the palms and soles. Whereas generalized means you see multiple pustules throughout the trunk. Isn't it? Generalized throughout the trunk. Now this generalized pustular psoriasis, this is also called by one more name. What is it? Yeah, I'm already getting the answers in the chat box. Excellent. So this is also called as von Zombush reaction. So this is also called as von Zombush reaction. Generalized pustular psoriasis is also called as von Zombush reaction. So now let me ask you one question. Is psoriasis an infective disease? Can one person of psoriasis pass on this disease to a next person? Is it something that comes under infections? Bilkul nahi. So in that case, if a patient is having multiple pustules over the palms and soles, or if the patient is having multiple pustules throughout the body, if we send these pustules for investigations to the lab, so will it be positive for bacteria? Yeah, will it be positive for a fungus? Yeah, is it going to be sterile pustules? So remember a very, very important point here. All the pustules in psoriasis is going to be sterile. So you are going to get sterile pustules when it comes to psoriasis. Okay, very, very important point. These are sterile pustules. Now let us see one more presentation. अब देखो, this one very severe है ना, क्योंकि entire skin is having a lot of scaling, and beneath the skin you can see that there is a erythema as well. So if you find that 90 percentage of the body surface area turns red, now what do we call for this kind of a psoriasis? Entire body has become red, there's so much of scaling, so this can be considered to be a dermatological emergency. So I need one name for this condition. Can you name this condition? Entire body red, lot of scaling. Anyone? This one is called as psoriatic erythroderma. Okay, this is called as psoriatic erythroderma. So a patient can go into, excellent, Spidey, Medico, whoever is answering. So a patient can go into a high output cardiac failure. So that is why we consider this type of a psoriasis as a dermatological emergency. Now let us also talk about nail findings. See, psoriasis, I'm just going a bit deep क्योंकि हर FMG exam में psoriasis is asked. In some exam they ask you about identify. Some exam they ask you ki what is a treatment. Sometimes they give you an image of a nail, ask you to identify. Sometimes they ask you about psoriatic arthritis. So we can't predict. So let's do it very quickly. So nail changes in psoriasis, please remember it as poison. Okay, Poison. So how about filling up this mnemonic of poison? So what is P? P तो already आज भी कर चुके हैं. What is P? P is when you get multiple depressions over the nails. So what is this depressions over the nails called as? Pitting of the nails. Pitting of the nails. So how about OI? So just see this image. This is an image of OI. What is it? You can see some lesion like this. So this is called as oil drop sign. Oil drop sign. Very good. Now, what is the next one? S. This image was already asked for your exam. So what is S? You can see that. I'll just zoom this image. Can you see that then the area of the nail just underneath has become thickened? So this thickening of the nails is called as subungual hyperkeratosis. So this is called as subungual hyperkeratosis. This was already asked for your exam. And what is the next one? O for onycholysis. Onycholysis. So what is onycho? Onycho means nail. Lysis means separation. So this is onycholysis. Okay, this one is onycholysis. So when the nail gets separated from the nail bed, what will happen? The distal part of the nail, it looks more white in color because of a separation of the nails from the nail bed. It is called onycholysis. And the last one, N, is nail bed dystrophy. This is called as nail bed dystrophy. So which means the entire morphology of the nails is lost. So when the entire shape of the nails is lost, we call it as nail bed dystrophy. So all these can be seen as a nail changes in psoriasis. So please remember POISON, pitting, oil drop, subungual, onycholysis, nail bed dystrophy. Clear? So चलते हैं next one. Now some of the signs in psoriasis. ये भी एक spotter जैसा आ सकता है for your exam. So what is this spotter? कि psoriatic plaque, when it is scraped, it can give you multiple bleeding spots. So this is a sign which you can see in psoriasis. Can anybody answer what is the sign? I'll give you a clue. It starts with A. So U. Yeah, very good. So this one is called as Auspitz sign. Okay, this one is an example of Auspitz sign. Another very, very important image in psoriasis. When you scrape over the lesions, bleeding spots on scraping the lesion. So this is called as Auspitz sign. This is called as Auspitz sign. So in psoriasis, there is one more very important sign. So now let's see what is that another important sign. If you get this image for your exam, ab bolo. So probably the psoriasis patient has scratched over the skin. After scratching over the skin, the patient developed psoriatic plaques. That is a clue for you. Scratching and the patient develops psoriatic plaques. What is this? Excellent. So this is called as Koebner phenomenon. So many times this topic has been repeated for your exam. That is Koebner phenomenon. So in Koebner phenomenon is also called as isomorphic phenomenon. It is also called as isomorphic phenomenon, where a patient can present with new skin lesions at the site of trauma. New skin lesions at the site of trauma. So how about quickly revising what are the diseases which show Koebner's? So what are the diseases which we usually will show Koebner's? You can remember it as LVP. So what is L? Anyone quickly? Now let's go a little bit fast. L stands for lichen planus. V stands for vitiligo. And P stands for psoriasis. So please remember, these are the three diseases where you can find a Koebner's phenomenon or a isomorphic phenomenon. Okay? New lesions appear at the site of trauma. Very good. So shall I move to the next one? So let's go on. So before going to Pityriasis rosea, I just wanted to add one more very important thing in psoriasis. That is going to be the histopathology finding in psoriasis. How about writing down the histopathology finding? First thing that I would like to ask you is there's a very, very important neutrophilic microabscess. Now, what is the name of neutrophilic microabscess in psoriasis? Extremely important. One is called as Monroe microabscess. And what is the other one? One more microabscess in psoriasis. This begins with K. Yeah, this one is going to be Kogoge spongiform pustules. So please remember, these are the examples of neutrophilic microabscess in psoriasis. So these are the examples of neutrophilic microabscess in psoriasis. Clear? So don't forget, this is also repeatedly asked. They usually club it with lichen planus and confuse you. But please remember, Monroe and Kogoge, they both are seen in psoriasis. They both are seen in psoriasis. Chalo. Now let's see the next one. Now what is this? Pityriasis rosea is the heading. So in Pityriasis rosea, so when you see this image, what is the largest lesion that comes to your eyes? Which is the largest lesion that you can find? This one, है ना? So this largest lesion is also the first lesion to develop. So let us write down what are the important features. The first lesion is also the largest lesion. So this first lesion or the largest lesion, this is having a name. So what is the name of this first lesion that develops in Pityriasis rosea? Very good, Harsh. This is called as Herald patch. So this is called as Herald patch or mother patch or mother patch. So after few days, what happens? The patient will develop multiple small lesions. So these multiple smaller lesions that develop over the trunk. So these lesions, they take up a peculiar pattern. So the pattern of the rash is going to be Christmas tree pattern. Okay, pattern of the rash is going to be Christmas tree pattern. Now, how about the scaling that you can see in Pityriasis rosea? The scaling in Pityriasis rosea can be cigarette paper, or a collarette of scales, Okay, and please remember, they will give you an example like a patient developed a large lesion, a large erythematous plaque, which was followed by the onset of multiple smaller erythematous plaque throughout the trunk in a Christmas tree pattern. So when you read these two sentences, you understand key this is Pityriasis rosea. If they ask you what is the treatment of this condition, would you like to go for a steroid? Would you like to go for some moisturizing creams or antihistamines or none of the above? So what is a treatment of Pityriasis rosea? Please remember, Pityriasis rosea is a self-limiting condition. So this is a self-limiting condition. No treatment is necessary. No treatment is necessary. Clear? So that is where you can go wrong in the simple topic called Pityriasis rosea. Please remember, it's a self-limiting condition in dermatology. So now moving to the next one. So when we move to this next one, just a minute. Yeah. So what you see in this image now, some patient wrist area is shown. So whenever you see this images, just try to describe the lesion. So when you describe the lesion here, there is a plaque lesion over the wrist area. So this area is going to be the flexures, isn't it? This is going to be the flexural area. And I will not try to describe it as red. Instead, I would describe it as violet color or purple color plaques. So when I say violet or purple colored plaques, what is the diagnosis that should come to your mind? No, this is not urticaria. This is not wheals. So remember, here the diagnosis is lichen planus. So this is going to be lichen planus. So what is happening in a lichen planus? So lichen planus mein, you can see a violet or purple colored plaque lesions. Violet or purple colored plaque lesion. So this can be seen, है ना? And second one is this can be seen over flexural surfaces. Flexural surface. And what do you call for the scaling that you can see in lichen planus? Like those whitish lines which you can see. Yes, Spidey is already answering. So this whitish scales which you can see is called as Wickham's striae. So that is a name for the scaling that you can see in lichen planus. So in lichen planus, in the FMG exam, they asked you about lichen planus lesions over the oral mucosa. So now you see this. Now what you see here, you can see that there is some whitish lacy reticulate pattern within the oral mucosa. So this is going to be oral lichen planus, where you can find whitish lacy lesions over oral mucosa. What is important here is, like, why is oral lichen planus very important? Any idea why oral lichen planus is very important? Like a patient is having violet color or purple colored plaques in the body. Along with that, when you examine the oral cavity, you can see some whitish lines like this. So you have diagnosed it as oral lichen planus. But I am definitely going to follow up this patient for a longer period of time. The reason is this is a pre-malignant lesion. Very important point. This is a pre-malignant lesion. So what is this lesion going to be pre-malignant to? So this is going to be pre-malignant to squamous cell carcinoma. That is the reason why I'm going to follow up this patient for oral lichen planus for squamous cell carcinoma. And now here, there is some hair loss that is associated with lichen planus. So today during the beginning of the session, I told you hair loss matlab alopecia. Two types of alopecia, isn't it? Cicatricial, non-cicatricial. Non-cicatricial matlab anything that starts with A and T. Now this is going to be an example of, cicatricial alopecia or a scarring alopecia. So please remember, lichen planus will give you a scarring alopecia. Okay? So this looks like alopecia areata, but if there is a patient with a patchy hair loss who also complains of purple colored lesions over the body, then think about the alopecia that is associated with lichen planus. So how do we differentiate between lichen planus and leukoplakia? See, Banu, what happens is in lichen planus, there is usually going to be skin lesions with purple colored plaques. Second thing, the patient may be having some complaints like burning sensation within the oral mucosa, especially while you take some spicy food and all. The patient would be symptomatic here. Okay, leukoplakia is entirely different. This whitish discoloration over the oral mucosa. It can be seen in association with candidiasis and all. I think I have an image of oral thrush coming up. So we'll just see that. Okay. So if the MCQ says patient with purple lesions over the skin along with white lacy lesions over the oral mucosa, answer should be oral lichen planus. Clear? Yeah, it is all going to be pre-malignant as well. So now let's go to see some of the nail changes in lichen planus. So what is the nail change in lichen planus? If there is a wing-shaped extension of the nails. So what do you call for this wing-shaped extension of the nails? Any answer? So this is going to be excellent. So Harsh, Spidey, all of you are answering. This is going to be called as pterygium. Pterygium of the nails. And what is the most common nail finding? The most common nail finding in lichen planus is going to be thinning of the nails. Thinning of the nails. There are many other nail findings that you can see in lichen planus, but please remember the most characteristic one, that is going to be pterygium, and the most common nail finding, that is going to be thinning of the nails. Nahi, oil drop, please remember, oil drop is the most characteristic in psoriasis. Okay, we don't find oil drop changes in lichen planus. Chalo. Earlier, many of you were answering as urticaria. Now, what is urticaria? Now it is time to discuss about urticaria. In urticaria, what do you see is that when you examine the skin of the patient, you can see that there are multiple edematous lesions, like there is some water underneath the skin. So this is called as urticaria. So there is edema underneath the skin. So what do you call for these kind of skin lesions? We call it as wheals. Okay, we call it as wheals. So edema underneath the skin is called as wheals. Okay, edema underneath the skins is called as wheals, and usually wheals disappear in within 24 hours. Usually wheals disappear within 24 hours. Okay, so in urticaria, so what is the drug of choice or the treatment of an urticaria? Jesse, a patient has taken some seafood. After taking seafood, the patient is developing multiple lesions of edematous lesions over the skin. So diagnosis, all of you know, that is going to be urticaria. What should be the treatment? Very good. The treatment should be antihistamines. Antihistamines. So like levocetirizine, cetirizine, fexofenadine, all these things can be used as a management of urticaria. So when it comes to urticaria, there is a phenomenon which can be seen. Like when I take this pen and when I'm going to stroke over the skin of the patient's skin can either turn white in color, red in color, or it can be sometimes black. So remember all this phenomenon. Yes, Adil, this is called as dermographism. So please remember multiple types of dermographism like white dermographism, red dermographism, and black dermographism. Black is rare, but just note it down. Dermographism. So what are the examples of white, red, and black dermographism? So does anybody know what are the example of a white dermographism? So please remember, white dermographism is seen in a condition called as atopic dermatitis. Atopic dermatitis. Yes. Black, Shivangi is answering, black is seen in nickel allergy. Yes, I agree. Black is seen in nickel dermatitis. How about red? Who can answer what is red? Red dermographism can be seen in chronic urticaria. So in patients with chronic urticaria, you can see red dermographism as well. Okay. So now let's see one more type. So before I discuss about this one, so let's talk about this image. What is this image? So a patient is complaining of a edema, okay, which is affecting over the lips, sometimes around the eyes and all. So when this is going to be an edema over the lips, we call this as angioedema. Angioedema. Very good, Shivangi. It can be due to a drug allergy. It can also be because of an infection, etc. So this is going to be angioedema. So in angioedema, please remember the edema does not resolve in 24 hours. So the edema does not resolve in 24 hours. Since you have already told that a drug can cause angioedema, can you name a drug which usually causes angioedema as a side effect? Any answer for this question? So name a drug which can cause angioedema. Yeah. So the drug which can cause angioedema can be ACE inhibitors. So ACE inhibitors can cause angioedema. Very good. So excellent. So let me just go through the previous image. So in the previous image, this is actually a sign. So in which disease can you see this kind of a sign? Just say I have taken a pen, I'm just stroking over the skin. I just draw over the skin. So once I draw over the skin of a patient, what is happening is the patient is developing that wheal flare and those reaction, isn't it? So some redness, some urticaria, all those things develop after stroking the skin. So this is an important sign. Can anybody name what is the name of the sign? I stroke over the skin. Stroking over the skin produces urticarial wheals. So this is called as Darrier sign. Darrier sign. Very good. So this one is called as Darrier sign. So do we see Darrier sign in Darrier disease or some other disease? So it's a bonus question for you. So any way you can memorize this one, where in which disease do you find a Darrier sign? So this is seen in a disease called urticaria pigmentosa. Okay, so this is seen in a disease called urticaria pigmentosa. Stroking over the skin, what happens? Urticarial wheals are produced. This is seen in urticaria pigmentosa. So now let's discuss about some of the types of erythemas. So while you were learning about dermatology, you must have seen that there are a lot of diseases which is given a name: erythema, chronicum migrans, erythema multiforme, erythema, different types of erythema, isn't it? So now let us see what are the types of erythema. Again, a commonly tested topic. So let us label one by one. So let's start with the first one. So what is this first erythema? If you want, I'm just zooming it for you. What I can see here is there is something in the center. Then there is a rim of erythema outside, something like this. So this is what I can see. Yeah, Spidey is saying that this is bullseye. I agree. So this is a bullseye or a target lesion. Now, which is the condition or what is the name of this erythema? Can somebody answer? हाँ, सब लोगों को पता है कि ये target lesion है, but I need the name of the erythema now. So this is erythema multiforme. Okay, this is erythema multiforme. So in erythema multiforme, what this is compared to a target or a bullseye lesion or a iris lesion. So target, bullseye या फिर iris lesion, this is what we see in erythema multiforme. And how about some of the examples? So when will a patient develop erythema multiforme? It can be due to infections या फिर it can be due to drugs. Infections like HSV or mycoplasma. Okay, please remember, infections like HSV or mycoplasma, or it can happen after consuming any drug. A patient can develop erythema multiforme. Now, how about the second type of erythema that you can see here? So in this image, what is the right answer? Again, when I zoom this image, I can see that यहाँ पे एक erythematous rash is there. Then there is again a rim of erythema. Does this also look like a target? So this also looks like a target lesion या फिर iris lesion, right? So this one is not target, but let us call it as target-like lesions. Target-like lesions. Target-like lesion. Now, what is the name of this erythema? Excellent. This is called as erythema chronicum migrans. Erythema chronicum migrans. So probably this disease where you find erythema chronicum migrans was discussed in PSM या फिर medicine या फिर some other subjects. Can somebody tell me what is the name of the disease where you can find a erythema chronicum migrans? It is a migrating rash. It is an expanding rash. The rash is going to expand on all the sides like this. ऐसे expand करेंगे rash. What is the name of the disease? This is seen in, so where do you find this? This is seen in Lyme's disease. So you learned about Lyme's, isn't it? Very good. Ambika, factor 5, all of you are answering. This is seen in Lyme's disease. So what is the causative? Causative in Lyme's is Borrelia burgdorferi. So is Lyme's disease happening due to a mosquito bite? How many of you think that Lyme's disease is happening due to a mosquito bite? Agree or disagree? Disagree. क्योंकि the answer is this is due to a ixodes tick bite, है ना? This is due to a ixodes tick bite. ठीक है? So now let's see the next erythema. So the next erythema is seen in rheumatic heart disease. So this is not a very typical image. एक transient kind of erythema होता है, but at least name the erythema that can be seen in rheumatic heart disease. That is going to be the next one. Any idea what is the name of the erythema that you can see in rheumatic heart disease? What erythema is this? Erythema, very good, marginatum rheumaticum. So this is seen in rheumatic heart disease. Okay, rheumatic heart disease. Excellent. So now let's see one more. This one, it looks very nice, isn't it? It's like a nice drawing over the skin. But is it a good news or a bad news? Obviously, it's a bad news, isn't it? So what is this? So this is where you can find that there is a wood grain pattern. Imagine a wooden grain and the cross section of which it looks something very similar to that, isn't it? ये जो wood grain pattern जो है, इसको what is the name of this erythema that we can call? Wood grain pattern. Yeah, I'm getting the answer in the chat box now. Excellent. This is erythema gyratum repens. So in erythema gyratum repens, what do you see? You find a wood grain pattern. Wood grain pattern. Good news है या bad news है? Wood grain pattern. Somebody is messaging. Shivangi is saying that it is associated with adenocarcinoma. Correct or wrong? Of course, correct. So this is a marker of malignancy. क्योंकि this can be associated with breast cancer, lung cancer, etc. So this is a marker of malignancy. अभी last erythema that we are going to discuss is the fifth erythema. That is, I'm talking about this. Imagine कि there is a child who is coming to you with fever. Along with fever, there is a red color face, especially over the cheek. It looks like somebody has slapped over the face. What is this? That is a clue that I can give you. Not erysipelas. Slapping a child. The face is red colored cheeks. Yes, so this is slapped cheek appearance. So where do you find the slapped cheek appearance? Parvovirus. Excellent. So what is the name of this erythema? Erythema infectiosum. Okay, this is erythema infectiosum. So Sharad Balaji sir may discuss about it later in pediatrics, where a child is having a fever plus red face. And this red face is compared to a slapped cheek appearance. So this is compared to a slapped cheek appearance. And what is a virus? The virus is going to be parvovirus. Parvovirus. Clear? So these are the different types of erythemas that we have learned. So we have already discussed about erythema multiforme, that is associated with infections or drugs. Erythema chronicum migrans, which is associated with Lyme's disease. Erythema marginatum rheumaticum, associated with rheumatic heart disease. Erythema gyratum repens, which is a wood grain pattern over the skin. Definitely not a good news. And erythema infectiosum, which can be seen in a child with fever and a red face. Clear? So all these are erythemas. So now moving on to the next topic. So what is this next one? Just if you're getting an image like this, question की जरूरत ही नहीं है. They'll just give an image like this, ask you what is the diagnosis. What is the diagnosis that you can say? Adil is quick, very good. Adil is saying it is vitiligo. Anar, Shivangi, all of you are agreeing with Adil now. So this is going to be vitiligo. So just write down. So this one is going to be vitiligo. So So what is vitiligo? Vitiligo is an infection. Vitiligo is an autoimmune disease. Vitiligo is a connective tissue disorder. What is it? So this is a autoimmune disease. So earlier when we started the session, I discussed that alopecia areata is an autoimmune disease. Similarly, vitiligo is also an autoimmune disease. So in vitiligo, the main thing is one time they gave you an image of a vitiligo, they asked you to identify. So when we are going to identify this lesion, so let me first discuss about the most common type of vitiligo. So this image is going to be the most common type. Most common should be vitiligo vulgaris. So why is this image a image of vitiligo vulgaris? I'll just zoom it for you once again. If you see symmetrical lesion, this side as well as this side, both sides are having vitiligo, then whenever you find symmetrical lesions, the diagnosis should be vitiligo vulgaris, symmetry. So this is the clue for you. Okay, this is the clue for you. Symmetrical lesions matlab vitiligo vulgaris. Now let us see this type of vitiligo. In this vitiligo, can anybody answer the type of vitiligo here? What I can see is there is a patient who is having a deep pigmented patch over the forehead. And I can be very confident that this lesion is not crossing the midline. So Abhi, if this is not crossing the midline, what is it associated with? Dermatomal distribution. Very good. So this one, Adil, Dr. Max, all of you are answering. This is called segmental. Segmental vitiligo. Segmental vitiligo. This is going to be along dermatomes. This is going to be along a dermatome, so it will never cross a midline. Okay, these are the very common types of vitiligo. There are different types, but these are the most common and the most commonly asked ones. So if I ask you what is the drug of choice in vitiligo, can you name the topical drug of choice? Topical drug of choice. It's a new name. It's not a common one. It's typically used in very few diseases only. So what is a drug of choice? Any cream? डॉक्टर मैक्स स्टेरॉइड्स यूज कर सकते हैं क्योंकि इट इज एन ऑटो इम्यून डिजीज बट मोर देन स्टेरॉइड क्रीम्स आई वुड लाइक टू प्रिफर टू यूज अनदर क्रीम व्हिच इज कॉल्ड एज tacrolimus or pimecrolimus. So what is tacrolimus or pimecrolimus? Tacro या फिर pimecrolimus, these are calcineurin inhibitors. These are calcineurin inhibitors which can be used as a topical drug of choice in vitiligo. So when there is large body surface area included, then you can definitely go for steroid tablets and all and other immunosuppressive drugs. Please remember this topical drug of choice. Okay? So shall I move to the next one? This image was asked in the last FMG exam. So if you have gone through the PYQs in dermatology, then you have definitely learned about this disease. यहाँ पे क्या हो रहा है? That's the face of a patient. In this face of the patient, you can see that there is a brownish discoloration, a brownish patch. So what is this diagnosis? It's a spot diagnosis, usually seen in middle-aged patients. Yeah, Medico, Anar, Adil, all of you are answering. Vasundhara. So this one is called as melasma. This one is called as melasma. So you get a brownish discoloration over the face. Brownish discoloration over the face. Now, what do you call for melasma in pregnancy? So melasma in pregnancy has a peculiar name. So any idea what do you call for melasma in pregnancy? Starts with C. Cloasma. That is cloasma. Okay, this is called as cloasma or the mask of pregnancy. Mask of pregnancy. And what is the drug of choice? If somebody is developing this hyperpigmentation over the face, we will have to use a depigmenting agent. So what is the name of the depigmenting agent which can be used for the treatment of melasma? That is going to be hydroquinone. So hydroquinone is going to be the drug of choice when it comes to melasma. When it comes to melasma. Yeah, these are tyrosine inhibitors. Excellent, Dr. Max. So we have just seen about melasma. I'll just zoom this image. Is this same as melasma or is it something different? If it is different, I want to know from somebody in the chat box why is it different from melasma? So this was melasma where a patient was having a lesion which is more than 1 centimeter in diameter. Large lesion tha. So when there is a large change in color, we call it as a patch lesion, isn't it? We call it as a patch lesion. Whereas when you see multiple smaller lesions, it's a smaller lesions are there. So these multiple smaller lesions, these are not patch, but these are macules. So this one is going to be called as freckles. Okay, so don't get confused. In freckles, what do you find? In freckles, you get macules. Whereas please note in melasma, you find patches. Melasma is going to be patches. Freckles is going to be macules. That is how you can differentiate both. Okay? Now there is one more condition where you can find that over the face of the patient or over the oral mucosa. Can you see that there is some blackish discoloration? यहाँ पे brown नहीं है. It is going to be black in color. Now this is associated with a very important syndrome. Probably आप लोगों ने surgery में किया होगा. This is not HSP, but you're very close. Yeah, this is called as lentigenes. This is called as lentigenes. And this is seen in which syndrome? Do you need one more clue? In this patient who is having this blackish discoloration, if I do an endoscopy, I can see that there are hematomatous polyps in the intestine. Hematomatous polyps in the intestine. Now I'm getting the answers in the chat box. Excellent. So this is seen in Peutz-Jeghers syndrome. So this is seen in Peutz-Jeghers syndrome. So Peutz-Jeghers, where you find hematomatous polyps in the intestine. So in Peutz-Jeghers, the skin manifestation is going to be lentigenes. And how does lentigenes looks like? It looks like this, where you find a blackish hyperpigmented macules over the skin as well as the oral mucosa. Over the oral mucosa. So this can be an autosomal dominant condition. Clear? Next one, few more changes, pigmentary changes in the skin. If you find these kind of yellow, sorry, if you find these kind of brownish lesions over the skin, brown color lesion, just like I had a coffee, I spilled some coffee over the skin, coffee with milk over the skin. Can you name this lesion now? This is called as CALM. What is CALM? Cafe au lait macules. So these are called as cafe au lait macules. So these kind of cafe au lait macules can be seen in a disease called as neurofibromatosis. Can be seen in a disease called as neurofibromatosis. At the same time, sometimes cafe au lait macules have a very typical presentation. Just the brown colored skin that you can see here, this is also cafe au lait macules, but yes, NF1. Okay. So in this one, what is the peculiarity of this image? यहाँ पे भी you get a brown colored lesion. But can you see something? Yeah, Adil is saying that this is not crossing the midline. Yeah, this is over a dermatomal distribution. Excellent, fine, excellent observation. So this is segmental cafe au lait macules. Why do I call it segmental? Because this lesion is not crossing the midline. Now this can be seen in another syndrome. Can anybody answer what is syndrome here? Medico has already answered in the chat box. Anybody else? So this can be seen in McCune-Albright syndrome. McCune-Albright syndrome, where the patient would be having a precocious puberty, polyostotic fibrous dysplasia, and a segmental cafe-o-like macules. Clear? That is about brownish discoloration. So both this brownish discoloration, they both are called as cafe-o-like macules. Cafe-o-like macules. Shall I move to the next one? All of you comfortable? Is everything fine? Should I go a little bit slow, or is the pace all right? Are you able to understand? Are you able to recollect? Okay, so I'll just continue now. Okay. So now we have left all those brown color, black color. Now let us come into blue color skin. So in this blue colored skin, what about this one? What do you call for this blue colored skin? This is called as Mongolian spots. Very good. Mongolian spots. So these are examples of Ceruloderma. ये Mongolian spot है. So for Mongolian spot, will you advise the patient to go for a laser therapy? हमें कोई laser therapy चाहिए क्या for Mongolian spots? Yeah, it is not required because Mongolian spots are going to be self-limiting. Now how about this one? In the face of the patient there is a bluish discoloration, as well as over the sclera also you can find a bluish discoloration. So what should be this finding? So this finding is going to be, yes, nevus of Ota. So remember Ota for the eyes. So nevus of Ota is where you can find the bluish discoloration over the face as well as over the sclera. But sclera not in all the patient. In approximately 30% of the patients will have a bluish discoloration over the eyes. Now how about this last one? Where do you find this bluish discoloration now? There is a baby who is having a bluish discoloration over the shoulder area. So what is this? Again, a spot diagnosis. This is going to be nevus of Ito. So nevus of Ota for eyes or the face, and Ito for the shoulder. Ito for the shoulder. Clear? चलो. And how about the treatment? Mongolian spots के लिए कोई treatment की जरूरत नहीं है. But how about these two? What should be the treatment of this one? This can be a Q switched ND-YAG laser. Q switched ND-YAG laser is going to be the treatment of nevus of Ota and nevus of Ito. Chalo. So now let's go into another very important topic in dermatology, that is a pemphigus group of diseases. So a pemphigus group of diseases में क्या होता है? Yeah, the patient can come to you with vesicles or bulla, isn't it? Bullous lesions over the body. So let's talk about the most common type of pemphigus first, that is pemphigus vulgaris. So vulgaris again most common. So how does a patient present? Please remember, any MCQ of pemphigus vulgaris will always tell you that the patient is having, where will the lesions start from? That is a key point for you. Okay, the lesions will always start in the oral mucosa. So oral mucosal erosions along with a flaccid bulla. So if you see this one starts in the oral mucosa along with a flaccid bullous lesions over the trunk, that the diagnosis is going to be pemphigus vulgaris, isn't it? Pemphigus vulgaris. I'll just show you the image also. So this can be lesions over the oral mucosa as well as the lesions over the trunk. That is going to be pemphigus vulgaris. What is the defect here? Any answer? Because the cells are usually sticking on to each other, keratinocytes. यहाँ पे क्या होगा? The keratinocytes will start separating because there is a defect of the desmosomes, isn't it? Yeah, capillary hemangioma. Yeah, no treatment. See, what happens in capillary hemangioma is that over a period of time, like 50% regression happens by 5 years. Around 70% happens by 7 years, 90% by 9 years. That is how you can remember. the strawberry hemangioma and all. So which means by around 10 to 12 years it will disappear. Okay, Hemant. Yeah. So now let's talk about pemphigus vulgaris. Please remember the defect is a desmosomal defect. The name is desmoglein 3 or desmoglein 1. That is a defect that can be seen in pemphigus vulgaris. So in pemphigus vulgaris, I'll just show you some more images now. So what is the importance in histopathology of pemphigus vulgaris? See, in the histopathology, there is a split here, which means there is a split just above the stratum basale. So this is stratum basale. So there is a supra basal split. So since there is a suprabasal split, what will happen to the keratinocyte? Yeah, what will happen to the keratinocytes in the stratum basale? The keratinocytes which was present like this will also now get separated like this. So when there is a separation like this is compared to a row of tombstone appearance. Row of tombstone appearance. Okay? So that is what you can see in pemphigus vulgaris. Now, can anybody tell me what is the name of this investigation which is done in pemphigus vulgaris? What is this investigation? Because in the last NEET PG exam as well as in the INICET, दोनों exam में they asked you about this investigation. One of the question was very simple, but tell me the name of the investigation that is done in vesiculobullous diseases. What is the name of this investigation, anybody? Yeah, this is called as DIF, that is direct immunofluorescence. ये जो direct immunofluorescence है in pemphigus vulgaris, the name of this pattern is called fishnet pattern or a chicken wire pattern. Fishnet pattern or a chicken wire pattern. Okay, IgG and C3 can be deposited in a fishnet or a chicken wire pattern when it comes to pemphigus vulgaris. Just a minute. Becker's nevus. I think you are asking about Becker's nevus because you are seeing this image. So just as 1 second, all of you. So in this image, you can see bluish discoloration. In case this color was brown, in such cases, you can think that this is going to be a Becker's nevus. Because Becker's nevus, the color is going to be brown in color, whereas in nevus of Ito, the color is going to be blue in color. Okay? So now let's move further. So in this case where a patient is having pemphigus vulgaris, if I apply a tangential pressure, imagine I am applying a tangential pressure over the skin. I'm just pulling the skin on a tangential pressure. The skin may get peeled off. What is the sign that I'm talking about? Any answer? Pemphigus vulgaris is having a flaccid bulla, and if I'm applying a tangential pressure, the bulla will get peeled off. The bulla will get peeled off. This is called as Nikolsky sign. So Nikolsky sign. So please note down that Nikolsky sign can be seen in pemphigus vulgaris, pemphigus foliaceus, as well as a disease called as 4S, staphylococcal scalded skin syndrome. So in all these diseases, we can see a Nikolsky sign. What is Nikolsky? Skin peels off on tangential pressure. Skin peels off on tangential pressure, that is called Nikolsky sign. So now let's deal about pemphigus foliaceus. Now, how did I tell you that we can definitely diagnose pemphigus vulgaris? Vulgaris can be diagnosed when a patient is having oral mucosal lesions and a flaccid bulla. Now, it's very simple. In pemphigus foliaceus, patient presents to you with flaccid bulla. But the most important differentiating factor is there is no oral mucosal lesions. So if there is no oral mucosal lesions, then this is called as pemphigus foliaceus. Important thing, easily breakable bulla, but no oral mucosal lesion. Answer is pemphigus foliaceus. What is the defect here? The defect here is only going to be desmoglein 1. Desmoglein 1. Whereas the DIF is going to be the same. What is the DIF? The same image here once again. That is fishnet pattern or a chicken wire pattern. Fishnet pattern or a chicken wire pattern. Clear? Now let's go to the last one. So another very important type of pemphigus or vesiculobullous disease is bullous pemphigoid. Now, bullous pemphigoid and pemphigus vulgaris and pemphigus foliaceus. What is the main difference when it comes to a bulla? Any answer? So how will the patient present to you? Will the patient present to you with easily breakable bulla or a flaccid bulla? The answer is no. How does the patient present to you? The patient present to you with a tense bulla. So if the MCQ will say that the patient is having a tense bulla, not easily breakable, think about bullous pemphigoid. यहाँ पे what is the defect that is going to be seen? Is it going to be any desmosomal defect? बिल्कुल नहीं. The defect is very deep into the skin. So this is going to be BPAG2 more than BPAG1. That is going to be the defect in bullous pemphigoid. Bullous pemphigoid. It's a much deeper lesion that is below the epidermis. So इसीलिए if you do this DIF in bullous pemphigoid, what do you see here? Do you see any fishnet pattern? बिल्कुल नहीं. There's no fishnet pattern. So here, if this is epidermis, if this is dermis, in between the epidermis and dermis, you can see a green color line, isn't it? So there is a linear fluorescence over the basement membrane zone or dermoepidermal junction. So this area is called as the basement membrane zone or the dermoepidermal junction. So what is deposited? It can be either IgG or C3, which can be deposited linearly. Okay, in bullous pemphigoid, it is going to be linear deposition. Is that clear? So now let's talk about some of the malignancies. So the first malignancy that we will talk about is a basal cell carcinoma. So for your exam, if you get this image like this, it's a spotter. It's a spot diagnosis. Why do I say it's a spot diagnosis? Because whenever you see a rolled up border with a central telangiectasia, so in the central part, there is some reddish discoloration also. So this is going to be called as basal cell carcinoma. Rolled up border with central telangiectasia is called as basal cell carcinoma. Okay? So now let's move on. This is the most common type of skin malignancy. And what is a rodent ulcer? Rodent ulcer is also a type of basal cell carcinoma, isn't it? So this is a type of basal cell carcinoma which can destroy the tissue underneath. It can destroy the tissue underneath. About this one, can anybody tell me a spot diagnosis? It's already written there, malignant melanoma, isn't it? So this one is malignant melanoma because whenever you get a new mole and we have to evaluate it with the ABCDE algorithm. So we have to always evaluate this mole with an ABCDE algorithm. This is called as malignant melanoma. What is A? Asymmetry. B? Border irregularity. C? Color. D? Diameter. E means evolving in size, color or the shape. That is called malignant melanoma. Can be a spotter. When you see this asymmetric lesion, This area is darker, this area is lighter. So all these things are in favor of malignant melanoma. So now let's move to one more spotter now. Just see this image. Tell me a spot diagnosis. Patient's armpit is being shown. There is a hyperpigmentation over the armpit and there is some investigation that is shown. In that investigation, we can see a coral red fluorescence. Diagnosis below. Very good. So this is called as erythrasma, where you can find coral red fluorescence, which was asked in the last exam in a Woods lamp examination. In a Woods lamp examination. Can you also tell me what is the causative? Is it caused due to Staphylococcus aureus or is it caused to streptococcus or some other bacteria? Yeah, Shivangi is answering. The causative here is Corynebacterium. So remember, this is caused due to Corynebacterium. It is not caused due to any Staphylococcus or Streptococcus. This is caused due to a Corynebacterium, which is a commensal bacteria present in all of our body. So now let's see some of the spot diagnosis, which can be seen with bacteriology. Okay. Anyways, I think the next session is by Mamta ma'am. So she'll be discussing more of all these bacterial infections. But let us just do a quick labeling of some of the common bacterial infections. If you find a group of pustules like this, what is the diagnosis? No, this is not carbuncle. Whenever you see a group of pustules, the diagnosis should be folliculitis. Yeah. Earlier, when we discussed about psoriasis, I said when you see pustules, that is going to be sterile pustules. But folliculitis mein kya hoga? If we send this for investigation, the investigation will be positive for Staph aureus. The investigation will be positive for Staph aureus. So now let's see the remaining two images. First, I will label this image. Wherever in our body, when there is a small abscess or a boil, we call it as a furuncle. It is also called as a boil. So whenever there is a small abscess or a boil, we call it as a furuncle. But furuncle is actually an infection of a single hair follicle. If multiple hair follicles are involved, it looks something like this, where there is a pus underneath the skin, multiple hair follicles ka infection. This is called as a carbuncle. So this is an infection of multiple hair follicles. Okay? So we have discussed about three: folliculitis, multiple pustules. Single hair follicle is going to be a furuncle and multiple hair follicle is going to be a carbuncle. Clear? Who usually can get a carbuncle? Which type of patients can get a carbuncle? Multiple hair follicle gets infected, especially around the neck region. Any idea? Yeah, this is seen in diabetic patients. Okay, it is more commonly seen in diabetic patients. Excellent. So now let's move on to the next one. Yeah, this is again bacteriology, impetigo. So in impetigo, I mainly want to emphasize on only one point here. Why do you say that this one is impetigo? This one is impetigo because of the characteristic of the crust. So what is the characteristics of the crust here? So here the color is going to be golden yellow crust. Okay. So if there any question which says golden yellow honey colored crust, then the answer should be impetigo contagiosum. Whereas there is another type of impetigo which is called as the bullous impetigo. Do you know what is the color of the crust when it comes to a bullous impetigo? So all of you were writing in the chat box ki honey colored crust can be seen. But what about when it is a bullous impetigo? Bullous impetigo mein we can see a varnish crust. A varnish or a brown colored crust. be seen. So that is very important when it comes to impetigo. That is important when it comes to impetigo. Now let us also talk about a few more bacterial infections where a patient can come to you with fever plus chills plus an inflamed skin. So imagine that you are the doctor in the casualty and you are getting a patient who is having fever, high grade fever and chills. And along with the chills, you examine that there is a inflamed skin, sometimes over the face, sometimes over the lower limb. Now what should come to your mind? Yeah, Anushri is saying erysipelas, Taufik, Medico, all of you are saying about erysipelas. Chalo, theek hai. So यहाँ पे we have two differential diagnoses. It can be either erysipelas or it can be cellulitis. Erysipelas versus cellulitis. I completely agree. Now, how can we differentiate a erysipelas and a cellulitis clinically? Clinically differentiate कैसे कर सकते हैं? When the borders are well defined. So when the borders are well defined borders, that is going to be erysipelas. Whereas when the borders are going to be ill-defined, like here, so we cannot define where is the border of this lesion in this leg. So ill-defined border is going to be cellulitis. Okay? So fever, chills, inflamed skin. Two differential diagnoses, erysipelas and cellulitis. Well-defined border, you should think about erysipelas. Ill-defined border, think about cellulitis. So now let's do some fungal infections now. Now, if there is an infection of the scalp, we know that this is called as tinea capitis. In tinea capitis, one of the most common infection is called as a chirion. So what happens in a chirion? So chirion is also a condition where a patient can develop a scarring alopecia. So I'm just repeatedly saying about the examples of scarring alopecia क्योंकि we learned about lichen planus. Lichen planus में क्या होता है? Scarring alopecia होता है. Chirion में क्या होता है? Again, we get a scarring alopecia. It is not non-cicatricial. It is cicatricial alopecia, where a child can have a painful swelling of the scalp. When a child is having a very painful swelling of the scalp along with hair loss, this is called as chirion. And in all these kind of tinea capitis, the drug of choice also you can remember, this is going to be griseofulvin. The drug of choice is going to be griseofulvin. And what about this image? If you get a patient who is having a round lesion, itchy lesion, और आपको scaling भी दिख रहा है, so round lesion है, itchy lesion है, scaling भी present है, then what is the diagnosis? The diagnosis here should be something what we call as a ringworm. So what is this ringworm? Medical terminology क्या है ringworm का? So ringworm should be tinea corporis, isn't it? So this one can be tinea corporis. Can you quickly tell me कि whenever you are suspecting a chirion or a tinea corporis or any fungal infection, आपका investigation of choice क्या होना चाहिए? What should be the investigation of choice? I'm just waiting for your answer in the chat box. Investigation of choice. Would you like to go for a Zank smear? Would you like to do a Wood slam examination? Would you like to do a diascopy? Yeah, something else. Exactly. So in all these cases, the investigation of choice should be KOH test. KOH test should be the investigation of choice. Now, if you get a patient who is having a tinea infection of the groin area, can we just label or just write down the spot diagnosis here? Agar a patient is having a itchy lesion over the groin area and you see something like this, so what do you call for this tinea? This is also called as tinea cruris. Very good, Taufik. You call it as tinea cruris. Okay, dhobi itch, yeah, jock itch. That is also called as tinea cruris. Now in the last to last exam, they asked you about this thing called as tinea incognito. So what is tinea incognito? When a fungal infection is treated with steroids, this is called as tinea incognito. क्योंकि fungal infection है. So how should we treat a fungal infection? We should treat it with antifungal agents, correct? But unknowingly, or if you treat a patient with steroids instead of antifungals, it is called as tinea incognito. So what should be the treatment or management of a tinea incognito? You have to stop something, you have to start something. So what should you stop? Should stop steroids. And what should you start? Antifungals. So that is called as tinea incognito. Clear? So चलते हैं Pityriasis versicolor में. So Pityriasis versicolor we have already discussed during the beginning of this session. क्योंकि Pityriasis versicolor. See this term now, versicolor, which means two different colors. The patient can either have hyperpigmentation or hypopigmentation. Because whenever we see these two terms in the MCQ, the patient may present to you with hyperpigmentation, yeah, hypopigmentation. So when you see both these things, you tend to rule out one. So that is not the scenario here. So here the patient can either present to you with hyperpigmentation like this, yeah, hypopigmentation like this. Both the cases, एक ही diagnosis है, pityriasis versicolor. What is the investigation that you will do here? Investigation is again going to be potassium hydroxide test. Potassium hydroxide test mein we have seen this. See, we can see that the patient is having either these kind of lesions, that there are some spores that can be seen, and there can be some hyphae also, spaghetti and meatball appearance. Just one more question here. What is the causative organism here? Causative organism is called as, can anybody say what is a causative organism? The causative organism here is going to be Malassezia globosa more than Malassezia furfur. Malassezia globosa या Malassezia furfur. That is going to be the causative organism when it comes to Pityriasis versicolor. चलो अभी थोड़ा deep fungal infections, isn't it? So abhi deep fungal infections mein what do you see? You can see that there is the hand of a patient that is seen. In the hand you can see that there are multiple nodules can also be seen. Spotter batao. What is this spotter? There is no question, just you are getting an image like this for your exam. And what should be the diagnosis? The only clue is it should be a deep fungal infection. Exactly. So this is sporotrichosis. Sporotrichosis is also called as rose gardener's disease, isn't it? Rose gardener's disease. So because of a prick with a rose thorn, a patient can develop multiple nodules over the skin, which is considered to be a deep fungal infection due to Sporothrix schenki. Abhi, the pattern of the rash, you can see there are linear arrangement of these nodules. As a linearly arranged queue hai, all these nodules. So there is a linear arrangement because this is running along a lymphatics. So this is running along a lymphatics. Clear? Now how about the next one? There is a farmer who presents with this kind of a leg. So till now, every time they give you a question like, it's again a repeatedly asked topic. Farmer with this large lesions over the leg. What should be the diagnosis here? So this one should be, yeah, Madura foot. Madura foot or mycetoma. Mycetoma. So how many of you think that Madura foot or mycetoma is completely a fungal infection? So do you agree with me if I would say that Madura foot is a exclusive fungal infection? Agree or disagree? Exactly, you have to disagree because this can either be a bacterial or a fungus, isn't it? It can be either. So if it is caused due to a bacteria, we call it as actinomycetoma if it is bacterial. Whereas if it is fungal, we call it as eumycetoma. Eumycetoma if it is going to be fungal. Clear? Exactly. So now let's go to the next one. Now this next one, as you know, it is already labeled as a viral skin infection. Now this is a spot diagnosis. I'll just zoom this image for you. So when you see this image, you can see that the patient is having multiple papular lesions over the skin. But in all these papules, there is a central umbilication. That is a clue. Spot diagnosis, batao. This is going to be molluscum contagiosum. So this is a viral disease, isn't it? Caused due to a pox virus, molluscum contagiosum virus 1. Now, there is one more phenomenon which can be seen here. Like patient, if this is the first lesion, then second, third, fourth, fifth lesions can be seen here. Like one lesion after the other. So if there is one lesion after the other, then what is this phenomenon that I'm talking about? Yeah, very good. Spidey, Anushri, all of you are answering it right. So this is also called as pseudo Kobner phenomenon. Okay, earlier we learned about Kobner phenomenon. Now we are learning about pseudo Kobner phenomenon. One lesion after the other, usually because of auto inoculation of the virus. So last one before we go to the next topic, that is what is the histopathology finding here? If I just excise one of the lesion, what is the histopathology finding that I can see in a molluscum contagiosum? Yeah, this is called as HP body. What is HP? Patterson body. Patterson bodies can be seen. Yeah. Now this is again a repeated question for FMG exam. If you go through PYQ, every exam you get this repeated topic. What is it? Some lesions over the genitalia. And these are some verrucous lesion, rough warty lesions over. Yes, Ranjit sir. Yes, Patterson bodies. So now let's come into condyloma acuminata. So is it lata or acuminata? Because some of you are saying that it is condyloma lata. So is it lata or acuminata? So this one is condyloma acuminata. So what is condyloma acuminata? These are the warty lesions that you see over the genitalia. So this genital warts is called as condyloma acuminata. Quickly tell me what is the causative or which subtype of HPV can cause condyloma acuminata? Yes, 6 and 11. How would you say, is it a high risk subtype or low risk subtype? High risk है या low risk है? Yes, so both these are going to be low risk subtype, which means that this is not going to proceed into a malignancy. Correct? It is not going to proceed into a malignancy. Please remember the treatment of condyloma acuminata also. So any idea what is the treatment? Because it is not the common treatment like what you do for your warts over the palms and soles. So it is going to be a little bit different here. The treatment of cryotherapy can be used, but that is not the treatment of choice when it comes to condyloma acuminata all the time. Any other answer? So we can go for something called as podophyllin, isn't it? Podophyllins can be used for the management. Whereas when do we go for a cryotherapy? So the treatment in pregnancy should be cryotherapy. Because podophyllins can be, see, imiquimod or podophyllins. They can be teratogenic. Which means the patient can deliver a baby with a birth defect, isn't it? So whenever there is pregnancy, we have to go for treatment with cryotherapy. So now let's talk about some few points regarding genital ulcer diseases. So in genital ulcer disease, See, we all know that there are different diseases which can cause genital ulcer. Please remember one important point here. Just try to remember the names of, yeah, after RD Singh, probably in another 15-20 minutes, we'll be able to wind up with Derma, and then we will have micro sessions by Mamta ma'am. Okay, so now let's talk about some of the genital ulcer diseases. So please remember painless genital ulcer. So painless genital ulcer, please remember it as LSD. So all of you know that LSD is a drug. You take a drug, you may not get to know the pain, isn't it? Think something like that, and then let us try to learn about painless genital ulcer. So L, it stands for LGV, S stands for syphilis, and D stands for donovenosis, and D stands for donovenosis. So that is how you can remember the painless genital ulcer. This itself will help you in most of the genital ulcer disease, because question is always going to tell you कि a patient presented with a painful ulcer या फिर painless ulcer. So based on that, you definitely would be able to rule out few things. Now just correlate these two images. Tell me one diagnosis. Because in the second image, I can see that the investigation being done is a dark field microscopy, where you can see what kind of motility of the organism. Yeah, the corkscrew motility. So this is going to be syphilis. So this is going to be syphilis because it is caused due to Treponema pallidum. Okay, so now let's go to the next one. So just correlate these two images. Give me one single diagnosis. See, Spidey, about condyloma lata, these are usually going to be flat-topped lesions on the genitalia. Whereas in condyloma acuminata, you can see rough-surfaced verrucous lesions. That is how you can differentiate. Okay? Yeah. So here what you can see is, you can see the gram staining here. So in this gram staining, you can see a very typical appearance. What is it? School of fish appearance. School of fish, isn't it? Or the railroad track appearance. Railroad track appearance. So where do you find the school of fish or the railroad track appearance? Yeah, this can be seen in chancroid. Very good. Chancroid, or with Haemophilus ducrei. Okay, with Haemophilus ducrei. So in case you get any image like this, this is the easiest genital ulcer image that you can get, because it can be a spot diagnosis also. Now correlate these two images and give me one diagnosis. What I can see is a ulcer which looks beefy red in color. Beefy red in color, isn't it? So what is this? Yes, so this is seen in donovenosis. This is seen in donovenosis. So in donovenosis, if you do a tissue smear, what you can see is something like this, a closed safety pin appearance. Can you quickly tell me what do you call for this closed safety pin appearance? So these are called as Donovan bodies. So these are called as Donovan bodies, which will help you to diagnose donovenosis. Chalo, let's do the last genital ulcer disease, which is called as herpes genitalis. So in herpes genitalis, what do you find in herpes genitalis? Yeah. So here you get multiple vesicles, isn't it? This is also usually caused due to herpes simplex virus. What is more common, HSV1 or 2? It is usually seen with HSV2, and please remember this is the most common type of genital ulcer disease. Genital ulcer disease. Yeah? Okay. So this is the image which I was talking about earlier. Somebody was asking about how do we differentiate between a condyloma acuminata and condyloma lata. So here you can see these flat topped lesions. So this is going to be condyloma lata. So what is a causative organism? So the causative organism here should be Treponema pallidum. And in which type of syphilis do you find this condyloma lata? Do you find them in primary syphilis, secondary syphilis, tertiary syphilis, or congenital syphilis? These are the four options for you. So condyloma lata, this can be seen in secondary syphilis. Okay, this can be seen in secondary syphilis. It's a highly infective lesion which can be seen in secondary syphilis. So a few things about a genital discharge. So whenever a patient is having a genital discharge disease, it can be either due to gonococcal urethritis or it can be due to non-gonococcal. Easily, how can you differentiate between gonococcal and non-gonococcal? Can you tell me which is more severe? Where does the patient present to you with purulent discharge along with severe dysuria? So when a patient will present with severe purulent discharge and a severe dysuria, then think about gonococcal, isn't it? Gonococcal itself, you know, the causative should be Neisseria gonorrhoeae. Whereas if a patient is presenting to you with some scandy mucoid discharge and a variable dysuria or not that severe kind of a dysuria, then think about a non-gonococcal. So here in non-gonococcal, what is the most common organism? So what is the most common organism which can cause a non-gonococcal urethritis? This should be chlamydia. Okay. So this is usually caused due to chlamydia. So that is about few things about discharge diseases. So another very important disease when it comes to parasitic infestations is going to be scabies. So in scabies, what is the type of skin lesion? The skin lesion in scabies, what do you call? Especially you look for this lesion in between the finger webs. So in the finger webs, you can see a S-shaped serpiginous pathway. So can anybody name what is the name of this lesion that you are looking for in scabies? In scabies, the lesion is called as, very good, Dr. Max, it is called as burrows. So this is called as burrows, where a patient can present with severe itching, especially during the night time. That is why we call it as nocturnal exacerbation. Symptoms become much more severe during the night time. And what is the treatment when it comes to scabies? When it comes to scabies, the treatment should be permethrin. And also try to remember that 5% of permethrin can be used in the management of scabies. Okay, 5% permethrin can be used. So just moving to the next one, that if you get a child who is having a toad-like skin. So what is a toad? Toad is a little frog. Toad-like skin. This is a condition which is called as, any idea? Especially over the elbow region. When you just palpate, you get a feeling like it's a little frog. So this is called as phrynoderma. So this is called as phrynoderma. However, this phrynoderma is not very specific to any vitamin deficiency. It can be seen with a lot of different vitamin deficiencies. So now let's talk about some of the vitamin deficiency. This is one disease or an image which is repeatedly asked for your exam. So what is this disease? Where you get a photosensitive rash around the neck. Yeah, this one is called as Cazel's necklace. And what is a vitamin deficiency that we are talking about? Yeah, this is called as pellagra, where you are getting a vitamin B3 deficiency. So there is a vitamin B3 deficiency. So these are mostly maize eaters, isn't it? All of you know about the 4 Ds of pellagra: the diarrhea, dermatitis, dementia, and in untreated cases, it can lead to death as well. How about this one? There is a child who is presenting to you with a rash. And the peculiarity of the rash is it is seen as periorificial, around the mouth, around the nose, around the eyes, around every orifice there is a rash. Yes, this is due to zinc deficiency. And what is the name of this condition where you have a zinc deficiency? This is called as acrodermatitis enteropathica. So this is called as acrodermatitis enteropathica, where there is a zinc deficiency. Is it an autosomal dominant condition or autosomal recessive condition? And the next question, so please remember this is going to be a autosomal recessive condition. Autosomal recessive condition. So a few things about some drug eruptions. So in case after taking a drug, a patient is developing a hyperpigmentation, be it over the lips, be it over the genitalia. So this is called as fixed drug eruptions. Okay. So and always this lesion will have a hyperpigmentation on taking a drug. And what happens when a patient is going to take a drug once again? The hyperpigmentation will reappear at the same site. That is what we call as fixed drug eruption. The lips and the genitalia are the most common sites. Okay, these are the most common sites where you can find a fixed drug eruption. So talking about a very severe type of a drug eruption, which we call as Stevens-Johnson syndrome or toxic epidermal necrolysis. So what happens? The patient will have massive peeling of the skin. So imagine that a patient has taken a antibiotic like amoxicillin. After taking an amoxicillin tablet, the patient is coming to you with massive peeling of the skin along with the involvement of mucosa. Then you suspect very severe drug eruption, which is like the Stevens-Johnson syndrome or toxic epidermal necrolysis. Okay, or toxic epidermal necrolysis. So it's considered to be a very severe thing. But are they the same entity? Actually, we can separate what is Stevens-Johnson and what is toxic epidermal necrolysis based on the body surface area involvement. If less than 10% of body surface area is involved, then we call it as Stevens-Johnson syndrome. Okay. Whereas how do you call which is toxic epidermal necrolysis? More than 30% of the body surface area, we call it as toxic epidermal necrolysis. So obviously all of you guys know what is more dangerous, which is having more mortality. Mortality must be higher definitely with toxic epidermal necrolysis because the body surface area involvement is higher, more than 30%. So this is how this skin can look like because of massive peeling of the skin. And what is this? A very common condition where the neck region or the axilla can look hyperpigmented, velvety in nature. So this is again a spot diagnosis, a repeatedly asked topic. So what is this? Yeah, Anar is answering. So this is called as acanthosis nigricans. So there are a lot of associations of acanthosis nigricans, but please remember the most common association of acanthosis nigricans is with obesity, because you may have learned that acanthosis nigricans is associated with metabolic syndrome X, PCOS, etc., diabetes, PCOS, all these things. So all these are the associations, but remember obesity is the most common association of, yeah, insulin resistance, obesity, all these are the common associations of acanthosis nigricans. So I think with that we have completed the dermatology, the important topics in dermatology. Okay, so following dermatology, we have a session by Dr. Mamta Java next for microbiology. And I wish you all the very best. I hope this session was helpful to all of you. So just few days for the exam. So just stay focused, try to be on track. So don't give up and try to practice maximum MCQs. For dermatology, as you know, that mostly image-based questions will be asked. So whatever we have discussed today, I'll be sharing you this annotated PDF via the Telegram group as well. Okay. So thank you so much. I wish you all the best. Yeah, Shivangi, patch test is our investigation of choice in allergic contact dermatitis. Okay, where we apply a patch over the upper back of a patient to understand to what the patient is allergic to. Okay. So thank you so much, all of you. So I will not delay further. If there is anything else, we will definitely be in touch through the Telegram group of Medit. So wishing you all the very best for, yes, Ambika will be sharing the annotated PDF. So wishing you all the very best for your exams. So stay focused and keep preparing. So we'll get back to you again soon. Thank you so much.
Hi everyone, good evening. I hope the audio and video are clear. Let me know please in the chat box. Good evening everyone. Audio and video are fine. Please let me know. Then we'll start. Okay. Good evening Vasundhara, Vidya, Bhanu. Hello everyone. Hi Shivangi. Welcome to the FMG Maha Marathon session, day 5. I hope you all have been enjoying these sessions. The annotated PDFs are being shared with you after the session, so make full use of these sessions. So starting with my subject, I have added many high yield topics in this session, and I do hope that you have downloaded the updated workbook. The previous one, which was earlier shared, that had a little issue with the formatting, and this was shared yesterday again in the group Telegram group of PW Merit, and today evening also it was shared. I hope everybody has got this workbook only, which you are seeing on the screen. चलो फिर we'll start. Hi Dr. Max. तो देखो सबसे पहला टॉपिक हम लेंगे नेगेटिव स्टेन्स पर. स्टेन्स पे काफ़ी कॉमनली क्वेश्चंस पूछे जाते हैं. नेगेटिव स्टेन्स के फटाफट से मुझे बता दो क्या लिखें हम. व्हाट आर द इंपॉर्टेंट एग्जांपल्स. क्विक. दिस इज गोइंग टू बी एन इंटरैक्टिव सेशन. एक प्रकार से आपकी एक रिविजन ही होगी इस सेशन के माध्यम से. एंड आई वुड रिक्वेस्ट ऑल ऑफ यू टू to interact with me when I'm asking some question. Kindly attempt to answer. Does not matter if the answer is wrong. It is okay to make mistakes now so that we learn from those mistakes and we don't make any mistakes on the D-Day. ठीक है. तो चलो. What do you think are the important negative stains used in diagnostic microbiology? We have got India ink and nigrosin. And what is the purpose of these negative stains? The purpose is to be able to visualize the capsulated organisms. So, India ink and nigrosin. And the purpose is to see capsulated microbes. ठीक है. अब एक बहुत commonly asked question is on Cryptococcus neoformans, which all of you know is what? It is a true yeast and this fellow is pathogenic also. ठीक है. And this very same picture has been asked in the entrance exams. So this is a picture of India ink preparation whereby we are seeing what? We are seeing the budding yeast cells of Cryptococcus neoformans, and sometimes this halo which you are seeing around these spherical cells, these halos are representative of the capsule of this organism. So this is one of the examples of those fungi which have got a capsule. So the capsule is a PS capsule, that is the polysaccharide capsule. Please remember this. Okay, a very straightforward question on negative staining. Then we have differential stain. इसमें we have to remember of course gram stain, जैसे कि the name itself implies this stain has got a lot of weightage. ठीक है, तो काफी वजनदार stain है. It was devised by whom? Sir Hans Christian Gram. And gram stain gives us a lot of information in very short span of time, लगभग 3.5 मिनट में, 3.5 minutes में we get a lot of information. And what is that information? What kind of bacteria are there in the clinical sample? So gram stain classifies bacteria into gram positive and gram negative, and the basis is what? Basis is the difference in the cell wall. ठीक है. Now please remember guys, whatever I've added in this workbook, each and every line is an MCQ. ठीक है, तो इसको याद रखना. Hi Mohammed, I am good. How are you? I think you have been attending the previous live sessions also. So good to see you attending this session as well. Okay, so the steps of gram stain have been asked. तो प्लीज ये मत सोचिएगा कि स्टेप्स हैं ये तो सेकेंड ईयर में ही आते हैं, एंट्रेंस में नहीं आ सकते, ऐसा कुछ भी नहीं है. ठीक है, सो समटाइम्स सच सिंपल क्वेश्चंस व्हिच आर वेरी वेरी स्कोरिंग आर आस्क्ड, एंड इट इज डेफिनेटली देयरफॉर वेरी वेरी इंपॉर्टेंट टू रिवाइज सच सिंपल थिंग्स आल्सो. ठीक है, सो दीज आर द 4 स्टेप्स व्हिच यू आर सीइंग ऑन द स्क्रीन. सो पहला स्टेप क्या होता है? एप्लीकेशन ऑफ अ क्रिस्टल वायलेट डाई. ठीक है, क्रिस्टल वायलेट डाई बेसिकली इट इज एन एग्जांपल ऑफ अ पैरा रोज एनिलीन डाई. Para rose aniline dye, we can use crystal violet or gentian violet or methyl violet. I'm writing in brackets. It's an example of para rose एनिलीन डाई. अब नाम से ही पता चलता है कि ये वायलेट कलर की डाइज होती हैं. सो मान लो पेशेंट के सैंपल में इस प्रकार के ऑर्गेनिजम्स हैं विच यू आर सीइंग ऑन द स्क्रीन. सो मॉर्फोलॉजिकली वी कैन सी 2 shapes, द स्फेरिकल वंस एंड द रॉड शेप्ड वंस. ठीक है, तो जो स्फेरिकल वाले ऑर्गेनिजम्स होते हैं उनको हम क्या बोलते हैं? कोकस. लेकिन ऑब्वियसली सारे के सारे कोकाए स्फेरिकल तो नहीं होते. लाइक फॉर एग्जांपल गोनोकोकस स्फेरिकल नहीं है, मेनिंगोकोकस स्फेरिकल नहीं है, न्यूमोकोकस नहीं है, एंड्रोकोकस नहीं है. लेकिन बस आम बोलचाल की भाषा में यू नो व्हेन वी यूज द वर्ड कोकस वी रेफर वी टेंड टू इम्प्लाई कि अच्छा ये तो स्फेरिकल होगा. तो यहाँ पे भी हम वही एक चीज लेके चलते हैं कि अच्छा स्फेरिकल ऑर्गेनिजम्स हैं और रॉड शेप लाइक दिस पेन. दीज आर द टू ब्रॉड कैटेगरीज ऑफ द शेप्स ऑफ बैक्टीरिया. तो क्या होगा? फर्स्ट स्टेप के बाद ऑल द बैक्टीरिया विच आर देयर इन द सैंपल दे आर गोइंग टू टेक अप द स्टेन. दे विल अपीयर bluish or violet in color. Okay, Adil Mohammed, noted. So after the first step, all the organisms are going to take up the violet or the bluish color. After that, you wash the slide, and then the second step is the addition of iodine, which serves as the mordant. Now you can consider mordant as a kind of fevicol or fevistick, which itself is not going to impart any color to the organisms as you are seeing on the screen. The job of the mordant is just to make sure that the primary stain, that is the crystal violet or whatever para rose aniline dye you have used, that stain is firmly attached to the cells and they retain their blue or violet color. Okay, so this is also asked as a question ki what is the role of the iodine. Okay, then the next step is washing. After every step you have to wash the slide under tap water, and here we come to the most crucial step of gram stain, which is decolorization, which is done with the help of, like for instance here they have mentioned alcohol. So the third step of decolorization is by virtue of using an organic solvent like alcohol, or let me write over here, apart from alcohol what we can use? Acetone. ठीक है, और alcohol acetone combination. Now acetone is also, remember, this is the fastest decolorizer. The nail polish remover has got what? Acetone only. That is why the nail polish remover just removes the nail polish very quickly. Okay, so after decolorization what we are seeing over here, some of the organisms, they have lost their color, some others have retained color. Now why this difference, this different response to decolorization? Because of the cell wall difference. So we can conclude that okay, we are dealing with 2 organisms which have got differences in their cell wall. And the last step is the addition of a counter stain, and that counter stain should be such a stain whose color gives a good contrast with the primary stain. So here they have mentioned saffronin, and let me also tell you that we can go for some other counter stain also. For instance, we can go for what? We can go for dilute carbol fusion. Both of these stains, safranin and dilute carbonyl fusion, are pinkish magenta colored stains. So what will happen? The decolorized organisms are going to take up the color of the counter stain. The word counter means what? Counter means opposite. So as I said, the color of the counter stain should be such that it is going to give, it gives a good contrast to the primary stain. So at the end of gram stain, what we are seeing two colored organisms. So you have to comment with what is the gram reaction, gram positive or negative. Remember, blue is the color of positivity. So the gram positive fellows are going to appear blue or violet in color, and the gram negative organisms are going to appear pinkish reddish in color. So you have to comment on gram reaction, that is whether you are seeing gram positive or gram negative or both, and then you have to comment on the shape of the bacteria. Like for instance, let me know in the chat box what should be the interpretation of this gram stain as you are seeing on the screen. Yes, definitely noted, Medico. I'll stick to only English. Okay, come on guys, what do you think this is? How should we interpret this gram stain? You are seeing things which are blue in color and certain things which are, pinkish, magenta in color. So RDC Singh, if you revise all these topics, a lot of important, lot of the PYTs will be covered. But do also go over your, own notes wherever you have done microbiology from. Whatever topics are going to be covered in today's session, those topics in themselves are sufficient. So if question is asked from any of these topics, you will be able to answer it. Okay, you can check out the previous live sessions also, which we have conducted on this very channel only, the same YouTube channel. If you do all those YouTube sessions, enough. Thank you so much, Mohammed. Now guys, I'm waiting for the answer. What should I write? What is the interpretation of this gram stain? So we are seeing what? Quickly. No, Medico. This is not methylene blue. This is gram stain only. So let's say the question is, the given below is a gram stain picture. What is your interpretation? So our interpretation is going to be, look at this. So we are seeing gram positive cocci, and you can see a definite arrangement of them also. I can comment that, okay, these are gram positive cocci arranged in what? Grape-like clusters, and I can also see these, rod-shaped pinkish organisms. Because they are pink, they are gram negative rods, but they don't have any specific arrangement as we are seeing in case of the gram positive cocci. Okay, so this is the interpretation, not spaghetti and meatball. Okay, Adil, I hope this is clear. Shahbaz, Adil. No, this is the gram stain slide. The question says you have been given a gram stain slide. I hope this is clear now. Yes, Ria, both gram positive and negative. Okay, so there are certain organisms which do not take up gram stains. So if we are suspecting infection in the patient by any of these organisms, then we should not waste time in doing gram stain. We should do other investigations, like for example, other stains. So a simple mnemonic for these is, these rascals may microscopically lack color. Now have a look at this. There was a movie. Now see this, guys. Okay, so this was a movie, Bollywood movie starring both these actors, and we can remember the organisms which do not take up gram stain like this. These rascals may microscopically lack color, where T stands for Treponema and other spirochetes, like for example, Borrelia and Leptospira. All of these are spirochetes. Then R stands for Rickettsia, M stands for Mycoplasma, and the second M stands for Mycobacteria. L stands for Legionella, and C stands for Chlamydia. So if we are suspecting infection by any of these based on the signs and symptoms the patient is presenting with, then we don't do gram stain. Nothing like that, Vasant. A lot of questions. You mean to say FMGE? No, no, no. I think there were 15 plus questions from micro, and touchwood, they were all very doable questions. And so let's keep our fingers crossed that this time also you get very easy questions from the PYTs only. Okay. Now next is next differential stain is Zeal-Nielsen stain, that is the Zn stain, also known as the acid fast stain, that is the AF stain. Okay, acid fast stain or the AF stain. Is this clear everyone? ऐसा कुछ नहीं कि क्वेश्चंस कम हुए हैं, ऐसा बिल्कुल भी नहीं है. Is this clear everyone? Okay, so Zn stain was devised by Sir Paul Ehrlich, who is regarded as father of chemotherapy. Now, acid fast means acid, non-decolorizable. Okay, so means generally what is the response to acid? Acid is going to extract out color. If let's say acid spills over the clothes or the furniture, they will lose color. But acid fastness is the property where even if you treat some organism with acid, the stain which the organism already has, that stain will not be lost. Okay, so let's say we first the first step is stain the organism, and then you stain then you add acid to the stained organism. We expect that acid is going to remove the color, but in case of acid fast organisms, what happens? They do not lose the color despite being treated with mineral acids. So that is what is meant by the property of acid fastness. So we have got broadly two categories of organisms, of acid fast organisms and non-acid fast. So the steps here also we have got multiple steps, because in differential stains obviously we are able to differentiate two kinds of organisms because of some difference in the property, and how we are able to differentiate by using two different colors. So there has to be multiple steps with one step of decolorization. So here let's say we add the primary stain, like for instance concentrated carbol fusion. Okay, and we heat the slide from beneath. Heat here serves as the mordant, If we take the example of Mycobacterium tuberculosis, which is the classical example of acid fast organism, so the most common type of TB is pulmonary TB. So let's say sputum sample comes to us, and while expectorating out the sputum, the throat commensals also are going to be present in the sputum. Now, if at all the patient is suffering from tuberculosis, the sputum sample is going to have MTB, which is acid fast, and the throat commensals are going to be non-acid fast. Okay, so the purpose of heating is what? The purpose of heating is to dissolve what is known as mycolic acid, a lipid which is present in the cell wall of acid fast organisms, which is responsible for their acid fastness property. Okay, if we don't heat the slide, then the MTB which is there in the sample is not going to take up the stain. But if we heat the slide, then mycolic acid will become liquefied and it will comfortably welcome the primary stain. The non-acid fast organisms will take up the stain anyways, but our idea is to not miss the acid fast organisms. That is why heating is done. I hope this is clear, everyone. Let me know in the chat box. So let's say this is the acid fast organism, and this is what? This is this wavy thing which I have drawn. This is nothing but the mycolic acid. And on the right hand side, let me just draw a box. This is the non-acid fast organism without mycolic acid. Then we use decolorization. Now, depending on what organism we are suspecting, what acid fast organism we are suspecting, accordingly we will make a decision to we will make a decision regarding the percentage of the mineral acid which we should use. So if you are suspecting Mycobacterium tuberculosis, the decolorizer we use is 25% H2SO4. Now, after the primary stain, both the acid fast and non-acid fast organisms will take up the pink color. When we add the decolorizer, what will happen? Because the acid fast organisms have got the property of acid fastness, they will not lose their pink color. But on the right hand side, we will encounter decolorization, meaning the non-acid fast organisms will be decolorized. Then we add the counter stain. For instance, we can add methylene blue. So what will happen? The acid fast organisms already they have taken up the color, so they will not accept any other color. But the non-acid fast organisms who had lost the color, now they will take up the color of the counter stain, that is methylene blue, so they will appear blue in color. All right. Now another example of the counter stain which we can go for. One is methylene blue, other one is malachite green. Okay, malachite green. So whatever color of the counter stain you are using, that color is going to be taken up by the non-acid fast organisms. Most commonly used is methylene blue. So I have colored the non-acid fast organisms blue in color. Is this clear, everyone? Please let me know. Is this clear, everyone? Okay, so these are the steps of the Zn staining. Application of the primary stain, that is the concentrated carbol fusion. Remember, in the gram stain, the counter stain used was dilute carbol fusion. Here the primary stain being used is the concentrated carbol fusion. Okay, then we have got heat. The second step is heat, which serves as the mordant. Then you can, apart from using H2SO4, you can also go for a combination of acid and alcohol, but most commonly H2SO4 only is used. Okay, and then we have got the counter stain. Now have a look at this. So this is the Zn stain showing Mycobacterium tuberculosis. So it is described as what? Long, slender, beaded, acid fast organisms. Acid fast, in other words, pink organisms. Okay, now this again is a favorite question of examiners. What percentage of acid fast stain we use? So as I said, for MTB, if you're suspecting MTB, then you go ahead with what? You go ahead with 25% H2SO4. For M. leprae, we use 5% H2SO4. For bacterial spores, it is 0.25 to 2.5%. For nocardia, it is 1%. Okay, rhodococcus also 1%. Head of sperm 0.5 to 1%. Legionella migdadi 0.5 to 1%. Legionella migdadi, another name for this organism is Pittsburgh pneumonia agent. And finally, very, very important, the oocysts of certain coccidian parasites 1%. Now, these are the coccidian parasites, three important ones which we are going to discuss today also. Cryptosporidium parvum, cyst isospora belli, and Cyclospora catanensis. These are notorious for causing refractory D4 diarrhea in AIDS patients. Okay, there's a difference between HIV and AIDS. AIDS, acquired immunodeficiency syndrome, is the final, or the terminal stage of infection with the HIV, human immunodeficiency virus. Okay, then coming to important aspects of bacterial cell anatomy. Firstly, flagella. Now please do not ignore this topic thinking that okay, it is anatomy, it will not be asked in the entrance exam. Nothing like that. It is being asked very, very frequently in all the exams. Okay, so flagella function is locomotion. There are certain microorganisms which are motile by virtue of flagella. Flagella are longer than pili and they have got three parts: basal body, hook, and filament. And they are made up of a protein called as flagellin protein, which has got what? The capital H antigen. Okay, H antigen. Then the arrangements of flagella, again very, very important. So let's say we have got this rod bacterium, that is the rod shaped bacteria, also known as bacillus or bacilli. So it has got two poles. Okay, this is one pole, this is another pole. Unipolar or monotrichous means what? A single flagellum is arising from any one of the poles. So this is an example of unipolar or monotrichous flagella, and the examples of these bacteria include Vibrio cholerae, which is the causative agent of cholera. Okay, and another important organism is Pseudomonas aeruginosa. Pseudomonas aeruginosa. Okay, remember that these are, VIP fellows, very, very important person, VIP. So V for Vibrio, cholerae, a small I is vowel, so that stands for nothing. P for Pseudomonas. Okay. So U for unipolar, U for also remember somebody who is very unique. Okay. People who are unique, the VIPs are a kind of unique people. So just remember U for unique, U for unipolars, and then recall Vibrio and Pseudomonas. Then we have got Lophotrichus. Lophotrichus is just like the tail of a horse, meaning a bunch of flagella are arising from one of the poles. This is the meaning of Lophotrichus. And can anyone tell me what is the classical bacterium having Lophotrichus arrangement of flagella? Anyone? Answer is Helicobacter pylori. Helicobacter pylori. Okay, then we have got amphitrichus. Amphi word means both. So let's say if this is a rod-shaped bacterium, flagella, a single flagellum is arising from both the ends. Amphi means both. So examples include alkali genes, fecalis, and spirillum minus. Spirillum minus. And then peritrichus. Now peri pertains to perimeter, meaning all over. So let's say if this is a rod-shaped bacterium, that is a bacillus, flagellae are arising from the entire surface, that is from the entire perimeter of it, and it is going to look something like this. Now peritrichus arrangement, classical example is the family Enterobacteriaceae. Like for example, E. coli, Salmonella. Okay. So remember, in Enterobacteriaceae family of bacteria, the bacteria are either motile or they are non-motile. So the ones which are motile, they are motile by virtue of presence of peritrichous flagella. Okay, and the other category is non-motile. There is no other arrangement in Enterobacteriaceae members, like we discussed in points 1, 2, 3. The only arrangement of flagella, if at all a bacterium of Enterobacteriaceae is motile, it is going to be motile only by peritrichous and not by Lophotrichus or unipolar or amphitrichous arrangement. Kindly remember this. Then the types of motility, again very frequently asked question. Darting or shooting star motility is seen where? It is seen in Vibrio cholerae, the causative agent of cholera. And remember, Campylobacter jejuni. ठीक है, Campylobacter jejuni. Remember VCD. VCD, Vibrio cholerae, Campylobacter jejuni, and darting or shooting star motility. Now, tumbling motility, classically seen in the bacterium Listeria monocytogenes. Listeria monocytogenes. This fellow is a gram-positive cocobacillus. Cocobacillus means what? It is neither properly spherical nor it is properly elongated or rod-shaped like this pen. Okay, it is somewhat midway between both the morphologies. So it looks like an oval organism. All right, this is very, very important. What is the meaning of tumbling? Tumbling meaning somebody, falls down suddenly but does not incur any injury. Okay, so that is the meaning of tumbling motility. And also please remember, Listeria monocytogenes is very moody. Not just we have our own mood swings as human beings. Some microorganisms also have got their own mood swings. Like for instance, this fellow is going to be motile in the environment. At 25 degrees Celsius, it is M for motile, and at 37 degrees Celsius, it is NM, that is non-motile. Just a little memorizing tip I will give you. This fellow is a saprophyte. Okay, it is there in the environment. So imagine when it is there in the environment, it is motile. Why? Because it is looking for some human being. It wants to disturb some human being. And when it happens to find such a human being and infects that individual, that is, it enters an atmosphere of 37 degrees Celsius, it will decide to make that person sick. So it will decide to become non-motile in the human body because it wants to stay in the human body and not, go here and there. So just a little memorizing tip. Remember this. Now, next is gliding motility. Gliding motility pertains to the motility of the, gliders, those kind of planes which are motile by virtue of the air currents and not the engines. So that is the meaning of gliding. Just the way a glider, becomes a glider moves. So gliding motility is seen in mycoplasma. Mycoplasma. Now this is pretty interesting. You know why? Because mycoplasma does not have flagella. So another MCQ over here is that which of the following motilities is not because of flagella, and then they will give you the option of mycoplasma. So remember, mycoplasma, by the way, also remember this is the smallest bacterium. B for bacterium. Mycoplasma is the smallest bacterium. It is motile but not by flagella. Then we have got stately motility. Stately word means slow or sluggish. So remember, stately motility is seen in certain members of the genus Bacillus and also certain members of the genus Clostridium. Okay, Clostridium. And then we have got swarming motility. I'll tell you in the last year in FMGE exam, which was held on 30th July 2023, there was a question on swarming, very simple question, but unfortunately many students did it wrong. I will tell you what mistake they did. The question was, which of the following gram positive bacterium shows swarming? So some students just read swarming, they did not read the question carefully, and they marked Proteus. Proteus is gram negative, not gram positive. Okay, so please be patient. The question is not running away anywhere. Please don't make mistakes in such easy questions. So read the question very carefully. Keep your calm in the exam and all of you will do well. So swarming motility is seen in Proteus. Okay, then Clostridium, tetany, and Bacillus cereus. Bacillus cereus. Proteus is what? Proteus is a gram negative rod. Clostridium tetani and Bacillus cereus, both of these are gram positive rods. Okay, so Bacillus cereus was there in that MCQ and the answer was Bacillus cereus and not Proteus. And I think on purpose the question paper setter had mentioned Proteus as option A, so that some students will do that mistake of marking Proteus just by virtue of reading swarming and missing out on the other on the remaining words in the question. So please be very careful while reading the question. Okay, now motility in spirochetes. Who are the spirochetes? Borrelia, Treponema, Leptospira. Now there are three kinds of motilities which you need to remember. The corkscrew motility, okay, the flexion extension motility, and the translatory motion, that is the spring-like action. Okay, and spirochetes are motile by what is known as endoflagella. The flagellum is not visible outside. It is endoflagella. It is present where? It is present in the periplasmic space. Because structurally, spirochetes, they have got the gram negative cell wall, even though they are not seen on gram stain because they are very thin or slender, but their structure is that of gram negative bacteria. Okay, so remember CFT. Okay, corkscrew motility is like this. Then flexion extension means the organism bends like this and then extends. Then translatory or spring-like action is like, for example, let's say this is a spring. You compress the spring and then you release it. The spring surpasses its original length and then eventually it comes back to it, retains it, regains its original length. And spirochetes are also spiral organisms just like the spring. So that is known as the spring-like action or the translatory motion of these organisms. Now, coming to the parasites which are motile. Giardia lamblia or Giardia intestinalis, also known as Giardia duodenalis. So three different names of the same organism, which is a protozoan. Now this is motile what is the motility? It is falling leaf motility. Falling leaf motility in case of Giardia. In Trichomonas vaginalis, which looks something like this as an inverted, pear-shaped organism. This is the anterior end. This is the posterior end. So two pairs of anterior flagella and a fifth flagellum comes out via the side of the organism. This is known as the recurrent flagellum. Recurrent flagellum, and the motility is described as what? It is described as twitching motility or wobbling motility, also known as jerky motility, jerky motion or jerky motility. Okay, so the anterior part of the organism is more motile than the posterior part. Now, motility is seen how? Motility is seen by a technique called as hanging drop, that is HD preparation, hanging drop preparation under the light microscope, and indirectly you can see it by electron microscope. Indirectly means what? You cannot actually see motility on electron microscope, because you cannot see live organisms under electron microscope. Electron microscope shows what? The ultrastructural details of the microorganisms, like for example flagella. So if flagella are present, you can conclude that okay, the organism should be motile. So please remember this. All of these are MCQs. Please remember all of these. Now coming to the next important question, bacterial growth curve. Now remember, there is something called as generation time or the rate of growth, which is predetermined or prefixed, or we can say it is an organism's destiny, okay, that it will multiply in so much time. So if we talk about the bacteria, the generation time or the rate of growth is the time taken for binary fission. Binary fission. Binary fission, by the way, is the name of the mode of multiplication in bacteria. So let's say some bacterium's generation time is 20 minutes. It implies that, next day only you will see the colonies on the culture media. So 20 minutes or around it, like 15 minutes or 17 minutes, 25 minutes, like that. So basically in minutes, if is the generation time, then the colonies, meaning the growth of the bacteria, colonies the next day will be seen. If it is 20 hours, then the colonies appear in how much time? Roughly 6 to 8 weeks. Like for example, we have got Mycobacterium tuberculosis. Okay, generation time of roughly 14 hours. So we have to wait for 6 to 8 weeks, for the organism to grow. If up till 8 weeks there is no growth, then only we will conclude that, okay, Mycobacterium tuberculosis was not present in the sample. Okay, then 20 days, such a long time, the colonies will appear in 6 to 8 months. Now, any organism which has got generation time in days, yes, M. leprae. That is why the culture of M. leprae, it does not make any sense. So culture is clean. Culture is, very irrelevant. It will not, we don't go for culture because it will take this much of time, and anyways we don't have any culture media to grow this organism. So remember, leprosy is what? It's a microscopic diagnosis. Okay. So coming with this basic knowledge of all these of the generation time, now let me talk about the bacterial growth curve. So let's say, we have got a broth. We have got the liquid culture media. Let's say in this test tube, this is the broth. Broth is the name of the liquid culture medium. Culture media, just remember them as or look at them as the bribe which we are giving to the microorganisms to grow for us. So patient sample comes, and let's say we add them to culture media. Culture media are going to provide nutrients. We have got solid, semi-solid, and the liquid media. The liquid media are known as broth. So let's say in this culture medium, I add these 5 organisms, which I am drawing as 5 dots. So these 5 organisms I have added to the broth. So what will happen? The organisms are being exposed to nutrients, which is a favorable condition for them. So we expect them to divide, but they will not do so immediately. There will be something called as a lag phase, somewhere over from here to here. Lag phase. Now in the lag phase, what happens? The B for bacteria. The bacteria are going to switch on their, enzymes. Basically, it's a preparatory phase, we can say. The bacteria are doing some preparation so that, after some time they will take a decision to divide. Okay, then once they are ready, once the preparation is done, now they will appear for the exam. What is the exam for them? Multiplication. So they will enter the log phase or the exponential phase, which is this. So as you can see over here, x-axis represents the time and y-axis refers to the log number of cells. So as you can see, the alphabet B indicates what? The increase in number of the bacteria. So that is the log phase or the exponential phase. So the bacteria number increases. And over here, the metabolic activity is pretty high during the log phase. But the nutrients are limited only and the bacterial number is increasing. So what will happen? A point will come where competition will start to occur amongst the bacteria for the nutrients, and also there will be a beginning of the buildup of the metabolic waste products. So then we will reach the point C, which refers to the stationary phase. So stationary phase, during it, the number of the live bacteria becomes equal to the number of the dead bacteria. And finally, as time passes by further, we will encounter phase D, when the number of live bacteria will, be lesser and lesser, and the number of dead bacteria will increase, because as time is passing by, the nutrients are getting depleted and the accumulation of metabolic waste products is increasing. So the phase of decline, the number of dead bacteria becomes more than the number of live bacteria. Now, if I ask you, the rate of growth in the log phase is what? The log phase or exponential phase. What is the rate of growth? Answer. Do you think it is increasing or decreasing, or it's constant? Anyone? Adil, Ria, Bhanu, Vasant, Mohammed. The rate of growth in log phase, what is happening to the rate of growth? No, no, no. The rate of growth is constant. It is the number which is increasing. As I said before, when I started off this topic, I told you that, the generation time or the rate of growth are the destiny of a bacterium. So if, let's say, Staphylococcus aureus generation time is 15 minutes, that is constant for it. So please remember, in this graph, the y-axis represents the number of bacterial cells. Okay, not the rate of growth. The rate of growth will be constant only. Okay, so we can say that the rate of growth begins to increase when the rate of growth increases at this point of time. Look at this. When the lag phase meets the log phase. Okay, when the lag phase meets the log phase, like this. I hope this is clear. Shivangi and Ria. Shivangi and Ria, kindly note. Okay, so the rate of growth begins to increase when the lag phase, when the lag phase meets the log phase. It just means that when the lag phase ends and the log phase just starts, then the bacteria will begin to divide. Now, bacterial cell size is maximum when, again, at the end of the at the end of lag phase. You know why? Because look at this. In the lag phase, I told you what, the bacteria switch on their enzymes and they're doing preparation. So the bacteria will become swelled up by accumulating so many enzymes. Okay. So that is why at the end of the lag phase, the bacterial cell size is maximum. Now, maximum amount of endotoxin is produced when endotoxin is present in gram negative bacteria, and it is there in their outer membrane. Okay, in the outer membrane. So obviously, when the bacteria die, they will they will become fragmented. Then the endotoxin is going to be released. So when is the maximum death happening? In the phase of decline. So the maximum amount of endotoxin is produced in the phase of decline. Phase of decline. Metabolic activity is maximum when? Metabolic activity is maximum in the log phase, and maximum exotoxin is produced when? Remember, maximum exotoxin is produced in the stationary phase. Even though few PubMed articles have commented that maximum exotoxin is produced in the log phase, because that's the phase of maximum metabolic activity, but still, quite a few texts, the standard textbooks, they have mentioned stationary phase. So if MCQ is asked, mark stationary phase only. Okay. Now the next important topic is bacterial food poisoning. Now these are very, very scoring questions. You just have to know what the patient ate, after after what time the symptoms started, that is the incubation period. Okay, and what symptoms were there. So, and then you will be able to ace these questions very nicely. So let's start. So we have categorized bacterial food poisoning into different categories. Like for example, incubation period 1 to 6 hours. So remember, sweet 16, 1 to 6 hours. Okay, so over here you have to remember two important organisms, Staph aureus and Bacillus cereus, and both of them can cause NVD. Remember, nausea, vomiting, diarrhea. Okay, Bacillus cereus can cause these symptoms when it contaminates Chinese fried rice, and Staph aureus can cause these symptoms, nausea, vomiting, diarrhea. And by the way, in brackets, please write down diarrhea is less common. Okay, vomiting is way more common. Okay, so nausea, vomiting are much more important. Remember, in these examples, Staph aureus, if present in all these food items, ham, poultry, potato or egg salad, mayonnaise, cream, pastry. So remember all these kind of foods, like mayonnaise, cream, pastries, which we generally use for when when we are celebrating something, we have pastries and mayonnaise and all. Okay, so remember it like that. Staph aureus is notorious for infecting these food items, and then after 1 to 6 hours, if the patient develops nausea, vomiting, all this is mentioned in the question. You have been told the food item. You are told that the patient develops symptoms like vomiting and all after, let's say, 3 hours. You know that the incubation period is 3 hours. So what do you have to mark? Staph aureus. If the question mentions that the patient had consumed Chinese fried rice and after 4 hours the patient started having nausea, vomiting, and few patients had diarrhea, if this kind of language is there, then you have to mark Bacillus cereus. Okay, so please remember these important examples. Then we have got incubation period in the range of 8 to 16 hours. 8 to 16 hours. Now over here, remember the amalgamation of symptoms: abdominal cramps, diarrhea, rarely vomiting. Okay, why I emphasized before that in the above, in 1 to 6 hours incubation period, diarrhea is less common because Bacillus cereus can cause another kind of food poisoning where diarrhea is the predominant symptom. And when diarrhea is the predominant symptom, that is going to occur when the incubation period is 8 to 16 hours. So when the patient is coming with these symptoms, what symptoms? Cramps, diarrhea, rarely vomiting, then you have to keep in mind these two bacteria. One is Bacillus cereus. The word cereus, by the way, comes from cereals, which were first implicated in gastroenteritis caused by Bacillus cereus. So Bacillus cereus is going to contaminate all of a variety of food items like meat, vegetables, dried beans, and cereals. So if any of these food items is mentioned and the question says that, okay, patient started having diarrhea after 10 hours, then you have to mark Bacillus cereus. But if the question says that the patient consumed, gravies, beef, poultry, legume, and started having diarrhea after, let's say, 8 hours, then you have to mark Clostridium perfringens. Please remember this. Then we have got incubation period more than 16 hours. Now here we have got different organisms based on what symptoms the patient is coming with. If the patient is having watery diarrhea, then remember two important examples: Vibrio cholerae and ETEC, that is enterotoxinic E. coli. Now, in case of Vibrio cholerae, the food item is shellfish. In case of ETEC, it is salads, cheese, meats, and water. Then we have got EHEC, which causes bloody diarrhea. Now, bloody diarrhea loosely can be used interchangeably with dysentery. Dysentery is also bloody diarrhea. But remember, in case of EHEC, strictly speaking, we call it bloody diarrhea. We refrain from using the word dysentery. This is straight, I mean, this entire table is from Harrison's textbook of infectious diseases. So they have mentioned in their table bloody diarrhea, which I am also using over here. So please remember, there is no fever in case of EHEC, mostly. Okay? But in case of dysentery, fever is also there. This is probably the reason why they did not use the word dysentery for EHEC. So for EHEC, remember the food items implicated are ground beef, roast beef, salami, raw milk, raw vegetables, and apple juice. So in incubation period more than 16 hours, remember the two types of symptoms: watery diarrhea and bloody diarrhea. Then we have got again now dysentery. Again, incubation period more than 16 hours. So two important causative agents of dysentery over here: Shigella and Vibrio parahemolyticus. Vibrio parahemolyticus is an example of a halophilic Vibrio. Okay, so the patient would have consumed some kind of seafood, and in case of Shigella, potato or egg salad, lettuce, and raw vegetables. Then again, we have got something called as inflammatory diarrhea in this category, that is more than 16 hours of incubation period. Inflammatory diarrhea meaning a lot of neutrophils are there in the fecal specimen. So we have got Salmonella species and Campylobacter jejuni. Please remember over here, we are not referring to those Salmonella species which are causing causative agent of enteric fever. Okay, so these Salmonella species, they come under the category of NTS, that is non-typhoidal salmonellosis. Okay, so Campylobacter jejuni, which has got a lot of animal reservoirs. So it's an example of a zoonotic disease, a zoonotic pathogen for us. So consumption of animal products like raw milk, poultry, and all. And in Salmonella also, here also we have got animal reservoirs present. For example, we have got Salmonella enteritidis and Salmonella typhimurium. So because these fellows also have got animal reservoirs, so basically animal consumption of meat and meat products, poultry and poultry products will be implicated in the food poisoning by Salmonella. So all these tables are straight from Harrison. Please remember this, and you will not face any problem in solving questions on bacterial food poisoning, which is a very, very important topic. Is this clear, everyone? Yes, Nizam, you're absolutely right. Vagarsuma agar, is used for growing Vibrio parahemolyticus. Kanagawa phenomenon is seen. In fact, this question was asked very, very recently in the INICT exam. Okay. See, I always tell the students now there is hardly any distinction between NEET PG, INICT and FMGE. So if you do the PYTs of NEET PG and INICT also, you will be getting an extra edge. You will gain a lot of confidence. Okay. So there is now, as I said, in most of the subjects, including microbiology, there is hardly any distinction between the kind of questions being asked in all these three exams. Okay. So good, Nizam, you pointed that out. All right. Now, the next thing which you need to know about is regarding the CSF. Okay, questions are asked on, meningitis, and I've put up this table. I'm sure you all are aware of this table, but from me as a teacher, I just wanted to, add a few points to it so that you are able to remember this. See, at the end of the day, see, there's no dearth of information is available everywhere, but what matters for any exam is how much you are able to recall during those 3 important hours. So if you are able to, if you are giving proper time to revision, you are able to remember things by certain stories or mnemonics or whatever. Then nothing can stop you. So the important thing is you should be able to remember. So that is what also I'm striving to do in this session. So as far as this table is concerned, we'll go from right to left, but before that, see the normal CSF characteristics you all know. The leukocyte count is 0 to 5, and if at all leukocytes are present, they are lymphocytes. Normal pressure is 50 to 150. Glucose 40 to 70 mg percent, total proteins 15 to 45. Now, with this background, let me talk about this table in detail from right to left. Meaning, we'll first remember viral meningitis, also known as aseptic meningitis. Yes, Nizam, that's what I said. That there is hardly any distinction. So even if you do the NEET PG and INICT PYQs, you will cover so many topics which obviously are going can be asked in FMG exam also. Okay. So this Vagat Agar definitely is important for FMG also and for other exams also. Okay, so viral or aseptic meningitis. Now look at this. The CSF pressure is only slightly elevated or normal. The total leukocyte count is 25 to 50 and the cell count, the cells are lymphocytes. Glucose is normal, proteins are normal or slightly elevated. So can I not say that, viral or aseptic meningitis is very lazy kind of meningitis? Lazy because the pressure is either normal or only slightly elevated. Okay, glucose is normal, cell count is not that high, and even the total protein, if we talk about it, it is either normal or only slightly elevated. So let me call viral or aseptic meningitis as a kind of lazy meningitis. Then we come to tuberculous meningitis, where the pressure is, now this tuberculous meningitis is a little more active as compared to viral meningitis. What do I mean by that? The pressure is moderately elevated. Cell count is roughly same as viral meningitis. Here the range is a little broader one, 10 to 500 cells. Again here also lymphocytes. Okay, then glucose is slightly decreased. This is the important point of distinction between tubercular and viral meningitis. In viral meningitis, sugar is normal, but in TB meningitis, it is slightly decreased. Okay, as far as proteins are concerned, they are moderate to markedly increased. So I can say that tubercular meningitis is a little more, hyper as compared to the viral meningitis. Now we come to the hyperest of all meningitis, that is bacterial or pyogenic meningitis. Okay, pyo means pus, genic means to produce. Okay, so here the pressure is very high, highly elevated, more than 180 millimeters of water. Cell count is also very high, 100 से 10,000, 100 to 10,000, and neutrophils are there. Remember, neutrophils, the name itself says neutro. So these are very ferocious cells. They are fantastic phagocytic cells, very hyper cells. They are the cells of acute inflammation. So here the cell type also changes. In case of pyogenic meningitis, glucose is decreased to absent and the total proteins are markedly increased. So the most active kind of meningitis kya hai? It is the bacterial or the pyogenic meningitis. Just remember this table and you will be able to solve questions on meningitis also, which are very frequently asked. Now coming to the next topic, sterilization and disinfection. So hot air oven, you all know it's a method of S for sterilization by what? By sterilization by dry heat, and what are the items which are sterilized in the hot air oven. Now when someone mentions about a hot air oven, one thing which you should remember is that anything which is made up of glass, so any kind of glassware like glass syringes, glass petri dishes and all, for their sterilization we use hot air oven. Okay, then we have got sharp surgical instruments. Okay, sharp surgical instruments. Then we have got certain chemicals like, for example, remember FOG3, where F stands for what? F stands for fats, then O for oils, G3. Remember grease, glove powder. Not gloves, glove powder. For gloves, autoclave is used. For glove powder, hot air oven is used. Okay, glove powder, then glycerol. Okay, plus also remember jellies. All right. And liquid paraffin. So remember FOG3, fats, oils, grease, glove powder, glycerol, and LJ से याद कर लो, liquid paraffin and jellies, all of these. Now the biological indicator which is used for the hot air oven is what? The biological indicator are the spores of Bacillus subtilis subspecies niger, which is also known as Bacillus atrophius. ठीक है, Bacillus atrophius, also known as Bacillus globigae. So एक ही बैक्टीरियम के तीन नाम है. There are three names of these three bacteria. There are many microorganisms which have got more than one names. Just like we have got our own official name, then one pet name at home, then another name may have been given to us by our friends. Okay, like that. So this is one bacterium with three names. Remember. Then we have got other indicators like, for example, Brownie's tube. It was devised by Sir Albert Brown in the year 1930. Okay, Albert Browane. Okay, I don't know how it is pronounced, Brownie or Brown. Anyways, so this is how this is how it looks like. So Brownie's tube has got this red colored heat sensitive dye, and it changes color to what? It changes color to green at the desired temperature. ठीक है. So if it if the color changes from red to green, it means it's a good news. It is a green signal for you that yes, whatever items you sterilized in the hot air oven, they were perfectly sterilized. You need not worry. Okay, so you can use these spores as the indicator. The spores are killed. That means whatever things you have kept inside the hot air oven are good to be used. Okay, and the other indicator, as I said, Brownie's tube. And then we can also use thermocouples, which are nothing but temperature measuring devices. These are a kind of temperature measuring device which tell us that whether the appropriate temperature is being reached or not. So the thermocouple, they record the temperature using a potentiometer. Okay, then we have got the moist heat methods. अब इसमें most important क्या है? The most important over here is hot air is autoclave. Autoclave, I personally call it as a stylish or a glorified pressure cooker. Stylish or glorified pressure cooker. Okay, now most commonly it is used for what? Most commonly the combination of temperature, time and pressure used is what over here. So most commonly 121 degrees Celsius temperature is used for what? For 15 minutes at a pressure of 15 lbs. Okay, so now 15 pounds per square inch. And what are the articles sterilized in an autoclave? All the heat stable culture media, then surgical instruments. Please remember, for sharp surgical instruments, hot air oven is preferred rather than autoclave, because obviously if you attempt to sterilize sharp surgical instruments in case of by autoclave, the moisture will be there on the sharp surgical instruments, which will then decrease the sharpness of the instrument. So ideally for sharp surgical instruments, hot air oven is used. Okay, for other surgical instruments, autoclave. Then, as I said, few minutes back for gloves, remember gowns, and also dressing material, like for example gauze pieces. Okay, for all of these autoclave is used. And what are the biological indicators for autoclave? Remember, spores of Geobacillus stearothermophilus, spores of Geobacillus stearothermophilus. Okay, now the word stearo is a very stylish kind of a word, and that is why I told you in the beginning that I personally call autoclave as a stylish pressure cooker. The principle of autoclave functioning is the same principle as that of pressure cooker, and this fellow autoclave is a stylish pressure cooker, that's all. So from stylish, just recall stearo. So remember Geobacillus stearothermophilus. Now we come to another important topic, that is the biological functions of different classes of antibodies. Okay, now there are five classes of antibodies, and the serum concentration you can easily remember as GUMD. IgG maximum concentration, followed by IgA, followed by IgM, followed by IgD, and followed by IgE. So remember GUMD, GAMDE. Okay. Now, firstly, IgM. IgM is an antibody of what? Antibody of acute or recent infection. Remember, IgM says to you, me first, meaning it is the first antibody which is going to be there as a result of the humoral immune response in response to any pathogen. It is also known as millionaire molecule. Why? Because its structure is like this. It is made up of these five monomers which are joined together by a J chain, as I've drawn over here. Now, the valency therefore is going to be what? The valency therefore is going to be 10, because one monomer can join how many antigens? Two antigens. So there are five monomers over here, 10. But the effective valency drops down to 5 because of what? Because of steric hindrance. So it's a pretty heavy molecule. That is why it is known as millionaire molecule. So what do you think? Such a heavy molecule, 80% of this antibody, 80% of IgM, what do you think, where it should be there? It should be confined to the bloodstream only, or will it be present in the extravascular spaces? 80% of IgM is intravascular, because it is difficult for such a heavy molecule to leave the bloodstream and enter the extravascular spaces. So this also you need not mug up. It is very logical. Such a heavy molecule, so 80% is intravascular. And also remember, this is the only antibody class which is made by the fetus before birth. If at all, the fetus gets infected, if the mother gets some kind of infection, that organism can cross the placenta, which in turn sets up fetal infection. Then the fetus can respond by producing IgM antibody. Okay, so when it begins to be produced by the fetus in the setting of infection, approximately 20 weeks of gestation. Also remember, this fellow IgM is present on the B cells as B cell receptor as a monomer. So in the blood it is a pentamer, remember, but on the surface of B cells IgM is present as a monomer, and because it participates in agglutination reactions, this antibody is also known as agglutinating antibody. And also remember, it's the most potent activator of the classical pathway of complement. Okay, then we have got IgG antibody. Remember, G for IgG, G for goes across placenta. Okay, this is the only antibody class which can cross placenta. And also remember, it's the most abundant antibody in the serum. Its half-life is the longest. It is 23 days. So remember, G se kya yaad karo ki jeete raho. Okay, so half-life is the longest amongst all the classes. And this immunoglobulin IgG signifies past or chronic infection, and it has got four subclasses. Inka serum concentration is IgG1 maximum, followed by G2, G3 and G4. So remember, IgG1 is number one when it comes to the serum concentration. Also, IgM, I said, is the most potent activator of classical pathway of complement, C, and IgG is the second most potent activator of the classical pathway of complement. Remember this. Now, but out of all these four subclasses, IgG4 does not activate the classical pathway, but it activates the alternate pathway, remember. And because IgG antibody participates in the precipitation reaction, it is also known as precipitating antibody. And what is the valency? See, IgG is a monomer only. So tell me now, what is the valency? What do you think? Come on, mention in the chat box. What is the valency of IgG? Guys, it's a monomer. So what do you think is the valency? Nizam, Ria, Shahbaz, Shivangi. Vidya, very good. Valency is 2, very good. Okay. Okay, very good, Shivangi. IgG also is a very good option in this. I see all of these are MCQs. Everything is an MCQ in this workbook. So please remember all these points. And out of the four subclasses, IgG1 and G3 are said to be even better options, much better than IgG2 and IgG4. So, I remember this as generally we say na 13 number is not good, but remember, I don't believe in all this, but 13 number is very good for us. Why? Because IgG1 and IgG3 are fantastic options. Okay, so please remember this. This also can be asked as a separate question. Yes, very good. Bhanu, Mukesh, Dr. Mukesh and Harsh. Chalo, bahut badhiya. Now let's proceed. IgA antibody. A for IgA, A for alternate. IgA activates the alternate pathway of complement, and it has got two subclasses. IgA1, which is in a higher concentration in the serum as compared to IgA2. So higher concentration यहाँ पे भी क्या है? IgA1. Remember, A1 is number 1 between both the subclasses, and it exists in two forms. What are these two forms? A monomer form and a dimeric form. Dimeric antibody, dimeric IgA is also known as secretory antibody. And what is the structure of the secretory IgA? It is made up of these two monomers, and these are joined together by a J chain. J chain also is a protein chain. So remember, J chain is present where? In polymeric antibodies, like for example IgM. J chain is not there in IgG, which itself is a monomer. Over here, because we have got two monomers, they have to be joined together by something. That something is nothing but the J chain. In IgM, we have got 5 pentamers, which are which are being kept together by the J chain. J stands for joining. Okay, and not just that, not just this, the secretory IgA also has got another protein chain, which is known as secretory component or secretory piece. Okay, so this is the J chain. This obviously is the J chain, and these two are what? These are the two monomers, and what I've drawn in orange, this is nothing but the secretory component. Secretory component or the secretory piece. Now, a frequently asked question is, what are the functions of secretory piece? Secretory piece, remember, it protects the secretory IgA molecule against attack by the bacterial proteases in the gut. Because remember, antibodies are nothing but proteins only. So in the gut, proteases are there, bacterial proteases, and IgA is the mucosal antibody. It lines the mucosal surfaces. Like for example, the GIT mucosa. So there it should not be broken down by the proteases, and this protection against degradation by the proteases is conferred to it by what? The secretory component or secretory piece. And the other function is that it helps in transport of IgA to the lumen. Also remember, IgA is the most abundant antibody class in breast milk and colostrum. Simple way to remember A, B, C. A for IgA, B for breast milk, C for colostrum. Okay, then as I said, IgA, remember, it is also referred to as what? It is also referred to as the mucosal antiseptic paint. It lines the mucosal surfaces like respiratory mucosa and GIT mucosa. Okay, and another MCQ is that the J chain and both the monomers, they are produced by what? They are produced by the plasma cells, and the secretory component or the secretory piece it is produced by what? It is produced by the mucosal epithelial cell. Okay, it is produced by the mucosal epithelial cell. Yes, Bhanu, you're absolutely right. For respiratory infections, we need good respiratory IgA antibody. Okay, so against respiratory pathogens, if immune response in the form of good IgA, a good concentration of IgA is produced, then we will be protected. Now, the next antibody class is IgD. Now, we don't know much about IgD other than the fact that it is present on the surface of B cells as BCR, that is B cell receptor. So, what two receptors I told you on B cells? It is IgD and what? And IgM. So remember IgM and IgD. MD, managing director. So they are present as BCRs on the surface of the B cells. So B cells functions are being managed by IgM and IgD, managing director, remember. Now, free IgD does not bind to the antigen. Therefore, strictly speaking, IgD is not referred to as an antibody. What is the technical meaning of antibody? Antibody is the name given to that immunoglobulin which can bind to its antigen. That is the strict definition. But IgD does not bind to any free antigen. So strictly speaking, it is not an antibody. It is just an immunoglobulin. And remember, it has got the second highest carbohydrate content amongst, all the classes. And it activates the alternate pathway of the complement. Then finally, IgE. Now, IgE, remember, it is associated with, extreme of things. Extreme of things means least concentration in the serum, shortest half life, least concentration. अभी मैंने बताया था IgGAMDE. तो E is in the IgE has got the least serum concentration. Then shortest half life, most heat labile of all the classes of antibodies. Antibodies are nothing but proteins only, right? So the proteins are heat labile. Amongst all the classes, which class is most heat labile? This one. It is also known as homocytotropic antibody because it attaches to what? Mast cells and basophils. Like for instance, in human species, that is why it is known as homocytotropic antibody. Its ability to bind to certain cells, in all the members of a species. And then it plays an important role in type 1 hypersensitivity, also known as reagenic antibody, and has got the highest carbohydrate content. Okay, highest carbohydrate content. So please remember all these important functions, the biological functions of antibodies. Now moving on. Leptospira interrogans. This is extremely important bacterium which is frequently asked because so many cases unfortunately are reported during heavy rains and floods. So this is how this organism looks like. It has got these hooked ends. You can see it's a spiral organism. It's a spirochete. Okay, and remember these hooked ends, the hooks are in opposite direction. The hooks are in the opposite direction. Let me draw a schematic diagram also, something like this. Essay. The hooks are in opposite direction, and this is the only pathogenic species for human beings. Okay. Now, leptospirosis. Remember, this is pretty also important because it is the most common zoonotic disease on Mother Earth. On Dharti Mata, this is the most common zoonotic disease. Remember this. It is also known as what? Leptospirosis is also known as rat fever. Please remember, not rat bite fever. Rat bite fever is a different thing. This is known as rat fever. Also known as paddy fever. Paddy means what? Rice fields. Also known as sewer workers disease because it is commonly encountered in sewer workers. And severe, it is also known as, by the way, 100-day fever. What is 100-day cough? 100-day cough is whooping cough or pertussis. Okay, now severe form of leptospirosis is known as Weil's disease, also known as icterohemorrhagic fever. Okay, icterohemorrhagic fever. Now leptospirosis is associated with 3 R's. Okay, so RRR, of course, is the name of a cult movie, a fantastic movie. But for us medicos, we also need to be aware of one more RRR. And what is that RRR? Rice fields, that is paddy fields. Okay, then rainfall and rodents, which are an important reservoir. Many mammals can serve as the reservoir, but rodents are very, very, very important. Okay, now how humans get infected. Now please listen to this very carefully. What happens in heavy rains or floods? The rodents are forced to come out of their burrows, and remember, the rodents are nothing but are important reservoirs, right? So in rodents, this organism, this bacterium multiplies and it passes out, it is passed out, it is excreted in the urine of the rodents. So during heavy rains, when the rodents are forced to come out of their burrows, they will start urinating here and there, meaning they will contaminate the surface water. And rodents are known to infest commonly kya? Rice fields or paddy fields. Please remember this. So this is the association amongst all these three R's: rice fields, rainfall, and rodents. Okay. So how humans get infected? By coming in contact of the mucous membrane or broken skin. Broken skin yaad rakho, not the intact skin. So humans get infected by contact of the mucous membrane or breached, that is broken skin, with such dirty water or the urine of the organism or the blood of the organism, matlab the rodent, okay, and not by rodent bite. This is how humans get infected. And being a zoonotic disease, see, there's a general rule about zoonotic diseases that they are not transmitted from person to person. There are only two exceptions to this. One is monkeypox, and the other one is pneumonic plague, and yes, one more infection, Nipah virus also. So these are three important examples of zoonotic diseases which can be transmitted from person to person. Okay, so let's write this. Humans get infected by contact of that is mucous membrane or breached skin with the contaminated surface water or blood or tissues of the infected rodent, in brackets please write down, and not following rodent bite. Okay, and also make a note, as I said, this disease is not transmitted from human to human. Now, what are the clinical features? Now, this has been asked as a NEET SS question also. Most of the infected persons, most of the infections are asymptomatic. This has been asked as an MCQ. Okay, it can be asked in your exam also. Most infections are asymptomatic. Then what about the symptomatic people? The ones who do have symptoms, fever is a common symptom. Okay, sometimes fever only is there, nothing else. Okay, then some people may develop the severe disease, which is known as Weil's disease, which is characterized by hepatorenal syndrome. So kidneys shut down and liver failure is there. And what is the pathology of leptospirosis? Exact pathology, although we don't know, but some books have commented vasculitis, but this also is a question mark. An old question was asked on leptospirosis about the pathology, and that time the answer was vasculitis. Okay. So let's say if they repeat that question, you get a question on pathology. Other three options don't make any sense. And then the fourth option will be vasculitis. So even though vasculitis is still plus minus, we have to mark vasculitis because चार option में से एक तो answer होगा ना. ठीक है. Then important pathological features in the kidney क्या हैं? Interstitial nephritis and tubular necrosis. And important pathological feature in the liver is centrilobular necrosis. Now, microscopic examination can be done for diagnosis for blood and urine. For blood, up to 7 days. For urine, 10 days. But the problem with microscopic examination is that it is less sensitive, so it is usually not done. Then culture also is usually not done, but questions have been asked on the names of the culture media. So you can remember the culture media as FEK, fake. So F stands for Fletcher's medium. E stands for EMJH medium, that is Ellinghausen, McCullough, Johnson, Harris medium, names of the scientist. You need not remember the full form. Okay. K stands for Korthoff's medium. So remember FEK, fake. Then serology, remember, is the mainstay of diagnosis. And leptospirosis is also, special in the sense that this is the leptospirosis is the only example of a bacterial disease where serology serves as the gold standard method. Generally, when we talk about gold standard method of diagnosis of any bacterium, it is usually either culture or PCR. Okay, but here exceptionally, this organism, this disease is such that serology is the gold standard method of diagnosis, and the test used is antibody detection test, जिसका नाम है microscopic agglutination test or MAT. Microscopic agglutination test, that is MAT. Remember MAT. For treatment, remember penicillins and tetracyclines. Then next organism is E. coli, again a favorite of the examiners. This is how it looks like on gram stain. So you can see what these are, nothing but the gram negative rods. This fellow obviously is a member of what? Enterobacteriaceae family. Enterobacteriaceae family. This is the family of gram negative rods, G and Rs, who are what? Oxidase negative and catalase positive. Any member of Enterobacteriaceae which is catalase negative. So catalase positive ka exception kya hai? There is one member of Enterobacteriaceae which is catalase negative. Its name is Shigella dysenteriae. Serotype 1, also known as Shiga's bacillus. This fellow is catalase negative. This also is an MCQ. Then residence. Remember, this organism E. coli is present as a gut commensal. Okay, it's a gut commensal. Response to lactose. Pink colonies, pink, that is LF, that is lactose fermenting colonies are produced on McConkey agar. So this agar is nothing but McConkey agar. McConkey agar is an example of selective and differential medium. It's an example of a selective medium. It is a selective medium for what? For gram negative organisms. So remember, selective media are those media which show selectivity or partiality or favoritism towards the growth of only certain organisms. They will not allow any other organism to grow. So when we say McConkey agar is selective, we mean that it is selective to the growth of only gram negative organisms. Okay, and it also is a differential medium or an indicator medium. Why? Because it helps us differentiate between the gram negative organisms which do grow on it. How? By checking whether the gram negative organism is a lactose fermenter or a non-lactose fermenter. Lactose fermenter will produce pink colonies. Non-lactose fermenter will produce colorless colonies. Now, colorless does not mean invisible. Colorless just means that the color of the colonies is same as the color of the background medium, as you can see in this picture. Then what else is asked on McConkey agar? The contents are asked. So remember, the contents include plant. You can remember as plant. Peptone, lactose, agar, neutral red, which is the name of the indicator, and bile salts like taurocolate are present. And because of these bile salts like taurocolate, McConkey agar inhibits swarming by Proteus. This again is a question. It inhibits swarming by Proteus. Guys, just give me a second. I need to switch off the heater. It is giving me somewhat heavy-headedness. Just give me a second, please. Okay, thank you everyone. Chalo फिर. Now E. coli ferments glucose, producing what? Producing both acid as well as gas. In other words, it is aerogenic. It is aerogenic. Kindly do not confuse it with anaerobic. Please remember, all the Enterobacteriaceae members, Enterobacteriaceae family members are what? They are facultative anaerobes. ठीक है? They are facultative anaerobes. Kindly remember this. Then Imvic reaction, you need not remember any details about Imvic reaction. Nobody will ask you. Okay, it is not asked in entrance exam. It is important for second year people. Indole test, methyl red test, Vaux-Prosker reaction, citrate test, abbreviated as Imvic. Imvic reaction is plus plus minus minus, meaning indole positive, MR positive, VP negative, citrate negative. Please remember. So we have got certain category, certain type of E. coli which are referred to as diarrheogenic E. coli. Remember, these fellows are not commensals. They are acquired from outside. Our commensals are not going to disturb us. Our commensals, the gut commensal E. coli, are not going to cause diarrhea or dysentery. Please remember. So these are a separate category, a separate type of E. coli altogether, which are notoriously referred to as the diarrheogenic E. coli. Their job is to disturb us. For instance, we have got enteropathogenic E. coli, abbreviated as EPEC. Now, EPEC has got P, so from P, remember, pediatrics means it has got something to do with kids. So it causes diarrhea in infants and kids. It's an important cause of diarrhea in infants and kids, but not the most common cause. What is the most common cause of diarrhea in infants and kids? Anyone? Most common cause of diarrhea? फटाफट से बता दो. Most common cause of diarrhea in infants? Most common cause is rotavirus. Remember, बच्चे रोते रहते हैं, rotavirus. Okay. And what is the mechanism of diarrhea? The mechanism of diarrhea is attachment, effacement lesions. No, not E. coli, Harsh. It is rotavirus. Yes, absolutely right, Shivangi. Rotavirus. Attachment, effacement lesions of the microvilli or the brush border of enterocytes. Shivani, you are absolutely right. It is rotavirus only. Remember, बच्चे रोते रहते हैं, रोते से रोटा, remember. Okay, so attachment effacement lesions होती हैं of the microvilli or the brush border. This is because of the LEE gene. Okay, so imagine my palm is an enterocyte and my fingers are what? Brush border or the microvilli. Imagine this pen is EPEC. So when this, the EPEC attaches to the microvilli, it flattens them. This flattening is known as effacement. Just like when we iron our clothes, the creases are flattened out. Similarly, this organism EPEC is going to flatten out the microvilli. So the absorptive surface area is greatly decreased, and therefore the result is diarrhea. Okay, and there is no production of any toxin by this organism, so it is non-toxigenic and also it is non-invasive. So will you encounter any blood or pus cells in the feces sample of this patient? Yes or no? My question is, will you see blood or pus cells in the feces of a patient suffering from diarrhea because of EPC? Yes or no? Yes or no? No pus cells, no blood, nothing, because there is no damage of any kind. No Harsh, no pus cells. No pus cells will be there. Okay. No blood will be there because damage to nahi ho rahi na cells ki. The cells are not getting damaged. I hope this is clear to everyone. Very good, Shivangi. No pus cells and all will be there. Okay, so please remember this. Now, the second diarrheogenic E. coli is known as ETEC, that is enterotoxigenic E. coli. अब इसके नाम में we have got a T. Remember, T for travelers. This is the most common cause of travelers diarrhea, and it attaches to the enterocytes or the gut cells via colonization fimbrial antigen. ठीक है, colonization fimbrial antigen. It is abbreviated as CFA. After it attaches, it produces two kind of toxins which will cause diarrhea. One is the labile toxin, other one is the stable toxin. Labile to what? Labile to heat. And stable to what? Stable to heat. Now, labile toxin. Let me tell you the mechanism of action over here. Let's say if this is the enterocyte. This is the enterocyte, all right? This question has been asked, by the way. I think last year, again, FMGE 30th July 2023, the question on receptor was asked. So this is what receptor? GM1 ganglioside receptor. This question has been asked. So the labile toxin is made up of two subunits. Okay, one is the B subunit, and the other one is what? The other one is the A subunit, like this. Okay, A subunit. So the B subunit is going to bind to the receptor, and after that it will facilitate the entry of what? It will facilitate the entry of the A subunit in the cytoplasm. So what will happen? In the cytoplasm, what will happen? This A subunit is going to bring about the separation of two important best friends. Let's say one is NAD and the other best friend is what? Other best friend is ADP ribose. They are inseparable best friends. But ये इनमें food डलवा देगा, इनकी लड़ाई करा देगा. So it is going to create a rift between these two best friends, because of which what will happen now? ADP, the NAD will take its own course, but it is emotionally stable, so it will not it will look after itself. But who is emotionally labile? ADP ribose. Okay, it will start to cry. So just to wipe off the tears of ADP ribose, what will happen? Some good people are also there in life, okay, even though they are less, but they're still there. So this ADP ribose luckily will find a good guy. Who is that good guy? The G stimulatory protein. Okay, so I'm using golden color to draw it. So this is the G stimulatory protein, and in the books what this process has been described, this process has been referred to as ATP ribosylation of G stimulatory protein. Remember, all of this story is happening where? In the cytoplasm of the enterocyte. So this attachment of ADP ribose to GS is known as ADP ribosylation. ADP ribosylation of GS protein. So together now both of these are very happy with each other. So together they will stimulate what? They will stimulate the enzyme adenylate cyclase, which will then convert what? ATP to cyclic AMP. So that means there is going to be increased intracellular concentration of cyclic AMP, and you all know what is then going to be the end result. There will be secretion of bicarbonate and inhibition of sodium reabsorption. In other words, there's going to be secretory D for diarrhea. Now here also there won't be any pus cells, any blood in the fecal sample, because the disturbance is purely biochemical. There is no damage to the gut cells whatsoever. So here also no pus cells, no blood, nothing in the feces. It's a secretory diarrhea. Is this clear, everyone? Is this clear, everyone? Stable toxin, on the other hand, it stimulates what? It stimulates guanylate cyclase enzyme, and that will change what? GTP to cyclic GMP in the enterocytes, and again the end result is going to be the same as we saw in case of increased cyclic AMP, that is secretory diarrhea. Okay, now this same mechanism of action which we have discussed for LT, that is the labile toxin of ETEC, same MOA is seen in case of cholera toxin also. But why we are so afraid of cholera? The cholera toxin, remember, it is 100 to 1000 times more potent than the labile toxin of ETEC. Remember that. So no damage to enterocytes, so no blood, no pus cells in the feces. Remember this. Then next we have got enteroinvasive E. coli. Okay, enteroinvasive E. coli. The name itself tells you it is going to invade the gut. So the invasion of the gut cells occurs because of what? Virulence marker antigen. Okay, virulence marker antigen, abbreviated as VMA. Now its gene is present on a plasmid, so it is plasmid encoded. And why EIC is called as atypical E. coli? Because of these reasons. Number one, it is NM, that is non-motile. Number two, it is non-lactose fermenting. Number three, it ferments glucose. It ferments glucose producing acid only and no gas, and therefore it is known as anaerogenic. An means without, aero means air, genic means to produce. So please remember, and remember all these features are also present in another member of Enterobacteriaceae also, that is Shigella. So that is why EIC, when it was initially discovered, it was confused to be Shigella, but later on the genetic analysis, the analysis of the genes revealed that actually it is some kind of E. coli and not Shigella. So it is known as atypical. So this, in these properties, it resembles Shigella, and like Shigella, this fellow is also going to cause dysentery. Remember, okay. So it penetrates or invades the tissue culture cells also, like for example HeLa cells and the Hep2 cells. And previously, not now, a test of invasiveness was done for it, Serenis test, which has been asked as an MCQ. So I have written it over here. So what do you do over here? You just inject a culture filtrate of EIC into the lower conjunctival sac of the guinea pig or rabbit, and the animal unfortunately is going to develop keratoconjunctivitis. Okay? So remember EIEC. This also causes what? This also causes dysentery like Shigella. So an MCQ is asked that disease by Shigella is similar to what E. coli? The answer is EIEC. Please remember EIEC. Then next we have enterohemorrhagic E. coli, that is EHEC. This fellow produces a toxin known as verocytotoxin, also known as Shiga-like toxin, abbreviated as SLT. So the mechanism of action of this toxin is what? The MOA, mechanism of action, is damage to the 60S ribosomes. And because this organism produces this toxin, by the way, why it is called as verocytotoxin? Because this toxin damages the cells of the vero cell line. Okay, so that is why this organism is also known as what? VTEC, that is verocytotoxin producing E. coli, or STEC, that is Shiga like toxin producing E. coli. Now EHEC causes what? There are two important diseases: hemorrhagic colitis. Remember, no fever. This I have mentioned while discussing the bacterial food poisoning also. There also I mentioned EHEC के case में mostly no fever. So mostly no fever. Patient will have abdominal cramps, and the foods implicated are raw or undercooked beef, that is beef hamburger, and the most common serotype of EHEC is O157H7. Abhi recently in the NEET PG exam, a question was on this. Oh, they mentioned that a patient developed diarrhea and O157H7 was isolated. What does H stand for? That was the question. So again, question on basics. Remember, O stands for the somatic antigen. Okay, it is present on the LPS, that is the endotoxin, which is there in the outer membrane of gram-negative bacteria. And H, I have told you while discussing flagella, it is nothing but the flagellar antigen. Kindly remember this. Okay. Now, hemolytic uremic syndrome, this you must have read in patho also. It is characterized by the triad of MTR. Just remember, MTR is the brand name of a famous food, pre-packaged food also, MTR. So just remember, M stands for micro angiopathic hemolytic anemia. T stands for thrombocytopenia, and R stands for renal failure. Okay, R stands for renal failure. Kindly remember this triad of hemolytic uremic syndrome. Then we have got enteroaggregative E. coli. They are called so because of what? They are called so because of the stacked brick appearance they produce on the enterocytes. So they aggregate on the surface of enterocytes like stacked bricks. If let's say these are the enterocytes, 3 enterocytes I have drawn. So enteroaggregative E. coli, they will arrange themselves like this, stacks of bricks. Because of this, they are referred to as enteroaggregative E. coli. It causes diarrhea where in developing countries, and it produces a toxin called as EAST1, that is enteroaggregative stable toxin 1. Kindly remember this. Then we have got the last category of diarrheogenic E. coli, that is the diffusely adherent E. coli, or DAEC. As the name implies, they diffusely adhere to the gut cells. That is why they are called so. And they cause D for diarrhea in what? They cause D for diarrhea in developing countries. Kindly remember this. Okay. Then, apart from diarrhea caused by diarrheogenic E. coli and not the commensal E. coli, we have got another important infection by E. coli known as urinary tract infection. And these UTI strains mostly are the gut strains. So mostly the gut strains. So what happens when the gut strains are displaced from their home, that is the gut, into the urinary tract? There they are going to cause disturbance. And what is that disturbance? E. coli. So if somebody wakes you up at 4 a.m. in the morning and ask you what is the most common cause of E. coli, you have to say what? E. coli. E. coli, UTI, they rhyme together also. The most common cause of UTI overall is again E. coli. Most common cause of community acquired UTI, E. coli again. Most common cause of hospital acquired UTI, again E. coli. Most common nosocomial infection is what? UTI. And therefore this again is an MCQ. A few years back there was an MCQ. Most common nosocomial pathogen is E. coli was there in the option, Pseudomonas, Acinetobacter, and one more was there. Many people wrote Pseudomonas. Please remember that's not the right answer. You know why? Because the most common nosocomial infection is UTI. Therefore, the most common nosocomial Therefore, the most common nosocomial pathogen also is kya? E. coli. Kindly remember this. Again, देखो basics. MCQs on basics. So, UTI is caused by strains called as UPEC, which stands for the uropathogenic E. coli. ठीक है? Uropathogenic E. coli. They attach to the urinary cells via what? Via the P blood group antigen, which is expressed on the urinary epithelial cells. ठीक है? Now, for diagnosis, most common sample collected is the early morning. Why early morning? Because that is the most concentrated urine specimen. Early morning. Midstream. Midstream क्यों? Because it will have less and less commensals. Early morning, midstream, clean catch urine sample. But the best sample is suprapubic aspirate, which again is going to be produced by, it's an invasive procedure, so it is not usually done. Suprapubic aspirate. So best is that, but most commonly collected sample is the early morning midstream clean catch urine sample. Now for culture, you can either go for a combination of blood agar plus McConkey agar. Okay. If you use only blood agar or only McConkey agar, you might miss out certain pathogens. So either use a combination of both. Or the best medium is what? This again has been asked as an MCQ. Cysteine lactose electrolyte deficient agar, that is the CLED medium. See, both McConkey agar, MA by the way is McConkey agar. Both McConkey agar and CLED, they both can differentiate between lactose fermenters and non-lactose fermenters, and both inhibit swarming by Proteus. But CLED is better. Why? Because it allows the growth of Candida and GPC, gram-positive cocci, which again are important causes of UTI. Okay, so remember C3. C3 means one C is CLED, second C is Candida, and the third C is the cocci. Which cocci? Gram-positive cocci. Now, Candida and gram-positive cocci are not going to grow on McConkey agar. So, if you are using alone McConkey agar alone, you don't have CLED, you will miss out on these pathogens. If at all some patient is infected with these, these organisms won't grow on McConkey agar. That is why I was saying ki if you don't have CLED, you use both media, McConkey plus blood agar, because let's say even if the patient is infected with Candida, it doesn't grow on McConkey agar, but you have inoculated the sample on blood agar also. Candida will go on blood agar. Okay, so Candida and GPCs can grow on blood agar. So that is why, if we have CLED, then a lot of problem is solved, because we don't have to use two media, blood and McConkey. CLED medium alone is sufficient. It will allow the growth of a lot of uropathogens like E. coli, obviously, Pseudomonas, Candida, GPCs. But McConkey agar does not allow the growth of Candida and GPCs. Hi, Janvi. Yes, this micro session is going to solve a lot of problems. So whatever I'm covering in this session, please do revise this, and it will solve a lot of PYQs. The other suggestion I would want to tell you all is, see, अगर micro tackle करनी है ना, तो ये session तो कर ही लो. अब ये तो आप कर ही रहे हो. Plus PW Method app पे ना, there are some rapid revision videos. अगेन उस पे भी मैंने MCQ से डिस्कस करे हैं. अगर वो कर लोगे तो बस योर माइक्रो इज सॉर्टेड. फिर कुछ मतलब आप यू विल बी एबल टू टैकल मोर देन 90% ऑफ द क्वेश्चंस. दैट इज माय अश्योरेंस टू यू. ओके, सो आप ये सेशन अच्छे से करो. ये करोगे और जो रैपिड रिविजन मैं बोल रही हूँ उसके बाद आपको बिल्कुल भी टफ नहीं लगेगा. Okay, so guys, this is how clade agar looks like. As you can see some yellowish colonies. Yellowish colonies are nothing but lactose fermenting colonies, and these so-called greenish bluish colonies, they are NLF. They are the colorless colonies. As I said before, colorless colony does not mean that they are invisible colonies. The colorless colonies are called so because, as you can see over here, the color of the colonies, the NLF colonies, is same as the color of the background medium. So this medium's color is somewhat like this, bluish greenish in color. Okay, most welcome, Janvi. Okay, next we have got CAS, concept of significant bacteriuria, which implies what? Significant bacteriuria means the presence of more than or equal to 10 raised to the power 5 colony forming units per ml of urine. Only then the bacteriuria is said to be significant. Bacteriuria means the presence of bacteria in the urine. Now, when to treat bacteriuria? Remember, if the patient has symptoms, symptomatic, significant bacteriuria should be treated. Okay, then There are some exceptions, although. Asymptomatic significant bacteriuria should be treated in the following cases. Remember PUN, PUN. P stands for pregnancy. U stands for urinary tract obstruction, either due to calculi, that is stones, or malignancy, that is tumor, and N stands for neutropenia. Okay, N stands for neutropenia. So we have discussed about diarrhea, we have discussed about UTI. Other infections caused by E. coli include, remember, it is the second most common cause of neonatal meningitis and neonatal septicemia in India. And bracket में लिख लो, the most common cause of neonatal meningitis and neonatal septicemia in India is Klebsiella pneumoniae. Klebsiella pneumoniae. जानवी, इस सेशन का जो एनोटेटेड पीडीएफ है ना, आपको पीडब्ल्यू मेडिट के टेलीग्राम ग्रुप पे मिल जाएगा, जहाँ से आपने ये वर्कबुक डाउनलोड करी होगी. ओके, उसी पे सेशन के बाद आपको मिल जाएगा. ठीक है. और मैं वैसे खुद भी पीडीएफ मैं भी पर्सनली अपनी इंस्टाग्राम स्टोरी में शेयर कर दूंगी जैसे ये सेशन खत्म होता है. ओके, डोंट वरी. नाउ apart from this, remember it is also the MCC, most common cause of, remember, IPC, that is intra-abdominal abscess, then P for peritonitis and C for cholangitis. ठीक है, C for cholangitis, तो kindly remember IPC. Also remember it is the most common cause of septicemia in geriatric population occurring as a complication of UTI, which means what? Remember, let's say there is some elderly individual, ठीक है, and the person develops UTI, and unfortunately the antibiotics are not responding, or the person is not compliant, so the UTI is not getting resolved. So the bacteria will enter the bloodstream. E. coli will enter the bloodstream from the urinary tract and will lead to septicemia. So that is the meaning of this statement, that E. coli is the most common cause of septicemia in geriatric population occurring as a complication of UTI. Now finally, treatment. UTI, the treatment is based on the AST report, antimicrobial susceptibility testing report, and the commonly used drugs are, quinolones, okay, nitrofurantoin, and for diarrhea, fluid replacement, antimicrobials are not usually recommended. Okay, then we have got Salmonella, another member of Enterobacteriaceae family. These are always pathogens. Unlike E. coli, they are always pathogens, and they're usually motile, except what? Remember, Salmonella pullorum and Salmonella gallinarum. Remember PG. Okay, PG, post graduation. So for post graduation, we have to be non-motile, we have to sit on the study table and read. Just remember it like this. Then it is a non-lactose fermenting organism, unlike E. coli, which is a lactose fermenter. And Salmonella ferments glucose producing acid plus gas, that is aerogenic. Except which one? Except Salmonella typhi. अब देखो S typhi के नाम में, let me just tell you, I have written capital T. Actually, there is a very complex classification of Salmonella typhi. So this is the name of the serotype, and it is written like this: S dot capital T Y P H I. Okay, this is not the name of the species, this is the serotype. And Imvic reactions, remember, minus plus minus plus. E. coli mein, what did I say about Imvic reactions? Plus plus minus minus. So remember, E. coli is plus in our body, it is present as a commensal. So start it off with plus plus minus minus. Salmonella, on the other hand, is a pathogen. It is not present in normal people. So start Imvic reaction with minus. So minus plus minus plus. ऐसे याद कर लो. Okay. Then citrate test is negative in. अब इसकी citrate test देखो, generally Imvic में हमने क्या बोला? Minus plus minus plus. That means citrate test is positive in case of Salmonella, but there are certain exceptions. That is, citrate test is negative where? Remember, citrate test is negative in, again, Salmonella typhi and Salmonella paratyphi A. इसको you can remember this by remembering can't. ठीक है. So C for citrate, N for negative. So C for citrate, N for negative, and A for paratyphi A and T for what? T for typhi. So I'm using these color codes. It will be easy for you to remember. Yes, fantastic, Shivangi. You're absolutely right. They are step ladder fever isme hota hai. We'll talk about it in a bit. Okay. So they are, remember Salmonella are H2S producers, except remember one important exception, Salmonella paratyphi. Okay, Salmonella paratyphi. Now, diseases caused by Salmonella. Typhoidal salmonellosis, meaning enteric fever. Most common cause is Salmonella typhi. So, if enteric fever is caused by S. typhi, it is called as what? Typhoid fever. Second most common cause is Salmonella paratyphi A. Third most common cause, Salmonella paratyphi B, and rarest is Salmonella paratyphi C. Remember, the S. typhi C is not seen in India. Not seen in India. So remember, C is not seen in India. Okay, and all of these are what? All of these are, remember, they are human pathogens. They don't have any animal reservoir. Okay, so the source of infection is a human case or a carrier. On the other hand, we have got non-typhoidal salmonellosis, which is of two types, and one type already I've talked about in bacterial food poisoning, that is gastroenteritis. Okay, the incubation period is generally more than 24 to 48 hours. This is also mentioned in certain books. Okay, so you remember both kinds of incubation period, this one also and the one in the table also. Now, gastroenteritis. As I mentioned before, what are the causes? Salmonella enteritidis and Salmonella typhimurium. Just a memorizing tip for all of you. Please remember GET, get. What does it mean? G for gastroenteritis. Okay, देखो, G for gastroenteritis, E for enteritidis, and T for what? T for typhimurium. Let me highlight also. GET, get, इससे याद कर लो. Then the foods implicated are poultry and poultry products and meat products. So as I said before, these fellows, enteritis and see, not just these, but all the non-typhoidal salmonellosis causes, they have got what? They have got animal reservoirs. So for us, these are what? These are zoonotic infections because we acquire them from animals. Then septicemia, one important cause you can remember, Salmonella cholera suis. Now the word suis pertains to pigs, and as I said, the NTS agents have got animal reservoirs. So here the reservoir is pigs. Of this organism, the reservoir is pig. Now coming to enteric fever. Incubation period is 1 to 2 weeks, 7 to 14 days. The mode of infection is, remember, FOR, fecal-oral route. Following ingestion, the bacteria are taken up by the macrophages in the gut. They resist the killing by macrophages. Then they will enter the portal blood. This is known as primary bacteremia. Then the bacteria travel to the reticuloendothelial system. That is, they will invade the liver, spleen, bone marrow, and there they will multiply inside the macrophages. You all know reticuloendothelial system is rich in macrophages. Again, they will spill over into the blood. Now, this is known as secondary bacteremia, and now the patient is going to have signs and symptoms. Now signs and symptoms will occur. Before this, before secondary bacteremia, the patient was in incubation period only. Kindly remember. So fever, as rightly pointed out by Shivangi, fever is step ladder pyrexia. Some people may have a rash, which is a salmon colored rash. Okay, salmon colored macular rash. Then non-specific features like H for headache, anorexia, okay, myalgia, very non-specific features. Then GI features like nausea, vomiting, diarrhea, NVD may be there. Hepatosplenomegaly, complications like GI bleeding, intestinal perforation, rarely neurological features. Relative bradycardia can occur. Why? Because of the inhibitory effect on the SA node by the bacteria. Then complications occur after second week of the fever, meaning they will occur in the third and fourth week. But these days complications, touchwood, are very infrequent because of the early commencement of the antimicrobial therapy. Now some organisms seed the gallbladder, and then they will be passed out in the feces, and some are going to be shed in the urine. Please remember this. Now for diagnosis, remember, isolation or culture of the organism. the organism can be isolated from blood. Remember bacteria mein ho raha tha na, and the organisms are also being passed out in the feces and urine. So samples which can be collected, blood, feces and urine. But fecal and urine culture is usually not done. Blood culture is preferred, and blood culture, remember, it has got 100% specificity, and therefore it is what? Therefore it is the gold standard method for diagnosis. Now the sensitivity of blood culture in different weeks of fever varies. In the first week of fever it is 90% sensitivity, in the second week 75%, third week it drops down to 60%, and the last week 30 to 40%. Now, when we collect feces sample, we should be able to remove the traffic of commensals, and that job is done by the enrichment broth or the enrichment media. For instance, we can go for selenite F broth, okay, then tetra thionate broth, or the gram negative broth. We incubate it for 4 to 6 hours so that the commensals cut down in number, and the pathogens, if present, they multiply. Then a subculture is going to be there on what? Subculture is going to be done on McConkey agar. McConkey agar पे कैसी colonies मिलेंगी? And McConkey agar, as I said before, in the beginning, the organism is going to produce what? Non-lactose fermenting colonies. ठीक है? Non-lactose fermenting colonies. Okay, then DCA or deoxycholate citrate agar पे मिलेंगी pale colonies with black center. Pale colonies with black center. Black center represents what? It represents the production of H2S. Then we have got XLD, that is xylose lysine deoxycholate agar. On this, the organism produces red colonies with again black center. Okay, and Wilson and Blair medium पे कैसी colonies मिलेंगी? Remember, the jet black colonies are going to be produced with a metallic sheen, because of production of H2S. Okay, then urine culture can be done on clad medium. Okay, then antigen detection in the serum is best done in the first week of fever because of maximum antigenemia, but this is not done frequently. Then we have got antibody detection in the serum by Vidal test, which is an example of a tube agglutination test, where we do what? We detect antibodies to the O antigen and the H antigen. Remember, Salmonella is a gram-negative fellow, so it is going to have endotoxin, which is going to have the O antigen, and it is motile, so H antigen also is going to be there. So we detect antibodies against both these antigens. So you should know some basic points about these antigens to be able to understand the Vidal test. Vidal test, by the way, has got a lot of drawbacks, so it is not recommended by WHO. Please remember, but in the question papers, it is still being asked. Okay. So O antigen is somatic antigen, H is flagellant antigen. O antigen, because it is polysaccharide, it is heat stable. H antigen is protein, so it is heat labile. So polysaccharide antigens, as compared to the protein antigens, they are not that good immunogen, so low antibody titer is going to be produced, and these antigens are less specific. Matlab, O antigen is going to be somewhat common between multiple species of Salmonella. Whereas H antigen, being a protein antigen, is a good antigen, so it is going to induce high amount of or titer of antibodies, and it is more specific, meaning different species of Salmonella, they are going to have their own unique antigen. Okay, so O antigen, because it is only polysaccharide, the human immune system, the immune response is going to be only in the form of IgM. But in case of protein antigens, you all know class switching occurs, so initially IgM will be produced, followed by IgG. Okay, so in books, there's this statement about the antibodies against O and H antigen, that is, for example, for H antigen it is written, the antibodies appear late, persist longer, and disappear late. Now this statement is in the context of IgG antibodies. तो IgG antibodies देर से आती हैं, देर तक रहती हैं, देर से जाती हैं, lazy antibodies. लेकिन in case of O antigen, the only antibodies we encounter are the IgM antibodies, which come early, which is obvious, because IgM antibody is the antibody which is going to be produced in case of any infection. मैंने कहा था ना थोड़ी देर पहले, M for me first, that is the nature of this antibody, and they leave early. Okay, then the agglutination is said to be coarse granular in case of O antigen, and fluffy cottony in case of the H antigen. And the tube, see, it's a tube agglutination test, right? So we use different kinds of tubes for O and H agglutination detection. So in case of O antigen, the tube has got a round bottom like this, and in case of H antigen, it is a conical bottom. So just a little memorizing tip. Remember DCH क्या होता है? Diploma in Child Health. So D for Dreyer's, C for क्या? Conical, ठीक है, and H for क्या? H antigen. Remember this. So we detect antibodies against the O antigen of H typhi, H antigen of typhi, paratyphi A and paratyphi B. We don't need to detect antibodies against the O antigen of typhi, O antigen of paratyphi and paratyphi B, because as I said, O antigen is non-specific. It is the O antigen of S typhi is also going to be there in paratyphi A and B. Okay, why have I not written paratyphi C over here? Because remember, paratyphi C is not found in India. So we add the serum sample in all the tubes, and we dilute the serum using normal saline. Why not distilled water? Because an optimum concentration of electrolytes is needed for antigen antibody reaction. Okay, so the visible agglutination occurs at some dilutions, and the titer is taken as the reciprocal of the maximum dilution. Look at this. So we add the serum and we keep on diluting it, and this is how this is the very good schematic representation. These different rows are made. We take a rack and different rows you can see. In the first row you add so basically you are adding serum samples in all these rows, and in the first row you add the O antigen, and in the second row H antigen, then paratyphi A, B and C. In India, we, as I said, we don't usually detect S paratyphi C because वो इंडिया में होता ही नहीं है. लेकिन अगर डिटेक्ट करना हो तो उसमें ऐसे करेंगे, बस 4 की जगह 5 हो जाएंगे, वही फर्क है. ठीक है. So we mix it properly, cover and incubate overnight at 37 degrees Celsius, and this is how it looks like. We observe for agglutination and interpret the results. So मान लो यहाँ पे let's say we get agglutination in 2 tubes. This one that is which is having 180 dilution and 1 and 60. So what is going to be the titer? As I said over here, the titer is taken as the reciprocal of the maximum dilution. So which is the bigger dilution? बताओ मुझे chat box में. Between 1 in 180 and 1 in 160, which is the higher dilution? बताओ. No, Shivangi. 1 in 160 is higher dilution. Higher dilution मतलब देखो left से right you are adding serum sample, okay, and you are constantly adding saline and you are transferring material from one tube to another. So remember, the higher the number, the higher is the dilution. Okay, so please remember. So in this case, the what is going to be the titer? Titer I said is the reciprocal of the higher dilution. Okay, so please remember the titer is the reciprocal. So 1 divided by 1 and 160. 160 will go to the numerator. So titer will be 1 and titer will be 160. ठीक है? Okay, please इसको याद रखना. Okay. Now, what are the drawbacks? As I said, Vidal test is not recommended by WHO. The problem is this: the false positive test in case of vaccination, and anamnestic reaction, which becomes negative in a week. Anamnestic reaction means, the Vidal test. If you ideally Vidal test should be done twice. Let's say one sample is taken today, then the other sample, next sample, second sample should be taken 10 to 14 days later to show an increase in the titer of antibodies. So anamnestic reaction means today you do viral test of the patient, test is positive, then you do it again after 14 days, it is negative. So that is known as anamnestic reaction. Okay, false negative test, early antibiotic therapy. Adil, please relax. देखो चलो इस पे बात करनी बनती भी है. सी दीज गाइस एवरीबडी, लेट्स जस्ट आई जस्ट कंटिन्यू इन जस्ट अ मिनट. देखो ये जो आपके एग्जाम्स है ना, दे आर जस्ट अ पार्ट ऑफ योर लाइफ. रिलैक्स करो, आराम से जितना पढ़ोगे, जितना शांति से पढ़ोगे, द मोर काम यू आर, द मोर इंफॉर्मेशन यू विल बी एबल टू रजिस्टर इन योर माइंड्स एंड यू विल बी एबल टू प्रॉपरली रिकॉल इन दी एग्जाम्स. ठीक है. सो इट्स जस्ट एग्जाम्स. अगर आप बिल्कुल शांति से पढ़ो, कोई स्ट्रेस नहीं लेना है, बस अपना काम करना है और ये एग्जाम भी आराम से निकल जाएगा. अगर यही एटीट्यूड रखते हो तो आप में से किसी को कोई भी दिक्कत नहीं आएगी. ओके, so don't worry. Adil Shah, I'm sure you will be able to tide over this exam also, so just don't worry. And whenever you feel down or upset and not in a good mood, just take a break. थोड़ी देर सो जाओ या एक अच्छी सी कॉफ़ी पी लो, टॉक टू एनी क्लोज फ्रेंड और फैमिली मेम्बर, ओके, टॉक टू पीपल, कुछ एक कॉमेडी का कुछ यूट्यूब पे देख लो, इतने अच्छे अच्छे स्टैंड अप कॉमेडियंस हैं आजकल, है ना, तो उनके लाइव शोज होते रहते हैं, तो जस्ट डोंट वॉच एनी काइंड ऑफ इमोशनल स्टफ, जस्ट कुछ कॉमेडी मूवी देख ली, थोड़ी देर के लिए ब्रेक ले लिया, खाना खाते समय आधा घंटा देख लिया, क्योंकि ब्रेक्स भी चाहिए होती हैं, अदरवाइज क्या होता है ना, बर्नआउट हो जाते हैं. So just relax, everything is going to be fine. I'm telling you, you will be on the other side very, very, very soon. ठीक है? I hope that helps. So आदिल, मैं आपसे यही बोलना चाहूंगी, बस रिलैक्स करो. ओके, एग्जाम्स बस जिंदगी का एक पार्ट होते हैं, दे आर नॉट इक्वल टू आवर लाइफ. बस यही एटीट्यूड रखो. So guys, there is something called as endemic titer. Endemic titer means like in countries like India where enteric fever is like ghar ki baat. Matlab we all, if we get our Vidal test done, we also will have some antibodies. Why? Because we got infected by fecal route, but because our immunity is good, so we did not have any symptoms. Still, if we are having antibodies, that's a good thing because the immune system was working for us. Okay, so for the endemic titer in India, for O antigen is less than or equal to 100, and for H antigen it is less than or equal to 200. Most welcome, Adil. Okay, now carriers and enteric fever. The carrier state develops in 3% cases. Okay, the convalescent carriers are the ones which shed the B for bacteria for less than 3 months from the body, whether urine or feces. Then temporary carriers shed the bacteria for 3 months, for 3 months to 1 year. And chronic carriers shed the bacteria for more than 1 year. Sometimes in case of fecal carriers, one modality of treatment is removal of the gallbladder. Remember this. Then, how not to diagnose carriers? One is blood culture, because if blood culture comes out to be positive, that person is not a carrier, that person is a sufferer of disease, that person is a case. Then Vidal test. Remember, Vidal test is negative in carriers. Vidal test is negative in carriers. Then what will you do to make a diagnosis? You can go for feces culture, urine culture, and you have to collect multiple samples because the organisms are shed intermittently. And the only serological test for diagnosis of carriers is anti-VI antibody, that is antibodies against the anti-VI antigen, that is antibodies against the VI antigen. VI stands for virulence. It's a PS, that is polysaccharide antigen. For prevention, proper sewage disposal and proper personal hygiene, because the organism is spread how? By fecal-oral route. Now coming to the drugs, this I'm sure you would have learned in pharmacology. Just for the sake of completion, I've added it. So remember, the empirical treatment, that is the treatment given before AST report is out. The drug of choice is ceftriaxone, and once the report is out, if the isolate is fully susceptible if the isolate is fully susceptible to all the drugs, then the drug of choice is ciprofloxacin. But if for some reason it cannot be given, then we have got alternatives like amoxicillin, chloramphenicol, and cotrimoxazole. Then you should know about the MDR strains. That is the multi-drug resistant strains. That is the strains which are resistant to chloramphenicol, ampicillin, and cotrimoxazole. So, इस case में drug of choice is cipro. Remember, then we have got nalidixic acid resistant strains. They are resistant to nalidixic acid with decreased susceptibility to cipro. तो cipro तो use ही नहीं कर सकते, तो क्या करोगे? Ceftriaxone is the drug of choice. For carriers, you can go for these options. Okay. Now, the next organism for us is Corynebacterium diphtheriae. Now, this organism is what? This organism is a gram-positive coco bacillus. It is NM, that is non-motile. It is fastidious, that is it is not going to grow on simple culture media, and it is a facultative anaerobe. Okay, they've got cytoplasmic granules which are known as what? Which are known as polar bodies because they are present on the poles of the bacteria. They are known as metachromatic granules. They are also known as volutin granules. They are also known as Babes Ernst granules, and they are nothing but the reservoirs of energy and phosphate. So they are also known as polymeta-phosphates. And these granules are common where? They are common in those cells growing in nutritionally deficient conditions. And the staining of the granules. See, the most common stain used for granules is Albert stain. As you can see, this पे भी question आ रखा है. Okay, so just a little tip. Remember BGGB, that is on Albert stain. B for bacilli, they appear green in color, and the second G is granules, which are going to appear blue in color. Okay, so remember BGGB, bacilli green, granules blue. Okay, granules blue. So as you can see over here, this is a schematic representation. The green dandiyan kya hain? These are nothing but the bacilli, and the dark blue colors, the dark blue circles at the ends, they are the granules. Remember, they are at the ends. So मैंने क्या बोला? These are more prominent in the at the poles of the bacteria. Okay, so Albert stain used most commonly. Then we have got Ponder's stain also for the granules, and Neisser's stain. Kindly remember, Neisser's stain is not for Neisseria, it is for the granules of Corynebacterium diphtheriae. Then the media used for the growth of C. diphtheriae. We have got enriched media, like for example, Loeffler's serum slope, that is LSS. Okay. Now on this, the good thing is that the growth appears faster. So faster growth, kitni fast? In 6 to 8 hours. And this medium is good for what? It is good for inducing granules. Okay. It is good for inducing granules. Then we have got a selective and differential medium. And also remember, this again is an MCQ. This is the best medium for C. diphtheriae. The name of this medium is potassium tellurite blood agar, on which black colonies are observed of C. diphtheriae. Then we have got other selective media. You can remember them as HMT, that is Hoyle's medium, Macleod's medium, and Tinsdale medium. Okay, Tinsdale medium. So remember HMT. Then we have got 3 biotypes of C. diphtheriae, that is gravis, intermedius, and mitis. देखो, gravis name itself implies it is going to cause the most grave or serious disease. So this is the causative agent of most serious disease. Mitis mild disease karega, so it is going to cause the mildest disease. So intermediate disease will be caused by intermedius. The colony morphology can be remembered as, remember, DFP from left to right, that is daisy head colony, frog's egg colony, and P stands for poached egg colony. Now hemolysis can be remembered from left to right as Venu, VE, chota e, N and U, where V stands for variable hemolysis, E stands for nothing, N stands for non-hemolytic, and U stands for usually hemolytic. Now the complications include gravis, remember H plus P, that is hemorrhagic and paralytic complications, intermedius, hemorrhagic complications, and mitis, obstructive lesions in the air passage. Okay, obstructive lesions in the air passage. Please remember this. Then the virulence factor of C. diphtheria is nothing but the diphtheria toxin. Okay, diphtheria toxin, abbreviated as DT. This is an example of an exotoxin, and it is produced by lysogenic conversion. That is, the gene, see, the gene for this toxin is present on a phage, namely the beta phage or Corynephrage. So lysogenic conversion means when this phages you all know, phages are nothing but the viruses which attack bacteria. So the name of this phage is beta phage or coroniphage, which attacks Corynebacterium diphtheriae. And when it attacks the bacterium, it is going to gift the bacterium what? It is going to impart the bacterium with this gene for the diphtheria toxin. So bacterium ki life badal jayegi. This is known as lysogenic conversion. So lysogenic conversion means what? Attack of, it means attack of CD, that is Corynebacterium diphtheriae, by the beta phage. Now the CD, that is Corynebacterium diphtheriae, CD is my own short form for Corynebacterium diphtheriae. CD starts to express the gene for the toxin. Basically it is going to produce the toxin, because diphtheria is because of toxin, no diphtheria. Now it has got two subunits, this toxin, A for active and B for binding. And what is the mechanism of action of toxin? The mechanism of action is, remember, ADP ribosylation. The B toxin, the B part of the toxin or the B subunit is going to bind to the receptor, then it will push A subunit inside the cell, just like I talked about in केस ऑफ लेबाइल टॉक्सिन ऑफ ईटीसी. यहाँ पे भी सेम चीज हो रही है, बट अंदर क्या हो रहा है, डिफरेंस क्या है? द ए टॉक्सिन विल ब्रिंग, द ए पार्ट, ए सब यूनिट विल गोइंग टू विल ब्रिंग अबाउट द एडीपी राइबोसाइलेशन ऑफ व्हाट? Elongation factor 2. Therefore there won't be any protein synthesis and no cell can survive without proteins, so it will lead to cell death. This is how the toxin acts. And remember, the exact same mechanism of action is also seen in case of another toxin, that is exotoxin A of Pseudomonas aeruginosa. But remember, D for diphtheria, D for destruction. Diphtheria toxin is more lethal. So I'm just writing it over here. DD, that is diphtheria toxin, is more D for destructive. It is more lethal or destructive. Please remember this. Then diphtheria toxin, remember, it has got affinity for, remember, MAN, that is myocardium, adrenals and nerve endings. ठीक है, myocardium, adrenals and nerve endings. Then diphtheria, mode of infection is respiratory route. Incubation period variably given in different books. Just remember 3 to 4 days, 3-4 दिन. Okay. Most common type of diphtheria is respiratory diphtheria, and in the respiratory tract also the area around the facial region is affected where the palatine tonsil is located. So remember, the most common type of diphtheria is facial diphtheria. So in the throat, what will happen? In the throat, the toxin is going to be produced by the bacteria, and the toxin will attack the epithelial cells. So the lot of dead epithelial cells, when tissue damage is going to be there, inflammatory infiltrate also will be there. So in the throat, lot of dead epithelial cells plus lot of dead B for bacteria plus fibrin plus inflammatory infiltrate will be there, and all of these are going to lead to what? The formation of a pseudomembrane. Pseudomembrane is going to be there in the throat. Okay, and this pseudomembrane, remember, it bleeds on removal, so it should not be manipulated, because if manipulated, diphtheria, in diphtheria, death can also occur because of detachment of the pseudomembrane, blocking the respiratory passage, resulting in asphyxia. So one cause of death is asphyxia because of pseudomembrane getting detached and blocking the respiratory passage. And the other cause of death is cardiogenic shock. Remember, I said the toxin has got affinity for MAN, myocardium, adrenals and nerve endings. So the other cause of death is cardiogenic shock. Okay, now for diagnosis, you can collect samples like, for example, throat swab, and you can do stains like gram stain, on which you will see what? Gram positive cocoa bacilli, or you can go for Albert stain to see the granules, but these do not establish the diagnosis because the stains are going to be positive. The stains are going to be positive in case of both toxigenic strains and the non-toxigenic strains also. Please remember this. ओके, बट डिप्थीरिया क्यों हो रहा है? टॉक्सिन की वजह से हो रहा है। तो हमें कैसे पता चलेगा कि पेशेंट के सिम्टम्स आर बिकॉज ऑफ डिप्थीरिया, मीनिंग द टॉक्सिन प्रोड्यूसिंग स्ट्रेन? So that is why they don't establish the diagnosis. Culture also, culture can be done on, you know, KTBA, potassium telluride, blood agar, but this also won't establish the diagnosis because culture में भी same कहानी है, toxigenic and non-toxigenic strains दोनों ही grow कर पाते हैं. Toxigenicity tests are the mainstay of diagnosis, where we have got in vitro, in vivo दोनों होते हैं, लेकिन in vivo आजकल नहीं करते हैं because animals उसमें sacrifice हो जाते हैं, so we go for in vitro toxigenicity test, like for example LX gel precipitation test, where we look for the arrowhead precipitates, and we have got cell or tissue culture cytotoxicity assay. तो इसमें हम क्या देखते हैं? We take live cells and we add the patient sample. If the cells die, then we can conclude that okay, the organism is producing the toxin which is causing cell death. Okay. The treatment mainstay is obviously antitoxin, that is antibody against the toxin. Okay, toxoid refers to the vaccine. It is not going to provide immediate protection. Other measures, drug of choice, you can remember PERC, PERC, gola banao, danda banao. P stands for what? Penicillin. E stands for erythromycin. Both of these are drug of choice. R stands for rifampicin and C stands for clindamycin. These are the alternatives. Okay, तो मैंने ड्रग ऑफ चॉइस ऑल्टरनेटिव्स दोनों ऐसे लिख दिए हैं पर करके, इसको याद रखना. इज दिस क्लियर एवरीवन? Then next we move on to the gram positive filamentous bacteria. पूरी bacteriology में these are the two important genera of gram positive filamentous bacteria, Nocardia and Actinomyces, which were initially confused to be fungi because of their filamentous structure. There are a kind of fungi which are, you know, long filamentous. They have got hyphae. They are nothing but the filamentous fungi. Okay. But later on, these organisms, Nocardia and Actinomyces, were discovered to have the prokaryotic ribosomes. So it was finally concluded that these are bacteria, not fungi. Okay, fungi, remember, they are eukaryotes. So Actinomyces, now salient differences. Nocardia, see Actinomyces, इसका नाम जब हम बोलते हैं actino, remember it is anaerobe. It is anaerobic. So जो लोग बोल के याद करते हो इससे relate कर पाएंगे. Actino, remember, is anaerobe. Nocardia on the other hand is aerobic. Nocardia is partially acid fast. We use 1% H2SO4 as the decolorizer in Zn staining, as I mentioned before also. Actinomyces is non-acid fast. Actinomyces is present in human body as a commensal in the oral cavity, ठीक है, in the gut and in the genitourinary tract, and that is why most of the infections are endogenous infections. And Nocardia on the other hand is not a commensal. It is present in the environment as a saprophyte, so the infections are acquired from outside, so they are exogenous infections. Okay, now this also is an MCQ. The most common species of actinomyces causing human infection is Actinomyces israeli. Now types of actinomycosis, remember, number 1, cervicofacial actinomycosis, also known as woody jaw. It is such a hard swelling of the submandibular region that it may mimic cancer also. Woody nose, anyone, is caused by what? Woody nose, ये आपने ENT में पढ़ा होगा. Woody nose is caused by anyone? Anyone? Woody nose is caused by Klebsiella rhinoscleromatis, a very hard swelling of the nose. ठीक है, उसको याद रखना. So cervicofacial actinomycosis or woody jaw, it is usually seen in people who are going in for some kind of oral manipulative procedure like dental extraction, etc. Okay, because during these procedures, what can happen? The oral commensals, they can, because the mucosal membranes are disrupted, these organisms again can enter the tissues and, set up the infection. Yes, very good, Shivangi. Okay, so this is one. Then we have got thoracic actinomycosis. Then we have got abdominal actinomycosis. Then we have got pelvic actinomycosis. This is seen in intrauterine contraceptive device users. Okay, as far as nocardiosis is concerned, remember we have got pulmonary nocardiosis. An important feature of this is that there is no lymphathy or lymphadenopathy. Other things are there, infiltrates, cavity can be there. Then we have got, brain abscess. Brain abscess kara sakta hai nocardia. And also remember another question is, a test is done, a culture technique is done for nocardia. Usko kya bolte hain? Paraffin bait technique. Okay, paraffin bait technique, which detects the ability of nocardia to use paraffin as the sole source of carbon. So nocardia uses paraffin as the sole source of carbon. Remember this, ye bhi MCQ hai. Then look at this, the gram chain of nocardia. On the left you can see the gram positive filamentous bacteria. On the right you can see acid fast stain. इसी acid fast stain picture पे question आ रखा है, इसको please याद रखना. Then we have got, look at this, gram positive Actinomyces israeli. Remember मैंने भी कहा था Actinomyces israeli is the most common species of Actinomyces causing human infection. Okay, so इसको याद रखो. And one more thing, Actinomyces के case में ना, remember the type of colonies. The type of colonies which appear on the culture media, they are described as spider colonies, also described as molar tooth colonies. This also is an MCQ, remember this as well. And then for treatment, remember the word snap, kola banao, danda banao. S stands for what? Sulfonamides. Sulfonamides are used for nocardia. Okay, and then for actinomyces, penicillin is used. For actinomyces, penicillin is used. Okay, then we have got two important, gram negative cocci. Gram negative cocci, Neisseria meningitidis, also known as meningococcus, and Neisseria gonorrhoeae, also known as gonococcus. Now, Neisseria meningitidis is a plano-convex, diplococcus surrounded by a capsule. Neisseria gonorrhoeae is kidney or bean shaped with no capsule. Remember in gonococcus में capsule gone away, capsule gone away. ठीक है, लेकिन इसमें होता है capsule which is a polysaccharide capsule. Sugar utilization, meningococcus utilizes both glucose and maltose, but gonococcus utilizes only glucose. Remember, glucose is a simple sugar, so that will be utilized by both, but M for maltose is a higher sugar, and remember M for meningococcus, M for maltose, so meningococcus additionally maltose bhi utilize karega. Okay, then meningococcus ke case mein mode of infection is via the respiratory route. Okay, and the site of carriage, remember meningococcus की क्या होती है? Nasopharynx, nasopharynx. Whereas in case of gonococcus, the mode of infection is sexual intercourse. It causes a sexually transmitted infection, that is gonorrhea. Beta-lactamase production is lesser in case of meningococcus, higher in case of gonococcus, and therefore drug resistance encountered is lesser in case of meningococcus and higher in case of gonococcus. Virulence factor, meningococcus में capsule है and gonococcus में pilae हैं. ठीक है, and these pilae, remember, they show what? They show antigenic variation. Now, meningococcus जब nasopharynx में, while it is there, and remember meningococcus is an important cause of meningitis with rash. Okay, so from the nasopharynx, मान लो, imagine this organism is there in the nasopharynx and it has got its own GPS to go to the central nervous system. Now it switches on the GPS, which shows this organism two routes to reach the central nervous system. So it can take two routes. Now, the more common route taken by this organism is the hematogenous route, meaning it will jump into the bloodstream and via the blood it will reach the central nervous system. This is more common. And the less commonly taken route by this organism to reach the central nervous system is what? along the perineural sheath of the olfactory nerve via the cribriform plate. ठीक है, please remember this. And the disease causing serotypes include serotypes A, B, W135, now it is simply known as W, X, Y. ठीक है, A, B, C, W135, X and Y. Most common serotype in India is A, most common in the West is B. Okay. Now the diseases caused are, एक तो obviously meningitis है. This meningitis is characterized by rash 2. Rash 2, which is a purpuric or petechial rash. Okay. Now, the second disease is meningococcemia. Meningococcemia, meaning the meningococci will enter the bloodstream, and they will cause an even more severe disease, which is characterized by, remember, these features. One is purpura. ठीक है, then purpura एक तो हो गया. Yaqeen Neat, you are from which batch? Purpura, shock and meningitis. Purpura, shock and meningitis. Then the most khatarnak disease is what? The most khatarnak disease is Waterhouse Friderichsen syndrome, which is characterized by what? Bilateral adrenal hemorrhage, and this is seen on autopsy because unfortunately patient unfortunately dies in just 3 to 5 hours only. Yaqeen Neat, are you asking for subscription? All subscription links you can find in the description of this video. Okay, my videos also you can find on the PW Merit app. All right. Now for diagnosis, samples you can collect CSF sample and blood sample. Now gram stain will show like this. Neisseria meningitis or meningococcus in the CSF as seen on gram stain. You can see a lot of neutrophils, and you can see these tiny dots. So these tiny dots are nothing but the meningococci. They're very small in size. Remember, they're less than 1 micron in size, and they can be seen both extracellularly and intracellularly also, that is inside the neutrophils also. Okay, so kindly remember this. Then for culture, this is a fastidious organism, so it will not grow on simple culture media. It will grow on enriched media, like for example, blood agar and chocolate agar. Chocolate agar is more preferred than blood agar because it is more enriched. Okay. Then selective media include modified Thayer-Martin medium. Okay, modified Thayer-Martin medium, and the drug of choice for treatment and prophylaxis is ceftriaxone. Then we come to Staphylococcus. These are nothing but gram-positive cocci, that is GPCs, arranged in grape-like clusters. They show a fermentative pattern in the OF test. They are facultative anaerobes, non-motile, non-sporing, and they're non-fastidious, meaning they don't have any nakhras or tantrums. They can grow on simple or basal media like what? Like for example, nutrient agar, okay, peptone, water. Then they are catalase positive, oxidase negative. Please remember, catalase is a very important valence factor because catalase enzyme is going to break down H2O2 produced by our immune cells into H2O and O2. And we can classify Staphylococcus based on the coagulase enzyme, also known as the free coagulase, as coagulase positive, which has got one important pathogen, aureus. I personally refer to a Staph aureus as the A1 or the number one pathogen in the genus Staphylococcus. Remember, A for aureus, A for A1 or number one. Then we have got the coagulase negative species like Epidermidis and Saprophyticus. Now look at this. This is a beautiful gram stain picture of Staph aureus from blood agar. And the culture media. See, this is a non-fastidious organism, so it can grow on simple media, as I said before, like nutrient agar. and it will show what? Golden yellow, approximately 2 to 3 millimeter sized colonies, and if there's a confluent growth, it will look like it is described as oil paint appearance. On blood agar, one more feature you will see, that is beta hemolysis, as you can see in this picture. So you can see these nice big 2 to 3 in size colonies, and with a clear transparency of the medium around the colonies. This is nothing but beta hemolysis, that is complete hemolysis on blood agar. Okay, so beta hemolysis means complete hemolysis. So you can just see through the medium just adjacent to the colonies. Alpha hemolysis is partial hemolysis, which is going to be characterized by a greenish discoloration around the colonies because of accumulation of biliverdin, a green colored substance. Okay, then gamma hemolysis is a misnomer, it means no hemolysis. Then milk agar is good for what? Milk agar is uh, good for seeing the golden yellow pigment, and milk agar is nothing but Na, that is nutrient agar plus milk, nutrient agar plus milk. Then we have got salt milk agar, which is nothing but milk agar plus 7.5% salt. Okay, so then we have got the selective and differential medium, namely MSA, that is mannitol salt agar, on which Staph aureus, which ferments mannitol. Staph aureus produces yellow colonies because it is a mannitol fermenter. And like for example, another organism is Staph epidermidis, which is an example of corns. It will produce colorless colonies because it won't ferment mannitol. Okay, so it's a selective and differential medium. So this medium is selective for the growth of all the species of Staphylococcus, and it will help us differentiate amongst the different species of Staphylococcus by virtue of mannitol fermentation. Okay, then we have got Ludlam's medium, L for Ludlam, L for lithium. So this again is a selective medium for Staphylococcus because it has got lithium salts in it. Then next we come to the virulence factors, or the arms and ammunitions, or the astra and shastra of this bacterium to make us sick. So we have got cell wall factors like lipoteichoic acid, which can induce shock-like features. It can induce shock-like features, just like what is done by endotoxin in case of gram-negative bacteria. Then we have got protein A, which attaches to what? It attaches to the FC part of IgG antibody. Then we have got the bound coagulase or clumping factor, which acts as what? Which acts as a receptor for fibrinogen. So all of these 1, 2, 3, they are attached to the cell wall. Therefore they are known as cell wall factors. And remember, bound coagulase or clumping factors is detected by what? It is detected by slide coagulase test. Then the second category of valence factors are the enzymes. So we have got free coagulase or enzymatic coagulase. Please, this should not be confused with the bound coagulase. So there are two different coagulases. One is bound coagulase, which is attached to the cell wall. It is not an enzyme. The other one is free coagulase. It is called as free coagulase because it's an enzyme in nature. Okay, so it changes prothrombin to thrombin, and this thrombin will convert fibrinogen to fibrin clot, and this fibrin clot it walls off the site of infection, and that is why we say Staph aureus causes what? Localized suppurative or pyogenic infections. Okay, so this is one important enzyme. Then we have got DNases, thermostable nuclease, phosphatase, hyaluronidase, and staphylokinase. These are less important enzymes. Then we have got certain important toxins of Staph aureus, like for example हेमोलाइसेंस. इनमें आते हैं अल्फा हेमोलाइसिन और पैराडॉक्सिकल टॉक्सिन. ठीक है, so the deal with this is the toxin gets inactivated at 60 degrees Celsius, and then paradoxically gets what? It gets reactivated at 100 degrees Celsius. So this is the paradox. The beta hemolysin, also known as sphingomyelinase, also known as hot cold hemolysin, it is a sphingomyelinase, which means it breaks down what? It breaks down sphingomyelin. Sphingomyelin, which is present where? It is present in the membrane of the sheep RBC. So it will cause hemolysis on the sheep blood agar. And it is called as hot cold hemolysin because it binds to the RBCs at a high temperature, but the actual hemolysis occurs when the temperature is less. Then we have got leukocidin or Panton Valentine toxin, which is made up of two components, S and F, that is slow and fast. It's an example of synergo hymenotropic toxin. Synergo means synergy, साथ साथ हम साथ साथ हैं, दो components हैं वो साथ में आएंगे. Hymeno means membrane. So these two components S and F, they have got affinity for the hymen or the membrane of some cell. Which membrane? For example, WBC. So leukocidin जो है, that causes WBC damage. Likewise, we have got another example of a synergo hymenotropic toxin, which is known as gamma hemolysin. Okay, gamma hemolysin. Then we have got delta hemolysin. Remember D for delta, D for detergent. So it has got detergent-like action on a plethora of cells, like for example, RBCs, WBCs, platelets, okay, macrophages. तो ये किसी को नहीं छोड़ता. Delta hemolysin. Then we have got epidermolytic toxin or exfoliatin. It causes separation of the superficial layers of the skin. This you must have read in derma also. So it causes what disease? It is an example of, by the way, super antigen. Okay, it causes staphylococcal scalded skin syndrome. Then we have got enterotoxins, A to G, except which one? Except F. Okay, these enterotoxins also, they are super antigens. Very good, Shivangi, SSSS. Super antigens, and these these enterotoxins are exotoxins, but unlike exotoxins, which generally are heat labile because they are proteins, these are very heat stable, very heat stable, and they cause what? They cause FP, that is food poisoning. V for vomiting is the main clinical feature in children, and this vomiting is because of vagal stimulation. And इसका incubation period क्या है? 1 to 6 hours. And this is what? This is a self-limiting disease. No antimicrobials are needed, obviously, because bacterium is not the villain over here. The villain are the toxins. Antitoxin also is not needed. The patient becomes fine in 3 to 5 days. Okay. Now, yes, very good, Shivangi. Ritter's disease in children. Good. Now, Staph aureus infections. So we can categorize them into the suppurative or the pyogenic infections and the toxin mediated ones. This again, I think this is a repetition. You must have read this in derma also. So we'll quickly revise this. So remember, Staph aureus is the most common cause of pyoderma, folliculitis, furuncle, carbuncle. MCC, most common cause. Okay. Pyoderma is a superficial infection of the skin. Folliculitis, superficial infection of the hair follicle. Furuncle is a deep infection. Carbuncle is multiple furuncles. Then impetigo ka MCC most common cause क्या है? Group A streptococcus, but Staph aureus also can cause it. Then cellulitis also, the most common cause is Group A streptococcus. Then Staph aureus can cause breast abscess, especially in lactating mothers, and it is also the most common cause of MCC, most common cause of acute osteomyelitis. But the most common cause of acute osteomyelitis in sickle cell anemia is what? Salmonella. Remember Salmonella. Then we've got the toxin mediated diseases like toxic shock syndrome, Staph aureus food poisoning, and SSSS. Then it can also cause pyomyositis, and it is the most common GPC responsible for nosocomial or healthcare associated pneumonia. Then it can also cause in the community people a severe pneumonia called as necrotizing pneumonia by what? By CA, MRSA strains, which are what? Which are leukocidin producers, remember. Then it can even cause surgical site infections, and it is also thought to play a role in Kawasaki syndrome. Then impetigo contagiosa, it is characterized by a honey-colored crust and weeping erosions, and it's also Staph aureus infection. Then treatment aspects, the drug of choice is penicillin G, but unfortunately resistance has been encountered very commonly because of the enzymes penicillinase, that is beta-lactamase. The gene for this enzyme is present on what? The gene is present on a plasmid. Okay, and this can be transferred from a resistant strain to a sensitive strain via the agency of phages. Okay, so just a little memorizing tip. Remember BPT or Bachelor of Physiotherapy, where B stands for beta lactamase, P stands for plasmid, and T stands for transduction. Let me highlight this: BPT, Bachelor of Physiotherapy, BPT से याद कर लो. So इसके to overcome this problem of penicillinase, we came up with penicillinase resistant penicillins like methicillin and iske bhai behan like oxacillin, cloxacillin, nafacillin, etc. Methicillin was unstable, at room temperature, so that is why these other oxacillin and all they came up. But unfortunately, resistance developed to methicillin also. Why? Gene known as MEC-A gene, which is present on the bacterial chromosome, and it encodes for the altered penicillin binding protein. तो ये altered penicillin binding protein का क्या मतलब हुआ? These penicillin binding proteins have become altered, so they no longer will be able to bind to penicillin, and they are written like this: PBP2 prime or PBP2A, P capital, B capital, P capital. And such strains are known as methicillin resistant Staph aureus, that is MRSA strains. Now, some cephalosporins, again, this you must have read in pharma also, which are some cephalosporins have got some activity against MRSA like ceftobipyrrole, ceftaroline, and ceftibutin. And what is the drug of choice for for MRSA? Vancomycin. If at all, God forbid, resistance to vancomycin also occurs, we will get vancomycin resistant staph aureus, that is VRSA, for which the drug of choice is, remember, linezolid and cynoside. Cynoside is a synergistic combination of quinupristin and dalfipristin. And also remember, the most common cause of acute endocarditis in intravenous drug abusers also is staph aureus, and this is usually a right-sided endocarditis. It means it involves more commonly the tricuspid valve. अब ये ऑब्वियस है क्योंकि पता है क्या है, स्टैफ ऑरियस इवन दो इट्स अ पैथोजन, इट मे बी प्रेजेंट एज अ colonizer in the anterior nares most commonly, and second most common site is the skin. So let's say there's an intravenous drug abuser who is a carrier of staph aureus. Staph aureus is there on the skin of that intravenous drug abuser. So while injecting the drug, the person is not obviously using antisepsis, so what is being injected into the veins along with the drug? Staph aureus. And from veins the blood goes to the right side of the heart, and therefore more commonly this endocarditis is right sided. Okay, please remember this. Then we have got coagulase negative staphylococci, that is cons, जिसमें आता है staph epidermidis. It's a commensal on the skin, oropharynx and vagina. Generally it is harmless and the colonies are white, they are not golden yellow unlike staph aureus, and it is much less virulent than staph aureus because it is non-hemolytic. And on mannitol salt agar, ये मैंने पहले लिखवा दिया है, it produces red color or colorless colonies because it does not ferment mannitol. Now, it causes diseases only when it gets an opportunity. Like for example, if the patient has got some prosthetic devices like implants, catheters, intravenous cannulas, artificial heart valves. You know why? Because remember, let's say if this is a catheter. Okay, now, so what happens? Staph aureus will start producing slime, which is this polysaccharide substance. So this is polysaccharide substance or slime. Then staph aureus will happily multiply inside this slime, and this is nothing but what? This nothing but biofilm. So this slime is a very sticky substance. It is impenetrable by antibodies, antibiotics, complement proteins. So that is why such infections are very difficult to treat. The best treatment for such infections is that you remove the device only. But it is not always possible to do so because can you remove a prosthetic heart valve? You can't. So that is why these infections are a nuisance for the clinicians. Also remember all these one-liners about staph aureus. It's the most common cause of nosocomial bacteremia, most common cause of end ophthalmitis after cataract surgery, most common cause of peritonitis after CAPD, that is continuous ambulatory peritoneal dialysis, most common cause of prosthetic valve endocarditis, most common cause of VP shunt infections, and most common cause of, and a common cause of stitch abscess, not the most common but a common cause. And overall, remember, staph epidermidis is the most common cause isolated from the clinical specimens. And also remember, this organism is positive for the phosphatase test. Okay. Then we have got the second cause, staph saprophyticus. Overall, remember, what is the most common cause of UTI? Tell me in the comment section. If somebody asks you what is the overall most common cause of UTI, क्या आंसर दोगे? बताओ. Very good, Shivangi. E. coli, and very good, Dr. Mukesh. So overall, the most common cause is what? E. coli. But if somebody asks you, name a gram-positive coccus causing, which is the most common cause of UTI in sexually active females, answer is Staph saprophyticus. Okay. So it causes UTI in sexually active females, which is known as honeymoon cystitis, and it is the most common GPC causing UTI in sexually active females. In sexually active females, if somebody asks you what is the most common cause of UTI, then also your answer is going to be E. coli only. But most common GPC koi puche to answer is Staph saprophyticus. So this organism expresses a 16 kilodalton hemagglutinin or adhesin, which helps it to attach to the uroepithelial cells, and we can differentiate this cons from the other cons, that is staph epidermidis, by what is known as novobiosine susceptibility test. Now, the mechanism of action of novobiosine is inhibition of DNA gyrase. Remember, epidermidis is novobiosine sensitive, saprophyticus is resistant. An easy way to remember is write down ESSR, gola banao, danda banao. E stands for what? E stands for epidermidis. S stands for sensitive. Okay. S stands for saprophyticus. So I'm writing the species name. Epidermidis and saprophyticus are species name. R stands for resistant. Simple. So ESSR इस सीक्वेंस में याद कर लो. Differentiating antibody test पे भी ऐसे questions आते हैं. Then we move on to Streptococcus. Unlike staph genus, this is gram-positive cocci in chains. Remember, strepto matlab strips matlab chains. So this is the gram chain of Streptococcus pyogenes, that is group A Streptococcus, which is the most important pathogen in the genus Streptococcus. And this is catalase negative. इस पे भी question आता है, what is the most important test to differentiate between staph and strepto? Answer is catalase test. So unlike staph, which is non-fastidious, these are fastidious organisms, and remember they are non-motile. And based on the oxygen needs, we can categorize them as anaerobes and facultative anaerobes. तो anaerobes में genus याद करो, Pepto Streptococcus, and the species include Peptostreptococcus anaerobius and Peptostreptococcus magnus. Now, these are Peptostreptococci are present as commensals in the oral cavity, gut, and the genitourinary tract, and they cause what? They can cause brain abscess, puerperal infection, lung abscess, and human bite wound infection, because they are present in the oral cavity. Now, so this is about the anaerobes. Now, if we come to facultative anaerobes, ye wale facultative anaerobes, they can be classified based on hemolysis on the blood agar into alpha hemolytic, beta hemolytic, and gamma hemolytic. Now, alpha hemolytic ko kya bolte ho? They are known as viridin streptococci, because as I said before, alpha hemolysis is partial hemolysis of RBCs, which will lead to accumulation of biliverdin, which is greenish in color. Because of this accumulated biliverdin around the colonies are going to have a greenish discoloration. Now, so viridins is not the name of a species, it's the name of group. There is nothing called as Streptococcus viridins. Please remember. So viridin streptococci is a group of alpha hemolytic streptococci. So the examples include Streptococcus mutans, Streptococcus mitis, Streptococcus salivarius, and Streptococcus sanguis. Okay. So all of these are oral commensals, and they're the most common cause of number 1, dental caries, and number 2, subacute bacterial endocarditis. Okay. Now, dental caries, remember that also is an example of biofilm formation, and okay, that is the most common by far the human infection. All of us during some point of time in our lives, we do visit a dentist for sure. So this is about the alpha hemolytic facultative anaerobes. Then we have got the beta hemolytic fellows. So beta hemolytic streptococci, they were classified by a female microbiologist, Rebecca Lansfield, ma'am. The grouping or classification which she gave is known as Lansfield grouping, based on the C carbohydrate antigen of the cell wall. So you have got A to V groups except I and J, and the most important one is group A. Group A is nothing but Streptococcus pyogenes. Group B is what? Streptococcus agalaxiae. Okay. Now, group A, as I said, Streptococcus pyogenes is the most virulent pathogen, so it's important to identify it. So, group A is bacitracin sensitive, whereas all the other groups are bacitracin resistant. So, as you can see in this picture, this is the bacitracin sensitivity test. This arrow is pointing towards the zone of inhibition around the bacitracin disc. So, the upper fellow, so this is the blood agar. Basically, you can see this yellow thing. This yellow thing is nothing but beta hemolysis. So, two strains were inoculated on this blood agar. The upper strain did not grow around bacitracin, so it was sensitive to it. The below strain was not sensitive to it. It was fearless. It went on to grow right up to the bacitracin disc. Okay, so the upper one is what? Group A streptococcus. Group A streptococcus. Kindly remember this. Then group A streptococcus, because it was so important, it was further studied and it was classified. Classification को क्या बोलते हो? Typing भी बोलते हो. In microbiology, typing means classification. So group A streptococcus, that is Streptococcus pyogenes, was typed into different types based on the M protein by what? By whom? By Griffith. And till date, around 100 Griffith types exist. Now, strep pyogenes or the group A streptococcus, on blood agar, it shows beta hemolysis. Remember, the transport medium is Pike's medium, and the selective medium for this organism is crystal violet blood agar. Crystal violet blood agar. The Willis factors of group A streptococcus, that is strep pyogenes, include capsule, which is made up of hyaluronic acid. This capsule is non immunogenic. Okay, because we also have got hyaluronic acid in our body, so antibodies are not going to be induced against this capsule. And this capsule is a valence factor because it is anti-phagocytic. Then the other important valence factor is M protein, which again is anti-phagocytic. Then teichoic acid, which is present in gram-positive organisms, it is an adhescent. Then it produces hemolysin, like for example streptolysin O, streptolysin S. ठीक है? Streptolysin O is oxygen labile and streptolysin S is oxygen stable. And streptolysin O is more antigenic, and therefore whoever gets infected with this organism, the immune system will produce antibodies against streptolysin O, that is known as the ASO titer. Okay, so ASO means anti-streptolysin O. Titer means, technical definition is the reciprocal of the highest dilution on which agglutination occurs. Roughly, you can understand titer means concentration. Okay. Then we have got pyrogenic exotoxin, or also known as the Dick toxin, or the erythrogenic toxin, or the scarlatinal toxin. It's of three types: A, B, and C. Okay. Now, A and C are examples of important super antigens. All right, A and C are, their genes are present on a plasmid, so they are plasmid encoded, and B is chromosomal. The B's gene is present on chromosome. Then we have got streptodornase. Remember, dornase has got D and D for DNase. So streptodornase or DNase, it breaks down the DNA of the infected cells, and it is therefore responsible for the thin serous nature. It is responsible for the thin serous nature of streptococcal exudates. Thin serous nature of the exudates. Then we have got hyaluronidase. Now this is pretty interesting. Remember, the first valence factor was capsule, which is made up of hyaluronic acid. So how is it possible that hyaluronidase also is being produced, which will destroy the capsule? Remember, hyaluronidase, is not produced by capsulated strains. So in strep pyogenes also, we have got two kinds of strains, capsulated and non-capsulated. जरूरी नहीं है कि सारे के सारे strains के पास capsule होगा ही होगा. जिनके पास नहीं होगा, they are producers of hyaluronidase. Then we have got streptokinase or fibrinolytic enzyme, collagenase, and serum opacity factor. Serum opacity factor का actually exact role is not known. Okay. Now these enzymes 8, 9 and 10, ये वाले 8, 9 and 10, because they help in spread of infection in the subcutaneous tissue. Therefore, remember, group A streptococcus is the MCC, most common cause of cellulitis. Remember. Now, the diseases caused by group A streptococcus include, again, suppurative infections, okay, and the non-suppurative immunological sequelae. इसमें दो चीज़ें आती हैं, acute rheumatic fever and post streptococcal glomerulonephritis. Suppurative में क्या आता है? Pyoderma impetigo, cellulitis, then necrotizing fasciitis, and sore throat. The most common cause of sore throat overall are viruses, but group A streptococcus is the most common bacterial cause. Most common bacterial cause of sore throat, which if not treated can lead to complications, like for example, peritonsillar abscess, that is quinsy, Ludwig's angina, otitis media. So remember these complications. Then we have got the non-suppurative immunological sequelae, which occur 2 to 4 weeks after the infection by strep pyogenes, but they're not because of the organism directly. They are as a result of the immune response which has been produced as a result of the bacterial infection. So we have got what? We have got acute rheumatic fever, which occurs 2 to 4 weeks after an attack of sore throat and not by skin infection. Please remember this, not by skin infection. So क्या होता है ना, antibiotics attack against the, sorry, this should be antibodies against the bacteria. They start attacking the host tissues because of molecular mimicry. Okay, molecular mimicry means this. So there are certain antigens on the bacteria which mimic which are very similar to the human antigens. For example, the M protein of streptococcus is very similar to the myocardium protein. So what happens, the antibodies which have been produced against the M protein, they start attacking the myocardium also. This is known as molecular mimicry. This is the whole कलेश की जड़ in case of acute rheumatic fever. Then we have got cell wall carbohydrate. Remember, carbohydrate has got CAR in its name na. So cardiac valve में भी CAR आता है, तो carbohydrate is similar to cardiac valves. Then cytoplasmic membrane is similar to what? Glomerular vascular intima. Peptidoglycan is similar to the skin antigen. Hyaluronic acid mimics what? I mean, hyaluronic acid is there in the bacteria, and our synovial fluid also has got the same. So this is the basic pathology, and the features include fever, myocarditis, subcutaneous nodules, migratory polyarthritis, chorea, and endocarditis. All of this you read in medicine and peds also, so please revise this well. Then we have got post streptococcal glomerulonephritis, which occurs 2 to 4 weeks after skin infection by group A streptococcus, less commonly following throat infection. तो याद रखो, acute rheumatic fever occurs only after throat infection and not after skin infection. Not after skin infection, लेकिन PSGN can occur after both, more commonly after the skin infection. So what happens? The antibodies against the bacteria, they combine with the bacteria, they form immune complexes, they circulate in the blood, and they reach the kidneys where they are filtered by the glomeruli, and they tend to deposit in the glomeruli and activate the complement. Now, why should they deposit in the kidneys? Because kidneys receive 1/4 of the cardiac output, and in kidneys, filtration of blood is happening to form the urine. That is why these immune complexes have got a preferential tendency to be filtered by the glomeruli. And these antigen antibody complexes, they can activate what? The classical pathway of the complement. Classical pathway is activated by the antigen antibody complexes, and that will result in glomerulonephritis. The patient will have what? Edema, oliguria, okay, hematuria, and RBC casts in the urine. The prognosis in this condition is good in contrast to acute rheumatic fever. And इस पे और भी question आता है, complement levels are decreased where? Complement levels obviously are going to be decreased in PSGN, because यहाँ पे complement is being utilized or consumed as a result of complement activation. Okay, now we move on to another organism, Streptococcus pneumoniae. Okay, this is the gram stain. This is basically a diplococcus. As you can see, this arrow is pointing towards what? These arrows are pointing towards the typical halo present around this diplococcus. So the clear area around the organism is the capsule. Okay, so kindly remember this. So this fellow, it's a gram positive diplococcus, and it is flame shaped. It is flame shaped, or also described as lanceolate shaped, something like this. So this is the schematic diagram I am drawing. Actual picture is already there. So this is one coccus which is flame shaped, another coccus which is again flame shaped, and it is surrounded by a capsule. So this is the capsule. Now, strep pneumonia, also known as pneumococcus, because it's a kind of streptococcus, it is catalase negative. Okay, so it is a flame shaped or lanceolate shaped diplococcus with a capsule, as I just said. It is the most common cause of what? Lobar pneumonia, and also the most common cause of community acquired pneumonia, that is CAP. CAP. It is non-motile, non-sporing, non-acid fast. Remember, most of the cocci are non-motile only, and it is also oxidase negative. Oxidase negative. Now it causes alpha hemolysis, that is partial hemolysis on blood agar. ठीक है. Now viridin streptococci we just learned they are also alpha hemolytic, but remember this organism strep pneumoniae is not kept in the category of viridin streptococci. Viridin streptococci are spherical cocci in chains, but this fellow strep pneumonia has got certain different properties. So in textbooks also it is discussed in a separate chapter, so it has got a special status, so to say. Okay, so it is very important to differentiate between the viridin streptococci and this organism, which I'm going to talk about in just a few minutes. Now the colonies of this organism initially are high convex or dome shaped. So initially they will look like this if you see them from the side, but after some time they will have a central depression, and this is known as what? Carom coin appearance or Drotsman appearance, because of the central lysis of the colonies. Now the virulence factors include pneumolysine. This again is going to cause lysis, hemolysis. So it also inhibits neutrophil chemotaxis and phagocytosis, and it is very similar to streptolysin O, जो अभी हमने थोड़ी देर पहले पढ़ा था, where I said that streptolysin O is a good antigen, and in response to it the immune system will produce antibodies. So though they are ASO, anti-streptolysin O antibodies. ठीक है. Then the other important valence factor is IgA protease. That is why this organism is able to set up the mucosal infection. Remember, today only we have learned that IgA is the example of mucosal antiseptic paint. It's the mucosal antibody. Then it has got a beautiful capsule, as we saw in the picture, which is polysaccharide, most important valence factor. It is antiphagocytic, and it is the basis of serotyping. We have got 95 serotypes of pneumococcus based on the capsular antigen, and quelling reaction can be done for serotyping. Okay, and also remember, this the capsular antigen diffuses into the culture medium, tissues, and exudate, and therefore it is also known as soluble specific substance. Now the final appearance of these colonies because of the central depression is because of what? It is because of an enzyme which is an amidase. It is also known as suicidal enzyme. So it helps in lysis of the bacteria, and it is responsible for the Karen coin appearance. So you might wonder why then it is a valence factor. It's a valence factor because when the organism breaks down, newer antigens, in other words newer epitopes, are going to be exposed, so that those will cause more tissue damage. I mean, in response to them, more immune cells will be activated, and the result is going to be more immune response, more tissue damage therefore. And it is also known as autolytic amylase, and its activity increases in the presence of bile salt. So it's responsible for bile solubility. Please remember this also. Now, this fellow is extremely important, and a lot of one-liners are asked on the diseases caused by pneumococcus. Firstly, remember, think about adults. Okay, think about adults. So in adults, the most common cause of acute meningitis is this organism. So A for acute meningitis, A for adults. अब बच्चों के बारे में सोचो, बच्चों में क्या कराएगा? It is the most common cause of otitis media in kids. Then it is the MCC, most common cause of लोबार निमोनिया एंड कम्युनिटी अक्वायर्ड निमोनिया. रिमेंबर इसके नाम में ही क्या है? निमोनिया. So lobar pneumonia and community acquired pneumonia. Then it's also is an important cause of sepsis in splenectomized people. It's also an important cause of it's also an important important bacterial cause of sinusitis. All right. And previously, please remember, this is a this is an important MCQ. Please don't do any mistake in this. Previously, the most common cause of epiglottitis was what? Haemophilus influenzae serotype B. But now the most common cause of epiglottitis is what? It is pneumococcus. And also remember, pneumococcus is an important cause of acute exacerbation of chronic bronchitis. Okay, like for example COPD. Okay, now the difference between viridin streptococci and streptococcus pneumoniae. Okay, we'll discuss this table, very easy to remember. Now listen to me very carefully और मेरे साथ ही बस याद करते जाओ. So viridans लेफ्ट में लिखा है, pneumococcus राइट में लिखा है. तो रिमेंबर VIP, तो VIP मैंने लिख दिया, ठीक है. तो V से विरिडेंस, I को छोड़ दो, और P से क्या है, न्यूमोकोकस. सो VIP, वेरी इंपॉर्टेंट पर्सन. ओके, now imagine there's a VIP who wants to open his or her bank account in Indian Overseas Bank. So the last three देखो, IOB क्या है, remember IOB, Indian Overseas Bank, that is inulin fermentation, optogen susceptibility and bile soluble. So remember, left से right, just remember viridans, pneumococcus, IOB. Very important person going to Indian Overseas Bank to open his or her bank account. So viridans does not ferment inulin, so inulin fermentation is absent. Pneumococcus ferments it. Then optogen susceptibility. Viridans is khadus, it is resistant to optogen antibiotic, and pneumococcus gives into optogen, so it is susceptible to optogen. Then viridans is bile insoluble, pneumococcus is bile soluble. देखो ये virulence factors में, like I discussed over here. So this organism has got amidase enzyme which is responsible for its bile solubility. तो इससे भी आपको याद रहना चाहिए कि pneumococcus is bile soluble. Now coming to the first 3 points of difference. As I just said, as I said in the beginning, pneumococcus is lanceolate shaped diplococcus surrounded by a capsule, but viridans क्या है, a spherical coca in gram positive chains, and they are non-capsulated. Viridans की जो colonies होती हैं, they are high convex or dome shaped, but pneumococcus की initially high convex होंगी, but eventually they will come to have carom coin or Trotsman appearance thanks to the autolytic amidase. Then viridans is less pathogenic for humans and animals, like pneumococcus is more pathogenic. This is clear from the fact that we have learned, so many diseases caused by this entire list of diseases for pneumococcus, which is very important. Okay, I hope you'll be able to recall, this organism in a better way, like this. Now we come to lab diagnosis. So remember, the specimens which we can collect include sputum, blood, CSF. We can do direct microscopy to look, by gram stain, which will show us gram positive lanceolate shaped diplococci with a capsule like we saw before. Then culture on blood agar, it will produce 0.5 to 1 millimeter sized glistening alpha hemolytic colonies with carom coin appearance. Then from the colonies, if you make a smear and you see it under the microscope, that is known as culture smear. So culture smear, when you make a smear from the colonies and you do gram stain, you will see the cocci are 1 micron in size approximately. And you can also do motility from the colonies by hanging drop preparation, which will show that these cocci are non-motile. Then the biochemical reactions, as I've already discussed in the table, remember IOB, Indian Overseas Bank. Then typing can be done by quelling reaction. And even though we don't do it, just no, this can be asked as an MCQ also. Mouth pathogenicity test. So intraperitoneal inoculation into the mice will lead to what? Unfortunately, death of the mice in 1 to 2 days. Then molecular methods, PCR. Then the drug of choice is what? The drug of choice is penicillin. Okay, but unfortunately resistance is being reported due to altered penicillin binding proteins, and if resistant, then other drugs like sulfonamides, aminoglycosides, quinolones can be given, and if still resistance is there, then you go for vancomycin. Okay, thank God vancomycin ke against resistance till date has not been reported in case of pneumococcus. Remember this. Then we have got Vibrio cholerae. This causes an acute diarrheal illness, namely what? Namely cholera. Now this fellow is non-fastidious, that is, it can grow on simple or simple media like nutrient agar and all. It's a facultative anaerobe. It is oxidase positive and it is also catalase positive. Then it is non-halophilic, which means it needs a decreased salt concentration for its growth. 1% is enough. Then it gives a positive cholera red reaction. All right. And the cholera red reaction, one second. Cholera red reaction, it is done in a single test tube. It's an amalgamation or a combination of 2 important tests. Number 1 is indole test, which is positive. Number 2 is what? Number 2 is nitrate reduction test, which also is positive. So cholera red reaction is positive in Vibrio cholerae. Okay? So you can remember this as COIN, COIN. C stands for catalase, which is positive. O stands for oxidase, again positive. I stands for indole test. N stands for nitrate reduction test. So COIN. ठीक है, COIN. Pranam Ramesh. Now, pathogenesis mode of infection is fecal-oral route. Okay, infective dose is what? 10^5 to 10^8 organisms. All right. Now, cholera, remember, cholera is a toxin-mediated disease. Most important valence factor is the toxin. Mechanism of action मैं पहले ही बता चुकी हूँ. In case of labile toxin in case of ETEC. Okay, sure, Anshad. So the toxin's name is cholera toxin or choleragen, abbreviated as CT. So same mechanism of action as I talked about in case of labile toxin, wahi ADP ribosylation of G stimulatory protein. But as I said before, cholera toxin is 100 to 1000 times more potent than the labile toxin of ETEC. Then tox-R gene is an important gene present in Vibrio cholerae. ठीक है? And this is present in a phage. So इसका मतलब क्या हुआ? The CT cholera toxin is a phage encoded toxin. Okay, and this again is asked as an MCQ that LPS or endotoxin has got no role to play in the pathogenesis of cholera. All right, remember this. Then we have got the clinical features: rice watery stools with flecks of mucus. Then, because this toxin is 100 to 1000 times more potent than the labile toxin of ETEC, so patient can go in for shock and its associated complications very quickly, like ARF and metabolic acidosis. Then, for diagnosis, we can collect freshly passed out feces, which is the best specimen, and for carriers and convalescent patients, we can go for rectal swabs. The transport media are these: Kerry-Blair medium, which is referred to as the universal transport medium, meaning it can be used for the transport, it can be used as a transport medium for feces if we are suspecting a variety, different kind of fecal pathogens, like for example, not just Vibrio cholerae, but others also like Shigella and all. And carry itself serves as a reminder for what? Carry. So it's a transport medium, remember this. Then alkaline peptone water, that is APW. Vibrio cholerae grows in alkaline pH, that is 8.5. Then we have got VR medium. Again, this is also frequently asked MCQ. And on Graham Stein's Sir Robert Koch, father of bacteriology, described the arrangement of these organisms as fish in stream appearance. Fish in stream appearance. Okay. Hanging drop will show what? These are motile organisms and they show what? Darting or shooting star motility. Darting or shooting star motility. Okay. Now for culture of the feces, because it is feces and we have got a lot of traffic of commensals, so it's important to add the fecal sample to some enrichment broth like salinite F broth. Now F in salinite F actually stands for feces only. Okay, then we have got tetrathionate broth. You incubate for 4 to 6 hours and then you do subculture on selective media, like for example thiosulfate, citrate, bile salt, sucrose agar, on which yellow colonies are produced because of sucrose fermentation. Then on McConkey agar, after 24 hours, non-lactose fermenting colonies are going to be produced, but after 48 hours, the colonies turn pink. That is, this organism is LLF, that is a late lactose fermenter. Okay, it is a late lactose fermenter. Then treatment, fluid replacement therapy, and remember, currently in the world and in India, the most common serotype is what? Remember, O1, L-TOR, and OGAVA. This is the most common serotype. All right. Now, coming to important topics in mycology. First question जो यहाँ पे आता है, which of the following is a sexual spore, which is an asexual spore? So remember, these are the four broad classes in of fungi: ZAPD, Zygomycetes, Ascomycetes, Basidiomycetes, and Deuteromycetes. And इनकी corresponding sexual spores are like these: Zygomycetes, zygospores and oospores; Ascomycetes, ascospores; Basidiomycetes, basidiospores. So remember these as ZOAB, zob. Now Deuteromycetes is also known as fungi imperfecti because it has got no sexual stage. और यहीं पे एक आपका MCQ बनता है, most of the medically important fungi, most of the medically important fungi, they belong to what class? Deuteromycetes. Okay, so just remember it like this, that even though deuteromycetes are referred to as fungi imperfecti, still they are perfect good to cause human disease. In other words, just remember, most of the medically important fungi, they belong to the class deuteromycetes. Now, dermatophytes, a lot of questions are asked. For instance, infection of the scalp can occur by dermatophytes, and infection of the scalp is known as tinea capitis. So two important varieties you should remember, Chirion and Favus. Chirion is what? It is nothing but an intensely inflammatory boggy swelling of the scalp, okay, with follicular scarring, and sometimes alopecia can also be seen because the hairs become loose, so they can be easily epilated. Favus, on the other hand, Favus is characterized by cup-shaped lesions known as scutula, which are nothing but encrustations of the causative fungi around the infected hair follicle. Now, the causative agents of these entities, remember, left hand side pe mentagrophytes and verrucosum, right hand side pe Schonlini and Violatium. This also you can remember as, in alphabetical order. Left में MV, right में SV. So MV, SV. Mentagrophytes, verrucosum. Verrucosum comes before Violatium in English. So verrucosum is in the left sided column. Violatium is on the right. Okay. Now tinea corporis क्या है? It is nothing but corporis is socho corporate all over. So it's the infection of the body, all over the body of the non-hairy skin. Then cruris is also known as jock itch or dhobi itch, infection of the inguinal region. Then pedis, infection of the web spaces, also known as athlete's foot. Unguum, infection of the nail beds caused by mentagrophytes and trichophyton mentagrophytes and epidermophyton flocosum. Barbe, infection of the beard and the mustache. Fasciae, infection of the non-bearded skin. Manum of the palms, and imbricata, characterized by concentric lesions on the skin caused by Trichophyton concentricum. Now, there is also something known as ectothrix and endothrix, where certain asexual spores, namely arthrospores. So remember, arthrospores are examples of the asexual spores. In the beginning, in this table, remember, ascospores are mentioned. तो ascospores के spelling में S आ रहा है, मतलब these are sexual spores. Arthrospores में S नहीं आ रहा, remember they are asexual spores. So please remember this, don't make any mistake. So ectothrix is the condition whereby the arthrospores or dermatophytes are formed on the surface of the hair shaft, and endothrix में क्या होता है, inside the hair shaft arthrospores are formed. Okay, then very commonly see questions are asked on the macroconidia of the three important genera of dermatophytes, that is Trichophyton, Microsporum, Epidermophyton. So micro and macroconidia, they also are examples of what? They are examples of the asexual spores. Okay, asexual spores. Macroconidia are very tiny unicellular spores. Macroconidia are big sized multicellular spores. Okay, now in Trichophyton, माइक्रोकोनिडिया आर अबंडेंट, तो याद करो ट्राइको में माइक्रो, macroconidia are very few and rare, and when present they are pencil shaped or cylindrical. Now have a look at this. Okay, so figure A is nothing but Trichophyton mentagrophytes. So you can see so many dots, itni sari dots, and they are nothing but microconidia. So remember, tricho में micro and macroconidia are few or rare, and look at this. This is pencil shaped or cylindrical. Okay, माइक्रोस्पोरम में उल्टा होता है, दैट इज यहाँ पे मैक्रोकोनिडिया आर अबंडेंट, ठीक है, माइक्रोकोनिडिया आर रेयर. सो यहाँ पे उल्टा होता है, तो इसको अगर मैं ऐसे क्रॉस कर दूं तो ऐसे आपको याद रहना चाहिए. ओके, सो इसको ऐसे याद कर लो. And the macroconidia are boat shaped or fusiform. Now look at this picture. This is Microsporum canis. You can see boat shaped or fusiform macroconidia in case of microsporum. Then lastly we have got epidermophyton. इसमें तो बहुत ही आसान है. एपी देखो, एपी मीन्स ऊपर, तो ये घमंडी फंगस है, ये बहुत हाईली सोचता है अपने बारे में. सो इट डजंट लाइक स्मॉल स्पोर्स, इट लाइक्स बिग स्पोर्स. सो इट हैज गॉट ओनली macroconidia, and that's not all. They are present in bunches. So the shape is club shaped, that is clavet shaped, and they are present in bunches. So look at this, epidermophyton flocosum के case में, look at this, how beautifully these clavet shaped macroconidia are shown in bunches. So please remember this. Okay, then again this is also a famous MCQ, hair perforation test किसमें positive होता है. Remember, it is positive in Trichophyton mentagrophytes and Microsporum canis, and negative for Trichophyton rubrum. Okay, negative for rubrum. Then tinea versicolor or pityriasis versicolor, it is caused by what? It is caused by Malassezia furfur, a lipophilic fungus, also known as Pityrosporum ovale. Why it is called as versicolor? Versicolor means variety of colors. So a combination of hypopigmented and less commonly hyperpigmented lesions on the trunk. Okay, it may be confused with vitiligo, but remember vitiligo is not scaly, but यहाँ पे scaly lesions are seen, and it is more commonly encountered in moist, humid areas. Okay, the lesions are painless, non-pruritic and non-inflammatory. All right, so these are the lesions are can be described as macular, depigmented, and sometimes hyperpigmented scaly patches. Scaly patches. Okay. Now, other manifestations include seborrheic dermatitis, which is nothing but erythematous, pruritus, scaly lesions known as what? Dandruff in adults and cradle cap. And these lesions can be very severe in advanced HIV infections, then atopic dermatitis, folliculitis. And even though it's a superficial mycosis, but again, another important MCQ is that rarely it can cause systemic infection in patients receiving TPN with lipid infusions. You know why? Because remember, this is an example of a lipophilic fungus. So it loves to grow in the presence of lipids. Remember this. So for diagnosis, skin scrapings can be collected and you can do what? KOH mount using 10% KOH. KOH, K for KOH, K for keratinolytic. So it will lyse the keratin, which is nothing but traffic. We don't want to see, we don't want keratin. So we can see the fungi nicely under the microscope using 10% KOH. So this is how it looks like. This is nothing but spaghetti and meatball appearance, also described as banana grape appearance. So you can see these small round yeast cells, okay, are surrounded by these short curved hyphae, and that is why it is typically referred to as described as spaghetti and meatball appearance and banana and grape appearance. Then culture can be done on STA overlaid with olive oil because it is what? Lipophilic fungus. After incubation period for 1 week, you will see what? Fried egg colonies. Fried egg colonies. Any bacterium you can recall which also shows fried egg colonies? Urine test is positive. And what does the wood lamp examination show? Golden yellow fluorescence. Then for treatment, selenium sulfide shampoo, ketoconazole shampoo or cream for 2 weeks, or terbinafine cream can be given. Okay. Now look at this. Now this is a very important subcutaneous mycosis. Now this picture only will help you remember a lot of important things. Look at this. So देखो, chromoblastomycosis. If I break down this word, chromo means color. Remember the causative fungi are dematiaceous or pheoid fungi. That is, they have got colored hyphae, black or brown colored hyphae. Only black and brown color, no other color, no Vibrio color. Remember. So chromo say, remember this. Blasto means, the lesions in most of the cases are blasting out of the skin. The lesions are elevated. Okay. Mycosis means fungal infection. Okay. So the causative fungi, by the way, they are saprophytes only. They are not commensal. So the infection is acquired from outside. So that means the infection is what? The infection is exogenous infection. ठीक है ना? Now, so just a little memorizing tip. Those who go outside the house more commonly, they are going to be exposed to the fungi more commonly, and the mode of infection is traumatic inoculation. So who goes outside the house more commonly, males or females? Males. So remember, chromoblastomycosis is more common in males than females. And when somebody, let's say unfortunately some accident happens or something, then somebody stumbles upon something, some soil area where this fungus could be there in the soil. So more likely the trauma is going to be inflicted on the lower limb. So remember, lower limbs are more commonly involved than the upper limbs. Okay. Now the lesions are said to be polymorphic. That is, a variety of morphologies can be encountered, of which the most common morphology is this verrucous lesions, meaning they have got a rough surface resembling a cauliflower. And these verrucous lesions, as you can see, they look like as if they are blasting onto the skin. That is why remember the name chromoblastomycosis. Okay. And this picture of the lower limb also serves as a reminder that lower limbs are more commonly involved than the upper limbs, and remember males are more commonly involved than the females. And if you take tissue biopsy, you will see something like this. These brownish spherical cells which resemble copper pennies, so they are also known as copper penny cells. They are 5 to 12 microns in size. So these are brownish cells with horizontal and vertical striations. Is this clear, everyone? So as I said, this is what? So as I said, this is an exogenous fungal infection. Okay, males more commonly affected than females. Lower limbs more commonly affected than the upper limbs. Males more than females. Lower limbs more than the upper limbs. Mode of infection is traumatic inoculation, and it's a very slow growing infection, chronic. सोचो इसका नाम इतना लंबा है, chromoblastomycosis. आराम से हम इसका नाम लेंगे. So it's a chronic slow growing infection. The lesions, as I said, are polymorphic, and the most common variety is what? Verrucous, meaning having a rough surface. Other types include nodular, that is tumor-like lesions can also be encountered. In some cases, the lesions can be in the form of ulcers, that is ulcerated lesions, and in some lesions there could be crust formation also. And as I said before, it is caused by demataceous or fuoid fungi, that is those which have got black or brown hyphae. Please remember, guys, there is nothing called as black fungus. That was a media-generated term. In the proper nomenclature of or classification of different bacteria, there is nothing called as black fungus. जो COVID-19 pandemic के दौरान the mucormycosis was happening, the black fungus erroneously was given to this to the fungi, I mean mucor and all. The wrong name was given because mucor, rhizopus absidia, which belong to zygomycetes, they are what? They are, they have affinity for blood vessels. They're angio-invasive. So when they invade the blood vessels, they will cause necrosis of the infarction of the tissues which are being supplied by those blood vessels. That's where the name black fungus came from. But remember, there is nothing called as black fungus. So why am I emphasizing on this so much is that even though these fungi have got black or brown hyphae, please, these are not to be referred to as, these are not known as black fungi. ये please याद रखना, ठीक है? So the causative fungi 5 याद करने हैं. Fonsecia pedrosoy, Fonsecia compacta. First two names are F2. Fonsecia pedrosoy, Fonsecia compacta. Please don't be petrified of these names. You are going to appear for an MCQ exam, so always give yourself confidence that the answer is in front of me only out of the 4 options. I just have to mark it. Okay, ये 2-3 बार पढ़ोगे आराम से याद हो जाएगा. Then second, third, fourth and fifth names you can remember as PCR. बिल्कुल 100%. इस बार 200 पार. ठीक है, Amen. ठीक है, fingers crossed. So PCR, Fialophora verrucosa, Cladosporium caryonae, Rhinocladiella aquaspersa. So remember this. So biopsy, as I have explained, spherical cells with internal septations. They are 5 to 10 microns in size. And apart from copper penny cells, they are also known as what? Remember, they are obviously referred to as copper penny cells. They are also known as medullary bodies, also known as muriform cells, also known as sclerotic bodies. Please remember this also, and you can remember all these names by remembering Master of Science, that is MSc, precisely M2SC. ठीक है ना, M2SC. So 1M is medullary, second M is muriform, S is sclerotic, C for copper penny. Then we have got sporotrichosis. So sporotrichosis is caused by a dimorphic fungus, namely Sporothrix shankai. ठीक है, so it is a dimorphic fungus. It causes subcutaneous infection. It is present on plants and wood. So ये भी environment में ही होता है. So that is why the infection is exogenous. The mode of infection again is traumatic inoculation. The fungus secretes certain enzymes which help it invade the subcutaneous tissue, like for example aspartate proteinase and serine proteinase. The most common clinical form is what? Lymphocutaneous sporotrichosis. lymphocutaneous porotrichosis, and this is characterized by ulcers present in series or rows. So what happens? The fungus enters through the skin and it invades the lymphatic vessels. It sets up, therefore lymphangitis will occur, and in response to the lymphangitis, the fungus will come out of the lymphatic vessels, producing ulcers in series or rows. And remember, initially these lesions are nodular lesions, later on ulcers are formed, and these are painless lesions. Okay, these lesions are painless. Okay, now the disease is also known as rightly pointed out by Dr. Mukesh, it is also known as, remember, rose picker's disease or gardener's disease, also known as carpenter's disease, because it is present on plants and wood. In India, it is prevalent where? In the sub-Himalayan region. In the sub-Himalayan region, and gender predilection more commonly seen in males than females. Now, to make a diagnosis, what you can do? You can collect a specimen, like for example, swab from the ulcer can be collected, or pus or aspirate from the nodules. So you can do KOH mount or calcofluor white staining. All right, you can do biopsy of the tissues, which will show something like this. So a central cigar shaped yeast cell surrounded by what? Surrounded by this star shaped host reaction. Star shaped host reaction. And this entire thing is known as what? Asteroid body. So remember, sclerotic body is seen where? In chromoblastomycosis. Asteroid body is seen in sporotrichosis. Then the definitive method is a culture. When you incubate the sample at room temperature, you will encounter the mold form, where you will see something like this, the rosette arrangement of microconidia. So in sporotrichosis, see this labeling is wrong. This yeast form is the upper one. Okay? This is the yeast form upper one. Cancel this. This is the mold form. So the rose in sporotrichosis, rose दो जगह पे आता है, rosette arrangement and rose picker's disease or rose gardener's disease. ठीक है? Now the drug of choice for all forms of sporotrichosis is itraconazole, and for disseminated disease or disseminated infection we give amphotericin B. ठीक है? Amphotericin B. Now we come to mycetoma. Now mycetoma is also known as Madura foot or Madura. It is also known as Madura foot or Madura mycosis. It was first discovered in India in Madurai. Okay. Now, it again is an exogenous fungal infection because the causative fungi are present as saprophytes in the environment. So, mode of infection is traumatic inoculation. So, initially क्या होगा? Initially, there will be microabscess formation containing neutrophils, followed by a chronic granulomatous reaction in the subcutaneous tissue. So, mycetoma is of two types. Okay, eumycetoma caused by fungi, actinomycetoma caused by bacteria. So remember, E is caused by F, A is caused by B. E by F, A by B. Then there's a condition called as botryomycosis, which resembles mycetoma clinically, but it is caused by bacteria, for example, Staphylococcus aureus. Now the triad of mycetoma, as you can see in this picture, there is tumor-like swelling, that is the tumefaction of the affected tissue. Then the multiple discharging sinuses or sinus tracts will be there, which will be having what? Which will contain sulfur granules or granules which are present in the sinus tract. Okay. Now the third component of the triad tumefaction, okay, multiple discharging sinuses, and the third component is the sulfur grains or granules which are present in the sinus tract. Now clinical features, they are more common again in males than females. Just like I said in case of chromoblastomycosis, here also lower limbs are more commonly affected than the upper limbs. Same theory. Who goes outside the house more commonly? Males. When trauma occurs, more likely it is like to be inflicted upon what limb, lower or upper? Lower. Sometimes the underlying bones may also be involved. Okay. Now the causative agents of eumycetoma are of two categories. Dementaceous fungi, again I'm emphasizing these are not black fungi, they have got black or brown hyphae. So remember, black or brown hyphae containing fungi, that is the dementaceous fungi, they can some of them can cause chromoblastomycosis, some others can cause eumycetoma also, right? And they produce what? They produce black colored granules. These granules or grains, they are nothing but the colonies of the organisms responsible for mycetoma, whether it is fungus or bacteria. So remember these important agents: Madurella mycetomatis, Madurella gricia, Exophiala, Genselma, and Carvularia species. And then we have got the hyaline fungi, which have got transparent hyphae. They produce creamy white or gray colored granules, like for example, remember Pseudalexia boydii, Aspergillus nidulans, Acrimonium species, and Fusarium species. Remember this. Then remember, A for adenoma, B for bacteria. They are caused by bacteria, and these bacteria are what? Gram positive filamentous branching bacteria. So today in bacteriology, we have covered nocardia and actinomyces as the two important examples of the gram positive filamentous bacteria. Now some of these filamentous bacteria can even cause mycetoma. Like for example, remember Actinomadura madurae, Actinomadura pelliteri. Now P for pelliteri, P for pinkish reddish granules. ठीक है, तो P for pelliteri, P for pinkish reddish granules. ठीक है, so Actinomadura madurae, Actinomadura pelliteri, Nocardia asteroids, Brasiliensis, Scabies, and Streptomyces somaliensis. So Nocardia has got three important species. Remember them as A, B, C: asteroids, Brasiliensis, and Caviae, which can cause actinomycetoma. And all of these, Actinomadura madurae, Nocardia के तीन species, and Streptomyces, they produce what colored granules? They produce yellowish granules. See, just a tip to remember, bacteria, there are so many important pyogenic or pus producing bacteria. So remember, actinomycetoma, which is caused by bacteria, there also the color of the granules is going to be yellow. Just a memorizing tip. ठीक है. Then diagnosis of mycetoma. The specimen which you can collect is nothing but the granules, because as I said, they are nothing but the colonies of the microorganism causing the granuloma. So clean the lesions with an antiseptic and collect the granules on a sterile gauze, okay, by pressing the peripheral margins. And you also have to comment on the color, the size, and the texture of the granules, which will give you a tentative idea about whether it is a eumycetoma or actinomycetoma. So granules are washed in saline, and then they are crushed between the two slides, and then they are seen under the microscope. If you are suspecting eumycetoma based on the color of the granules, then you can do a KOH mount to reveal what? More than 1 microns in size hyphae along with chlamydospores. And if you're suspecting actinomycetoma, like you see pink or yellow color granules, then you can do gram stain, which will show less than 1 microns filaments, because these gram positive filamentous bacteria, their filaments are very, very thin as compared to the fungi. If you are suspecting nocardia, then go ahead with what? Acid fast stain. For nocardia, what percentage of H2SO4 you use? 1%. Okay, so 1% H2SO4 you use. Okay, now this you must have read in patho also, histopathological examination of the granules. Actinomycetoma will show what? Will show a granulomatous reaction with the filamentous bacteria at the margin, and eumycetoma will show what? Eumycetoma, granulomatous reaction with palisade arrangement of the hyphae in the cement substance. Then culture. What is the best specimen for culture? Granules. They should be obtained from deep biopsies because they are expected to have the live organisms. Okay? Then for culture also you can use STA or LJ media. And overall, remember, actinomycetoma has got a better prognosis than eumycetoma, and overall actinomycetoma is more common also than eumycetoma. Although in India also actinomycetoma is more common than eumycetoma, although in certain regions like Rajasthan and all and a few other places, eumycetoma is more common. Yes, Mohammed, definitely. After the session, I will share the annotated PDF. I'll share it with the team also, and I'll personally also share it in my Instagram story. Don't worry, I will share it. Okay. Now, coming to systemic mycosis. Now, systemic mycosis are caused by what? They are caused by dimorphic fungi, meaning these are thermally dimorphic fungi, meaning they have got two different morphologies at two different temperatures. At environmental temperature, they will exist as the mold form, and at human body temperature, they will exist as the yeast form. They will exist as the yeast form. Please remember this. ठीक है. Now, firstly, histoplasma capsulatum. इसके नाम पे मत जाओ. It is not capsulated, and the disease which is caused by it is known as histoplasmosis. Histoplasmosis, or also known as Darling's disease. Now, at 37 degrees Celsius, as I said, yeast form is going to be seen. So the budding yeast form will be seen, a single tiny bud, 2 to 4 microns in size. And at 25 degrees Celsius, the mold or filamentous form will be seen with asexual spores or conidia. So the asexual spores are of two types. Tuberculate macroconidia. Okay, they have got typically thick walls and finger-like projections, just like you can see in this picture. So this is a good schematic representation of the tuberculate macroconidia, like this. And these are what? Figure B is nothing but a tiny microconidia, unicellular. Okay. Then this is how histoplasma capsulatum is going to look like at 37 degrees Celsius. So this, you can see the yeast cells within the macrophages. So this arrow is pointing towards whatever purple things you are seeing, they're nothing but the yeast cells in the cytoplasm. And this was a specimen of spleen. Okay. Then next we have got blastomyces dermatitidis. The disease caused by it is known as blastomycosis. It is also known as Chicago disease or North American blastomycosis, also known as Gilchrist disease. Okay. So at 37, you will see what? The yeast form. Remember, broad-based budding yeast cells. Something like this. You can see this is the schematic representation upar. And niche dekho, this is the actual picture of the broad-based budding yeast cells. And look at this. This is a schematic representation of the mold form, figure B. So remember, blasto में क्या होगा ना? Blast हो जाएगा. So blast जब कोई चीज होती है तो छोटे-छोटे टुकड़े पड़ जाते हैं. तो there is only going to be microconidia in case of blastomyces. There are no macroconidia. ठीक है. There are no macroconidia. Please remember this. Okay. So at 25 degree Celsius, septate hyphae with pear-shaped microconidia are seen, 2 to 4 microns in size. And mode of infection क्या है? The mode of infection is inhalation of the microconidia. Then we have got Coccidioides immitis. Okay. So the mold form is there in the soil, that is in the environment, at 25 degrees Celsius. Okay. Now infection is associated with certain ground disturbing activities, like for example landscaping, construction, farming, archaeological excavation. क्योंकि क्या होता है, because of these ground disturbing activities, the spores of the fungi, the arthrospores, they get disseminated into the air, and these spores, arthrospores, which are the infective form, they are very, very tiny, and they can be easily inhaled, and they can go deep into the respiratory tract. Okay, so these are the arthrospores. They are what? They are the infective form. Barrel shaped they are the infective forms. The barrel shaped arthrospores. Okay, so this is the actual picture of arthrospores. Okay, they look like this, barrel shaped. And look at this. Now Coccidioides immitis is different from other dimorphic fungi in the sense that at 37 degrees Celsius, the typical yeast form will not be seen, but something like this will be seen. This big circle sphere is nothing but a spherule. Inside this are present endospores. So it is known as what? Endosporulating spherule. Endosporulating spherule. Okay. Then the next dimorphic fungus we have is Paracoccidioides brasiliensis. Again, it is a dimorphic fungus, and it causes what? Paracoccidioidomycosis, which is also known as South American blastomycosis, also known as Lutz mycosis. Please remember, it is called as South American blastomycosis. South American blastomycosis is not caused by Blastomyces dermatitidis. It is caused by this fungus. Okay, remember this. Now, epidemiology, it is found in Latin and South America. And look at this. Paracoccidioids. Remember, para means all over. So this is a memorizing tip to remember that it is going to have buds all over, arising from all over its surface. And this resembles what? Ship captain's wheel appearance or mariner's wheel appearance. And if let's say only two buds are there, this is known as Mickey Mouse appearance. I wonder why they don't call it Minnie Mouse appearance. Anyways, if two buds are there, then Mickey Mouse appearance. And this is the morphology. This is the mold form encountered at 25 degrees Celsius. Okay. So we have got over here septate hyphae with what? With chlamydospores. Septate hyphae seen with chlamydospores. Okay. Then next we have got Penicillium magnifi or Talaromyces magnifi. This again is a thermally dimorphic fungus. At 25 degrees Celsius, mold or filamentous form which produces a red wine colored pigment. So this is an example of a fungus which produces pigment. Okay. Then at 37 degrees Celsius, it produces yeast form. It exists as yeast form by forming what? Transverse fissures, something like this, transverse fissure. So this is a peculiar or important thing or a different thing about the yeast form of this fungus. And the reservoir of this fungus are what? Are Chinese bamboo rats. Okay. Now, infections are more common in rural areas where these rats are found. And it's found in Southeast Asian countries like Thailand, Vietnam, South China, and Manipur. But remember, there is no rat-to-rat transmission. In our country, in India, it is present where? In India, it is prevalent in the eastern part of our country, like for example, Manipur. Mode of infection is inhalation of the microconidia. These microconidia, when they are inhaled in the lungs, they will transform into the yeast form, and then it spreads via the blood to the reticuloendothelial system. And also make a note of the fact that penicilliosis, meaning the last systemic mycosis I've told you, and the first one I told you, histoplasmosis, they are examples of what? They are examples of AIDS defining illness. Okay? They are examples of AIDS defining illness. Then Trichomonas vaginalis, again a favorite of the examiners. It causes a sexually transmitted infection called as trichomoniasis. Okay? So this is what? This is a genital flagellated protozoan. In males, it can cause urethritis, but the males are usually asymptomatic. In females, it causes, remember, vaginitis and not endocervicitis. Unlike who? Unlike Chlamydia trachomatis, Serovirus, D2K, and Gonococcus, both of them can cause endocervicitis, but not vaginitis. Females, on the other hand, are symptomatic. Okay, vaginal pH becomes altered, it becomes more than 4.5. VIF amine test is positive in this condition. And if you do colposcopy, you will see, punctate hemorrhages on the ectocervix and vagina, which is described as colpitis macularis or strawberry vagina. Okay, so punctate hemorrhages on ectocervix and vagina. Okay. Now motility, remember, as I told before, it has got twitching or wobbling or jerky motility. And a very famous MCQ on this organism is that, remember, Trichomonas vaginalis has got only the trophozoite stage, and no cyst stage. Take a no cyst stage. Now for diagnosis, remember, the samples which can be collected are urethral discharge and vaginal discharge. You can do a wet mount to see the motility. You can do the VIF amine test, whereby you take the vaginal secretions and mix it with 10% KOH. If you are able to appreciate a fishy odor, it implies it's a positive test. This fishy odor is because of the production of volatile amines like trimethylamine. The vaginal pH is altered in this condition, that is, it becomes more than 4.5. Then Feinberg's medium can be used for culture, and culture, by the way, is said to be the gold standard method of diagnosis. Then we have also got a rapid test for antigen detection in the vaginal secretions by immunochromatography. Okay. Then antibody detection can be done by ELISA in serum and vaginal secretions. Then for treatment, this has been asked as an MCQ. Metronidazole or tinidazole, 2 grams single oral dose, treat both the partners. In pregnancy, metronidazole is contraindicated. Go for clotrimazole vaginal suppositories. And look at this. This is a schematic representation of this organism. As I told before in today's session, that this looks like an inverted pear-shaped organism. Okay. So there are two pairs of flagella arising from the anterior end and one sideward flagella known as the recurrent flagellum. Okay. And look at this. This is the actual picture. Picture of two trophozoites of Trichomonas vaginalis obtained from the in vitro culture like this. Okay. All right. We'll just take a very mini break, 5 minutes break. It's 10:55. I'll start right away at 11. Okay. Okay, I'll be back in just 5 minutes. Okay, we'll continue. Now, next is this very important table on coccidian parasites. Okay. Now, it's very simple to remember this table, and this will help you answer, all the questions on this topic. So we have got these three important coccidian parasites which cause refractory diarrhea in AIDS patients. So from left to right, we have got Cryptosporidium, Cyclospora, Isospora, and these names are in alphabetical order. Cryptosporidium first, followed by Cyclospora, followed by Isospora. Okay. Now the infective form is what? The infective form is sporulated oocyst in all these, and the diagnostic form, meaning the one which is present in the patient feces, which we examine, that is what? In Cryptosporidium, it is sporulated oocyst, whereas in both the sporas, it is what? Unsporulated oocyst. Now, why is that so? Remember this. See the second last point of this table, sporulation of the oocyst. Now what happens is, in case of Cryptosporidium, the sporulation occurs inside the host cell. So sporulation body mein hi of the host cell, that is why the feces also will have got the sporulated oocyst. ठीक है, sporulated oocyst. And on the other hand, in case of both the sporas, cyclo and isospora, the sporulation occurs in the soil. It occurs in the soil, and that is why the feces are going to have the unsporulated oocyst, which when enters the soil will undergo sporulation. So this is why. Now, as far as outbreaks are concerned, now Cryptosporidium, the outbreaks are common. Cyclospora, the outbreaks are what? The outbreaks are occasional. So remember, both the sporas are sporadic. They have got occasional outbreaks. Now, the oocyst of all these three organisms is acid fast. And if we talk about the shape, the shape is round in Cryptosporidium, again round in and 4 to 6 microns in size. Again, round but bigger in case of Cyclospora, and Isospora it is oval like this. Okay, so numbers are also easy to remember from left to right. 4 to 6, remember 4s and 6s in cricket. Then after 4 and 6, which are even numbers, what are the next two even numbers? 8 and 10. And then we have got 23 to 36 microns in size. Okay, now this you need not remember, sporulated oocyst. This is more important for second MBBS students. If you don't remember this, that is perfectly fine. Coming to acid fastness, so Cryptosporidium and Isospora, they are uniformly acid fast, but as far as Cyclospora is concerned, it is variably acid fast, as if it is confused. Being in the middle of the table, it is confused. Now guys, have a look at this. I have put up these pictures. This is the Cryptosporidium oocyst seen on acid fast stain, modified acid fast stain, that is 1% H2SO4 is used. Then look at this, the next picture. So here you can see the variability of the staining of the 4 oocysts. So यहाँ पे you can see 1, 2, 3, 4. 4 oocysts are there, of which only the second one has taken the pink color. First, third, and fourth have not taken the pink color. So that is what I was trying to say, that the oocysts of Cyclospora catenensis are variably acid fast. So that picture will help you remember that point. Okay. Okay, then coming to autofluorescence. Now remember, autofluorescence. So God compensated for the variable acid fast nature of the oocyst of Cyclospora by blessing it with some other important property, and that is autofluorescence. So autofluorescence plus plus, it is seen in case of Cyclospora, not seen in case of Cryptosporidium, but obviously it can be stained with the fluorescent dye. And autofluorescence is plus minus in case of Isospora. So here we almost finished the table. And as far as treatment is concerned, this is a frequently asked question. For both the sporas, it is cotrimoxazole, and for Cryptosporidium, it is nitazoxanide. So please remember this. रिएक्शन किंग, ये पूरा सेशन ही इंपॉर्टेंट है. FMG एग्जाम में जो परसेंटेज यूजुअली दी जाती है ना, कि इतने परसेंटेज क्वेश्चंस, इतने परसेंट क्वेश्चंस इस सब्जेक्ट से आएंगे, इतने उससे आएंगे, उस पर भरोसा नहीं करना चाहिए. आप हर सब्जेक्ट के PYTs करो, बिकॉज लेट्स से दिस ईयर दे हैव आस्क्ड 10 क्वेश्चंस फ्रॉम अ सब्जेक्ट, नेक्स्ट ईयर दे कैन आस्क 12 or 15. Okay, like that. So whatever I'm covering in this session is extremely important. You cannot skip anything. Okay. Now coming to Isospora belli. Now remember, Cystoisospora belli, by the way, is the new name. It is the new name of Isospora belli. Remember, and the oocysts are what? Oval, and size kya bataya tha? 23 to 36 microns in size. Remember this. Now coming to the next important thing, the eggs of helminths. So these are the important eggs. From left to right, if we go, We have got Trichuris trichura, which is a large intestinal nematode. As you can see, it's brownish egg. So remember, it is bile stained, it is barrel shaped, and it has got these mucus plugs at both the ends. So two mucus plugs at both the ends. Then we have got Enterobius vermicularis, again a large intestinal nematode. So both of these are what? They are LI, large intestinal nematodes, remember. Now, Enterobius vermicularis has got this plano-convex egg. So plano serves as a reminder for clean, saaf